viewers, we have enjoyed putting up EPL 2023 for you. Keep enjoying it.
Good morning, ladies and gentlemen, esteemed guests and fellow enthusiasts of scientific exploration. I welcome you all to the EPL 2023. Day 1 was incredible, and let's start the scientific journey of Day 2. The session that we are going to start is responsible endoscopy, balancing patient safety, cost and environment. And with deepest gratitude, I invite the moderators on stage, Dr. Pramod Garg and Dr. Randhir Sood. Welcome, gentlemen. Some of the most eminent people in this country whom I invite as panelists, Dr. Shiv K. Sareen, Dr. G. V. Rao, Dr. Anup Saraya, Dr. Matthew Philip, Dr. S. K. Acharya, and Dr. Sandeep Laktakia.
Well, ladies and gentlemen, we have the pleasure of having so many eminent people amongst us whom we specially chose to deliberate on this evolving concept where we must transform our practices from what we do to how we do it to make it safe for the patient, keeping still very consciously the cost and its environmental impact in mind. So first I have the pleasure of inviting Dr. D. Nageshwar Reddy to tell us about how does endoscopy impact the environment.
Thank you, Randhir. I think we have a very distinguished panel here, so I'll try and be very short so we can have some time for discussion. I've been asked to talk on the environmental impact of GI endoscopy, but why should we know about the environmental, how does climate change affect us or bother us? So just briefly to give a background of what happens here is that all our activities generates carbon dioxide, and this carbon dioxide gets trapped in our atmosphere, and because it gets trapped in the atmosphere, it generates an amount of heat, and it keeps the planet at an ambient temperature, and this ambient temperature is very important for normal human life. Again, optimal carbon dioxide is released. Till recently, this was the situation. So life evolved in a very progressive manner from a single cell to what we are today. This is because of this whole phenomena of global warmth being kept by this technique. But what happened is this perfect balance has now been made imperfect, mainly because of industrialization, because of large amount of excess greenhouse gases that are being released, and these greenhouse gases then result in more and more carbon dioxide getting trapped in the atmosphere. The average global temperature is rising, and because of an increased global temperature, you have the so-called global warming. Now, when you talk about global warming, it's starting to make Earth now an inhabitable place. When you talk about greenhouse gases, there are many other greenhouse gases in addition to carbon dioxide, and all this together is known as the carbon footprint. The term carbon footprint is often used for this. So anything that you do which directly or indirectly increases the emission of all of these carbon related gases or greenhouse gases are called carbon footprint. So it can be simple even buying a shirt, and now there are carbon dioxide equivalents because methane, nitrous oxide, and for example all these other gases are also being recorded in the recent years, and this of course translates to markedly increased temperature on the Earth. And what is the result of this? We have droughts, we have wilder weather, excessive rain, the glaciers melt, floods come in, forest fires, and all this I think every day we are reading the papers. And like Randhir mentioned, we as responsible citizens have a duty to say how we can contribute. But again, how is healthcare involved in this? Healthcare is climate change related to healthcare and healthcare related to climate change. A large number of diseases are directly related to this climate change. I won't go into this, but look at these statistics. In United States, 10% of all greenhouse gases are generated by healthcare. It's 7% in Australia, 5% in Canada, 3% in United States. And okay, among this, GI endoscopy is the third largest. It's surgical care, ICU, followed by GI endoscopy. GI endoscopy is the third largest contributor to these greenhouse gases. So this is a little surprising, but this is what the facts are. So how does GI endoscopy contribute to greenhouse gases? There are three methods: direct emissions, emissions which come from the electricity which you use, and indirect emissions from products. And briefly, directly, of course, we use a lot of carbon dioxide. All our endoscopy is now carbon dioxide. No more air is used. Similarly, the anesthetists use nitrous oxide. We do reprocessing, disposable accessories. So all these are contributing with relative contributions of some which is more, some which is less. Now let's come to the first thing, the carbon dioxide. The carbon dioxide, of course, we can't change because we got used to it. We are trying to see if carbon dioxide can be replaced by other gases, but this has not been possible up to now. Even washing on endoscopes can create a huge amount of greenhouse gases, and you can see this. We have each one produces 24 kilowatts of greenhouse gases, and for example in AEG we have 40 these machines working continuously throughout the day, and you can imagine the amount of greenhouse gases that we are producing. Similarly with COVID we become a little more careful, the amount of accessories that we are using, disposable accessories, disposable gowns and so on. In fact in our unit now we are changing from disposable gowns to cloth gowns because we feel that's more environmental friendly, and that's what's happening in all over the world. Of course, there are other things like plastic waste. Large amount is generated, 1.5 kg. Again, calculations in our hospital showed it's 1 kg. In some places, for example, in Japan, it's 3 kg. So depending on where you're working, it's a huge amount. And most of our plastics come from surgical gloves and so on. Again, we actually looked at the plastic waste coming out from AAG, and we found that it's 1 kg per occupied bed, approximately 1 kg per occupied bed at endoscopy area. So we have several ways of disposing this off. This becomes important because the bins that are used, most people don't know the significance. What does the yellow bin mean and all that? I'll come to that a little later because that's important. Of course, what are the solutions? Can we change from standard processing to ETO or plasma? ETO, of course, is a problem now. Plasma is coming in a big way in Western countries, but the cost is very high. Again, look at the comparison. More advanced countries, a lot of plastic waste are coming in, and this is how we try and decrease this. What happened to this plastic waste? So whatever plastic waste that we're using in endoscopy, syringes and so on and all, go to the landfills, and this is a picture of one of Hyderabad landfills, and these landfills are just left like this. There's a lot of bacterial sludge on top of this. Huge amount of methane and other gases are produced from this, contributing to environmental waste. So when you have these plastics and try and sort them out, what happens is they're disposed of to the red bin. The biohazardous are disposed in the red bin. And this is a problem because this produces much more carbon dioxide than others. In fact, when we look carefully to sort out our plastics, we found that 70% can be shifted to non-biohazardous and therefore decreasing the amount of gas that comes out. In addition to this, also there is a lot of gas coming out of energy consumption from computers, anesthetic machines, washing machines and so on. In fact, the carbon dioxide emissions which come here, and what happens is many times we just leave our endoscopy room lights on throughout the night. In between the processes are left on. All this generates enough help, and therefore they're now feeling that in addition to looking at this, we should also try and change the way we report. Why don't we become totally digital? We don't actually give paper reports and so on. Maybe this will come in future. So there are varieties of ways of doing things. In fact, we have now formed a consortium with Cancer City. There's a company called Greenco in Hyderabad, the largest environmental related company in Asia, and AAG, trying to do several things to see how we can get down these environmental hazards in endoscopy. Can we change the carbon dioxide use? Of course, digital reporting is the easiest, low-hanging fruit. Can we change the way we actually clean our endoscopes? Again, there's a lot of controversy about whether we should reuse accessories, which I think Ajay is going to touch, and so on. These are the factors we're looking at to see whether we can actually decrease the carbon footprint by efficient strategy to minimize waste, smart utilization of equipment, and other strategies. We now have just started using a machine where all the plastic waste in the endoscopy room can be converted into manure which can be used for a garden and so on. So this is a recent paper that we published, a group of individuals from different parts of the world. I recommend that you read this paper just to know how to go green, right, starting from the pre-procedure part, how we can use various non-invasive techniques, intra-procedure, what you can do to decrease carbon production, and of course post-procedure. So if we follow these steps, we believe that a time will come when endoscopy units can become net zero. Thank you for your attention.
Thank you, Nagi, for a wonderful talk. And now I'll invite our next speaker, Dr. Ajay Kumar, to tell us the safe and environmentally safe, both safe to the patient and environmentally safe techniques of endoscope and device reprocessing. I don't know, Ajay, this is your photograph? You look
certainly not mine. Thanks Ranveer for giving me an opportunity to read about this topic. Actually, when I was given this topic, I was wondering what to talk on, and Nagi actually has put a very good background to it, but it's always difficult to follow a speaker like Nagi on any issue. The friends, we usually keep on talking about the effective disinfection which is safe for the patient. But today that is not the subject of discussion here. Today we are talking about environment safety, which is closely related to what Nagi has actually laid the framework for. So question is, we have been doing endoscopies for so many years. We never discussed these issues. But why are we discussing it today? I tried to think about it, why is there so much of debate, why there is so much of talk, so many papers coming up on that. The way I perceive it is that whereas there is a higher focus on disinfection practices, which actually started after we realized that high-level disinfection that we are used to using, especially in the duodenoscopes, after the seeing of CRE-related infections, we realized, till that time, we were all thinking that HLD is good enough, it is a semi-critical device, and whatever infections occur, they occur because there is a break in the disinfection process or the practices have not followed rightly. But with this particular thing, we realized that even when you are following the right practices of high-level disinfection, the infection rate has gone up from 3.6 to 5.4%. This I'm talking about the duodenoscope related, of low or high concern organisms respectively. So that raised a concern. People started having a relook at what we are doing. And we all know about these 8 steps of disinfection, high-level disinfection, and you realize that the high-level disinfection, which is shown at number 5 here, is only one part of the whole thing. The major challenges there was in the manual cleaning and drying, which is not related with the actual disinfection. But at the same time, people looking into it started looking at how to improve the high-level disinfection. Of course, they started talking about automatic endoscopy reprocessors and so on. In that, lot of suggestions came, and that is, you should do a manual cleaning of biofilm, you should do double HLD, and people even started going to the extent of saying sterilization should be preferred if feasible. And in US, lot of centers shifted onto sterilization, that you should put this equipment into a critical device rather than a semi-critical device as we understand from the Spalding's classification of sterilization. But the next step to that, the industry took over. That basic fault is in the design of the duodenoscope, and they started modifying the duodenal caps, disposable caps, and even to talk about disposable duodenoscopes. So, as I said, the first reason, the sequence of events actually, not the reason, the sequence of events which led on to this discussion. So when this happened, there was the introduction of the disposable equipment, and the moment it came that you were taking a fully functional endoscope and throwing it away, the whole noise broke out that you are adding to the environmental hazards, you are increasing the waste, and you are actually contributing to the so-called greenhouse gas emissions which Nagi talked about. But before this came, we already had ureteroscopes, Caesars, and almost all anesthetic material has become disposable. And there are enough studies in the literature to show their greenhouse effect. With this background, and then of course, as Nagi mentioned, UN Sustainable Development Goals number 13 on climate change is to reduce greenhouse gas emissions and to ensuring responsible consumption and production. Here the two words we should be familiar. As a doctor, we don't talk about them, that a responsible consumption as well as production of the gases, and recognition of the medical waste as an important contributor starting taking place with these developments. And that's the reason people started talking about it. And Nagi already mentioned that the medical waste is the biggest contributor to the emissions, greenhouse emissions. So as these things happened, people started talking about environmental hazard. So there was a higher focus on the looking at the hazards of chemicals that we use for disinfection. And when you are knowing the health hazards of these chemicals, there are guidelines have come that everybody who's dealing with them should have a personal protective equipment. And of course, disposal of chemicals and disinfection apparatus. And that's to say that if you're doing a regular disinfection, that's the amount of waste in the personal protective equipment and the disinfectant that you produce, which is not small. So the measurable environmental indices for these is a resource consumption and emission. I mentioned these two words earlier. And then you have to look at what is involved in our disinfection practices. And that is the cleaning material, CO2 and the personal protective equipment. With this background, that how this whole discussion started, then you had a study here, as way back about, as early as about a few years back. Now before I talk about this study, let me clarify, this is a study which is sponsored by the manufacturers of disposable endoscopes. And this is a Danish study from the same place where the Ambo disposable endoscopes come in. They compared the environmental effects of reusable and single-use bronchoscope. This is, we don't have an actual study on the duodenoscopes, but we have the study on the bronchoscope. And to surprise, if you look at this, the blue tower is the disinfection or the reusable scopes. And the pink towers are with the disposable scope. If you look at the resources used, materials used, and the CO2 emissions, which is sounds very shocking. But if you go into the details, to the credit of the authors, they have clarified. This is when you are disinfecting a single endoscope and compared with the disposable. Because your personal protective equipment, they have kept that with that you can use only one, you can use only disinfect one scope. But the moment you make it, so on disinfecting more than one scope with the same PP, two systems are comparable as far as consumption and CO2 emissions are concerned. If Nagi's BZ center, if they are doing it at about 30 to 40 scopes at a time, then it becomes much more competitive, rather much more safer than as compared to the disposable endoscopes. So one should not be carried away by the title of this study,
one should go into the details and the messages are different. And then after looking at this, then look at the hazardous chemicals. This is nothing new, but then they became more into focus. At all these hazardous chemicals, whether we are using glutaraldehyde or whether we are using the hydrogen peroxide or paracetic acid, the major issue is skin, eye and respiratory irritants. All of us know that glutaraldehyde is the commonest used disinfectant in our country, and there are advantages of that, and they are quite effective and a time-tested thing. Of course, the modifications have been produced. But still, all these health hazards we should be aware of, because this also becomes a part of a occupational hazard and also related to the environmental hazards. That's the throat irritation, asthma-like symptoms, nose, burning eye and conjunctivitis, and so on. All these are well documented case studies and the patients reported, and so ultimately we come to that for these health hazards you have to have a stringent following of the safety guidelines and personal protective equipment. And so is the true with the different disinfectants, glutaraldehyde and OPA, paracetic acid, hydrogen peroxide or a electrolyte acid water. All of them have the similar sort of a thing. So endoscopic reprocessing, staff safety is important, and so accordingly personal protective equipment plus the designing of your disinfectant rooms is also important. So different ways of sterilization, a word, 1 minute on that, they said that to shift from disinfection to sterilization, ETO is the commonest one which is used, but if you look at the environmental hazards of that, it's a carcinogenic, teratogenic, and it's a neurotoxic, which is a well accepted thing. And in February 2019, in Illinois, a plant was shut down because of the ETO plant was shut down because there was an increased level of sterilant in the environment outside the factory. So nothing is black and white. If you start banning all these things, then you should ban all the motor vehicles, air conditioners and everything. It's a question is, we have to be rational, we have to be aware, and so future, what we need, I conclude by saying that we need to have better, reproducible, user-friendly, cheaper, environmental-friendly methods to disinfect the scopes, and thank you very much.
Thank you very much, Dr. Ajay Kumar, for an excellent talk. Now it's my pleasure to invite Dr. Mahesh Goenka to talk about safe use of accessories, which is actually, I think, the most important issue when it comes to environmental friendly endoscopies. Over to you, sir. Thank you.
Thank you, Pramod, and good morning, everybody. Thank you, Randhir, for organizing this EPL regularly. This is the flyer of EPL 2015, and this is a flyer of this year's EPL. Not much have changed, except that we are missing Murli, who was with us in 2015. Can it move? Slide need to move. So I think rightly Randhir has made this topic as responsible endoscopy balancing safety, cost and environment. And we heard a lot about the environment in the previous two talks. I'll add efficacy to the safety as another parameter which is important. So I personally believe that whether you talk of safety, efficacy, environment and so on, it's ultimately the money which matters. So if you look at the gastroscopy cost in the various countries, and this is a study published in 2019 from Korea, look at the cost of gastroscopy in UK, USA as compared to some of the other countries, including Korea and Poland, and India would come somewhere there. And average cost of upper GI endoscopy in a private sector today is between 3,000 to 5,000. If you look at the cost of ERCP in India, and in the different countries, the starting price is around 11,000, and it can go up, average cost is around 33,000. So when we talk about endoscopy setup, we have to invest in infrastructure, instrument, human resource, and so on, and the infrastructure can cost quite a bit of amount of money. Some of the instruments like US are really cannot be cost effective. But I'll primarily talk about the accessories, which was a topic which was given to me. And accessories form a very, very important component for a successful and effective endoscopy. So we know that the accessories can be either reusable or they can be single-use device as per the company's instructions. And accessories are always considered as critical device by Spalding classification. So now in the market there are very few reusable endoscopies, accessories, and it's mostly single-use accessories. So when can accessories be reused? Which are the reusable accessories? The accessories which can be disassembled, which are flushable, and where the components can be tolerant to the sterilization is the only one which are marketed as reused accessories. Some of the cost of these accessories are worth looking at. Sphincterotome is 10,000, guide wire is 18,000, balloon extractor is 12,000, and so on. Now if you look at the CGHS approved rates for Delhi, it's really ridiculous. For endoscopic biopsy, which you use a single use, cost will be 1,500 and the reimbursement is 397. For endoscopic dilatation is 1984. For ERCP with stone extraction is 2,777 and for mechanical lithotripsy is 9,200. So these are really very low compared to the cost of the accessory itself. Now if you look at the cost which we incur if you use a single use accessory, then this is what it is for a simple small stone extraction. Where you use a guide wire, a sphincterotome and a balloon extractor, the accessories if you use single use will cost about 40,000 rupees. If it's a complex stone, a large stone where you require a laser lithotripsy and a stent to be placed, there will be additional cost of about 40,000 rupees. Now if you talk about hilar cholangiocarcinoma where you put two metal stents and you use dilators to guide wires, brush cytology and so on, this cost will be actually at least 2 lakh rupees. We are not talking about the cost of infrastructure and so on. If you require additional procedure like spy scope or a RFA, that will cost about 1,20,000 or 40,000 rupees respectively. So that's the actual cost. So when we talk about cost and efficacy, these has to be taken into consideration. This is a repeat slide which I discussed somewhere else also, that the major problem is that the people are not sensitized to the complexities involved in the ERCP. There may be some surgeons in the hall and we have one surgeon who is on the chair as well. Often I get a patient who comes to me, the surgeon has said he will do a lap chole. There's a small stone stuck in the bile duct, just get it removed it's an easy job, get it removed by the endoscopist. I think that's underplaying the importance of ERCP. Now we must come to the term that accessories needs to be reused. From whatever background information I've given, we understand that in India at least, we cannot use single-use accessories, single-use, very, very difficult to do. Now, if you look at the European guidelines, they are very dogmatic about it, and they say yes, single-use endoscopy accessories should always be single-used, and they should be discarded immediately after the use. If you are using a reusable critical device accessory, then it must be reprocessed immediately by the standardized and validated reprocessing systems. And these are again costly as was mentioned. Both Nagi and Ajay discussed the advantages and disadvantages of using a single-use device, reusing it. The advantage of course will be to reduce the cost, and we talked in depth about the reduction in the waste product and carbon print. The disadvantage of reusing is that it will increase the risk of infection and possibly decrease the efficiency also, and we have a very important medico-legal aspect. So this is a study which was done by Vikram Bhatia at the US Needles using a device to calculate the bio burden as well as the positivity of infections, and the culture positivity were reused after following all the systems was 8.8%, and there was significant bioburden on the surface of the US needle. Now if you look at the reusable but versus single-use forceps, they are sample adequate, both are adequately excellent results. However, you spend a lot of money for reprocessing when you use a reusable forceps. So what are the medico-legal issues involved in this? We must have a hospital written policy. To safeguard yourself as an endoscopist, your hospital must have a written policy so that at least part of the burden goes to the hospital. There must be a well-documented maximum uses. So we have a JCI accredited hospital, Apollo Hospital, and the JCI says that you must write down in your hospital policy that a sphincterotome will be used 10 times or 8 times or 12 times, and you must have a tracking device to find out how many times this accessory has been used. a consent from the patient from reuse is very, very important. It is little bit of gray area, but we have incorporated this line in our consent form that I have been informed about the use of reprocessed single-use device duly approved by the Infection Control Committee as per the hospital policy. I think this is very vital for saving yourself from medical legal issues. And here, the society like SGI can play a very major role in giving us some guideline in position paper. Now, if you need to work on doing a good work, you must have a cross-subsidy concept where you balance the use of accessories, costly accessories and complicated procedure by the volume of gastroscope and colonoscopies you do, and maybe you can keep 2 or 3 levels of prices for your complicated procedures. We may ask the patient, and we do sometimes, to ask the patient to buy some of the accessories from the pharmacy, and of course they buy the stent, and we charge only for the procedure sometime. We need to negotiate with the industries, and we do use single-use biopsy forceps, but we have negotiated the price to almost 1/3 of that they would usually charge by giving them a large volume. Now, we must encourage the indigenous accessories and instruments, not at the cost of quality. And if you look at the sum of the cost of the accessories made by the Indian companies, they are significantly lower than that by the multinational companies. However, there is always a doubt about efficacy, and we must not compromise on that. Now, we have a problem that, at least in Calcutta, I can tell you that some of the ERCP centers are charging, or endoscopy centers are charging very low for the procedures, and that creates a problem. So we must make friends with the endoscopist in our city, so have a basic minimal rate for performing these procedures. Now, when you use reusable, single-use accessory reuse, so if you use a sphincterotomy 10 times, then for each procedure, the cost comes out to be 1,000 rupees for a sphincterotomy which costs 10,000, and so on. If you are using the guide wire 6 times, the cost comes out to be 3,000 per procedure. So by this, you can bring down the cost of the accessories. So to give you an example, if I'm doing a simple ERCP and a stone extraction, I would charge about 30,000 rupees, for which the accessories cost will be 10,000, doctor's cost will be 10,000, and 10,000 go to the hospital for the infrastructure. So that makes it feasible. If I am doing a biliary stenting, the cost may be 60,000 rupees, where the infrastructure hospital gets 20,000, accessories will be costing about 20,000, and the doctor will have 20,000 as the earning. Of course, the stents, costly stents like metal stent, will be charged extra. So my take-home message is that we must look at the safety, efficacy, cost, and the environment as we talked about. We have to come to the terms that the accessories in India, even if they are single-use accessories, need to be reused by reprocessing. We must sensitize patients about complexity involved so that their procedures are not underplayed. We may ask the patient to buy the accessories or stents. We must negotiate with the industry. We encourage indigenous accessories and instrument manufacturing. Cross-subsidy concept, which I talked about, and we must make friends with the endoscopist of our city. Thank you very much.
Thank you very much for this excellent talk once again. And I think we'll have question answer from the panelists now.
Yeah.
Okay, you can start with one.
Yeah, you see, these are 3 very illuminating talks which have emphasized on the impact of endoscopy on environment. But I would like to invite comments from the panel. Dr. Subrat Acharya first.
Well, these are very learned speakers. And I realize that as gastroenterologists, all of us has done, doing, and will do endoscopy and many things. I never realized that we are a part of people who are contributing to the greenhouse effect and killing people, extinguishing species, destroying environment. And that creates a serious questions in our own mind that you are the most brainy people and educated people and you are contributing to this. The second aspect I learned, particularly from Nagi, Mahesh as well as Ajay, that in our subject when you do endoscopy, we have 3 issues. We are destroying environment because of greenhouse effect, because we are using so much of equipment. You are raising a question of safety to you as well as patient, and the procedures are expensive and many people cannot afford it. These are the 3 aspects. I have a basic question, sir. You are all top-class endoscopists. Now, all of us are clinicians, including Professor Sareen, who is the biggest clinician, JV, Anu. Sareen kahan chala gaya? And Professor Dilavri is the culprit who is sitting here, started ERCP in this country for the first time. Now, will Nagi, Amit, Ajay, Pramod, and Randhir will agree with the first thing, that 30% of your endoscopies are unnecessary. Will you agree? Is it adding to the cost, greenhouse effect, and safety? 1/3. Now, you know methods. Second thing, another 15 to 20% of endoscopies are avoidable. Now you have a absolutely splenic stiffness, fibroscans, already KPA is more than 22. Now you want to screen for varices. And then you have to, every 3 months, do screening and prophylactic sclerotherapy, showing, randomized studies showing, even the prevent first bleed, non-selective beta blocker is used. Are you using it? Now, you are doing colonoscopy for all irritable bowel syndrome, right? Now, the third aspect is the endo, first is avoidable, second is, first is unnecessary, second is avoidable, and third is non-impactful endoscopy. A person with metastasis in brain and lungs, with everywhere, liver, you want to search for primary, doing a upper GI, doing a lower GI, right? Doing a enteroscopy, doing a CT scan, doing a PET scan. See that. And the last aspect is referral. There will be huge referral from other disciplinary, which is creating unnecessary endoscopy. And lastly, when you have so many conferences, is it producing greenhouse effect? So many people, so many lights run there. You yourself has produced, right, 1,500 kgs carbon dioxide equivalent, which will need 1.8 acres of forest, right, to ameliorate. That will be my comment, what I learned.
Thank you. I think that was very sane and sagacious advice to all of us. And I think we overlook it sometimes because of our personal interest and knowing very well that it is unavoidable. And I think there is a message in it. Thank you, Subrat. Janu? I'll request you to be brief in your comments so that we can have
some questions.
Actually, Randhir, I find myself an odd man out in this meeting. Whatever Dr. Acharya says, I agree to a great extent, because gastroenterologists, they are responsible for producing waste, which is, I think, in the hospital setting, they come at number 3, after anesthesia and radiology in various studies. We are discussing these issues in our country. We have not done any study so far. Very little we have done in this regard. And I think Dr. Acharya was conservative in saying that 30% endoscopies are useless. I think the figure is more than that. And then we keep on repeating it also. Once it has been done, we keep on repeating. Whether it has been done in the private sector or in the government sector, if a person comes, we keep on repeating and keep on generating waste and greenhouse gases. My question is that we are looking for alternatives and solution from the present system, when present system itself is responsible for degradation of environment. I always see health as a political subject, and people don't agree with that to a great extent. What is happening today? The production in the present world order is totally divorced from the objective need of the society and with profit motive. So same principle applies everywhere in all fields. And this rapacious loot of environment is guided and dictated by the economic policies of the West to a great extent. So, if we are really serious, you see, Dr. Acharya is from Orissa. I'll ask a question to him. What has happened to his state, the so-called development, which I say is rapacious loot of environment and natural resources by multinational corporation? What has happened in that state, and what has happened to the medical establishment there?
I think we'll restrict ourselves to endoscopy for the time being, because this is a huge thing, and we'll have to have a word.
Everything is linked, Randhir.
I
Everything
agree.
is linked. If we don't see in totality, we will keep on seeing things in isolation, cut off from its interconnection. There are certain interconnection, and we should be in a habit of seeing things in continuity and in its interconnection.
I agree.
Thank you.
Thank you. I think in the greenhouse impact disruption is happening in all the fields or every walks of life, not only in gastroenterology or anything. But no, I think as a responsible group of people, we should actually step forward and bring out how we can reduce the greenhouse impact or carbon emission, carbon dioxide. What I think is we have to start from not only from our endoscopy suite, but also for everything like conferences. I don't know whether you remember 2018, ISC was the first conference in India to have a green conference, and it was actually taken up by Limca record book. But unfortunately, because of the documentation deficiency, we did not get an award. Otherwise, there would have been the first carbon negative conference happen in India. But not only that, but as Mahesh has told, that you have to have a very good balance between patient safety, carbon impact, and as well as cost of all these things. But as a society, what I think, we should be having advocacies to use or single-use devices. But for that, we need data. But unfortunately, we don't have. Unless we have enough data to say that reusable is good enough and it is not creating any problem to the patient, then otherwise it is difficult. And I think, we should work for that. As society, we should take it up. I'm sure that we had some meetings already, and it is coming up. And I think that is the most important thing which could really make any impact on this. Because we have to convince the society, convince the people, convince the government, and then only we can say that, yes, we have done a study like this. It's not easy that reuse can produce what all impact on the clinical applications, safety, as well as the durability of the equipments also. Thank you so much.
Thank you, Randhir. With due apologies to all the endoscopists. Actually, Mahesh was talking about making friends with endoscopists. I think you should make friends with surgeons. Actually, I can run a randomized control trial as in today to show the amount of carbon print that we surgeons produce for a similar procedure compared to the endoscopy. I think the endoscopists agree. I think we can run a randomized control trial between the amount of carbon print that we produce as surgeons vis-a-vis to the endoscopists, amount of disposables, amount of carbon dioxide, amount of sterilization that is used, especially for some procedures, not for all procedures. But I think it will be dramatically less than what is being produced on the endoscopy side.
I think, Randhir, you are the leader. You do three things. 3 R's, what I thought. Reduce, reuse, right, and recycle. If on these 3 aspects you work, and that's particular specific, you can probably made a significant contribution as a leader in endoscopy.
Thank you, sir. Thank you for these excellent comments. Yes, Dr. Media.
Yeah, I just want to make a comment that I heard all the 3 excellent lectures, the comments from the panelists, from the chairpersons. I have a feeling, and I'm sure all of you will agree with me, that the CO2 emission which is coming from GI endoscopy is predominantly if we are going to dispose of plastic accessories. I don't think emission comes too much from just reprocessing endoscopes. By doing washing of an endoscope, especially if you have endoscopy cleaners with 2 or 3 scopes at a time, we are not going to increase the CO2 emission. So it's of extreme and prime importance that our country has to come out with some guideline through SGI, even though SGI is not a statutory body, We have to come out with guidelines that in our country, we should be able to reuse endoscopy accessories. Extremely important, because that is the maximum waste and the maximum increase of CO2 emission. Of course, I have discussions with JCI also, and JCI is also ready to accept. If SGI comes up with guidelines, then even insurance companies like JCI are ready to accept those guidelines. And later on, this will become a game changer. I think this is of prime importance as far as GI endoscopy is concerned. So we have to work on it as fast as possible.
I agree that we need to generate evidence. Last comment from Ajay and Nagi, would like to give any comment? Because we'll wrap it up.
I just want to endorse what Amit said, and I just want to say that already we have worked on that. We had a big meeting, full-day meeting in Jaipur ISG at the time of that, and the papers, initial drafts have already come, and we should be able to process. Actually, my request to the academic endoscopists in the group is that there are certain areas which in questions evidence has to be, please produce that evidence, and which will strengthen your guidelines, because we produced a position paper on the same thing almost 10 years back, and it's a follow-up of the same thing that we are coming up this, but we need some more evidences to support scientifically.
Just to finally, just to wrap it up, I think what Dr. Acharya said is right, but I think it's not practical. It's not going to be practical for us as a community to say you don't require endoscopy, you can't control the whole community. Although it's theoretically right, I think it's not practically right. So what we should do is to see how we can reduce our greenhouse gases continuing the same practices. And we have shown in a paper just published in GUT recently that you can do it. You can make your endoscopy unit net carbon zero using certain practices. If anybody is interested can read that paper, and that's what we should aim for, and not try and think about other unrealistic things like reducing and not following the guidelines and so on.
So I'm a little bit disagree with Dr. Acharya, because don't look from the bird's eye view. Look at the helicopter view. Because doing an endoscopy, you save so many lives. The carbon emission, what is the negative impact by endoscopy only? I don't think that's true. Yes, it adds on, so we should have as objective guidelines to know that what we are doing, is it beneficial or not, and what we are giving damage to the environment. And then yes, you may be right, but practically these things are not possible, that 30% of endoscopy are not required, 20% are unavoidable. One cancer in one family has a lot of impact. So I think we should consider that part also.
Rajesh, I am not denying the indicated endoscopy. What I am denying, and all of us your senior clinicians have a heart.
I agree with all your inputs. We, in respect of time, ultimately we have to wrap it up. Otherwise, we'll
I think as a society should remove all these erosive gastroenteritis, lax, LES. 90% of them has this gastric enteral hyperemia, right? Giving HP kit, right? You see, you know it. Now you want to argue out, right? It is your impression.
I think we can have a lengthy discussion on indication and contraindication. Just one clarification, that JCI has already agreed that you can reuse your single-use accessories provided you document it in a hospital policy. So I think there's nothing wrong in reusing it if you use proper reprocessing, and there's a hospital written policy. That's it.
I think this is important.
Thank you, ladies and gentlemen. I think we had wonderful discussion. We had opinion of people who are predominantly not endoscopists, because that was very essential, because otherwise we look at from inside. Having an outside view was very essential. Thank you, everybody.
Ranveer, I contest this. I was endoscopy. When you were a resident, I only made you learn how to make this endoscopy.
That's why I do more.
Thank you, gentlemen. Surely you are the doctors who redefine excellence. Now we are moving towards the symposium that was scheduled for the day one, and we are having it today now. And I invite persons with healing hands and compassionate hearts. with deepest gratitude for the symposium on palliation of malignant complex hilar blocks. As chairpersons, I invite Dr. G.V. Rao, Dr. J.B. Dilavari, Dr. M.S. Khuru. I welcome you all on stage. And as panelists, I invite Dr. Sharat Chandra, Dr. Subhash Nandwani, Dr. Dinesh Shrestha, Dr. Arvind Kumar, and Dr. Rohit Gupta. I request the chairpersons to be here next to the podium chairs and the panelists on those chairs. The stage is all set. Over to the chair.
Well, malignant hilar block is a challenging problem. If surgery can be done, that's the ideal situation and the endoscopists have no role to play. But when you deal with the surgery is not indicated and is only for palliation, then we need a multidisciplinary team to find out what's the ideal treatment for a patient. And the three experts are involved in that. The endoscopist who does the ERCP, the endo ultrasound, also part of ERCP but a different procedure, and the radiologist who will do the intervention. So let's start with the first one, is Dr. Vikas Singla, who's going to talk on ERCP. Vikas Singla, please.
A very good morning to all of you. At the outset, I'm thankful to Team Vedanta for the kind invitation. So the malignant hilar block, by definition, the obstruction is above the level of insertion of cystic duct and up to the level of biliary hilum. And cholangiocarcinoma is the most common cause. In India, the CA gallbladder is also a common cause. And other rare causes leading to hilar obstruction are the hepatocellular carcinoma, lymphoma, or the metastasis. And there can be benign causes also like post-surgery, PSC, and the IgG for cholangiopathy. So it's essential to have a bismuth classification prior to any intervention. Type 1, it involves the bile duct above the level of insertion of cystic duct, but it spares the liver hilum. Type 2 involves the liver hilum, and 3A involve the right-sided branches, and 3B involve the left-sided branches, and type 4 involve both the left and the right side branches. So whenever we have a patient with the hilar obstruction, it can be a benign obstruction or it can be a malignant obstruction. So it's essential to classify. So we should have a good history. Rapidity of symptom, old age, it suggests it can be a malignancy. Similarly, weight loss, anorexia suggests it can be malignancy. Past history of surgery favors the benign etiology. And LFT and CA19-9 can also give a clue regarding the etiology. And it's essential to have a good CT scan with the contrast and MRCP. So based on this evaluation, we can differentiate whether it's a benign lesion or the malignant lesion. If it's a resectable lesion, they don't require a tissue diagnosis and patient can straight away go for the surgery. So MRCP can give an idea whether it's a benign or malignant. If on MRCP it's irregular, asymmetrical and long stricture, it's likely to be malignant with a high accuracy of more than 90%. So these patient doesn't require any tissue diagnosis, resectable lesion can go for the surgery. A study from the AIMS, it look into the hilar strictures, benign and malignant. We can see that if there is a mass formation, irregular margins, asymmetrical, this favors the malignancy, and similarly length of stricture, long stricture, it's likely to be malignant. Abrupt cutoff can be seen both in the benign or the malignant. Again, MRCP is highly accurate in defining the benign or the malignant stricture. Here we can see abrupt cutoff on both the sides. This is a symmetrical stricture likely to be benign. This is the irregular stricture likely to be malignant. So then we do either CT angiography or the MR angiography to define the resectability. Only 30 to 40% of cholangiocarcinoma are the malignant. On the CT scan, we have to look for the distant metastasis, we have to look for the lymph node involvement, and we have to see the four things. We have to see the lobar atrophy, we have to see involvement of the biliary segment, we have to see portal vein, hepatic artery involvement. If there is involvement of biliary segment on both the sides, it's unresectable. If there is a atrophy or the biliary segment involvement on the one side and the other side vessels are involved, it's again unresectable. So we should have one segment without atrophy, without biliary or without vascular involvement to call it a resectable lesion. So ERCP is indicated either for the preoperative drainage or for the palliation. Preoperative drainage is mostly not required. Patient who are requiring the right lobectomy, in this patient the liver volume will be low. They may have a liver failure. So patient planned for the right hepatectomy may undergo portal vein embolization and they can undergo the preoperative biliary drainage. Otherwise the preoperative drainage is not required. And in patient who had a unresectable malignancy, these are the indication for the palliative drainage. Patient who require the chemoradiotherapy, they may require the biliary drainage. Similarly, for palliation of pruritus or for the treatment of cholangitis, the patient may require the ERCP. So whenever we do the biliary drainage, we have to remember the golden rule. Higher the grade of obstruction, more challenging is the ERCP and less effective will be the drainage, and there is high risk of complication. So as a rule, in a higher degree of obstruction, one has to be extra careful regarding the complication. And these are the principle of ERCP for the hilar obstruction. Always have a good MRCP to have a roadmap prior to the ERCP, and one should always avoid opacification of duct which are not planned for the drainage. One should always cross the level of obstruction, only then one should inject the contrast. Never inject the contrast from below the level of obstruction. It will go into all the segments which may not be drainable. So always first cross the obstruction and then inject the contrast and avoid drainage of the atrophic lobe. And one can avoid the contrast and one can use the CO2 or the air for the cholangiogram. One has to aspirate 15 to 20 ml of bile followed by injection of 10 to 15 ml of air to opacify the biliary system. We can see here the air can opacify this is called air cholangiogram. So this is a study by Dr. Sood group. The patient had type 1 or type 2 block, and all the 17 patients had undergone successful ERCP and without any cholangitis. So the air cholangiogram may avoid the contrast injection and may avoid the cholangitis. The next question is how much liver should be drained. If the patient has preserved liver function, 1/3 liver may be drained, and if there is a deranged liver function or the patient has liver failure, more than 50% of liver may have to be drained. And now next question is which stent to be used, plastic or the metal stent. Metal stent has a longer patency, they require the lesser number of reintervention and they have a longer patient survival. So metal is preferred over the plastic stent. Now we have two options, which one to choose, PTBD or the ERCP. The benefit of drainage with the PTBD is that we can have a desired duct puncture. ERCP, we don't have the control over the wire may not go into the desired duct. With the PTBD, we have a good control which duct to puncture. A higher risk of pain with the PTBD, higher risk of bleed with the PTBD. With the ERCP, there is a risk of cholangitis, and with the PTBD, there is a risk of external biliary catheter. In patient with the inaccessible papilla, the PTBD can be done, ERCP is not feasible. So this is a study from the AIMS. Patient had type 2 or the type 3 block carcinoma gallbladder. Patient underwent either PTBD or the ERCP, but there was only a plastic stent was placed, not the metal stent, and only the single side was drained. And it was seen that successful drainage was higher in the PTBD group as compared to ERCP group, and cholangitis was higher in the endoscopy group. But the limitation of study was that the plastic stent was used and only one system was drained even in patient with the type 3 block. And another study which compared type 3 and type 4 block, all the patient underwent metal stenting either by the PTBD or with the endoscopic approach. And retrospective study, we can see that successful biliary decompression was higher in the percutaneous group as compared to endoscopy group, and the complication were similar in two groups, but there are one death in the endoscopy group, and median survival and the stent patency was similar in two groups, and we can see between the endoscopic and the percutaneous drainage type 3 and type 4 block with the metal stent, cholangitis was higher in the endoscopic group and the one death in the endoscopic group. So between the ERCP and the PTBD, if there is a lower level of block, ERCP may be preferred, but in higher level of block like type 4, the PTBD should be preferred. So I think there should be a personalized approach in a patient with the hilar cholangiocarcinoma. One should have a good MRCP and have the bismuth classification. If it's a type 1 block involving only the CBD below the hilum, single stent is sufficient. If the life expectancy is less than 3 months, plastic stent can be placed. But if the expected survival is more than 3 months, metal stent can be placed. In type 2 block, if there is a cholangitis, both the systems should be drained and the uncovered SEMs should be placed. If there is no cholangitis, the indication is only palliation of pruritus or the chemotherapy. The single stenting or the bilateral stenting can be done. With the single side stenting, it's easier, the cost is lesser, but there is a risk of partial drainage and there is a risk of cholangitis. So this meta-analysis compared the unilateral and the bilateral stenting in patient with the hilar cholangiocarcinoma, and it has shown that more than 1200 patients, and it was seen that technical success was higher in the unilateral group. In patient with the cholangiocarcinoma, sometimes it's difficult to place stent on both the sides. So the success is higher in the unilateral group. The functional success is similar in both the group, and there is similar risk of complication in both the groups. So unilateral and the bilateral stenting is equally effective in patient with the hilar cholangiocarcinoma. But in this study, there are no subcategorization according to the type of block. So when one is planning the bilateral stent, it can be either a side-by-side stenting or it can be stent in stent. And the study has shown that stent in stent and the stent by stent both are equally efficacious and with equal rate of adverse events. In type 3 block, the goal should be to drain at least 50% of liver volume. If it's a type 3B involving the left system, one can drain only the right lobe. This will give drainage of more than 50%. If it's a type 3A block involving the right lobe, if the right lobe is atrophic, one should drain the left lobe. If the right lobe is non-atrophic, one can drain either the left lobe with the right anterior or right posterior, or the right anterior with the right posterior, or one can drain all the lobes. If with the ERCP there is failure to drain at least 50% of the liver volume, one can go for the complementary PTBD. In patient with the type 4 block, there is high risk of cholangitis and ERCP should be avoided. If the patient requires biliary drainage, PTBD should be preferred. So sometime during the ERCP, we can do the local ablation also. The RFA may be used. RFA has a high frequency current which leads to local hyperthermia and it can lead to coagulation necrosis, and after RFA, the metal stent can be placed. And it was seen that randomized study comparing its meta-analysis compared the RFA group with the RFA with the stent and only stent group, and it was seen that after the RFA, the median survival was higher and the stent patency was higher in the patient who underwent RFA with the stenting. So to summarize, cholangiocarcinoma and the carcinoma gallbladder are the most common cause of hilar biliary obstruction. ERCP can be done for palliation in selected patients who are undergoing the chemotherapy or having itching or cholangitis. During ERCP, one should avoid the contrast injection. One can use air or the CO2. In patient with the cholangitis, all the segments of the liver should be drained. In patient without cholangitis, 50% of liver volume should be drained. In patient who had a type 1 block or type 2 block, one stent may be sufficient. In patient with type 3 block, mostly they will require 2 stents. And ERCP should be avoided in patient with the type 4 block. They should be sent for the PTBD. Thank you very much for your patient hearing.
Thank you, Dr. Singla. Excellent talk. I think we have discussion at the end, if you don't mind, because the multidisciplinary approach to this problem. So let's 3 speakers give their suggestions about the talk, and then we will have the discussion at the end. If you two would take a place there.
It is my pleasure to invite Dr. Rajesh Puri talking about malignant biliary strictures and US. Dr. Puri.
Good morning, ladies and gentlemen. Greetings from Medanta and EPL. So I'm going to talk the role of endoscopic ultrasound in the palliation of complex hilar block. Whenever a patient of hilar block or a malignant hilar block come, invariably as a gastroenterologist, we'll end up doing the ERCP. And ERCP in these patients are very challenging, as Vikas has said. First, the cannulation is difficult, risk of post-ERCP pancreatitis, difficult to go into the desired system where you want to put the stent, and sometimes you are not able to put the multiple stents, and these patients land up into a cholangitis and you require assistance of your PTBD colleague. So the term, I think palliation of the complex hilar block is not right. We should say the management of hilar block, it should be a personalized care. Gone are the days when there was a concept of stent and forget. With an advancement of chemotherapy and immunotherapy, these patients has a longevity of life, and these patients come for the multiple time re-intervention. So I think each case of hilar block is unique, should be treated as a singular case, and I feel there should always be a multidisciplinary management, as Dr. Jang Dilavri said. Before embarking on that, we should sit together, plan the treatment, plan how much of the liver volume, what type of the stent, how to diagnose, and then take the corrective action rather than putting the stent. So I think that is very important. The concept of stent and forget should not be applied in 2023. When I was resident, I distinctly remember hilar blocks come, is malignant, you put one plastic or two plastic or one metal and patient goes home and he never come back. So I think that era has gone. We all are witness in the last 5 years the emergence of role of endoscopic ultrasound in the biliary drainage. I think endoscopic ultrasound is the standard of care for the lower and bile duct block, but in the hilar malignancy the data is emerging and it's still a niche procedure, but every day the skill is improving for US. And I Google it and I find out that 371 article, the role of endoscopic ultrasound in the bile duct drainage in the last 1 year. So what do we really want when we talk about the palliation or the management of the hilar block? The relieving the jaundice, maximizing the drainage. If patient has a cholangitis, you palliate the cholangitis, enable the patient for chemotherapy or immunotherapy, or if patient requires surgical intervention, and the most important is to improve the quality of life. I think the principle of management for palliation has changed from 33% to 50%, and now the concept is as much as possible, and at least more than 70% of the liver volume required to be drained to enable that patient for chemotherapy or immunotherapy. So where does the role of endoscopic ultrasound? As I said, it requires a multidisciplinary team. There are subset of the patient who requires dual or one modality. So you have to decide before embarking for the procedures. So EUS may be useful if patient has inaccessible papilla, patient has a hilar malignancy with a gastric outlet obstruction, or you failed in ERCP. Or to achieve the complete drainage if patient has cholangitis post-procedure or de novo as a part of multimodal drainage to achieve the adequate liver volume to make this patient unable for the chemotherapy. And as I said, with an advancement of chemotherapy and immunotherapy, these patients, the longevity of life goes high, and these patients come up for the re-intervention in occluded transpapillary stents. What can we do in EUS? We can use the EUS-guided hepaticogastrostomy, EUS-guided antegrade stenting, hepaticoduodenostomy, and combined EUS and ERCP-guided drainage. But remember, the role of choledochoduodenostomy has no role in the hilar malignancy. In HGS, you do stent from the left hepatic duct to the stomach. In EUS, hepaticoduodenostomy, right posterior duct with the lateral part of the duodenum. EUS bridging stent that you do a hepaticogastrostomy, put an covered stent from the right to the left ductal system, and then put a covered stent in the left to the stomach. And combined ERCP and EUS, meaning that you did an ERCP, you know that patient has a type 3A block, You put a two metal stent in the right anterior and right posterior, and you can do the hepaticogastrostomy. That is combined endoscopy and ERCP. So now the data is evolving from the Asian countries, and this is a paper from the Sridhar Sundaram, and he compared the EUS guided biliary drainage with the percutaneous drainage in a patient of hilar malignancy, and it shows both has equal efficacy. But in EUS BD, the number of days of admission post-procedure was less in comparison to PTBD. The role of endoscopic ultrasound as a rescue for the reintervention procedure for the high-grade hilar stricture, out of 84 patients when they followed up after the ERCP, 28 patients had a stent dysfunction in 6 months, and the repeat ERCP was successful in around 62% cases, but 10 patients who remain where ERCP was not possible, reintervention failed, EUS guided biliary drainage were possible in all these patients. Again, paper from the multi-center trial from PGI, Hyderabad, and from the Europe, and they compare, it is a retrospective multi-center trial comparing the EUS HGS versus left ductal PTBD. But they have shown that the technical success in both the group was same, but the clinical success was better in the EUS group. Immediate peri-procedural complications was less. The advantage of endoscopic ultrasound, it gives the tubeless drainage, one-time procedures, and there is no hanging tube outside. Hospital stay was much lesser in the EUS HGS group in comparison to PTBD. Late adverse event and the reintervention rate was again less in the EUS HGS group in comparison to PTBD. So I agree definitely with an EUS, the data is either a single center or in the form of case reports or case series. But there are n number of the data in the last 5 years that shows that EUS guided biliary drainage in the hilar stricture is the technical and the clinical success is 80 to 100%. This is one of the case who came with the type 1 or we say type 2 hilar stricture. We did an ERCP, patient has a gastric outlet obstruction. In the same environment, we changed the endoscope and we did a bridging right to left, one uncovered stent, and then hepaticogastrostomy, and the antral stent was placed. And many of the time as an ERCP, you do an ERCP, you remain an undrained segment, IR people call a day before, a day after, and patient land up into a cholangitis. So just changing the scope in the same sedation, in the same environment. Yes, the most important thing is you should have a skill and you should know that this can give the complete drainage. Now in the patient of surgical altered anatomy, if patient has a malignant hilar block, you can do the EUS HGS along with the enteroscope guided ERCP for the right-sided hilar block. Patient who has a cholangitis, EUS can achieve the complete drainage. By EUS, you can do hepaticogastrostomy, you can do the EUS guided hepaticoduodenostomy. So you can do from the duodenum, you can do from the stomach, and the place where the stent was there, so you can give the complete drainage if patient has a cholangitis. This is a recently published study in endoscopy where they compare the EUS, that is combined EUS and ERCP versus PTBD, and this is a multi-center observational study, 21 patients in the combined group and 17 patients in the PTBD group. And what that shows that technical success and the clinical success was same, but the complication rate, recurrent biliary obstruction at 3 months and the recurrent biliary obstruction at the 6 month was much lower in the combined EUS and ERCP group. So this is another an example. We were planning to put the two metal stents, but we were not able to negotiate the metal stent into the left hepatic duct. So again, changing the scope, right system was drained with an ERCP and the left ductal system was drained with the help of EUS. We did a hepaticogastrostomy and patient salvage on the same setting. As I said, these patient has a longevity of life, so reintervention in occluded stent is another problem. And EUS is very useful. If patient has an occluded biliary stent, you do an ERCP, you put two stents in the biliary system, the reintervention is difficult. So you can do the EUS guided hepaticoduodenostomy or you can do the hepaticogastrostomy. This is again a multi-center study from India where it shows that patient who has a moderate to severe cholangitis, EUS guided biliary drainage in the form of HGS, CDS, antegrade stenting and rendezvous is possible and has a very good technical and the clinical success, and it is more effective in the distal block in comparison to the proximal block. The question comes, when one will choose the EUS guided biliary drainage? I don't want to give this message by my presentation that all cases are suitable for EUS. That is not right. But yes, if the ERCP is not possible or ERCP is failed or inaccessible ampulla, expertise of EUS and skill is available. And if most commonly the people says that ascites and coagulopathy is a contraindication for EUS, I think that is not. That is a relative contraindication. You can do the 100% drainage or you can very well achieve more than 70% drainage with the help of EUS. You should always have a backup of PTBD, your colleague. So both the side of the story when we talk about the EUS guided biliary drainage, the advantage is single stage procedure, tubeless internal drainage, that does not traverse the tumor. That is one of the most important advantage. When your stent is not going through the tumor, the risk of ingrowth is not there, risk of pancreatitis is not there. But there are several disadvantages. That is, we have a limited experience, we don't have a level 1 evidence, no large RCTs, limited availability of the skills and the expertise. We require more skillful endosonologists to perform this. This requires a steep learning curve, insufficient development of dedicated equipment, and re-intervention within EUS is challenging. So this is a paper from AIG, Sandeep and Partha Pal, and it's a very nice flow chart, a malignant hilar block with an accessible papilla, you do an ERCP. If patient has a transpapillary stent occlusion or undrained segment, you are able to place only a one stent and remaining segments are required drainage or impassable stricture. Many of the time your wire goes, but you are not able to place the two metal stent. You can have an option of PTBD or you can do the EUSBD. Or if the papilla is inaccessible, again you have a two choice, PTBD and EUSBD. If there is a communicating block, you do an HGS or hepaticoduodenostomy or EUS rendezvous. Non-communicating block, you can put the bridging stent or you can do the combined ERCP and EUS. Advantage of EUS, I have already discussed, lower patient discomfort, internal drainage, does not traverse the tumor. So ladies and gentlemen, to summarize, ERCP and PTBD is still the primary modality of drainage for malignant hilar block. Endoscopic ultrasound guided biliary drainage is emerging alternative to PTBD in a patient with a malignant hilar block and failed ERCP, but more data, level 1 evidence is required. Preliminary data suggests that outcome of EUSBD is superior to the percutaneous technique. Multiple technique of EUSBD available. You can do EUS HGS, you can do the hepaticoduodenostomy, you can do the bridging methods. Complex procedure, high risk, high level of skill, and the trained endosonologists are required. I think patient selection is critical. Each patient is a unique patient. Always before embarking on the palliation, do a multidisciplinary discussion and then plan, is this patient is suitable for what kind of procedure, what is a skill set available in your center, and accordingly you can take. And I think let's work together for each patient rather than generalize that you are an endoscopist, you can put the stent. And again, I would like to invite you all for the next year EndoCon under the banner of ISG. Thank you.
Dr. Puri, for that excellent presentation and identifying the role of EUS in this multidisciplinary approach in hilar blocks. Next, please.
Yeah, thank you, Rajesh. Beautiful talks, actually. Now, can I request the most accomplished radiologist, actually, Dr. Sanjay Baijal, to talk about the interventional radiology aspect in malignant hilar obstruction.
Good morning. I think aptly said in the previous presentations, we are the backup. So we always come in at the end. So, but let's talk our way through the topic of today, and that is malignant hilar block. So effectively it's 3A, 3B/4. Interestingly, there is some data which was published just barely about 20 months ago, and surprisingly, it didn't show anything else other than PTBD being the first line of therapy, though, like Rajesh said, there's a lot of work coming in. And that was basis these 4 studies that had been analyzed in this paper, and it's a mixed bag. The problem with all these studies is that somebody is using plastic stents, somebody is using metallic, somebody is using catheters for drainage, and therefore there's no true, accurate, absolute comparison of what is state-of-the-art endoscopic intervention versus current day IR strategies. But in all of these, effectively what they tried to summarize was that there is still an issue with endoscopic interventions when you're trying to intervene very high up in type 4 blocks. And therefore it was the same thing, so I'll skip these slides because they have been actually discussed. Just to show you a patient of a hilar cholangiocarcinoma, this patient had 3 isolated systems on the right side, and if you would like to just see the videos, coronal or axial, you would see that the left lobe is atrophic, many systems isolated there, and there are 3 systems on the right side which need to be individually intervened and drained. And effectively the PTBD technique allows you to selectively access each of those isolated systems, effortlessly go down. You can do a endobiliary RF as was done in this patient, and then the stents are deployed. And these days we don't actually keep catheters electively too long, and we just embolize the tracks and come out. The SGI published on what should be the standard of guidelines and standard of care for management of hilar blocks. And we looked at this, and recommendation 10 said that yes, with slightly weak evidence but strong agreement, they said that yes, endoscopic management is still difficult and requires expertise, which has been emphasized by the previous 2 speakers. We must be very clear as to what we are doing. Are we preparing these hilar blocks for surgery? Because there is still a role for surgery in hilar blocks. We don't write off anybody and everybody with a hilar block. We take a very close look, and if it is a pre-operative preparation, one has to be then selectively deciding what you really need to drain and what not. If it is palliation, then certainly the strategies that were discussed earlier absolutely apply, and all of us sit together and decide. The European Society also at the same point around 2017 reported again that for type 3 and type 4 strictures, they still prefer PTBD or a combination of PTBD and ERCP if required. I can skip this. These are the same things. Interestingly, here was a paper which applies to you all, and I'd value your opinion and the experts endoscopists, that this paper said that if the angle between the bile duct, and especially on the left side, is more than 103 degrees, it makes for a very difficult cannulation, especially when you're trying to deal at high level in the hilum. So probably maybe of some significance for all of you. It doesn't apply to us, just by the way. So another patient here again, you've got to absolutely understand and study the imaging. This patient had a 5 and 8 segment communicating, then there was a 6 and 7 communicating, and then there was another isolated 6. So if the intention is to drain the right, then we need to again select each of those ducts. So detailed study of the CT, and we certainly don't want to do the left because very often they are all atrophic and crowded ducts. Identify your ducts which have to be drained, again an access, an intraductal biopsy, which was just part of the procedure, but we continue in the same step, do the endobiliary RF as well, and then deploy the stents. So it goes through quite easily. Recommendation 13 from the same paper again said that if you're looking at endoscopic ultrasound assisted procedures, certainly with a very strong agreement, it seems to be an acceptable clinical success in patients with malignant block. Interestingly, the success was not so high when you look at papers, but obviously this was a paper in 2017. And like Rajesh said, it's last 5 years where the huge burst of data and skills have enhanced in endoscopic ultrasound assisted procedures. The mean patency rates in endoscopic biliary drainage were not very good, and that probably was the bane. And they said that it was worst in the type 4 blocks. Case 3, if you look, a large tumor based on the left, occupies virtually the left, isolates many systems of the right. The patient needs to go in for chemotherapy, and you've got a whole bunch of complex separations on the right side. That's the tumor. If you would just again see the video, if it runs, yes it does. The right anterior and the left segment 4 is virtually all consumed by the tumor, and you have multiple ducts isolated on the right side. So best and appropriately treated endoscopically, not treated endoscopically, sorry, and we head in percutaneous primary. We can't have too many stents going down, so we create a T formation inside. We reconstruct the secondary and tertiary level isolations and minimize the number of stents going down. So you would see a bunch of stents which are traveling from the right to the right inside itself, and then you take the T configuration, take them down, again exit with your catheters. And all of this is done in one session. We don't like to break it up unless the patient has very severe cholangitis, which was in this patient. In this patient, bilateral, multiple ducts isolated, a small atrophic, segment 2 and 4 combination, segment 3 was separate, and we had multiple isolations on the right. So we had to reconstruct rather. We had 2 T configurations structured inside the right lobe of liver, then those ducts coming down and communicating with the left, and we finally had only 2 stents going down, the previously deployed metallic stent which had been deployed endoscopically. So again, just saying the same thing that you need, if you're trying to go in with EUS, I think it's best done in high volume expert centers, because it can lead to trouble as well. Now this was a patient who had a type 2 at best. Some time ago, an endoscopic intervention was done, very elegantly a metallic stent was deployed. This patient comes back, the disease has progressed higher up. Now there are systems isolated on the right and left. The endoscopist decides that let's do a HGS, EUS assisted. They go in from the left side. They're not able to cross to the right side. They deploy the metallic stent on the left side. A hepaticogastrostomy is created. It looks very good. Unfortunately, the patient develops ascites on the next day. It's biliary peritonitis. We drain. Then as a salvage, we deploy 2 more metallic stents on the right side by draining the right. Unfortunately, clinical failure, patient dies, technical success. So at the end of it, what have we achieved? So we have to be very careful in our selections. We can't overemphasize the same thing. We have to strategize what is the best that could be done, minimize the number of interventions, evaluate the skills available all round, and take a sound decision for best patient outcomes. Thank you.
We had 3 very excellent talks. Thank you, Rajesh. Yeah, sit down. Now since it's a multidisciplinary meet and a challenging problem of a patient with malignant hilar block, I will ask any questions from the panelists or from the audience.
Very 3 good talks, but I think we should select our patients wisely. In the north of the country, you have carcinoma gallbladder, and that has a very bad prognosis. I think we should take our patients who are in need of them, like patients with cholangitis, and you can do the procedures, you can justify the procedures that patient needs chemotherapy, patient needs palliation. Only if the patient has itching and cholangitis, I think that needs drainage, especially in patients with type 4 blocks. I think all of us have burnt our hands in dealing with type 4 blocks. Type 1 and 2 is okay, good. You can almost in 100% you can palliate or put in a stent and do good to the patient. But in patients with type 3 and 4 blocks, I think you should be very, you should think twice before putting in stents, especially if the patient is asymptomatic.
Okay.
Very good talk. As Dr. Rajesh has highlighted, we should go maximum drainage, going from 33% to 50% to maximum. But when we see our IR guys, there are 3 stents, 4 stents, even in type 3A, 3B and 4B. Whether with IR we are doing over-stenting these patients, 3 stents, 4 stents going simultaneously. What is the optimal from the Dr. Bajal sir?
So what I would say is that we look at the anatomy, and the examples that I gave was trying to highlight the point that we stay away from the atrophic segments. We try to drain areas where there is significant good functioning liver volume. And there now, if you are partially draining within a segment or a lobe, there the risks of cholangitis in the undrained ducts would be higher. If you've left an entire lobe and you work on the other side, the attempt should be to try and achieve complete drainage of that lobe. And that should be the best. If that can't be done, then you should try to say that, okay, I'm going to select the posterior or the anterior. But we shouldn't be sort of select partial drainage, do one of the posterior ducts, one of the anterior ducts. And that's why I think better that that area is drained fully if it requires 2 or 3.
And part 2, what is the role of RFA by the IR guys? Because we people as an endoscopy use less of RFA. So what is the advantage of RFA in real world practice? Naive patients.
So see, our use of RFA is based on your data, absolutely. So it's not very different. The reason why we tilt towards using RFA more on individualized basis is because we know we don't have a second chance to go there. Once the reconstructions have happened and the T configurations are in place inside, it's impossible to get any ablative thing inside there. So we always talk about whether we should use very focused SBRT if required. Should we use brachytherapy endobiliary before RF or RF? But we try to do one of these once you're really putting in so much of an investment into a patient.
Thank you.
That's the last question.
Concept of RFA is with the cholangiocarcinoma increases the stent patency by 6 to 8 months. So we as an endoscopist also does, but we see less cholangiocarcinoma, and the probes are not there with as an endoscopist. IR people has a better reach and the probes are available with
Thank
them.
you.
One last question for Dr. Bajal and Dr. Rajesh. In the end, what is the median survival for type 3 and type 4 blocks that we are doing now? Have you really made a difference?
So what I would say is that I think, like Rohit said, it's the disease in the background. If it's a cholangiocarcinoma or if it's a CA gallbladder, I think the outcomes are so dramatically different.
My question is, what is the median or the mean survival? I mean, we are talking about a figure.
Right. So I don't think I have an exact number, but what I know is that the use of biliary drainage to allow for further treatments is what makes the difference. I don't think purely biliary drainage alone is going to enhance substantially the outcomes of improved survival.
Well, you make patient comfortable.
Yes, so quality of life, sir. Quality of life and improvement in outcomes if further treatments are possible. Those would make the difference.
So answer to Dr. A.S. Puri question is, first, as an oncologist, if they are sure that this patient can be given chemotherapy and immunotherapy, we are talking those subset of patients who are fit and able to take the chemotherapy and immunotherapy. In these patients, if you do a biliary drainage and these patients are subjected, then the average survival rate is 252 days.
Well, thank you very no, I think we have to stop because live demonstration have just started now. And this was an excellent session, 3 excellent speakers. And I think basically we have to think about the patient. Whoever can do the best job, that's why it's a multidisciplinary meet. Thank you.
Okay, now we are moving towards the live demo, and I invite the persons with healing hands and compassionate heart onto the stage. Chairpersons, Dr. Rajesh Dharamsi, welcome sir. Dr. V.K. Dikshit and Dr. Sanjay Kumar. I welcome you all on stage. And I invite the panelists, Dr. Sushant Sethi, Dr. Sanjay Bandopadhyay, Dr. Kapil Jamwal, Dr. Hemant K. Gupta, and Dr. Hemanta Nayak.
And we will start with live sessions in the morning. I'd like to request Dr. Shanky to present the first case that will go on to live. Dr. Shanky, please.
We'll start with our first live case demonstration. So the patient we have here is a 24-year-old female. She had vague epigastric pain for last 6 months. She did a screening ultrasound, which detected an incidental uncinate process mass around 15 to 10 mm. She underwent PET DOTA and it came out to be pancreatic NAT in the uncinate process. EUS FNA was done, suggestive of grade 2 PNAT with Ki67 index of 4 to 5%. So our plan is EUS guided RFA of the lesion. Back to room 2.
Yeah. Hello everyone. Good morning. Nice to meet you again. I'm Taejun Song. Today's case is a neuroendocrine tumor at the pancreas originate process. Please show the EUS. Okay. I already insert my scope to the duodenum D2. Oh, but yeah. And Dr. Sood already insert the pancreatic stent. Yeah, you can see the stent. Yeah, do you see the mass? The right side of the US image. Yeah, on Doppler image, yeah, you can see the hypervascular tumor, hypoechoic and well-defined mass. So for this region, I will do the RFA. And before the procedure, I will introduce the RFA electrode. Is USRA electrode is a kind of 19 gauge RF electrode. Is insulated metal shaft. And the tip of the electrode, just 1 centimeter, is not insulated. So that portion is the active electrode. And typically, inside the RF electrode, there is a circulation system. So this is water pump. Through the beer, the water pump, the chilled saline circulate the electrode. The circulation of chilled saline is very important. It prevents overheating of RF electrode, because the over than 100 degrees of Celsius is not optimal for the ablation. For ideal the ablation, the temperature is between 60 to 100. The circulating of chilled saline is very important role. So I will do the RFA for this mass. Yeah.
Professor Wrong, do you use contrast before RFA?
Usually contrast enhanced EUS after RFA. To confirm that there is a viable tumor after RFA, I will perform the contrast enhanced EUS with Sonadroid.
Do you put pancreatic stent in all cases?
Usually pancreatic stent is recommended, but the minimum distance from mass to the pancreatic duct is 4 millimeter. Less than 4 millimeter, P-duct stent is usually recommended to prevent the injury. Initially, I will control the, please, here, control this. Yeah, the low level. Oh, yeah. Yes. So, yeah.
So it's a 19 gauge needle with 1 centimeter tip for RFA, right?
Yeah, usually you use 1 centimeter. Initially, there are lots of, please, several, just 1 centimeter. Yeah. Okay. Yeah, okay. Initially, several kinds of rings, but in this case, 1 centimeter is safe for the RFA. And then we connect the chilled saline line and electrode. We use RF generator. RF generator can control the power of RFA and the time. So in this case, I will use.
So we are using a star-made generator. Yeah.
30 watts power. Yeah, Russell vessel.
Yeah. Is that vessel bothering?
Yeah. Yeah, to find out the best position.
We had one.
Shortening again. Yeah.
And this looks okay.
Yeah, that is here.
Yeah.
And the RFA needle is here.
Yes.
Do you see?
Yes. It's a big vessel.
Yeah, this
SMB
is
down.
yeah.
So we have a safe window.
Yeah, I think the long distance, so
Yes.
it's okay.
Which part of the tumor you want to target first?
Because the first part is right inferior portion, this area. Because after RFA, it make coagulation necrosis and white bubble. The white bubble interfere the next ablation.
Okay.
So the right distal portion is ideal for the first puncture.
Yeah.
Yes.
This is the needle.
Yeah, we are inside the tumor.
Yeah, inside the tumor. I think this is the tip of the needle and these active electrodes.
Yes.
So, yeah, start. Yeah. So I will start the RFA ablation. Yeah, start.
How many seconds you want to keep at one place?
Usually 10 seconds, and you can see the white bubble.
Yes.
Yeah. And until the white bubble is pop up over 10 seconds. You can see the ovulated area here, and in this position, slowly pull back the needle.
Same trajectory.
Yeah, same line. And repeat RFA again. Yeah, please start. Yeah, you can see the white bubble.
Echogenic cloud.
Yeah, echogenic bubble. It means coagulation necrosis and pop up. Yeah, it's okay. Yeah, you can see the cloudness of the mass. And then we puncture another point.
Another point.
Yeah.
Yeah. Got that. So there is a concept of slow cooking where you reduce the watt and cook for a longer period of time. Something
Excuse
called
me?
slow cooking where you reduce the wattage to prevent the injury and cook for a longer period of time.
Yes, yes.
Earlier they used to do with 50 watts, now they have come down to 30. Yeah,
But usually 30 watts power is needed to operate the tumor. So usually 30 watts to 50 watts is usually used. You can see the needle in another point, and please begin the RFA. Yeah. Do you see the bubble?
Echogenic cloud can be
Yeah, and pop up. Yes, okay. I think this area is enough.
Maybe one more area.
Yes, and
Yeah.
I will perform the one more area. Yeah. Yeah, puncture again the proximal portion.
Yes.
Yeah, I will perform RFA.
Yes.
Yeah, please start.
Do you also see the impedance?
Impedance is more than 100 and less than 500.
Okay.
Yeah, it's okay. Yeah.
We have ablated around 75%.
Yes. And one more, please. Yeah. Yeah. Yeah, stop, please.
Nice.
Yeah, okay.
Majority of the area is covered, I think.
Yes.
What is your target? I mean, you have to ablate 100% or say, any target?
Excuse me?
So they are asking, what's your end point? You want to 100% ablate in first sitting?
Usually the purpose is 100%, fully covered by white bubble. But in the large tumor, multiple session is needed. Especially more than 2 centimeters, we need 2 or 3 sessions. And I think in this patient, about 80% is ovulated.
And there's some immunogenic effect also, some delayed effect also. So even if a smaller area is done, it causes necrosis of the surrounding area.
Right.
So you need not endoscopically ablate the 100% area.
Yeah. Oh, yes, this is.
How do you look for the completeness of the procedure? That means everything has been done.
So they're asking, how do you want know the completeness, like it's completely ablated?
To confirm the complete ovulation, we use contrast enhanced EUS after RFA.
You do in the same sitting, or you call the patient after 1 week to do a contrast?
Usually, because of heat injury, we wait about from 3 days to a week, after stabilization. Because now the tissue is not ablated, but heat injury. Yeah, you also get the heat injury by tissue.
Yes.
So we wait several days the further stabilization of the mass.
And then we do contrast.
Yeah. And we do the contrast in SEUS. If there is a viable tumor, we repeat
in the same
again.
setting,
Yes, yes.
Professor Song, this is Dr. Prasad.
Yeah.
Are there any head-to-head trials comparing the EUS RFA versus surgery? A completeness of eradication of the tumor.
So they are asking any head-to-head trial or RCT comparing surgery versus RFA in less than 2 centimeter entities.
No RCT now. We report our initial result for the neuroendocrine tumor and solid pseudopapillary neoplasm. In the study, we get the complete resolution is 8% or 80% of the tumor is less than 2 centimeter, and so it may be a good option for the small neuroendocrine tumor or other benign solid tumor, but the high risk of surgery or repeat surgery, and is a less invasive technique, relatively safe.
Professor, do you use for cystic neoplasm also?
Yeah, cystic neoplasm, because in case of IPMN and oligolocular or unilocular cyst, we don't need more evidence.
Okay.
In our hospital, we usually perform the Hughes, the microcystic, the SEN, the with symptom. Some SEN Hughes mass, there is a honeycomb appearance.
Yes, solid forming.
Yeah, it causes recurrent pancreatitis or pancreas atrophy or pains. In that case, we tried several cases, but in the cystic region, the complete resolution rate is very low.
Yes, 50%.
Usually, yeah, partial response.
50%.
Yes.
In such a case, would there be a need to repeat Dotanox scan after some time to see the adequacy?
Do you mean the duodenal stent?
No, they are asking, do you need to repeat a DOTA scan, gallium DOTA scan? I don't think that is required in this case because
it's not required.
We select these patients who are non-metastatic, localized disease, less than 2 centimeter, well differentiated, and then we follow up with contrast US.
What is the role of elastography in this patient? Is it useful before and after the ablation? Elastography, will it help?
They're asking any role of elastography after ablation.
We don't usually do the elastography because the stiffness, the hardness of the mass, I think do not change so much. So contrast in SEUS is the best option.
There will be fibrosis as well, so elastography may be false in this case.
Yeah, right.
Thank you, Dr. Song, Dr. Nikhil.
Can you put Doppler?
Shift to
We want to see the tumor vessels, what happened to tumor vessels. Can you put Doppler on that lesion?
They want to see the Doppler if it has come down. So,
yes. Yeah.
Some decrease in the Doppler uptake.
Yeah, there is no blood flow in the ovulated area.
Yes,
Near the mass, there is some Doppler, but in the mass, there is no Doppler flow. I think most of the tumor is ovulated.
Excellent demonstration.
Yes, that's nice.
Thank you.
Thank you.
Thank you so much. I'd like to shift to the next room. Dr. Shanky, can you please tell the history for room 1?
Sure, sir. So we'll be switching to our next case. She's a 52-year-old female having symptoms of acid reflux and heartburn for last 5 years. And now she has developed dysphagia, which is progressive for last 6 months. An endoscopy was done, which revealed a small hiatus hernia and a diverticulum of 4 into 5 centimeters. She underwent manometry that was within normal limits. So our plan would be D point, diverticular point.
Sir, you are online in room 1.
Are you audible?
Hello, can you see us? And are we audible?
Yes, very well, Amol.
Okay. So good morning, everybody, and thank you, Dr. Sood and Sukrit and the entire team at Medanta for this fantastic gathering and workshop. And this is a very interesting case. I've already put the scope inside because I wanted to have a look after listening to the history. So can you just hold it for a moment? I'll just show. So this is the LES over here. The LES is at around 37 centimeters. And as I pull back, about 3 centimeters proximal to that, there is a diverticulum over here. Not a very deep diverticulum, but still a relatively, large diverticulum. And there was some residue over here when I put the scope inside. And you have to trust me on that. I'm not lying about that, so which I had to clean up. So, and this is the septum. The other thing is, when I pull the scope back into the esophagus, there is a little bit of tortuosity of the esophagus that I can see, at least in the distal part over here. So I do believe this patient has some kind of a motility disorder, and that has led to this kind of this diverticulum over here. So the idea would be that we will divide the septum and we will start a little bit proximal to that. I don't want to do too long a myotomy because the body motility is normal. And what we will do is we will extend the myotomy up to the LES. We will probably divide a part of the LES, but we will not go too much distal into the stomach because the LES is quite open, as you can see over here. So we don't want to do that because otherwise patient can land up with reflux. That is the main thing. So
Amol,
that is a plan.
Amol, do you think that this diverticulum is responsible for dysphagia?
I would say more of regurgitation. I'm not very sure.
Because they said that patient has dysphagia.
No, that is it.
Yeah.
But I definitely do feel that this patient may had also symptoms of regurgitation, and there was some food residue in the diverticulum which I could see when I put the scope inside. So that indicates that yes, probably some food is staying there and then causing some difficulty when you are this thing. So for this, I'm going to use, I'm using the Olympus X1 system, but I'm going to be using the speedboat device. This is a new device. I don't know how many of you all are familiar with this device. So this is one of the only devices which has the capability of bipolar cutting, because as we know, most of our regular devices and knives are monopolar, which means that when we are cutting, the electrode is the active electrode, but the return electrode is the patient plate. But this is the device, and this is called the speedboat. It comes from Creo Medical, and they've got their own generator over there. You can just focus on that.
So what advantage you have, sir? Dr. Amol?
Yeah.
So what advantage you have with this bipolar as compared to the monopolar?
Right. So I will just show you that. So this device is shaped like the hull of a boat. Can you see over here? Can you focus and zoom in on this?
Yeah.
Because I am just showing you things. So the under surface of this is completely insulated. And the tip of this, the C shape over here, is the cutting edge. And there are 2 sets of electrodes on that, and the current passes only between those 2 sets of electrodes. So it is a very safe current, and it uses less energy as compared to the monopolar current as well. The other advantage of this is that we are using a microwave technology for the coagulation purpose. Microwave also is a different kind of an energy as compared to the regular electrosurgical energy. And that causes, there also we require less energy. And the main advantage is that there is no charring when you are doing the dissection, and you will see that. The second thing is, because the undersurface is completely insulated, it protects. Because in the diverticulum, sometimes we have to dissect on both sides of the septum. And at that point in time, there is a risk of mucosal injury. So here we can rotate this device and we can create a good thing. And the device also has a needle, inbuilt needle in that. Here, show me the needle out. So you can see over here that the needle comes out. It's a little bit longer than what I would like, but still you can inject, and so it is a single device which can do everything. So you don't need to keep changing devices. for injection, dissection and coagulation. So needle back, yeah. And the way this is controlled is that your assistant has to be familiar with this, that we have to rotate the device and accordingly we have to do the dissection. So we will start the procedure, we will just make an injection. Now let me see. This is the septum and there is a little bit of a curve over here. So I am going to start just behind this curve and I am going to make an injection over here and then make an entry and then we will start off giving the needle out. Okay, start injecting and okay, that is good. And our 10 cc. Okay. So your first injection is always the best injection. Now one of the downsides of this device, let me tell you, is that we have to use a large channel, therapeutic channel scope because the device diameter is 3.2 millimeters, so you can't use a regular gastroscope, needle back. And that is one of the downsides, but I believe the company is coming out with a slimmer device, which can be, yeah, a 2.8 millimeter device. Okay, so left, right up, karo, pura.
And they might sacrifice the needle in that device.
Yes, that is the main thing. So, but they've got a flushing pump which actually does that. Pura vertical kar do. We have to take a mucosal incision.
Earlier, I think before middle of this year, we only had the 3.7,
Yeah.
which was even bulkier and sometimes this
Yes.
is much better though.
This is much better. This is much more flexible. So now what I'm going to do is I'm going to make the mucosal incision. Now you can see that I'm making the mucosal incision using this. And then okay, so we are a little bit superficial. We need to do a little bit more. So one of the thing is that this cuts just forward view, but you can't hook. So when you are used to the hooking, this thing of the PT knife or the hybrid knife, this you have to relearn a few techniques when you are using this device. But you can see that there is hardly any charring over here, no charring, and it cuts very clean.
These are pre-blended currents also. There is
Yes.
no changing the currents on the generator.
Right. So now here I am going to be using this fashion.
The tip of the device.
Yeah. Yeah. Right up, thoda. Right up, right up, right up.
I think in the beginning we would be very afraid of how much knife to keep out. But actually
Yeah.
the true cutting area is not that big.
Right up, cutting. Right up, right up. Hey, sorry, left up, left up.
This coordination between technician
Yeah,
and
this
doctor.
coordination is very important because otherwise, नहीं इतना है अपने को you have to cut on the right side. So थोड़ा सा right up करो अभी, yeah, right, yeah, right is good. बस ज़्यादा नहीं.
But collateral damage to the muscle is much lesser. because
Yeah, no, the device definitely has its advantages. Now that is a bleeding point. So let's see. We will use the microwave. You have to really press hard. And this is the microwave coagulation that we are using.
Takes around 6 to 8 seconds. actually
Yeah,
to take in.
it takes about a few seconds, but you have to maintain the.
But one advantage is the tamponade with the bigger device.
Yeah. And you can see that there is no charring whatsoever. That is the beauty of this. Left up.
can see how it's going layer by layer.
Trimming at the apex.
Yeah. Creating a ledge over here and undermining the edges so that we are creating right up. Okay, enough. इतना भी नहीं, थोड़ा सा एकदम पूरा vertical मत करो. देखो horizontal कट करना है ना. देखो horizontal ही करना.
Amol, for
yes,
this is Dr. Pankaj here. For injecting, you have to take out the needle, or you can inject with the needle back in the tunnel also.
You can also, once you are inside the tunnel, you can inject with the needle inside also. Although it is more like a flushing pump, that it acts like a flushing pump. But it is enough inside the tunnel. Just now I might have to bring the needle out. Right. Right. Yeah.
You have attached the flushing pump to the needle or hand injection?
Hand injection.
As some practitioners, you directly inject mixing glue and saline through the flushing pump itself.
Right.
So like Dr. Kasab, he does not use a needle or injector.
Yeah. So that technique is quite good. Only thing is in fibrosis, I don't. Moin does claim that it works even in fibrosis, but I have found that in fibrosis you have to sometimes use a sharper injection. That is what is left up.
Amol sir, if you allow me for a minute to start a parallel room, I'll come back to you.
What we will do is make an entry, and then when we come to the diverticulum, we can show you the septum once you've done the dissection.
Thank you, sir. Thank you, sir.
Yeah.
So, Dr. Shanky, can you please tell the history for the next case?
Sure, sir. So the next case we're taking is a 51-year-old male who's a known case of chronic ulcerative pancreatitis. Now has persistent pain in abdomen despite inadequate therapy, medical therapy for last 1 month. So cross-sectional imaging detected multiple PD stones with the largest at the genu region. So the patient underwent 2 sessions of ESWL. So now our plan is ERCP with PD clearance. Back to room 3.
Sir, you are live. Can you hear me? Hello?
Yes, yes,
Am
we
I
can hear
audible
you.
in the hall?
Yes, yes, very well.
Yeah, good morning. I think we have a young patient who is a case of chronic pancreatitis. Chronic calcific pancreatitis has a calcification present both in the main duct as well as side branches. He has, I believe, undergone the ESWL yesterday. I don't know the details, but generally we will take 3000 shocks till we reduce the density of the calculi to less than 3 millimeter in diameter. Here you can see I'm standing in front of a papilla. Here we'll try to cannulate the papilla, and we will not try to bow our thing and try to go to the left side of the papilla to have a pancreatic duct cannulation. Can I have a guide wire, please? Can you show us where we are? We have entered into the pancreatic duct here. We will try to go deeper into the main pancreatic duct. Can we have a reduction and try to go into the MPD? We can see some of the calculi there. They are still slightly higher than 5 millimeter in size. Hopefully the fragmentation would be present for us to extract it completely. Yeah. Yes, yes, push.
Already you can see the stone particle.
Yeah, you can see the fragments of the stone particle already coming out here. We'll try to go a little bit more in. As you can see, I have a really very good assistant who can swiftly push me into the the main pancreatic duct, and you can see the stones which are probably far more fragmented. I don't think we really need a pancreatogram here because we have a radio-opaque calculi, but for the sake of anatomical achievements, we will take a pancreatogram and check it up. Then we do a EPT to increase the size and see how much pancreatic duct stones we can completely clear. While the dominant stone load is in the main pancreatic duct, there are few stones in the side branches. You can see the dilated pancreatic duct now and the pancreatic duct in the head and the body completely filled with calculi. Can we see the multiple calculi in the pancreatic duct?
Yeah.
And with this, we will try to now do a EPT, use a balloon to extract these stones. These are soft calculi. Quiet. We are now in the main pancreatic duct. You can see there are mobile calculi. The ESWL seems to be quite effective in this case.
Sir, what is your practice, normal practice, day-to-day practice? Like, when do you consider for pancreatic ERCPs and when do you refer the patient for surgery?
Okay. When pancreatic stone load is predominantly in the head and the body, only then I will consider. If it is diffusely distributed in the pancreatic head, body and tail, then probably I wouldn't take the patient for an ERCP. Also, the need is if the stones are less than cumulative diameter of 3 centimeter, 3 to 5 centimeter, then I will consider them. If the cumulative stone load is beyond 5 centimeter, then I will prefer the surgery. Another thing which I take into consideration is the stone density. If I have a CT scan which shows the stone density to be more than 820 Hounsfield unit, then the ESWL possibly will be less successful in these circumstances. So I will be more cautious using the ESWL and ERCP technique for stone extraction. Also, if there are complications like multiple strictures in the main pancreatic duct and the stone proximal to the strictures, then while it is possible to extract, it is difficult in that situation. Also, if there are associated fluid collections or pancreatic duct obstruction, I'll be extremely cautious to take these patients for the ESWL and thing. Isolated stone load in the tail also is a problem because you may have an inadvertent splenic injury in these situations. So keeping this in mind, the stone load predominantly in the head and the body, preferably less than 5 centimeter cumulative stone load, and an uncomplicated chronic pancreatitis will be my indications. No, sphincterotomy and then sphincteroplasty. Can we bow a little bit?
Function.
So both the procedure you can take at the same time?
Yeah, I will now be taking the balloon, and with the diameter of around 6 millimeter of a sphincteroplasty balloon here will help me not to do any significant risk of perforation with the 8 millimeter duct approximately here. It is approximately half the size of the scope, so around 7 to 8 millimeter, and 6 millimeter will be an optimum size for my sphincteroplasty here.
Sir, can you tell us the pancreatic sphincterotomy, what are the techniques? How it is different from biliary sphincterotomy?
Sphincterotomy or plasty?
the technique of sphincterotomy or plasty?
Both.
Okay. As you can see that I have kept myself at about 1 o'clock position in this. I have done a sufficient sphincterotomy to get the initial mucosa away, but I have not gone full length here. The sphincteroplasty will give me an access to the inner muscle layer, which I'll have to cut carefully if I do only sphincterotomy. So sphincteroplasty helps me in making sure that I have a complete avulsion of the papillary muscles as against the mucosal dominant cut if I take only sphincterotomy, unless and until I am very careful to cut the inner muscles very safely. And hence a combination of sphincterotomy and sphincteroplasty is easier and safer. The diameter of sphincteroplasty balloon normally I will consider with the lowest diameter of the pancreatic duct or the bile duct, and it should be approximately a size below the diameter of the duct. Here, can we inflate it?
What is the length of this balloon?
Pardon?
What is the length of balloon?
4 centimeter is the length of the balloon. We can go to the maximum here. What we do is we keep the proximal edge of the sphincteroplasty always under the vision, so that when there is a avulsion of the muscle, it should not be done without vision being there. So it should always be kept there. With the maximum inflation, we will deflate it now gradually.
For how long do you keep it inflated?
I would prefer to actually give a contrast and see the waste disappearance without any time consideration. But in case if we want to reuse the balloon and we are not putting the contrast, then for about 30 seconds is what the time I will leave it for. You can see the free flow of the pancreatic juice and the fragments of the stones already coming out. And we will take a small balloon, small diameter balloon here to gradually take the stones out, as many as possible.
Is that the biliary extraction balloon or something else?
Biliary.
It is a biliary balloon. Okay.
You can use basket also, pancreatic extraction.
Yes, you have a smaller baskets available. You can use the pancreatic baskets also. You have to be very careful while using balloons because the characteristics of the pancreatic stones are slightly different from the bile duct stones. There are spikes on the surface and can lead to higher chances of balloon rupture. So in that scenario, probably a basket will be useful, but the diameter of the basket is usually small when we are looking at the pancreatic duct clearance. Okay. Just inflate partially.
And the sphincteroplasty is adequate.
Yeah.
The stone is
Easily.
balloon is coming out freely.
Inflate partially again.
Do you take the initial stones first and then to prevent that jamming?
We can see the stones coming out. We are gradually going from below upwards to see whether the maximum clearance can be achieved. Partial inflation once again. You can see the fragments of the stones
We can
slowly
see.
coming out
Yeah,
here.
yeah, we can see the stones coming.
And the ductal clearance getting gradual.
Sir, if you just allow us, we will just shift for a brief time to the poem room. We will come back, sir, as you finish the case.
Sure.
Thank you, sir. Room 1, Amol sir, you are back live.
So we've gone into the tunnel, you can see that, and we are dissecting a little bit over here. As anticipated, there is quite a bit of fibrosis in the diverticulum region. And the other thing is, We are just trying to identify the septum, fibrosis and a little bit of vascularity over here. So we're just trying to identify that.
Is there a mucosal, Amol?
Yeah.
Is there a mucosal breach there? At
Yes, there
11
is
o'clock?
probably a mucosal breach there. We will handle it in a moment. Possibly a mucosal breach. I have not checked it from outside, but possibly yes. But we will tackle it at the appropriate time. So that's the septum opening up now. Yeah. Now at this point, what we can do is we can inject here and then we'll turn the speedboat around so that the cutting edge is onto the septal side, so that then we don't increase the mucosal breach. I will definitely close it. Needle. Yeah.
And the fraction also makes it bigger.
Yeah. Okay, wait a minute. Yeah, start injecting.
They show the needle sometimes seems too big. It goes
This needle is a little bit long, too long. Okay, wait a minute. Just keep the needle out. Keep injecting.
Amol, you will actually deal with the mucosal breach first, or you continue with the dissection?
I will probably, see it is, now I have separated it out. There is a small breach over there. So now if there is not much of traction on it, I might just, wait for a while, because that area is going to become narrow once I put a clip. So that is another thing that you have to be careful about. Turn the speedboat around.
Possibly closing it down will be less likely to get a good grip as well. We'll be
I'll open it.
worried that we might touch the muscle underneath.
Yes. Pura.
Full
Pura
rotate.
Or full rotate.
Rotate in flat on the muscle.
Flat on the muscle. Insulated part is towards the mucosa. So I'm going to be.
Now because muscle we are anyhow going to cut. So
Muscle anyways we are going to be cutting. So there is no big deal about that. I mean, just write down.
Slightly more right down.
Yeah, that's better.
Amol sir, we'll just come back to you in a minute. We'll go back to the ERCP room.
Okay.
Live in room 3, please.
Concept that North India doesn't have it. We have a lot of such treatment.
No, but you are doing a good job. I'm really impressed with the way the lithotripsy has been done in this. It's virtually powder.
Yeah.
We have a lot of cases.
Sir, we are live in room 3, sir, ERCP.
But we dedicated, kept the penicillology to Dr. Mishra, so he takes care
Dr.
of that.
Wadhwa sir, we are live in your case.
Okay. Anyway, we have achieved a near total duct clearance. We hope that we will be taking a pancreatogram once again and then putting a stent. I am taking my basket again because we, after clearing with balloon, we wanted to go right in the tail of the pancreas and see if there are any stones remaining in the tail of the pancreas. You can see a lot of these stones have already come out, if you can see in the duodenum. We are across the spine now while opening the basket. Open it.
Doing a pancreatogram.
Raju,
We are now checking with the pancreatogram. You can see the stone density has dramatically reduced as compared to the initial pancreatogram. We'll see whatever remaining, if we can take out all the remaining stones and put a stent across. Open the basket, please.
normally what you get is multiple stones with strictures, and in this case, you had multiple stones but there are hardly any stricture. So it was an easier case, but if there are strictures, then what is your strategy to do?
We will have to powder it completely First and second is we will have to do an initial stricture dilatation. Multiple strictures are contraindication. A single or a couple of strictures can be dilated in these situations. That's what I said. An uncomplicated chronic pancreatitis, especially a stricturous chronic pancreatitis, or those with the fluid collections inside, those with the CVD obstruction will pose the problems when we are doing these kind of ERCP.
Right, that you put in a stent first and then do next time.
Yeah, and in this situation, what now we will do is we will put the stent since you know, at least 70 to 80% of the stone load has been cleared. The remaining fragments with the sphincteroplasty quite often will come out on its own, or at the time of stent removal, maybe we can clear the rest of the stone load. We don't need to do any extra procedure to do that. We will be taking a 7 French stent since the duct is grossly dilated, and we will be putting it to the length of about 7 to 9 centimeters so as to provide the stability in these circumstances.
Vadva sir, if you allow, we'll go back to Dr. Amol for a bit.
Just give me a minute, I will place the stent.
Okay.
We'll close the case itself.
Okay, sir. Okay.
Did you use a balloon or only basket? Both.
Both. We used both. Initially balloon, and later on when the stone size became bigger, basket, because the balloon, you know, ruptures when we use it for a larger stone because of the spikes on the surface of the stone. These are unlike biliary stones, and they are very sharp.
Raju Pankaj here. Are you putting a straight stent or a pigtail?
Ideally, I should be putting a pigtail. I am not a friend of a straight stent, but here they have given me a straight stent. I use a single pigtail stent in these situations.
Yeah, because a lot of high chance of migration inside.
The risk of migration of a single pigtail stent is significantly lower than the Amsterdam type of stent in these situations. We have placed the stent, as you can see now, with a stent in draining almost the entire pancreatic duct, and the large fragments of the stones removed. We leave the patient like this for about 4 to 6 weeks with the stent removal. After that, clearing if there are any residual fragments of the stone in the main pancreatic duct.
Thank you, sir. We'll shift to Dr. Amol now. Thank you so much.
Excellent, Dr. Vadva. You can hear the clap.
Thank you so much. Thank you.
We are going back in room 1 with Dr. Amol, sir. Amol, sir, we are live.
Hi there. So, in the meantime, the needle got blocked of the device, so we just changed to a regular needle. And at that point in time, we also came out and we checked for the mucosal, area, this area which we thought was the mucosal tear. But it is not a mucosal tear, it is adventitial. And you can see actually the peritoneal cavity outside over there, or the mediastinum. So we are at around that. So, and we checked outside, there is no mucosal injury at all. So nothing to worry. I think we are quite safe regarding that. Inject karo.
You can see the septum being exposed now. This is the septal fiber.
Yes.
Inject
करते रहो. थोड़ा सा 10 cc करते रहो कि वो rapidly जाता है.
So using a separate needle to inject.
Yeah. Okay. Enough. Back. Give me the speed board. So these are the septal fibers which are becoming evident now. And what we can do over here is we can start dividing the septum as we progress ahead also. That makes the procedure a little bit faster, because otherwise dissecting it becomes a little bit difficult and it can become time consuming. So as we dissect, we will also divide the septum partly and then we'll this thing. Come on. Hold up. घुमा दो ऐसा और पूरा घुमा, यहाँ से घुमाना, यहाँ से घुमा, पूरा घुमा. हाँ, नीडल साइड ऊपर चाहिए, घुमा दो और पैरेलल टू द सब. ये
You have an option to start a myotomy simultaneously sometimes. Gives us more.
So what I'm going to do is I'm going to divide this and I'm going to do a myotomy over here. थोड़ा सा राइट अप कर दो. Yeah, this is okay.
Sometimes when the muscle is same, there can be zipper-like effect.
Yes.
It's always better to divide the septum under vision, because sometimes we take try to take too big a chunk of the muscle.
No, and then it can bleed also, and sometimes you don't get any effect on it. That also happens.
Now that
I want to proceed a bit more.
Yeah, I want to do a little bit more over here. With the needle.
You should be careful when you see this happening, waddling of the mucosa and submucosa.
Yeah, because
injuries can happen at this side.
needle out. Needle out नहीं आ रहा. So this portion we have to rotate मत करो. इनको ऊपर ही needle. So what I'm going to do is, I'm going to separate this mucosa a little bit from the muscle layer, because otherwise that indentation will not go from the outside. So I'm going to straighten it out and dissect in the submucosa over here. And then if needed, extend the myotomy a little bit deeper down. Inject here. Inject here. Okay. Wait a minute. इधर थोड़ा इंजेक्ट करना है. Inject here.
So again, like the unilateral Venker OS that we do now, we only dissect on one side. Would you like to take the same technique here?
Yeah, I mean, see, we have actually divided on one side only. And what we have done is, now this muscle has to be divided further, probably. That is what is going to be needed. But we will first have to separate the mucosa. Without that, it will become difficult.
Amol Mohan Prasad here. When do you say that this septotomy is enough, or should you cut more?
Okay, so now typically most of the diverticuli that we see are associated with an achalasia. So there you take the diverticulum as part of the myotomy that you are doing for achalasia. But in this situation, I would be a little bit more careful, because I don't want to go too deep into the G junction. But at the same time, I do feel that given the fact that there is a little bit of tortuosity and also the fact that there is a diverticulum with hold up, थोड़ा सा right up कर दो. The myotomy should extend at least up to the G junction, if not beyond. That I do feel. Meaning anybody in the hall probably has a different opinion. Maybe Pankaj, I don't know whether Mohan is there. Rajesh, I think, Sukrit, what do you think?
So most of the time these are associated with major disorders of motility. Dyslexia or spastic disorders, and we eventually have to do some bit of esophageal myotomy.
Impulsion.
However, we were told that this case has a normal
manometry. But even endoscopically, we felt that there was some resistance at the LES. But we have to go by the manometry. But to prevent a blowout also, we would rather err on the side of cutting a little bit of the lower esophageal sphincter than to leave it completely intact.
Now, this is the place where you can see that the feedwort is really making a difference, because, you know, you can dissect so close to the mucosa and still be so safe.
Yeah, now we're getting more space. But a CT chest should always be done along with a manometry for these patients, with tuberculosis being so prevalent in our country, traction diverticuli.
Yeah. There could be a lymph node outside which is actually
Pulling
pulling away, and then.
Also, if you allow me to shift for a moment, is it okay?
No problem.
Thank you, sir. Thank you, sir. So, Dr. Shanky, can you please tell the history for the next case?
Sure, sir. So the next case, we have a 30-year-old male who has a PPI refractory GERD. On endoscopy, he has a small hiatus hernia and a Lex LES, that is Hills grade 3, with pretty high Demister score of 35. So plan would be GERD-X application. Back to room 2.
So, we are live in room 2, Rakesh, sir.
Okay, hello, good morning everyone.
Good morning.
We are now here to demonstrate the GERD-X, the endoscopic fundoplication. I have Dr. Yogesh with me, who is going to be with me as a third eye for me. And the patient is being intubated and in supine position. Dr. Deepthi and her team has done the good job. So now before starting the procedure, I'll explain you how the device looks externally. So this is how the GERD-X device looks. It's got a handle with a joystick kind of thing and a distal tip which has got a shaft of 16 to 17 mm. And there are a couple of components one has to understand before you start the procedure. As you see the proximal end of the device, you have two handles and a lever which is used to press and open. Then you have the helix which comes out through this right side channel, and on the left side you have a channel through which you can pass in the ultra slim scope or the pediatric scope. If you see the distal end of the device, let me open and show you. These two are the prongs on which the sutures are mounted upon, and as you see here, I go to the close mode. You can focus them on my hands, and now the device gets closed. The plate jets will be closed and opposed. So this is how the device looks externally, and what we are going to do now is show the first step when it starts. Rajesh, can you just hold on this? Okay, so as you have seen here, can you focus them on the patient's mouth? So this is a metallic guide wire, just like a Savary-Gillard guide wire used for dilatation. It comes inbuilt within the device. So what I have done before I came onto the screen is I have put in a routine upper GI scope and pushed this metallic guide wire beyond the pyloric area and then left there. So now what I am going to do is mount this GERD-X device on the metallic guide wire. As you see here, the distal end has got two plicators which have opposed both of them, and there is a hole here through which you negotiate the guide wire. You can show them my hand movements. You don't have to show our faces. And as you see, this device, the guide wire is passed on to the device. It has got one groove here, and then it will go into the device. So now I'll slowly railroad the GERD-X device onto this metallic guide wire till the distal tip of the GERD-X device comes on till the patient's oral cavity. As you see here, concentrate on my hand movements. Now I'll hold the device with the left hand, with my left hand at the handle here, and then this will be perpendicular to the ground. Can I have some silicone gel? No, not this one. Yeah, okay. So I'm going to lubricate the distal end of the device for a smooth entry by putting in a silicone device. Now with this position, I'm going to intubate. Can you lift the chin like this? Yes. Okay. If they can show a glimpse of the fluoro to see how it is being negotiated. Can we have a fluoro, please? Okay. Show the proximal end, towards the throat. Okay. Yeah. Just tuck the chin, lift it. Yes. Okay. Yeah. Can you show them the fluoro, please? The tip of the device. Okay. Can you appreciate there? it's going down, and once it goes up to the gastric shadow, then I'll stop there and take out the guide wire. Can you take out the guide wire? Oops. So the guide wire is being taken out. Can you adjust the mic, please?
Please adjust the mic.
Do you have to dilate before you put? This is
No, not required, not required. So this is a 16 to 17 mm shaft, so you don't really need to dilate any time. And now what Yogesh is doing is he has lubricated the endoscopic channel, and we are going to tie a BP cuff, sphygmomanometer cuff, to inflate the stomach cavity, the gastric cavity, okay? So you can come this side, you can hold this, and Yogesh can get the scope, take the scope and then pass it. So Yogesh is now taken a pediatric slim scope which he will pass through the, yeah. So can you show them the endoscopy screen? So the pediatric slim scope is being passed. Can I adjust my mic, please? No, this part, this is hanging. Yeah, okay. Okay, go in, go in. Go in. Yogesh, you should show me the distal end of tip of the device.
Give me a button.
Cap, cap. Yeah, you can push it. Push it down. Push it down. Push it. Yeah, push it down. Go beyond the...
Yes, yes. I need that.
Can you screen once, fluoro? Yeah. You need a cap?
Yes.
Yeah. Can somebody give a cap, scope cap, channel cap?
In between, I invite Dr. Shrikant Mukhevar, chairperson on stage,
Yeah.
please.
Okay, so Yogesh, can you just push it down?
Welcome, sir.
Yeah, you can inflate. 1 second, 1 second. Screen, screen.
And Dr. Devendra Singh
just
and
see the
Mayank Kabrawala
Scope should be
as the
straight,
panelist.
neutral. Okay, perfect, perfect, perfect. Okay, so now can you inflate? Okay, so let me go down, and Yogesh, can you just push the scope a little bit more down? Okay. I want the distal tip of the device, to be shown to them. Yeah, okay, okay, perfect. So let me retroflex along with me. You also retroflex. Okay? Okay, got it? Yeah. So now you just have to turn to the other side. Okay. So now what I'm going to do is open the device, open these flanks. Can you push it down a little bit? Push it down, push it. No, push it, push the scope down, down. Okay, so that they can appreciate better here. So what I'm going to do now is pull the helix out so that I can grab the tissue. Okay, just turn, let them see the helix, how it is comes out. Yeah, now you can see the helix. So I'm going to rotate clockwise 3-4 rotations and get the tissue inside. Can you lock the helix, Rajesh? Okay, yeah, so now once the helix is locked, I am going to position myself and then get a comfortable position where I will adjust in such a position. And can you deflate, Yogesh, so that I'll get good amount of tissue. Can you push it a little bit down? Your scope down. Okay. Yeah. Inflate, inflate, inflate.
Inflate.
Inflate, inflate. Inflate. Okay. Keep inflating. Okay. Okay. Now I got the mucosa inside the two flanks. So with this, now I'm going to can you put, show them the device? So I've gone to the fire mode, and as you see here, I'm going to press twice the lever. Once the lever is pressed twice, it automatically becomes tight. That means that the plication has been done and the sutures are deployed. Now once that is done, I'll go back to the open end and then loosen the helix, unheal the helix, take it inside, enough. No, lock it, lock it. And once it is locked, then I'll open the claws and gently push down. So you see the first suture has been deployed. Can you deflate. And under guidance, I am going to close and make the device along with the scope neutral. Fluoro, please. Fluoro. Yeah. And take the device out. Now I have to reload the plicators. Can you take the scope also out? Just scope out. Okay. The first plicator has been put. Now I'll reload and come back for deploying the second plicator. Can you reload? Okay. So with the same scope, I'll go in and then mount the guide wire which you haven't seen in the last step. Any questions from the floor? We'll be happy to answer.
So you have to do the entire thing again. Again, take the scope down, put the wire.
Yes.
How many stitches you take normally?
By and large, because the standard criteria is Hills grade 1 and 2, we usually maximum 2 plicators is what we use many of the times. Because if we are not going to take a Hills grade 3 or grade 4. So 2 plicators most of the time suffice. If it is Hills grade 3, then probably you might require 3 plicators.
Right.
So now I am putting in the guide wire again and then pulling back the scope, and on this guide wire again I will mount. Okay.
Rakesh sir, please give us some 1 minute. We have to go to Dr. Amol sir's room for a important step.
Yeah. In the meantime, I'll put the device ready and.
Thank you, sir. Thank you, sir. Amol sir, we are back with you.
Okay. So we finished the dissection and we've completed the myotomy. I just want to show you from outside first in the lumen. So you see that the ridge which was very prominent over here is now flattened out, and we can go into the G junction, and we have extended. So the injection is still here. We've probably gone just up to the G junction. I will show you that from inside. But this part is there. And as you can see, there is no mucosal injury on this side at all, on the mucosal aspect at all. And now let me go inside. So this is how the tunnel looks. This is the entry of the tunnel. And this is where the diverticulum started. So we started our myotomy over here, and we have completed the myotomy. This side is the mediastinum that has been opened up a little bit. You can see over here, and the myotomy has extended right till the distal end over here. So that I believe is enough. I think Gaurav is also here with me, and we've been discussing how long to go ahead. And it's always a catch-22 situation. You're never sure how long to go in, but since this patient has a normal motility, we don't want to overdo things, and I think this is enough. What do you think?
Yeah, so we've hit one.
I will also take your comments about this.
Yeah. So we've hit a landmark. We can see the diaphragmatic crura on the right.
Yes.
So that's suggestive we've gone close to the LES, and we don't want to go more deep inside. So more of a mediastinal dissection. And on the left, you can see the tunnel, the mucosal aspect of the dissection.
And this is the muscle which has been divided. This is the submucosa which is holding up over here. And I think this is adequate.
Yeah.
We've got complete hemostasis as well. So I think we are done, and we will just come out and close the mucosal incision. Now I'm going to be using the Boston clips, I think, for the closure.
Amol?
Yes.
This is Dr. Mukewa here.
Yes, sir.
What is the manometry in this patient?
The manometry actually was normal in this patient. That is what Sukrit told me.
Achha.
And that is the reason we are not going the conventional poem where we will cross the G junction and do a complete myotomy, because you don't want to unnecessarily divide the normal muscle.
And the mediastinal part you want to close or you don't want to?
No, because that we are going to close with the mucosal incision only. That is behind.
Okay.
So there is no reason why we are we have to close the mediastinal defect separately. So that is not.
And how do you differentiate between the other ordinary poem versus D poem? Is there any technical differences between the two?
Okay, fine. Yeah, so most of the times, you know, your diverticuli are associated with achalasia, in which case you have to do a conventional poem, but do it in the direction of the one of the edges of the diverticulum so that you can divide the septum in the direction of the myatum. And so it is a D poem plus E poem or esophageal poem, that is what you do. Now in this kind of a situation, what you are going to be doing is only do the septotomy, and we are not going to be doing the complete esophageal myotomy. The technical differences are that, okay,
Fire.
Technical differences are that usually you will find significant amount of fibrosis and increased vascularity near the septum, and you have to divide the septum, you have to dissect the septum from both sides, separate the mucosa, and then, you know, divide the septum. And you have to be sure about the anatomy and also make sure that there is no perforation to the mucosa. The third thing is you invariably end up doing much more mediastinal dissection in these patients. So these patients are more prone to developing surgical emphysema and gas-related issues. In this patient also we did have a little bit of, you know, about 5 minutes when the ETCO2 went up, and she has developed a little bit of surgical emphysema. But I think that will go away with hyperventilation once we will bring the scope out. So that's nothing to worry about. But one has to be sure that we are taking care of that in case.
Amol sir, we need to just shift to the Gerdex for the last stitch there.
Okay.
Excellent demonstration. Amol, excellent demonstration from you.
Thank you so much.
Thank you, sir. Thank you. So we are back live with the room 2 Gerdex.
Okay. So welcome back. So now we have mounted the second plicator.
So we
and
are,
as you see, I am repeating the same step of taking the helix inside with the mucosa. And now the second will be more towards the lesser curvature. Can you just inflate and then show them? I think there is a blurred vision on, but I am going to go to the close mode and position myself. As you see here, the device is completely controlled with your movements of the hand like a joystick. That's the reason why it's device like this. And you see now I have closed, gone to the fire mode. There's already a wrap kind of thing created here, you can see. And now once I fired, I'll unlock the device, unlock the helix, take it inside, close, and open the distal prongs and push it down. So now the second plication also is done. And can I have the upper GI scope? We can show them how exactly it looks once it opens up. So the second plicator also has been put, and we'll just change the scope into upper GI scope and show you how the wrap is being created. And as I told you, usually 2 plicators are good enough. Can I have upper GI scope? And these 2 plicators will cover the small hiatus. The inclusion criteria is very important in this. One, a high volume reflex episode GERD symptoms, PPI dependency of course, Hill's grade 1 and 2, and a small hiatus hernia. So if you have these categorical inclusion criteria, then the outcome is good. Because if the patient has got a low volume reflex or a 0 volume reflex, this procedure is not going to really, give any positive outcome in these patients.
When you choose ARMA over GERD or GERD over ARMA?
That's a very difficult question, Yogesh. There's no data on that. But personally, anecdotally, what we can see is if the volume reflexes are not very high, then ARMA might be a choice. But if they are very high volume reflex, then you need to alter the anatomy of the GE junction by doing this fundoplication. But we don't have any proper evidence of inter-comparison studies between ARMA versus GERDX.
Sir, hello.
What is the outcome usually? How long they will be off PPI?
Sorry, I couldn't hear you. Can you come again?
What is the outcome usually? How long they will be off PPI?
Outcomes, see, the post-operative, typically what we do is, we give a 10 days of PPI, and if you have a very high volume reflex, probably 2 weeks of prokinetics, which are available in India, of course not in the Western world. And then typically the patient will be off PPIs by second week, and then we'll observe. And as you see here, there's a nice wrap. Can you appreciate there on the screen? So this is the fundal wrap.
We don't have the endoscopic image.
Okay, can you show them the endoscopy image?
Yes, now we can see.
Okay, okay. So this little bleeding is not to worry, but as you see here, there is a nice wrap created, just like a Nissen's fundoplication. So this is how the end result happens. The blood here, not to worry, it's just self-limiting. It will stop on its own.
Rakesh, is there any data comparing lap fundoplication with this?
No, not exactly. In fact, the fundoplication, what we do endoscopically is only a small hiatus, unlike lap where we do a fundoplication on a large hiatus. So ideally, to have comparison between these two modalities, I don't think any study will come in near future. But in fact, in Mayo, in some parts, they are doing even for large hiatus fundoplication with TIF or esophagus and a hybrid technique of repairing the hernia with laparoscopy.
Okay. Rakesh,
thank you.
What is the long-term data of these TIF? It's been using for the last, I think, 7 or 8 years.
Yeah. So we have a 3-year follow-up of our randomized control trial, which we published in 2022. So we have a sustained improvement both in subjective and objective parameters in almost 80% of the patients. We just came up with the data and we'll be soon publishing the 3-year follow-up of the whole subset of patients.
And manometry-wise and other things, do they improve?
Yeah, manometry-wise, I don't think there will be improvement. See, I'll tell you one thing. If these long-standing GERD patients have an ineffective esophageal motility, their outcome, both in terms of endoscopic or laparoscopic fundoplication, is not as good as the patients with intact motility.
So thank you. We need to shift to the room if possible, sir. Thank you so much. Dr. Shanky, please tell the history for the next case.
Sure, sir. So the case we are taking is a 54-year-old gentleman who is a diagnosed case of CA gallbladder, underwent radical cholecystectomy in 2018. Now has developed jaundice for last 1 month. So MRCP was taken that showed a segment 7 indeterminate lesion with a mid-CBD lesion with intrahepatic biliary radical dilatation, which is likely neoplastic. So our plan is cholangioscopy along with biopsy of the CBD mass. Back to room 3.
So good morning. I have got Dr. Reddy with me to give me confidence. And Nagi, would you like to comment upon this papilla?
Yeah. I think the papilla looks very bulky, and of course from the history of this patient with a CA carcinoma of the gallbladder and now another mass in the CBD, I would think a potential possibility of villous tumor or a mucin secreting tumor is a possibility because it's a very bulky papilla, very inviting.
That's why I thought I'll take it up so that I don't end up with.
No, but you can also do even if it's cancer, no problem. I think you're directing towards the CBD now.
Yeah. So we as explained yesterday, we targeted the sector between 11 o'clock and 1 o'clock to go inside the CBD, and we never push the device. Whatever device you're using here, we're using a Ultratome XL. Too much. We see if I push it, I crinkle the distal CBD. That's why we do submucosal. But I relax it. But I have not taken the device out. But I have relaxed the distal CBD.
You don't have floral veins.
No, I have, we have not put in any contrastor wire yet. So I'll ask, Bhagwan, who is assisting me, to push in the wire slowly. It should never be done very rapidly.
Yeah, so I think this is the important point. You can see Randir is actually just abutting the papilla and Bhagwan is actually feeding the papilla.
Leave. You should never be unnecessarily trying to rotate the wire and trying to get into the papilla. Now what we'll do, we'll change our tactic. We'll you know, bow the papillodrome to become little more in the roof.
So this is also another important point. Don't do the same thing going on and on. Change whatever you're doing so that will, I think now it's gone a little deeper inside.
Yeah. So let's see. We'll put in the wire because there may be obstruction there.
Yeah.
So if the wire, the way it is turning, it's turning towards the pancreas. I'll put in some contrast. Small amount of contrast.
Two drops usually.
Yeah.
To tell us, yeah,
See?
it's the pancreatic.
This, you can see the weight. It's the pancreatic duct we were going in, because you should be aware of the direction the tip of the guide bar takes, because otherwise you will bow.
And now it seems to mean it.
Yeah.
So what is your threshold for a pancreatic stent, Ranjit? How many times?
I'll say he has been given the suppository. If I go more than 2 times, I'll consider pancreatic stent. But in malignant distal obstructions, normally that's not the case. This is not the right direction which I would like to have. So just put in the guide wire. But because there is a distortion down there, because the possibly the villus adenoma, which starts very low. Now still we are going.
I think the other thing is whenever there's a tumor causes distal, I think you're in the pancreatic.
Pancreatic, yes.
It causes distal collapse. This thing is very common.
Keep the wire out.
Now we use the double guide wire technique.
Maybe I'll see whether if I can cannulate with the guide wire. No, keep the wire up. Yes, and very little guide wire up.
So this is also very nicely shown that you go to the tip along just with the guide wire in a totally different direction. Now it looks little different direction.
Yeah. Just see.
Yeah, so this is a good exercise to see how different angles are being used to get into the selective wildhead candidate.
Wait. Wherever you have this wire turning back on you, don't persist, because then you will do a submucosal, like what happened yesterday, and use suction as your, as your friend, because this opens up the distal CBD. So what we are going to do is, we are going to impinge it here, bow.
Again, it has gone in a little.
Yeah. So now we'll see.
Same thing.
Same thing. You just put in contrast whether we are in a little different direction. If I can see that.
Coming back.
Yeah. But now it's so pacifying a little. Yeah. There may be obstruction.
Maybe you can magnify the lower end.
Yeah.
Lower end magnification.
The zoom.
Yeah, I think lower end.
Yeah, just inject. Inject now.
Dr. Sood,
Yeah.
what will be your threshold for using needle
This
knife?
is a tumor which is appearing like a stone, because this patient has undergone EUS at 2 different institutes. One by earlier at ILBS by a person like Vikram Bhatia, whom I'll respect with the reporting. He will not miss a stone.
But this looks like a stone.
Yeah, it looks like a stone, but you see the dye going in between the stone. So wire, just see the wire.
We didn't get the question. Can you repeat the question? The panel was asking a question. We didn't get it.
No,
So I think
Dr. Nagi, what will be your threshold for using the needle knife?
so.
Pre-cut.
The threshold is different in different units. If we can't go in more than 2 times, as Ranjit said, if you have the guide wire deep into the pancreatic duct, we put a pancreatic stent and then use a needle knife. Our threshold also is 2 times, but again, it depends on the indication.
Yeah.
If it's a CBD stone in a lady, young person, I very quickly put a pancreatic stent. I don't wait too much. Elderly patient, malignancy, I'll give it a little more laxity to use. But in general, 2 times.
Yeah,
the guide wire is
another trick I'll show you, that what we do is that because there is a long interduodenal part in this also and we are getting obstruction there, we at times, once we are sure that we are in the CBD, because we inject some contrast. You see the, we are in the PD now. We shifted from the, so you should not be overconfident.
So I think a needle knife question continuing, needle knife should always be on a pancreatic. You can do a free needle knife, but always preferably it is done on a pancreatic stent. Now we are in the CBD.
Yeah.
Nice. Oh, great. So I think the subtle change in the movement, Randir, that you just went more up and then sort of shortened the scope, which was done involuntarily, and then quickly it went into the
So another thing which I always insist is that use suction as your friend, because I sucked out, so some bile came out, so that opened up the distal CBD. Now put in contrast because we want to see
that's a very important, interesting point. So we can see very nicely the upper part, which seems to be okay.
Yeah.
It's only the
See
lower
all
part.
this, you see there is some filling defects happening. They will be easily mistaken for a stone, but we know that this gentleman had cholecystectomy. You see this? Now you see what is differentiates stone from the tumor. You see that contrast going in between irregularly, not like stacked up stones. But you know, many times you have the benefit of other information, so you try to be very philosophical, and you try to teach people that this is the way to differentiate. But I would have taken it as multiple stones if you have no
in this
information.
picture, one would think of multiple stones rather than.
You can change the guide wire. So what we are going to do is, we are going to change the guide wire. We are going to do a wide papillotomy and do and put in a plunger-scope to see it carefully, and then take biopsies. Now this is not the very comfortable place for doing plunger-scopy, but we have a space of around 2 centimeters below the tumor.
So would you try and do a sweep? And then for that, just to see what happens.
That will produce some blood and may change the morphology. I want to do a direct plunger-scopy, because what happens is that then the blood will alter that view. So because we have the information of the ultrasound, that's why I'm not.
So you have great trust in your endoscopic ultrasound.
The two ultrasounds showed the same finding, different people. So see again what Nagi demonstrated yesterday. You come back a little, push your papillotome down, so that you are
very comfortable. I think this is very important. Most
beginners, you see that
go very close.
Your hand should be holding the scope like this in your angle of the index finger and the thumb, and it should not be. You should not be moving. You should not be uncomfortably positioned yourself. That means you're torquing the scope. If you are comfortable. But I'm not doing very wide papillotomy, because the tumor may be, if there is a tumor, it possibly is infiltrating the distal CVD, and I'll unnecessarily,
Just enough to put in the cholangioscope.
I'll rather do a balloon.
Balloon.
I'll do a 8 millimeter balloon at least,
I think that's a very good point, that very often when you're putting a cholangioscope, you can do a small sphincterotomy, but a balloon would help in the distal part at least.
Yeah. So that I don't, all said and done, we had the morning session. We would like to optimally utilize our plunger-scope. It's meant to be single use, but we try to preserve it.
So I think you can see, again, for those who are watching on the screen, there this small amount of ooze that doesn't concern, it stops spontaneously.
Yeah.
And some of it is bile flowing through, actually washing it out and causing.
Yeah, and there are two terminologies: endoscopically visible bleed and clinically significant bleed. So this is the endoscopically visible bleed. You should not be halting you should not be doing additional procedures to control it initially. If it is significant at the end of the procedure, we'll tackle it.
So any specific balloon that you like to use?
We are using a hurricane balloon in this situation, because we are.
It's a
Hurricane. Hurricane is a very reliable balloon. Of course, Quantum is the second balloon which we use from Wilson Coop. Hurricane is from Boston Scientific, the real workhorse.
And you are doing 8 millimeter now?
Yeah, 8 millimeter balloon, and I'm using a jag wire, because we changed the wire from Termo to jag. We always start with what you showed last time, the tangled J wire to cannulate. We have a philosophy of having two different wire strategy, that we will go with the the cannulation wire or the access wire, and then exchange wire.
So I think the camera should focus also on the gun here which Bhagwan is holding. looks like a real gun. So Bhagwan is dangerous now, but I think we can.
And also see the fluoro. What I'm trying to do is I'm keeping the balloon below the tumor so that it doesn't bleed unnecessarily and doesn't distort the anatomy. So I'm trying to do that. And so that's why I'm not putting the entire balloon in to inflate.
Randir,
Yeah.
what is the distance between the papilla and the tumor?
It seems
Approximately.
like just a centimeter or so. So there is a trick of doing pull-through colonoscopy. That you go with the colonoscope above. That's why I'm keeping the wire in. I'll go over the wire. I'll go up, and then come back. So that I can do a pull-through colonoscopy, deflate. See, you can see that, you can see that I kept it below the, I tried to keep it below the tumor, and you can see now from the balloon, it is about 2 centimeters. Because less than half of the balloon was in, and this hurricane is 4 centimeter balloon. Is it?
So we see
4
some
centimeter?
ooze coming from inside, so that I get an indication.
Of a tumor. Yeah.
So anyway, I think we're all very anxiously looking forward to see what is inside. I think the reputation of the endocrinologist will depend on
Yeah.
either you can break or make a career.
So this will decide whom to refer
So
subsequently.
Srikanth, what is your, let's get your panel opinion. What do you think based on the radiology? What do you think?
Well, looking at the radiology, it will be difficult. It looks more like stone as far as the appearance is concerned.
Yeah. So that's what I also was thinking. What about the other panelists there who are there?
Could be multiple small stones. That's the reason why some air was visible inside.
We also feel it looks like stone.
Everybody is in favor of stones. So
Yeah.
let's see. I think, do you have any prize for this, Randir? Whoever guesses right gets some prize.
Yeah. I think we'll ask Boston Scientific to give them a colonoscope.
Okay.
I think it would be tumor because the EUS has been done already and the stone has not been
so
seen.
that's the reason why
That's why I don't think that they will be,
No, but
still,
if it turns out to be stones, all the 4 panelists will get a cholangioscope.
Yeah. One colonoscope to all the 4 panelists and they can fight it out.
Yeah. Okay,
Fluoro, please don't keep the wire too much up.
What was the EUS diagnosis of this defect in the common bile duct?
See, I'm not trying to now use my elevator, and if you now put the view.
So you go to the large view on the.
Yeah.
Okay. And also, I think probably you have to keep flushing some water.
Flush.
So this is water control. So you leave it to your assistant, Randir, or you control them?
If it is a Heiler block, I'll keep it in my hand.
Yeah.
But if it is any other situation, then I'm not so worried. But
so this is very important, so you don't contaminate.
Sir, could you have put a biliary dilator first? That would have helped the entry of cholangioscope by the side of the tumor?
Yeah. I think he's going by side tumor, and Randir said he'll use the pull-through technique.
So that I can, when I'm coming back, I'll look at it because there's very little distance between.
Now you're above.
Yeah. See this?
You can see, yeah. So I don't think anybody will get the cholangioscope.
Wash. You see the
very
tumor?
Nice, very nice. The villous tumor, and that's the reason why the papilla also appears like that. That's indirect evidence.
Nagi, you can see inside the bile duct also without cholangioscope.
Now you see this?
Yeah, very nice. Beautiful pictures. Fantastic. Huh? This is a typical villus with some amount of problem mucin secreting.
Yeah.
And that's the reason we have this appearance of the papilla. Very nice.
So what we'll do is we'll take biopsies because this gentleman, now for taking biopsies, what I'm doing, I'm taking my scope higher up because you see, it is going right up to the hilum. You see this?
Yeah. So Randir, you want to get a biopsies, you want to just check quickly right and left also, nothing.
Yeah, sure.
But other thing is regarding the biopsies, don't you think we can get a good biopsy directly also?
We can, but then once we are there with the colonoscope, why not use the colonoscope?
Does doing NBI of the colonoscope help? NBI of the colonoscope, does it help?
Which one?
NBI for this lesion?
No, there is no NBI in the cholangioskop.
Not
right
in this cholangioskoscope, except the what Olympus is developing,
Yeah.
which we used earlier, that did not have the biopsy channel.
There is a little.
There is yeah,
So,
yeah.
so what do you predict the histology of these tumors?
It's a villous adenoma. I think it's very clear.
Very
now.
clear.
In fact, we won't even require a villous adenoma.
Yeah,
What you will probably get from histology is a little
this
K
area.
index, the amount of
See,
mitosis.
it is reaching right up to here.
Yeah.
Right up to the
I think
bifurcation.
it's going around there.
Yeah.
Actually, it's creeping along the bile duct and going up to that.
We'll have to stent him also after this because he's developing cholangitis in between.
Is
So
there
he's
any
not-
correlation of CA gallbladder which he was operated and these
You
tumors?
see the neovascularization? You see the
right up
wash.
the No, I think that's a very interesting point because we are discussing whether there is any correlation between the CA gallbladder and this.
See,
I
yeah.
think Randir, you think they're independent, don't look
I
like
think
that.
they are independent because the CA gallbladder, the hilum would have been affected.
Yeah.
This gentleman had already had a surgery, and the only thing is that this is either a second malignancy or even when the gallbladder was having, whether there is a gallbladder adenoma which became malignant, that's a possibility.
Yeah, actually it would be better to revive the gallbladder histology, whether it was villous adenoma leading to
See this,
malignancy.
you see the tumor very clearly. So we'll put in the biopsy forceps. Yeah, see the.
You can see little mucin type of fluid also is coming out because of villous structure there.
So it's our, that policy that we will, in such situations, we'll also send the bile for the cytopathology.
Yeah.
Randirji, Mohan here.
Yeah.
I just wanted to know why you had to go all the way up. Is it
Yeah,
for
because see the
stability?
stent.
Is it for the stability? Because it's
Yeah.
low down tumor?
Sure, it is for the stability because it was just 1.5 centimeter from the distal end. When we come back, you will realize that. And also when you're putting in a spy bite, you cannot introduce it when your scope is in the distal CBD.
Yeah.
You will need a direct, you will see that where the spy bite gets stuck. It will get stuck where the bend is. Now we are not using any he's feeling resistance. You see the fluoro? Show the fluoro. Now see, if I had not taken it up, it wouldn't have come smoothly. Now with the spy bite out and open, I'm going to retrieve my cholangioscope while he's flushing simultaneously.
I think for opening the spy bite without any difficulty, I think this is a beautiful technique.
Do suction to the
And I think in all villous tumors of the bile duct, it's always important to examine all the areas of the bile duct because the surgeon will get a view of how much to actually resect because at surgery they will be blind unless they are using a spy discovery also in the operation theatre. When they, of course, they can examine. But you can see there's some villi right from there.
Yeah. So I'm coming down now with the spy bite. Just withdraw the spy bite a little bit into the scope, so that otherwise it restricts my movement of the tip. Now you watch so that I can show them it.
So what Randir is doing is all the time stabilizing the scope so that it's in the center of the lumen, and he has partially fixed the up and right knob so that there's not free movement there. These are two important
See,
tricks.
this is the, now I see the villus, one of the villus fronts. Just show me the fluoro, I want to corresponding.
Still higher up there.
Yeah.
You can come down.
Yeah, I can come down a little. I have to balance the stability and, now you can open. Yeah, open.
Very
see,
nice. Very nice.
Now we see, we are directly there, close. You see this?
Yeah.
Yeah.
I think this would.
Yeah.
Then again, number of biopsies, Randir, you have any policy?
Yeah, I think we take 3 biopsies in all patients.
Yeah.
But it is not, it is dependent on the type of tumor also.
Again,
in villus, it may be one may be
Even one or
sufficient.
two, yeah. So we, I think Shyam Vadrajan's studies actually showed 3.5. They can't do 3.5, but 3 or 4 would be enough in most cases. Unless it's a very stricturous tumor, then probably you have to go to 6 or 7.
See, now we pulled it out, Nagi. Now we might feel some resistance while we are going in. So that will, but the max, they have really improved the mechanics of the channels now. It's just fluoro.
Going in nicely.
Yeah.
Or maybe the hands.
Yeah. No, it's a.
I think even the scope plus the biopsy
Yeah.
process also, we feel that 5 max to get a much higher.
That's a easier introduction. Fluoro. Now we are
Lower end, we can
just
show
the lower end.
lower part.
Show the lower part. Why are we keeping high? Show the lower part. See, I'm getting resistance now. I can't go beyond it. So I'll have to push my scope. See, this is the trick. Once you're there, you push the scope up, and now you can actually
see it
it is closed. And see, now the scope position matters. I put the scope in a position so that.
So you take out that curve now.
Yeah.
So you're looping the cholangioscope in the duodenum.
Yeah, we put the we introduce the cholangioscope so that the part where it gets stuck is pushed into the CBD.
Yeah.
So this is important. That's why when you asked me why did you take it up so high up, one was to examine, the other was to facilitate introduction of my spy bite.
So now it's come nicely. Now, I think my feeling is that just one more would be sufficient.
Yeah, that should be sufficient. We can, we can actually not necessarily keep on with this case. We have. Fluoro. What? Yeah.
It's a longish tumor, much
much longer than what.
Cholangiography.
Along the CBD.
Yeah, very nice. You can see right there up there. So it's quite a long tumor.
Yeah.
The surgeon probably would have to do a very high hepatic.
Absolutely. See this?
Nice.
Now you can see this very clearly.
Open it.
Yeah. Open the forceps.
Beautiful.
Close.
Sir, are we contemplating any ablative procedure also here or after biopsy?
What is the problem?
Ablative, some ablative therapy.
No, I think this is a case which is a case for surgery.
Yeah,
I don't think
actually.
we think of ablative. Reem, you agree? Yeah. I think we should do, this is a...
The only problem is that he also has a child acidosis.
But I think these are the cases, I think that should be okay.
Sufficient?
I think,
Okay, there's sufficient. We can put in a plastic stent here to take care of his jaundice and ablate him. So I'm taking out, Bhagwan, I'm taking out the cholangioscope.
So I think question was regarding radiofrequency ablation. If you are not resectable case or there's some comorbid conditions prevent, then one could think of a good radiofrequency ablation going right up to the higher regions where the lesion is. But I think in this case you can get a clear margin on, you can see right and left are separated out and the lesion not extending in. So a hepatico-jejunostomy with like a
will be
okay. The ripples with hepatico-jejunostomy will be what?
There is the patient has child's A cirrhosis?
Yeah, child
A would not be a contraindication.
Yeah.
He doesn't have, we will see while coming back whether he has varices. And what my policy, as I told you yesterday, is that if I have a good opening, I load my plastic stent and go with the introducer itself. And we don't waste time on putting in a guide wire in and out. If you're confident of going in the bile duct, comfortably, you can save time. Now the question actually which should have been asked by the panel was that when will you use a metal stent and when will you use a plastic stent in this? If I was seeing a significant bleeding, I would have put in a fully covered metal stent.
And because also this patient had a cholecystectomy, the chance of a gallbladder cholecystectomy is very
that's not there. So
this would be, I think, another alternative. Other thing is, if you think of a neoadjuvant, of course, one would think of a complete.
May I ask one question? I mean, while you are debating about the type of surgery and all that, are we forgetting that indeterminate lesion in segment 7, which was told to us at the presentation? I mean, will it change our management? Do we need to take a tissue from there?
I think this patient, my feeling is, in this patient, I would think of a PET scan. Because we're doing it, that has been done.
Because the clinical presentation mentioned that there is an indeterminate lesion in segment 7.
I didn't do
that was earlier. We had discussed it. That was not a significant lesion at all. We had discussed that. But we are planning
No,
before.
if that has been evaluated, then it's okay, but that's all. That's
Because,
fine. That's understandable. That's fine.
Planning that in case we decide about surgery, we will do a FNAC from there. Really.
Yeah. I think that completes the.
Yeah, wonderful demonstration, Randy.
Thank you.
Nice. On behalf of all chairperson and panelists, we compliment you.
Thank you very much.
Thank you, gentlemen, for your precious time. I thank the chairpersons and the panelists.
Oh, yeah.
And now we are moving towards.
Very long.
Yeah.
Now we are moving towards our next session, and for that, I'm delighted to invite the chairpersons on stage, Dr. Prem Ashish Kar, Dr. K. Rawal, and Dr. Dinesh Singhal. Welcome, sir. For the panelists, I invite Dr. Rajiv Grover, Dr. Amitav Goswami. Chairpersons, please. Thank you. Thank you. Over to you all. Thank you.
Dr. Gaurav, you can go ahead, please.
So thanks, Sukrit, for this opportunity. This is a case of a young female who's got iron deficiency anemia and diagnosed to have a sigmoid.
Dr. Gaurav, you are not audible. Adjust your mic, please.
Can you hear me?
Better? Yeah, better.
So this is a young female who's got iron deficiency anemia and has a polyp in the sigmoid colon. And I was just, studying this polyp, and as you can see, I'm withdrawing it somewhere around 15-20 centimeter from the anal verge. And you can see a polypoidal lesion started to form over here. And this is a little vascular, there's some bleeding while I'm examining it. And I'm giving some CO2, distending the lumen, and trying to study this. So the first thing that you notice when you want to do any polypectomy is study the morphology of the polyp. Just under good white light imaging, you spend some time and study the morphology. So the few things that you can clearly see is this seems to be having a wide stalk over here. A stalk which is extending somewhere from 5 o'clock and going above up to 12 or 1 o'clock over here. And along with the stalk, there is what we call as a chicken puckering of the submucosa or the mucosa over here, suggestive that there is some traction. There could be submucosal infiltration because of inflammation or because of the tumor itself. Next is you study the surface of the polyp, and you can see it's slightly irregular. The contour is, it's not a homogeneous, simple polypoidal lesion. It is slightly irregular, and these point towards that this is a process which is started to grow a little, invasive. It is not just a simple polypoidal lesion. Now, I've placed the scope in such a way that the polyp falls at 6 o'clock, and you can see the gravity is somewhere around 11, 12 o'clock.
That will always help.
Yeah. So this is a good position for any procedure that you want to do. You want to keep the lesion at 6 o'clock, your working channel, while the gravity is the opposite side. Next is I start studying this polyp on white light imaging, and I see the surface architecture of the polyp. And as you can see, the surface architecture is quite homogeneous. It's irregular, but it is somewhat homogeneous throughout. And then I start looking at the vessels. And on NBI, you can see over here the meshed capillary pattern. Can you appreciate these vessels are?
Right, anyone?
Yeah, yeah. So you can see these vessels are branching, they are regular in course, and they are sort of forming these mesh capillary patterns. So this is like a 2A polyp at this area, and as I go deeper towards the site where the polyp,
Towards the stop.
yeah, towards the stop, and here I start seeing vessels which are slightly, end-on vessels. Some of these vessels are more short and more amorphous over here.
So do you think this occurs due to constant flopping of the polyp?
Yes, yes.
Because these are usually pseudostalks that you
Yes, so yeah, as Sukrit said, many a time these vessels and could be just because of the movement of the polyp. It is not really, could not be invasive, but just could be because of movement of air and flatus throughout it, and that can give rise to this appearance. So now the objective over here is either we get it en bloc with using a snare, or either we dissect it with a ESD. So I've been told that we can attempt, EMR in this polyp, and what do you think?
I think underwater AMR should suffice.
Yeah. So I'm going to try and get this entire polyp unblocked in a technique now which has been described widely, and it's been, the mainstay of our EMRs at our department. So this is an underwater technique where what we do is we first go distally, start injecting a lot of water, and what happens is this is the buoyancy effect, and you can see as this in this these mucosal folds start to lift. So the submucosa which has fat in it, it starts to expand and it pushes the mucosa. So any lesion which is pure mucosal starts getting lifted up, and because of this the need for injection in such cases is minimal. I'm injecting.
Gaurav,
yeah.
Dr. Rawal here. Don't you think now all the EMR should be underwater only?
Good point, Dr. Rawal. I just said, in our department, I think almost all the cases in the last couple of years, water is stopped. Pani chalega.
Dr. Gaurav,
Yeah.
Dr. Suraj here. So you have a lesion with Kudu type 4 pit pattern.
Yeah.
Is this Janet 2A or early 2B?
This is, majority is 2A, and some areas it is 2B, and it has a wide stalk. So the advantage of doing UEMR over here is you can get the entire lesion unblocked in just a single snare and get it out. So even if you're having some deeper injury, because you're not expanding the submucosa, you can easily go and clip the defect or a perforation that can be caused. But water nahi aa raha.
And Gaurav, this is a wide base. Would you apply loop to be sure there is no bleed post-pulpectomy?
Yeah, so that's a good point. Now, another advantage of UEMR is that you're not expanding the submucosa. So the vessels do not retract and do not get space to expand. So if there is bleeding, the muscularis mucosa and the propria compress these submucosal vessels. As a result, even if there's bleeding, it is slow bleeding, and you can pinpoint catch these vessels after the resection. There's no water.
Dr. Gaurav, is this a stop or is it a pseudo stop?
Possibly a pseudo stop. Possibly, because see the position of the patient, it's falling towards the gravity. Pani aa raha hai kya?
But why did you choose for underwater EMR versus an ESD?
You can do both in these cases. UEMR can be quicker, easier, and I have a strong feeling that I can get this whole polyp out in an end block.
ESD might be overkill in this case.
No, but then you have an early Janet 2B.
Yeah, I think the JNET 2B portion possibly is due to the inflammatory changes which occur due to the movement artifact of these polyps. That's why the pseudostock is formed as well. So we have to take that with a pinch of salt. Because JNET 2B in the more prominent polypoidal areas, then I would be keen on doing an EFD as well. But with underwater EMR as well, we get a deeper plane of submucosa with the snare. So the recent studies that we are getting with underwater EMR up to even 3 centimeter lesions, they are getting a very high R0 dissection rate even for SM1 lesion.
So, are there any lesions which should not be undertaken underwater EMR, or all can be taken?
Another good question. So if you're already seeing a polyp which is a very high risk of submucous, so it's a non-granular LST or a non-granular which is with a nodular mixed, like not a homogeneous LST. Sometimes I need more water.
I think Paris 2C should not be.
Now, 2C definitely, it has a deep, ulcerated or so not ulcerated, but a pseudo ulcer. Get more water.
That's
So
what
the
Neela
most
told us.
important pre-requirement is that you need a good irrigation. So what is happening is some air also being trapped into the pump, and so the prerequisite is you need to go ahead, suck out all the air. My finger is off the air channel over here, or you can just switch off the air over there, and then just irrigate, and let the mucosa just rise. Start?
Yeah, now it started. Yeah.
Started? Okay.
Yeah.
So continuous.
Continuous.
करते रहे. चल. So snare open.
So what water does it basically is separating the mucosal lesion from the muscular plate without having an actual injectate in the submucosa. So you are doing, it's like an injection EMR without the injection, and it's much quicker in our practice, and the data shows that en bloc resection rate for supra 2 centimeter tumors is higher than conventional EMR.
So again, there are some issues with the air. There is some air coming as I am trying to, push in some water.
Keep your hand on the button, don't press it. So you'll be able to suck the.
ये डालूँ? हाँ. Water ही नहीं आ रहा है.
Now, Sukrit, if you have a polyp with 2B, Janet 2B, and you have a long stalk, so what will you prefer?
I think with the long cruise stalk, then you do a polypectomy, like you would otherwise, because there, say for pedunculated polyps, JNET and NICE are not very accurate. Your pathologist is the king, the Haggett classification will be followed. Try to hold it from at least, just leave 1/3 of the stalk if possible, just for hemostasis if needed, but it will be the pathologist's call then. JNET and NICE do lose their accuracy and sensitivity to a large extent with truly pedunculated polyps.
You want me to convert to a?
I think we can convert to a hybrid if needed. You can do an injection EMR otherwise.
Yeah, or else we can just do a conventional EMR if there's a yeah.
Gaurav Mohan here. What is the snare that
Can we
you
inject the water through the channel or through the syringe?
Yeah, but you need continuous irrigation.
You need to replace all the air with water. And currently the pump is not functioning too well right now. So we can switch. You want to switch?
Yeah, you can switch. We can just
We can just switch the plan. That's the good thing with EMR.
Yeah.
We can
Injection there,
conventional
conventional. Yeah.
What is your preferred injector?
In colon, normally we use gelofuscin, but for such small lesion, normal saline itself is good. And more importantly, you want to use a fluid which stays in the submucosa and it doesn't cause any adverse reaction.
A lot of these new gel-like formulations didn't reach India because I think they lost their FDA approval as well recently.
Yeah. So because of there's an issue with the water jet over here, so I'm going to do the conventional technique. At least let me lift this polyp and show you.
I think one thing more with the injectator, your pathologist should be happy with the specimen they get.
Yeah.
Sometimes you get the histological artifact due to the injectator itself.
So you want to go to the base needle out.
And how frequently you use lifting sign as a marker of deep invasion?
Mostly NBA is accurate enough.
Yeah,
but yes, for when you're not sure, it's not a bad idea, but it can also give you a false sense of security. With a particular part of a complex polyp, let's say you're dealing with a 2A, 2B complex polyp, a laterally spreading tumor, and most of it lifts and you're happy, you start the procedure, a part of it might be pseudo-depressed.
So you see what has happened, I've injected and the polyp has moved away from me, and suddenly there's a loss of the lumen of the colon.
We could have started orally. So now we'll compensate by injecting on the oral aspect.
Pani continuous. Open the snare.
So there's something important for the beginners. Don't just inject under a polyp. See where it's going to fall once you do it. Over injection can be an issue as well. There's not a poem where you want to inject 10-20 ml of injected. Just enough to make a plane between the muscle and the mucosa.
Sukrit, what is dynamic injection?
So dynamic injection is when we are continuously just giving tap. That is what Dr. Raju has taught everyone to teach the technician. So we are going layer by layer. We are not asking the technician to fill up a whole syringe and make sure he injects the whole aliquot in one go. We are asking them to go tap, and then we have more control and we are when it's adequate,
Yeah,
we have
okay,
enough
funny.
place in the lumen, we can ask him to stop as well. And we
Until
can
the
keep
chalu
injecting and cutting that for piecemeal. We can keep doing the repetition as well.
Okay, snare out, snare open. So we've injected a bit, and I want Ashwini to open the snare. Now important is to hook this polyp in the snare. Okay, I want to see the snare. Rotate the snare, please.
What snare are you using, Gaurav?
This is a braided snare which we are using. Most of the polypectomies we use a braided snare. And then with this we try.
2 centimeters.
Yeah, 2 cm. Okay, open completely. Okay. And you try to hook the polyp. You want to just go slowly, gently.
Move the shaft of the spoke towards the polyp.
Yeah.
And again, a good coordination with the technician is a must.
Thoda sa left, snare left.
Slightly make it fall either with the spoke torque or with the
Smooth the
turning
snare.
of the snare.
Okay. Okay, start closing. Wait.
We'll just go closer to the
Wait,
polyp.
wait.
There is also something important. Don't fall too far away from the lesion.
Open.
Some people cut the polyp too far away from their
Open,
origin
open.
point. That's where most complications occur.
Okay.
Another technique that has been described recently is just making 2-3 pre-cuts in the mucosa so you can hook the snare, anchor the snare better in those particular tiny pockets. Like Dr. Bing, who made small pockets before he placed the pseudoscope
Okay,
clip
open.
in the large ESG defect. Similarly, you can make
Open,
these
open.
tiny notches just with the endocut mode
So
with
you-
the snare tip and try to hook the tip of the snare in those. It makes a much better grip.
Okay, start closing. Okay, so you see what I've done. I've got the polyp at, below. Wait. Don't completely close. Okay.
And always now insufflate air.
Now I'll
breathe.
insufflate, I'll withdraw.
Yeah.
Wash little. Wash. Thoda sa open. Slightly open. So I'll go little more deep. I'll try to get more of the base. Wash little.
Dr. Gaurav, what should be the ideal position of polyp? 6 o'clock or anywhere?
So
Because
6
now
o'clock
we are
is ideally
reversed.
important.
Yeah.
6 o'clock is ideally important. But in this case there was extreme talking of the scope. And this is what can, so I've got some part of the polyp. I've still not got some. So open little.
So always never commit to the dissection either.
Slowly.
You'll try to get it unblocked. It should be possible.
Dr. Gaurav, you can still position it to 6 o'clock for a better.
Yeah, yes.
You want to torque it back? Go back to the...
And we are not sure whether the whole polyp is within the snare.
Yeah,
Yes.
so when we hold it, we'll insufflate air, we'll move it and
Inject,
we'll
close.
make sure before we give the command for the cutter.
Okay, close.
Yeah, I think better.
It's
Just
slightly
check.
better. We got more of the tissue. Maybe some polyp is there. So maybe we'll have to do a piecemeal. So this is the disadvantage when you're doing conventional EMR. I could have got the entire polyp en bloc, but looks like we'll have to go piecemeal. What do you think, Sukrit?
Yeah, possibly. Since it doesn't hurt much, you can just do a snare tip, soft coagulation. And
Yeah, and I'll have to get this
Yeah.
polyp also. Open little. Okay. I go in again. I go on the left. Okay, close. Okay, I don't think I'm getting the whole polyp.
You want to just turn around, just go to the starting position.
Okay.
I think
Okay, wash. Keep washing, keep
wash
washing,
was
keep
left.
washing.
Now go underwater.
Yeah,
Let
yeah,
the
yeah.
polyp float so you'll know better.
Are you
Okay.
still doing UEMR?
No,
Yes.
now this is a hybrid.
Okay, I think I've got slightly more polyp chunk than the previous one. I'm not too sure I've got the entire polyp in block, but nonetheless, I'll go ahead. Now I'll start with the endocut mode. Start
So the
closing.
endocut Q.
And I'm going to use 316.
Yeah.
Cut,
Effect
cut.
of 3,
One
interval
cut.
duration 1 and interval 1 and duration of 6.
One cut. Okay.
Can we see the cautery settings also?
So we've used 316, endocut 3. So this is the part of the polyp we could not get in the first attempt. No problem. We'll go ahead, open the snare. Open.
And the important thing is the duration, the whole polyp should come out within 4 seconds. If it is more
Yes.
than that, then you have caught the muscle.
Yeah.
Yeah.
So you can see some fibrotic base over here. Open the polyp, open the snare, pura open.
I think with piecemeal even, I think cold technique works for the same reason because very difficult to actually go through the muscle with cold EMRs.
Close.
If you have committed to a piecemeal, you can do a cold technique as well for large polyps.
Wash. So I'm getting the second bit chunk of this polyp and open. Okay.
Tiny bit is left.
So will you do APC of the edge also in this case?
Yes, yes, that's a very important question. You know, all EMRs in the colorectum, you can reduce the recurrences. Okay.
By 27%.
Yeah. Okay, open.
Dr. Burke's group. He studied the native soft coagulation, but there's enough data with APC with similar results. But those who don't have APC available, just use the tip of the snare, switch to soft coagulation mode, and even at just 40 watt, you can do the snare tip soft coagulation with the effects of 4 or 5.
This is the last bit of the polyp remaining. Open the snare.
Gaurav, we should probably try to align it to the working channel. No?
Yes,
Is it difficult? Because
it's slightly it's slightly coming difficult. Give me some injection, yeah.
Twisted position.
Yeah,
of the scope.
this is the sigmoid bend, so it's not really coming at the desired channel. But nonetheless, what we'll do is we'll just inject a bit at the other end so that the distal part falls right on
the
time.
injection actually changed the the injection made our job a bit harder.
More difficult. I mean, if it was just straightforward underwater, I think this would have been coming out in unblocked.
Dr. Gaurav, can we, if you allow, just switch to another room? Yeah.
Sure.
Thank you.
Sure.
Thank you so much. So, Dr. Shanky, can you please tell the history for the case in room 3?
Sure, sir. So in room 3, we'll be taking up a case, 24-year-old female with history of pain, abdomen, and vomiting soft abdomen for last 8 months, with associated loss of weight and loss.
I thank the chairpersons and the panelists for this session. Thank you, gentlemen, for your precious time. Moving on to the next live session, and I invite the chairpersons and the panelists on stage. I invite the miracle workers in white coat, Dr. P.C. Dalai, Dr. Gunjan, Dr. P.C. Dalai, Dr. Radhika Chavan, Dr. Srihari Anikhindi, and Dr. Sumit Bhatia on stage. Towards the, yes, and now I invite the panelist, Dr. Somin Shah, Dr. Shaukat Chaudhary, Dr. Shivam Khare, Dr. Alok Mishra, Dr. Abhinav Sharma, and Dr. Shubhashish Mazumdar. Chairpersons towards this side, sir, and panelist on that side. Over to the live room. Thank you.
Sure. So I'll be announcing the case. So the case we are taking in room 3 is a 24-year-old female with history of pain abdomen with vomitings off and on for last 8 months. She has an associated loss of weight and loss of appetite. Cross-sectional imaging detected a heterogeneous hyperintense lesion at the ampulla with dilated CBD and mildly dilated PD. Side-wing endoscopy revealed a large ampullary mass, which was biopsied, which came out to be ampullary adenoma, villus with moderate dysplasia. So our plan would be ampulectomy. Back to room 3.
Mr. You are live from the room. Dr. Medya sir, we are live from your room.
So I'm live?
Yes sir, you are live sir.
Okay, so now here we are supposed to do a ampulectomy procedure. So I've passed the duodenoscope inside. Now after passing inside, the finding was a little bit surprising because if you were to see here, I'm going inside the duodenum. I'm taking a right turn, going in. Now look at this. There is a large polypoidal mass. It's quite huge. Look at this. Look at this. So this is almost like a large duodenal villus adenoma. Like a duodenal adenoma. We can't see the ampulla obvator at all. We don't know what is the relationship of the ampulla obvator to this. See now, removal of this has to be like a removal of a duodenal adenoma. So this is not just a simple ampulectomy. So this has to be removed piecemeal. So the question is whether we start from below upwards, start from above downwards, is the whole point. But we need to debulk this whole thing. And only when you debulk it, then the whole anatomy will become little clear. So ideally, if you ask me, Randhir, we should intubate this patient and do, ideally. Yeah, that is also a possibility. Yeah. Yeah, because here, doing the whole thing will take a couple of hours. But at least this polyp, I think first, the one which is on the right side, we'll take out first. Yeah, see this one? Let's do this one first.
Sir, can you hear?
So what is the opinion of the panelists there? What will you do in this situation?
Sir, what are the chances of carcinoma in situ or malignancy being there in this large polyp?
Carcinoma chances are very less if you look at this. But anyway, this needs to be removed endoscopically first, send the whole specimen for histopathology. Hold the scope like this, hold the scope, across scope like this, needle out, inject.
Sir, Dr. Swamini here, sir. Can we go for that surgical ampulectomy and the frozen section on table, and it turned out to be a malignant, can we change it to the Whipples?
Yes, that is also possible. But I think this is a polyp where we should attempt endoscopic first, because you never know, we probably will be able to take out the whole thing endoscopically. And if you don't find any malignancy here, then unnecessary you can prevent a duodenotomy, no? Needle out.
Dr. Medev, sir. Sir, any benefit of applying endo loops first before starting the procedure to prevent?
No. Here you don't see a proper peduncle. So if
Yes,
you
sir.
see a proper peduncle, then applying an endo loop is suitable. So here, let us see now, try to get into a position. This has to be a piecemeal resection. Buscopan is given.
Sir, Dr. Radhika here.
Yes.
So was US done for this patient to see the ampullary involvement and intraductal extension?
Pardon?
Was US done for this patient to see the...
Yes. I think EUS was done, and I don't think they found any intraductal extension. So now let me catch the first one. Yeah. So this has to be done as if you are doing a polypectomy. Keep on giving the injection, try to see the plane, but all this is with a ERCP scope, so it's not going to be easy to maneuver equipment. So the biomedia now is, I spoke to Dr. Randhir, and Randhir is saying that we should try to do as much debulking as possible today. Yes? Yes.
Amit, are you using endocut current?
Yes, we are using endocut. So now I'll give a little bit more injection. Yeah, open the snare. I'm pulling the scope back, catching it now, yeah.
Amit, Mohan here. Looks like you will complete this case in 5 minutes.
No. That's not my intention.
Sir, so we'll just shift to a parallel room by the time you debug the tumor. Dr. Shanky, can you please tell the history for the next case in room 2?
Let us take out the tumor what we have already debulked. Let us push it
Case
down.
in room 2, that is a 60-year-old female who's a case
Okay,
of acute necrotizing pancreatitis, developed born, underwent drainage in Feb 2023, now has recurrent left upper quadrant pain for last 3 months. So the imaging shows pancreatic duct disconnect with 8 mm dilated pancreatic duct in the tail region, and our plan would be EUS guided PD drainage. So back to room 2.
We are live.
Yeah. Hello, everyone. Nice to meet you again. Sontali, please introduce yourself.
Yeah. So Professor Song will be doing. I'm Dr. Nikhil. Dr. Ankit is there. It's a complicated case. So you have listened to the history. The plan is to puncture the pancreatic duct and try to negotiate through the stricture and try to do a pancreaticogastrostomy.
Yeah. There's you can see the dilated P duct is here. Okay, thank you. Yeah. P duct is a body portion and is much dilated. The most dilated portion is more than 1 centimeter, I think. And when, please measure. Yeah, 10 millimeter, okay. And when we trace the dilated P duct, you can see the fluid collection is here. Because because of this fluid collection, the pancreatic duct is disconnected. So from here, you can see the dilated pancreatic duct. And when we trace the pancreatic duct at the body portion, there is a stricture here. Yeah. Here you can see the stricture, but there is no mass. So I think this stricture caused by chronic pancreatitis. And when we trace the P duct, there is a multifocal stricture at the tail portion. Here. So very difficult. And when we turn on the Doppler, the splenic vein, cover the P duct at the tail portion. So we will puncture the body portion of P duct, but when we want to insert guide wire to the tail portion, there is a stricture right here. So we have to pass the guide wire, the stricture site. So plural, please.
Yeah. Professor Song, how do you decide your puncture position?
Because it depends on the procedure. When I want to integrate or rendezvous technique, the scope position is the toward for the pancreas head portion. And when I want to insert the EUS guided pancreaticogastrostomy, the scope position is
towards the tail.
Yeah, toward the pancreas tail portion. But in this patient, we don't have much choice because of the splenic vein is much dilated and cover the pancreatic duct. So I puncture this area. Plural, please. This position. So guide wire manipulation is very important in this patient.
So we are using a 19 gauge Olympus ED short needle.
Yeah, right.
Dr. Nikhil, what would be the minimum diameter of the pancreatic duct needed to plan for a pancreaticogastrostomy?
So it depends on the clinical scenario. In disconnected duct, experts have even done in a diameter of 3 to 4 mm, but ideally it should be more than 5 mm.
Professor Song, are we intending to put in a stent upstream of the stricture towards the tail or in the proximal to the stricture?
Yeah, if I fail to negotiate the guide wire to the tail portion, I will try integrate stent insertion to the fluid collection from stomach to the cystic fluid.
First attempt will be to pass the wire towards the tail. If we fail, then we'll convert it to antegrade.
Yeah, fluoro please. Okay. Very tight. Yeah, one more try, one more shot. Okay. Yeah, the needle is in. Yeah, okay, just inject transfer video, yeah.
So we'll take a pancreatogram now.
Pearl, please. Yeah, you can see the P-duct dilated and the cut off at the neck portion.
Yes.
Yeah, please, guide wire.
The tail portion is not filling.
Yeah.
Only towards the
Yeah, yeah.
Not
Okay.
वो have to try to collect them में जाएगा तो collection.
The collection में fill नहीं हुआ यार.
We will use the 0 to 5 digital light too.
This is Terimo actually.
This is the hydrophilic guide wire there.
Yeah, yeah. Pearl, please. Yeah, please, June.
In the hall, you can appreciate the fluoro image. This is the most critical step of US guided PD drainage.
Yeah, slightly I push the scope. Okay. Yes,
Yes, so
yeah.
beautifully we have negotiated into the head area.
Yeah, it's very difficult to insert guide wire to the tail portion, I think, because of the tight restriction here. So please negotiate the guide wire to the head portion. Yeah, okay, okay. We will, yeah, cystotome. Yeah, please coil the wire.
Coil the wire.
Yeah, more.
So the plan is we'll exchange the needle with a cystotome and then we'll again try to manipulate the wire.
Okay. Yeah, it's okay. I will remove the
Dr.
needle.
Nikhil, by the time it is exchanged, can we just shift quickly to Dr.
Sure.
Amit Sir's room?
Sure.
So we are going back in room 3, please.
Dr. Bing, in this case, okay.
Dr. Medhu sir, we are live back with you for a minute or so.
Okay, so I'm doing this piecemeal cutting now.
Sir, larger the tumor is, the bigger is the feeding vessel. So are you worried about bleeding?
Yeah? Yeah. So I just want to show you what we have reached. So before I proceed, I'm going to pass a gastroscope now and do a little cleaning of this area. Because now we don't know which polyps are removed and which are not. But that big bulk which was there, that seems to be already less. I've taken out quite a bit. Okay. Give a gastroscope and a rough neck. You see some of the pieces I brought out into the stomach. Now I'm going to take out this ERCP scope, put a gastroscope, and just clean that area a bit. And take out the polyps which are removed with a Roth basket. Then we can see the remnant polyps better. Suction on. Suction is not on. Suction is on. What is the vision? Maybe. Suction चल नहीं रहा है. Suction चल नहीं रहा है. इसको को रेडियो दें. Suction is होती है. Proper करो. Flush it, flush it, flush it. Let's catch it out first because that is stuck at the pylorus. Oh, this should be with a normal loop, not with a Roth. This should be with a normal basket. ये पकड़ लेंगे जाना जी. Other side, no? You want it out, no? Close it. What I'll do is with the scope only I'll try to push it in the duodenum. Yeah. It's got stuck at the pylorus. इसको पकड़ो. हाँ, अभी मत पकड़ो. पकड़ो. Don't flush water. Stuck होत नहीं है स्कोप में. Okay, give.
Dr. Medusa, we'll be just back with you in a minute.
Yes, yes, yes. Let me do a little toileting here, cleaning up.
Thank you, sir. Thank you, sir.
Once I get a little better view, you come back.
Thank you, sir. Room 2, please.
Right?
Dr. Song, we are back
with you in
room 2.
Balloon. Yeah, 4 millimeter. Yeah.
Are we online?
Yes, you are online, Dr. Nikhil.
Okay.
Wire across the cutoff. So what the plan is?
Yeah. Yeah. Please show the fluoroscope. Yeah, there is two, the stricture point, the neck portion and the body and tail portion. So we cannot insert the guide wire to the head portion or tail portion because of tight stricture. We try several times, but we cannot negotiate the guide wire. So in this position, we will insert the plastic stent to the dilated body portion. So then exchange the cystotome with 4 millimeter hurricane balloon. Floor, please.
Dr. Nikhil, which wire did we use for the exchange while inserting the cystotome?
Yeah. Yeah, straight one, yeah. 7 French, yeah.
Dr. Nikhil?
Yeah.
Which wire did we use for the exchange while inserting the cystotome?
So we are using VisiGlide 2 now. Initially for negotiation we had tried with Teremo, but it didn't work out.
Dr. Bing?
We change.
Dr. Nikhil?
Can you hear me?
Dr. Nikhil?
Yes, I can. We can hear you.
Okay, yeah. Floor, please. Okay.
We can hear.
Dr. Nikhil?
Yes, okay.
Please proceed with the question. They can hear you. We are just adjusting the mic here.
Okay. Yeah, dilating. Yeah, floor, please. Yeah, now we are dilating the track before plastic stent insertion. Yeah. Okay. Deflating the balloon. Okay. Remove the balloon. Yeah, floor, please. Okay.
Dr. Bing?
Yeah. Keep going the floor.
Yeah, Dr. Bing. For EUSPD, one requirement is duct dilatation, that should be more than 6. But second is duct should be opacified in the tail region. So in this case, it is very difficult how we can maintain that stent position in this small duct. Whether it be helpful in this case?
So that's what we were discussing. Now the issue is the tail is atrophied. We have checked his MRCP, we have checked her USPD. Tail portion is almost atrophied.
The voice from the room is not audible.
Yeah. Oh. Yeah, floor, please. Seven. Yeah, okay. Floor, please.
We cannot hear you.
Dr. Nikhil, we still can't hear you.
Okay. Floor. You can see the stand. Yeah, okay.
Yeah.
Change the view.
We are using a 7 French 7 centimeter stand. Stand is already negotiated inside.
Yeah, you can see the stand.
Now we are seeing the
endoscopic
endo view, release the distal part.
Yes, please. Yeah.
Excellent. So a pancreaticogastrostomy has been done using a plastic stent. The only thing is we could only drain the middle part because of the 2 strictures. Great demonstration, Professor Song. Thank you.
Thank you.
Thank you. I thank the chairpersons and the panelists for this session. Thanks for gracing the dais. Thank you, gentlemen. And the lady? Okay, now we are moving to our next session, and that is damage control. And for that, I am equally honored to invite the chairpersons on stage. I invite Dr. V.G. Mohan Prasad on stage, sir. V.G. Mohan Prasad, Dr. Monica Jain, Dr. Sanjay Rajput, Dr. N.H. Banka. And I invite the panelists, Dr. Shivam Khare and Dr. Ankush Bansal. Dr. Vineet Gupta, Dr. Ashok Dalal, and Dr. Soumya J. Mahapatra. I invite you as the panelist. Thank you. Over to the chair.
We are starting our session with a damage control. The topic is damage control, and to take the first session, we have Dr. Matthew Phillip. He will be talking on post-ERCP bleed. Matthew, sir, please.
Respected chairpersons, my dear friends and senior colleagues, I bring in greetings from Indian Society of Gastroenterology. I am thankful to the organizers for giving me this opportunity. When we talk about complications of ERCP, the commonest would be the sedation or anesthesia related, but other 4 major complications are pancreatitis, bleeding, perforations, and infections like cholangitis. Bleeding is quite, the incidence is quite low, only 1 to 2%. Mostly it is mild. My talk will be on this following outline. Briefly touch upon vascular anatomy, classification, risk factors, management strategies, preventive strategies, etc. When you look at the vascular anatomy, you can see 2 major arteries supply the ambula, and there is a big arcade of vessels in that region. When you look at the micro dissection, and you get a set of anterior arcade and a posterior arcade, and when you look at the ambula, here this is a cross section, we see that the black dots or arrows are all the arterial channels, but when you look at that, this area here is relatively low. So God has created the ambula in such a way that we can do ERCP and sphincterotomy. So when you look at the, in a clockwise, the ambula in relation to the vascular pattern, earlier we all thought that, we knew that it is from 11 o'clock to 1 o'clock is a safety zone. And still we see blood, bleeding with sphincterotomy. This is basically because the number of vessels are much higher there. A later study which has shown that when you look at from 10 to 12, the vessels are only 15 to 17% there. But if you go further, selectively between 10 to 11%, into 10 to 11 o'clock, it is only 10 to 11%. And also, you can see that only 10% of the total papillary arteries are in this particular region, that is from 10 o'clock to 11 o'clock position. And out of the 19 specimens they studied, that is by microdissection, 7 of the 19 people did not have any arteries in this region. So when you look at that, probably this is the safest region to go. So how do you classify the post-ERCP bleeding? It can be a minor bleed. When you do a ERCP, sometimes we see some oozing, or it can be endoscopically significant or clinically significant. The clinically significant is classified into mild, moderate, and severe, and this can be either time-wise, it can be immediate or delayed. What is meant by an immediate one is that is intra-procedure while you do the procedure, or immediately after sphincterotomy. You cut and come, when you withdraw the sphincterotomy, you can see, or while you are doing other procedures, you can see the bleeding on the table during the endoscopic procedure itself. Delayed is actually, it can be hours or weeks after the procedure. It can be late if it occurs after 2 weeks. What is meant by endoscopically significant bleed is one is that it obscures the visual field, making it impossible to proceed with the intended procedure. But now the quality of endoscopes, and there is actually water channel, everything is there. So this may not be very important, because we can actually make it possible to see the bleeding site, and we can do therapeutic procedures. And it even any degree of bleeding which continues after the therapeutic intent of the procedure is completed, still that is considered to be endoscopically significant. And when you see that the severity of the post-ERCP bleed, it can be classified into mild, moderate, and severe. And this is, I'm not going into details due to the time restriction. So I think these are very important to find out the amount of blood transfusion required, amount of hemoglobin drop required, and when you have to abort the procedure, all depends upon, and then how you classify them to mild, moderate, and severe. When you look at the risk factors for post-ERCP bleeding, it can be patient-related, procedure-related, and operator-related. If you take one procedure which actually makes the bleeding possible, the possibility of bleeding occurs is that is endoscopic sphincterotomy. And patient-related factors can be anything, and that can be cirrhosis, or it can be patients on anticoagulants, etc. So when you look at the risk factors, then we classify it again into definite or maybe or no. This is by significance by multivariate analysis, or what available from the studies available. So the definite one is coagulopathy, whatever be the reason. It can be cirrhosis, it can be on antiplatelets, on anticoagulants, or cholangitis prior to ERCP, bleeding during ERCP. When you do a sphincterotomy, when there is bleeding, that itself creates the possibility of high risk. Then the oleum in the center where your lower ERCP case volume is there. That is, they are considered definite factors. So when you look at the management, there is minor bleeding just oozing, which usually just controlled by itself, or endoscopically significant or clinically significant. And minor bleeding stops spontaneously, and endoscopically significant, you need to go for endotherapy in the same session, which can be following, which I will come to later. If it is clinically significant, you classify it as mild, moderate, and severe. And most important thing is the initial management is quite important, and also look at the comorbid conditions like coagulopathy, etc. And when it is clinically significant, the treatment varies according to severity. It can be mostly endotherapy, but also sometimes you have to resort to other modalities. So when you come to endotherapy, I think the most important thing is the usage of epinephrine. This can be used for spraying or clearing helps to clear the vision. Sometimes it also reduces the superficial bleeding. And injection of epinephrine is found to be quite useful, and it is the most common first line. So here actually you can see that while doing a sphincterotomy, you can see there is some amount of bleeding coming, and this can be coagulated with the same procedure. You don't have to do anything extra, and the minor bleeding can come down. Sometimes you have to coagulate it more. And while you are doing a sphincterotomy, if there is bleeding, you can actually use the balloon. Here actually it's a cirrhotic patient, so I used a balloon for further dilatation for stone removal, but unfortunately the patient developed bleeding, and I used a balloon to stop the bleeding for temporarily. But it's actually a very temporizing measure. You have to switch over to another one. And here after balloon terminate, I proceeded with the completion of the procedure. I put a stent, and I injected with 1 in 20,000 adrenaline. So that will make sure that the patient may not bleed, but not 100%. We have to keep this patient, a strong follow-up patient should be admitted and observed. And also we can try thermal techniques, but it is very seldom used. Here this is actually an ambulectomy case. I am using a coagulus for forceps and stopping that. Hemoclips are another thing which can be very carefully used, but sometimes it's technically challenging with a side wing endoscope. And you have to be very careful that you should not put it on the ambulary, or put it on the pancreatic duct orifice. Here we can see there is bleeding while cutting. We are just washing, we are trying to inject, but still it is continuing bleed. You have to better put a clip. You can see that we have maintained the guide wire there. And finally you can put a desired procedure, whatever you want to do. Rarely we use hemostatic powder, and in desperate situation where there is bleeding is not being controlled, I think this is, you can resort to a fully covered metallic stent. I don't know what's happening. Okay. Sometimes you require more than one measures. You can use injecting and also thermocoagulation in the same patient, and combination therapy is supposed to be slightly better than a single therapy. Here actually a bleeding occurred, we have put 2-3 clips, but still the bleeding is continuing. We have tried adrenaline spray, etc., but finally we resorted that the patient should be maintained on a fully covered metallic stent. So here is actually multi-modality therapy sometimes you require to salvage the patient. This is actually a video which shows two mistakes. This is actually a case of portal biliopathy, and we can see that this is actually a borrowed one. This we can see the cutting is done and using a balloon sweeping. If you should not use a large balloon, big size balloon sweeping in portal biliopathy, because sometimes that can lead on to severe bleeding. And once that happens, it is always better to put a stent and close it, and put a fully covered metallic stent. Unfortunately, here you can see this is uncovered stent placed there. So this patient was referred to me in this situation, and then finally we had to remove it. Actually, I put a fully covered stent over that, and then it was taken out. So what happens if there is recurrent bleeding? There is no accepted management strategies, but you have to adopt measures according to the availability at your center and the clinical status and severity of the bleed. And most likely, most of the patients will respond very well to endoscopy procedures, but rarely you resort to angiography, interventional radiology procedures, and rarely surgery. And this is one of the patients who had a bleed. You can see the clips there. In spite of all the measures, the patient bled and taken up for interventional radiology. What are the preventing strategies? Best is to identify the patient at risk, pre-procedural optimization, adoption of intraprocedural techniques, and discontinuation of antithrombotic agents. And you can actually follow the guidelines by the Indian Society of Gastroenterology, and that is very well written how to take up these patients. And it also has to be weighed against the risk of thrombosis. And of course, there are certain endoscopic strategies. One is the position and axis of sphincterotomy, which I told you, papilla cutting length, sphincterotomy with a needle knife is slightly high risk of bleeding, electrocontary, the current modality which you use, and when you use large balloon dilatation for stones, then the bleeding risk is slightly less. And also, as I've shown you that once there is some bleeding, you always do some submucosal injection to prevent further bleeding after sphincterotomy. So how do you manage this patient in a nutshell? Conventional measures for hemostasis. Epinephrine injection is the commonest one, followed by balloon tamponade, clip placement, etc. And if this fail, then don't hesitate to put a fully covered self-expanding metallic stents. If this is unsuccessful, then you need to resort to angioembolization of gastroduodenal artery or superior and inferior pancreatiduodenal artery. Very rarely you need to go for surgery. So what are the take-home points? Post-endoscopic sphincterotomy bleeding is mostly mild. You need to identify the risk factors and optimize before ERCP. And treatment is primarily endoscopic, which is quite effective. You need to keep a caution to avoid injury to the pancreatic duct orifice, and always try to maintain the access to the duct and complete the procedure. Because if there is a lot of bleeding, and then the whole thing will become a mess, you then find out it will become a difficult issue to get into the duct again. And fully covered metallic stent is a salvage procedure. So whenever you are doing with a high risk case, please make sure that this is available in your department prior to trying for this one. Interventional angiography is only considered in very rare cases and severe, and when the clinical situation of the patient is quite poor and endotherapy is not possible, or when endotherapy fails. This happens only with the recurrent bleeding situation. Surgery is very rarely used. Thank you so much for patient hearing.
Thanks, Matthew sir, for a lovely delivery of, you showed a lot of, videos, also how to stop the bleed. It was really nice. but due to paucity of time, we are not going to take up questions. So may I request you to
Thank you.
be seated. Thank you, Matthew sir. Now there is a war going on between the second space and the third space. But ultimately, I think the third space one, we will request Pankaj Desai to come and deliver his talk on how to prevent complications, how to manage complications of third space. Of course, Raju Wadhwa has to wait for his talk. Thank you. Over to Pankaj.
Good afternoon, and I thank Dr. Randhir Sood and the entire team of Medanta for this kind invitation. Respected chairpersons, very quickly, we will go to managing the third space complications. As we have been seeing the entire 2 days now, that third space has advanced into a lot of procedures starting from POEM, going to POEM F, STIR, G POEM, Z POEM, diverticular POEM and PRAME. And there are incipient complications which are related to these procedures, and they are roughly divided into 3. That is a pre-procedural, that could be in POEM would be aspiration of the esophageal contents. Intra-procedural, what we are going to deal with is insufflation related, injury to the mucosa and bleeding. And post-procedural, that is delayed bleeding, mucosal barrier failure and infections. The major complications related to are causing hemodynamic instability or premature termination of procedures, bleeding which would require transfusion or re-interventions, and mucosal injury causing a long stay or some special closure techniques. And then of course the sepsis. There are very specific procedure related problems, as like in eclasia, the complications or the risk factors would be due to unhealthy mucosa, sigmoid esophagus, prior treatment, prior Botox or prior surgery, a lot of food residue and candidiasis. Very important when you are dealing with large esophageal tumors, more than 3 centimeters, doing a stir sometimes causes a lot of complications. Tumor originating from the muscle or tumors at the cardia, you can get lost in the tunnel, you will not find it, or an extra luminal tumor. Similarly, the other would be scarring in the antrum during because of gastroparesis during G-POEM, or large size of a diverticula, as you saw in Amol's case. These can lead to complications. The most important is insufflation-related complications, and these as inadvertent in the third space procedures because the submucosal plane is close to mediastinum and the peritoneal cavity, and we are going to utilize this space only to do all the procedures. So now this is a brief diagram which would show you that when you are operating in a submucosal area in the mediastinum, because of the spaces, the retropharyngeal, carotid or visceral, the CO2 can leak out into the neck, go into the upper limbs. Similarly, it can go into the retroperitoneum, extraperitoneum or the peritoneal spaces. So this is very important to understand that all these spaces are interconnected, and therefore because of the continuity between the neck, mediastinum, retroperitoneum and pelvis, we can have a lot of CO2 insufflation related complications. Now what we can get is, this is a lot of complications like subcutaneous emphysema, pneumoperitoneum, retroperitoneal air in the mediastinum, pneumothorax, pericardium, and majority of them would not require management. Though high incidence is written in literature up to the tune of 54 to around 90%, these are, however, only 6% of these patients would require interventions. So therefore, not all gas-related events requiring intervention should be categorized as adverse events. These are a part and parcel of the procedure. So out of this, significant is only 1.6%. And what are the risk factors? Use of air is a disaster. So we should be sure that you are not using air and using only CO2. Don't create a narrow submucosal tunnel, whatever procedure you are doing. High flow of CO2 should be reduced. Continuous heavy burst of current during tunneling or myotomy will cause these problems. And use a knife with water jet so that you reduce the number of exchanges and reduce the complications. Operator-related problems are long operative time and, of course, during the learning curve. And how would you diagnose these? abnormal distension of the abdomen, increase in EtCO2, the peak airway pressure going more than 30 centimeter of water, and fluoroscopy, of course, if it is there, showing capnoperitoneum or retroperitoneal CO2. And how do you prevent this? The first is use CO2, very low flow, use a wide tunnel, apply, and there are few tricks which you, depending on the machine you are using, you can use a three-way valve, you can use some things like this that you can tie gauze, and or maybe you can use other low flow machines which are available. And these decreasing the flow of CO2 in these studies by Mohan and Familiari have shown that these will reduce the complications related to insufflation. Now, when you have a complication, when would you intervene? Surgical emphysema usually resolves in 24 to 48 hours, so you don't need to do anything. Capnoperitoneum and retroperitoneal CO2, what you do is ventilatory parameters. If the tidal volume is more than 50 and clinically significant distension, then you have to intervene. You have to do a gastric decompression, temporarily stop the procedure for 10-15 minutes, allow the anesthetist to wash out the excessive CO2 by increasing the positive end expiratory volume, increase the respiratory rate and giving 100% oxygen. So you have to take rest in between the procedure. And then of course you can do a needle drainage. And how do you do a needle drainage? Select area on the right upper quadrant, and as you can see here, put a needle 16 gauge intracate with saline and allow the CO2 to escape. Sometimes if the procedure is going to take long, it's very difficult to hold this. So we have devised this with the help of our friend from Australia, Rajwinder, that he put a coffee cup like this so that the needle can be supported. So these are a few tricks which you can do to see the CO2 escape. Retroperitoneal CO2, again, you can do drainage with the needle. For retroperitoneum, I think it's just a matter of pausing and changing the ventilatory settings. Capnothorax sometimes needs an ICD, and capnoperitoneum pericardium, only 2 cases have been reported, but this is life-threatening, so we should be on a watch out for this. So for gas-related events, the prevention is, again, use CO2, low flow, positive ventilation, observe all the parameters, and anything goes beyond the accepted limits, change, and management is pause, do gastric decompression, ventilatory settings adjustment, and drainage. Mucosal injury is disastrous because mucosa is the only protective layer between the lumen and the mediastinum or the peritoneum. And there are 3 types of injuries which have been described. Type 1A is mucosal scalding. You just see a small red spot or a white spot. Type 1B is a superficial mucosal injury, and type 2 is full thickness perforations. So 1A and 1B are easy to repair, but should be repaired. Don't leave anything to chance. I will show you. These injuries occur in around 4.8%, more at the G junction. Discoloration, blanching and perforations as can be seen, and the reasons would be either thermal because of electrocautery, injudicious use, or mechanical. So, and the risk factors are unhealthy mucosa, excessive fibrosis, inadequate submucosal lift that you get, or in an anatomy which is esophagus is tortuous, diverticulum is there. Anterior poem is said to cause more risk of perforation because the knife can fling. This is the classification of the mucosa, EMIA classification, and in the last 3 types, there is a higher risk of perforation of the mucosa. And of course the fibrosis, as you can see, this 4 types of categories are described, and when you have severe fibrosis type C and type D, there is high risk of causing mucosal injuries. These are a diagram which is showing you that in sigmoid esophagus, because of the excessive shaft force, there can be excessive pressure on the mucosa and the mucosa can give way. This is for anterior and posterior. Now, clips can fall off delayed. So we have completed the procedure, but then after after a couple of days, you can see the dehiscence of mucosal clips, and this is because the initial mucosa was edematous, thick and friable, and this will cause delayed perforation. And these are some of the situations which you see. Large necrotic area, necrosed mucosa. You can see here the patient has a leak going down in the tunnel, and you can see here this is mucosal dehiscence. So in these cases, there is very high risk of causing sepsis or causing empyema or peritonitis. And in these cases, what we have to do is to prevent, use your knife judiciously, inject more, keep the direction of myotomy and perpendicular to the muscle, avoid prolonged bursts of spray coagulation, avoid accessing traction during myotomy, and don't let the knife fling and injure the mucosa. If there is fibrosis, reduce the power and avoid spray coagulation. Inspect the mucosa post-tunneling and post-myotomy, and any small area which is doubtful, you should clip it. And if the tissue is healthy, use hemoclips. Large defects, you can use over-the-scope clips or endoscopic suturing. But if the tissue is unhealthy, surgery or placement of SEMS is advised. So these are examples. You are using a SEMS in the first case. We are using a loop and clip closure because of this very ragged incision in the second case here. And we are using only clips in the third case here. Post-closure, observe the patient, keep the patient inhaled perorally at least 2 to 3 days depending on the clinical scenario, good nutritional support, and if required, use vacuum therapy. So the last, we will come to bleeding. Intraprocedural bleeding is very common because of thick mucosa sometimes, and this is more frequent in cases of long-standing achalasia and stasis. So choose an appropriate avascular area, and sometimes dichromatic RDI, if you have the facility, would show you that this is a good area. Now sometimes what happens is when you have a bleeding during entry, it will spoil your field of vision. So it is very important that you identify the bleeder and do a good hemostasis with a soft coagulation using a 40-watt setting with a coag grasper. Pre-coagulation is very important. That is, identify the vessels. You can see in this here that when we are dissecting in the Silhout, you can see this is a big vessel. So what we do is inject around the vessel, catch the vessel at the base, catch a little above, do a precise coagulation. I call it cooking. So cook the vessel properly. Otherwise, even after, if you do an half-hearted coagulation, these can bleed. And this is one more example here, doing a myotomy. You are seeing that nothing is happening. The moment you cut, there is a spurter. So what you do, press by the cap, get your coag grasper inside, identify the bleeder properly, and close it properly. So these are the tips. Do not panic when there is bleeding, and use your cap to tamponade. Delayed bleeding is there, which is can be managed by sometimes only doing a balloon tamponade, or sometimes you may have to remove the clips, go in the tunnel, remove the clots, identify the bleeder, and then stop the bleeding. Infections, when you have a leak, this is the last video which I would like to show, that we had one perforation which was a delayed perforation, and this I had taken. So what happens is there is a large esophageal rent which you cannot close. So this is our laparoscopic surgeon coming to our rescue. This is a big defect, as you can see here. And once they identify the defect, and there was a lot of necrosis and pus debris in the chest thoracic cavity, it was cleaned, suturing was done over a tube, and the patient could be salvaged. We had to do a feeding jejunostomy in this case. So very important is we have to be very careful in these procedures, selecting our patients, and the strategy to prevent infection is insufflation, we have already discussed. For infection, prophylactic antibiotics and aspiration of esophageal contents. Mucosal injury, we have discussed all the points, how to avoid. Prevention is always the best in third space endoscopy of complications. Thank you so much for your kind attention. And any questions, if there are, I will be ready to answer them, please.
We are going live for 1 minute. I am thanking Dr. Pankaj Desai for excellent lecture as usual, and I would like to invite Dr. Raju Wadhwa for another complication of ERCP and perforation and prevention and treatment. Sir, we are live.
We are live, sir.
Amitji, can you hear
Yeah.
us? Yeah,
So can
beautiful.
you see
Beautiful.
now what I've done? The whole thing is out.
Yeah,
Am I audible?
Yeah, very well. As we predicted, you did a fantastic job. So.
And I've put a stent in the pancreas now, prophylactic pancreatic stent. And now I'm going to try to cannulate the CBD. Let me see where it is.
Amit, so this ultimately was an ampullary adenoma.
Right? Ampullary, and plus there was a lateral component over here on above, you see here?
Oh yes.
So I've removed one over there and one on the ampulle.
Wow. Sir, it looks like a different case only now. We are not seeing any ampullary adenoma now.
No, wait, don't be in a hurry. Fluoro on, please. Yeah, now you have one.
Actually, this case was managed by me, and
so
we
the
were
fluoro
thinking of
up.
surgery actually. It
Pardon?
was so big. I am Dr. Nishavan here actually.
Yeah.
I was managing this case, and we were thinking of surgery. Now there is no polyp there. So thank you so much.
Thank you. Okay, I'm going to do a little bit of sphincterotomy, but now if you see at the apex, there are some blood vessels there at the place of the resection.
Amit, did you encounter any bleeds while you were doing the ampulectomy?
Yeah, during the procedure there was just mild oozing.
But we don't see any clips, so there was no major arterial bleed.
No major artery just now, but I'll just show you something. Let me put the biliary stent first, then I'm going to show you something. You will see that part above apex where there is a little blood clot there.
Yes.
There I have a feeling there are some vessels which may bleed later.
Wow.
So what I'm going to do is, after I place the biliary stent, I'm going to take the coag grasper and coagulate that area a little bit and also apply a hemoclip at the apex from up, catching all the tissues together.
Yeah,
so,
that makes sense.
When you remove the PD stent, you may have to widen the pancreatic duct opening a little. Today I've done a small papillotomy, but that may stenosis because there is a lot of charring in that region. 15 days maximum because the pancreas is normal. No? I say so initially even I thought that I'm going to land in trouble, how I'm going to take it out, but in such a situation you have to be piecemeal. Don't try to catch the whole thing together, it's not going to be possible. But one by one if you start debulking, then the whole anatomy starts revealing itself. So now let me place bile duct stent. And after that we will achieve the hemostasis part. Oh, this is buckling. So how is it? Okay.
It's okay. Sir, we are starting our lecture here. Switch on.
Okay, out.
Sir, we are starting with the lectures, so we will be stopping the live transmission if that is okay, sir.
Okay.
Okay. Thank you so much, sir. Very good.
So, big round of applause to Dr. Amit.
Good afternoon, dear friends. At the outset, let me take this opportunity to thank Dr. Randhir Sood, Rajesh and Sukrit with the whole team to allow me to stand here and to speak on this important topic, which is relatively uncommon but a dreaded one. The incidence is much less than the other complications of bleeding and pancreatitis, but has a higher mortality rate here. Generally, there are risk factors which can be divided into patient-related, like abnormal anatomy, elderly patient in female sex, or those with procedure-related. Pre-cut needle knife is one of the important aspect of the perforations which we encounter, especially if this needle knife is handled by an inexperienced endoscopist. There are 4 types of perforation. The type 1 is the lateral wall perforation, which is a free perforation in the peritoneum. occurs due to sheer mechanical force on the bending of the scopes, or a recoil injury which comes onto the lateral wall when you suddenly release the pressure out of it. The type 2, or the commonest one, is periveterian, which occurs during sphincterotomy or during a pre-cut sphincterotomy, and is the most common injury. Type 3 is either a biliary or a pancreatic duct injury. They are also relatively common, probably underappreciated, especially if this injury occurs in the bile ducts, intrahepatic bile ducts. And type 4 is when you appreciate the air in the retroperitoneum, but you don't have any visible mucosal tear to tell us that there is a perforation here. Now coming to the specific risk factors for a specific type of a perforation, the type 1 or a free perforation occurs more commonly when you have a stenosis of the upper GI tract. In the post-operative upper GI tract also it's very common because of the abnormal anatomy. You have situs inversus. Rarely you can get it, as I will show that, when you are doing a large sphincterotomy and you are trying to pull the stone out, or a large stone with a lot of pressure, there could be a recoil injury in that. The type 2 is the commonest one, which occurs more commonly when you go beyond the traditional landmark of 11 to 1 o'clock position, causing a sphincterotomy. If you use a disproportionate size of balloon as compared to the lower CBT diameter, normally it should be equal or less than the lower CBT diameter. The larger the size of the balloon, the higher the risk of this. We have just seen the papillectomy or ampulectomy, which could be an increased risk factors. Diverticulum and needle knife sphincterotomy in type 2. Biliopancreatic stricture dilatation increases the risk of type 3 perforations, while type 4 perforation there are no specific reasons, but it is most often asymptomatic and you can only detect a retroperitoneal air. It does not require intervention in majority of circumstances, so we will not go much about it. Such air occurs presumably due to dissection through the intact bowel wall or due to sealed microperforations. Now these perforations can be clinically graded into mild, moderate or severe. Mild is when you have to abort the procedure, you have recognized it, requires an unplanned hospital admission but does not require an intervention, and patient goes back home healthy within a period of the next 4 days. When it is unplanned admission requiring an intensive care at least for 1 night and a need for blood transfusion, then it goes to a moderate category requiring intervention in these circumstances. Those which require the long ICU, prolonged ICU stay or the need for surgery are graded as a severe perforation. How do you prevent it? An essential element is to understand the anatomy completely before we actually put in the scope. So evaluate before ERCP. Any suspicion of narrowing in the upper GI tract, an ERCP scope should be preceded by an upper GI scope and then go on to do the ERCP. Insertion, almost all accessories are now guide wire associated. They should be done with the guide wire to reduce the chances of entering into the tissue, unintended entry into the tissue, especially in the papilla. Soft tip wire, which prevents the false tract formation. Avoid overbowing of the sphincterotome and a zipper cut, which we also used to call it as. Needle knife should be learned properly before handed over to an inexperienced endoscopist, because that's the highest risk of perforation. Of course, the size of sphincterotomy and sphincteroplasty, we should be careful and choose suitable for the need. We will take some of the management thing based on the cases. A 35-year-old female presented with abdominal pain, fever and jaundice, underwent ERCP for multiple large CBD stones and required a mechanical lithotripsy. While it required a lot of pressure and suddenly there was a recoil injury, as we can see that. You can see a large stone in the papilla with a large sphincterotomy done there. While you are trying to crush the stone, you have the recoil injury and you realize that you have perforated. Now unfortunately in this you had an additional complication, that the fragments of the stone have gone into the peritoneal cavity. Here, before we removed the stone, placed the stent, but realized that through the perforation, the stones have already gone into the peritoneal cavity. So you cannot just close the defect, leaving the stones in the peritoneal cavity, which is a sheer disaster. So each of these stones were carefully removed, fragments. From the perforation, and then over the scope clip, was used to close the entire defect completely. This patient surprisingly did not even complain of minor pain post-operatively. So the important thing is the recognition of this during the procedure, identifying and closing the defect completely. This is an endoscope done about 2 months after the procedure, which shows a complete healing and a clip still in position. So probably the most important thing here is identifying the procedure and then taking a recourse immediately. This is another similar case, which was where while taking out the stone, there was a recoil injury, and those people who are third space enthusiasts will identify this particular thing and clearly tell that this is a perforated duodenum. A similar hole on a pudgy-scope used the multiple clips here, large clips to close the defect immediately as soon as the identification of injury was identified. So this is the type 1 injury. The type 2 injury is, this is a patient which had an inadvertent cannulation of pancreatic duct, and subsequently you can realize that there is a long segment of the bile duct, so a long sphincterotomy was attempted, and you see a very typical perforation. This is a retroperitoneal perforation. It will give a triangular air. That's the identification mark. This air will usually not cross the mid-clavicular line on the right side. On the left side, it will be near the spine, and there will be under the liver. It will be restricted. This gives you an idea that this is inside the retroperitoneum. Now, what do you do in these circumstances? You immediately took measures of putting a nasobiliary drain and then reduce the nasobiliary drain so that you are actually bringing the mucosa very closer, so that the leak stops, and as you can see 48 hours later the leak has completely healed off. There is no actual leak when a thing is taken from NBD. NBD additionally helps here because it gives you can give a mechanical traction for the closure of this. The same thing can be done in another circumstances. This is a similar perforation. As you can see that you have that triangular air in the retroperitoneum. Here you can put a metal stent to actually close the perforation completely. Fully covered metal stent which can be removed after 3 to 4 weeks so that the perforation can be complete. There are a few uncommon types of perforation which we can encounter. These are not standard class under the standard classification. There might be some colonic perforations due to migrated stent. Diverticulosis remains the risk factor. This is usually almost always a delayed, or there can be a perforation on the contralateral wall of the duodenum due to the stent which can perforate through the bowel wall. Now, whenever you encounter the perforation, we need to keep in mind that there are 4 R's which you need to do. The first is to recognize, make an attempt, and believe me, a proper watch on to your patient. 70% of the perforation can be identified on table. And once you recognize it, react in the sense to see the severity of perforation. If you feel that you can manage this perforation on table, preferably you should finish it off. Closure of the perforation on table, especially if it is a type 1 perforation. If you cannot manage it off, make sure that you reach out to your colleagues. This is an important aspect. Your surgical colleagues will help you. It is believed that if you have a free perforation, The surgery done within the first 24 hours gives a much better result than the delayed surgery, which causes a far higher morbidity and mortality in the long run. Once you have taken up the closure measures, either endoscopically or surgically, then revisit. Of course, it is necessary for all of us to understand that these patients need to be kept nil-per orally and supported with antibiotics during these management measures. If you successfully close this perforation, make sure that you rejoice. You have come out of a difficult situation. So you can take this as an algorithm, evaluate the perforation risk before, initial evaluation by gastroscope if you suspect an upper GI block. If there is no, you can go for direct ERCP. You can classify the perforation either type 1 or type 2 and type 3. Type 3 can be taken up for conservative treatment. I have not discussed much about it. It is usually NPO and IV antibiotics with or without the nasobiliary drain. Type 1 or 2, identification is important. If you identify, make an attempt to do an endoscopic closure. If you can't do it, then reach out to your surgical colleague. They are the best friends in these circumstances. Thank you very much for your patient listening.
Thanks, Raj Wadhwa, our evergreen hero, for a beautiful presentation. We'll just have a quick comment from the panelists before we adjourn for lunch.
So Shivam here. So very nice presentation, sir. Sir, in type 2 perforation, if you got perforation during balloon dilatation, CRE balloon dilatation, can we, what is your experience during this time?
The first is identify that. If you have it, there are some ways patient, there will be definitely, if the patient is not under deep sedation, the pain intensity will increase. You can keep your hand on the back side. You can have an emphysema on the back in these situations, in some of these circumstances, apart from the radiological identification which I have just described. These emphysema, if you persist, can actually subacute emphysema can go into pneumomediastinum. It can cause a pneumothorax also. But none of these requires majority of the times any intervention. What you need to do is not to panic. Make sure that your CBD is cannulated. I will prefer a nasobiliary drain for 24 hours because I can use a traction of the nasobiliary drain to close the opening. If it's minor, if it's a major opening, large opening seen directly, I will use preferably a covered metallic stent to close then and there only.
I think we'll stop here because we are running behind schedule. Please forgive us, sir. Thank you.
Thank you, everyone. Now we move to our next session. I thank the chairpersons and panelists for sparing their precious time. We have another session, How I Do It, the video lectures. And for that, the chairpersons invited on stage are Dr. Sanjeev Sachdeva, Dr. Ramesh Roop Rai, and Dr. Sethu Babu. Welcome, sir. The panelists are invited on stage. Dr. Chalapati Rao, Dr. Munish Sachdev, Dr. Kapil Sharma, Dr. Prashant Solanki, and Dr. Rajneesh Gulati. We are having our panelists and chairpersons. Over to the chair.
So, good afternoon. The first lecture in this series, How Do I Do It, is by Dr. Bing Hu from China. He is going to talk about endoscopic appendicectomy.
Good everybody afternoon. I'm being from Western China Hospital, China. So I order to shine my presentation, and that's big pancreatomy. My first endoscopic pancreatomy started in 2019. Published in the endoscopy 2019. Now I have complete 40 cases of endoscopy pancreatomy. Any complication? A new treatment option. Not this pancreatomy like the flower. This flower is transfer the National Cancer Center, Japan, anatomy center, director of anatomy center, Professor Sato. This Sato, Professor Sato, is a conference says pancreatomy is 4 cities. Now, last year, my team published in endoscopy reported the 13 cases endoscopy transfer endoscopy. Now, this 1, 2, 3, 4, the step. So we show the process. This adenoma, NBI, and nickel color. And that origin in the middle. So first step, around the nation, I do the marking. After marking, I use a dual knife around the nation. Incision the mucosa. Now the mucosa incision, submucosa incision, we use a 80 knife incision muscle layers. So we can say the serosa. Now I separate the submucosa. We can see the panicles. Panicles in the top column, the right side is panicles. Now I use a snare, check the panicles. We can see the panicles. We must patient to the panicles at home. Use a gospel coagulation, control the bleeding. No? This video is don't continue. I use a snare, check the appendix. So I use a IT knife incision. It's an IT knife. This video working is not good. Now I complete incision the appendix. I use the snare to get out the specimen. Now the specimen already get out here. So the next step, we close the use the clip and the loop. This clip the loop. This is not the clip. I use after the last dip, I use check the loop the tail. And tight the loop. So I, because the appendix is position, so I do the double closure. Use a clip. Reduce the pressing. So the patient, after that, there will be maybe conditions where no complication. Thank you.
Thank you, Professor Bing, for an excellent video presentation. Any two questions from the floor or from the panel?
In presence of the inflammation in the cecum, which is already diseased, because once we have appendicitis, the cecum is also involved. Then where you go from the, apart from the cecum, can you go from the ascending colon and reach the appendix and take out?
Now, well, we set up a baseline first the incision, the mucosa, submucosa, and muscle layers from the no pollution to the high pollution with incision around the nation.
What is the timing of appendectomy? Do in acute setting or you do after 4 to 6 weeks?
Why?
Timing of appendicectomy, is it immediately in the period of appendicitis or after 4 to 6 weeks?
Oh, we do the appendectomy indication adenoma, submucosal tumor, but no appendicitis.
So basically non-inflammatory conditions.
Yeah.
Tumors. Thank
Yeah.
you so much. So
Yeah.
with this, we'll wind up this session and we'll reassemble after 20 minutes after lunch. Thank you, Dr. Bing. Thank you so much.
Thank you.
Karan. Hello, Karan. Check one. Check. Hey, hello. Hey, testing. Hello.
Hello everybody. Good evening and welcome back to the post-lunch session. And because of the time constraints that we have now 2 lectures. This last session was split up. And the delay was because some cases were so exciting that we didn't want to break for lunch and we just continued. So now, after Dr. Binghu's lecture, we have 2 remaining lectures which will start at 2:45, which is another a minute or so. The first speaker is going to be Dr. Praveer Rai, and Dr. Praveer Rai from SGPGI needs no introduction. And so may I please request Dr. Praveer to come on the stage and deliver his lecture.
Very good afternoon. I'd like to thank Dr. Sood and his team for this wonderful conference. I'll be talking about US-guided therapy for fundal varix. So as you all know, gastric varix occurs in around 20% of patients with portal hypertension, less common than esophageal. However, the bleeding is most severe and associated with higher mortality. The cumulative risk of bleeding of incidentally detected gastric varix is to the tune of around 44% at 3 years. And mortality from the first varicose bleed is to the extent of 20%, and that's the reason you need to manage it adequately. So this is classification of gastric varix, GOV1 along the lesser curve, GOV2 predominantly cardiofundal varix. If you see the percentage, around 23% is constituted by cardiofundal varices. The GOV1 shares the vascular anatomy similar to that of esophageal varices and same response to treatment. However, the cardiofundal varices need to be managed in a bit different way. So this is AGA guidelines 2021. They have clubbed IGV1 and GOV2 as cardiofundal, GOV1 as lesser curve gastric varix, and IGV2 as distal gastric varix. Treatment options: endoscopic therapy, transvenous obliteration, TIPS, and surgery. You need to be aware of all these treatment modalities because only one treatment modality does not do for all cases. So endotherapy with cyanoacrylate is the initial treatment. However, treatment requires a clear field of view during endoscope retroflexion, and the intravascular needle placement may be inaccurate. So that is a problem. Hemostasis 60 to 100%, significant rebleed rate to the tune of around 40%. And intervention radiology guided procedures have promising results. However, there are certain limitations. So what are these we need to be aware of? TIPS has the risk of encephalopathy or shunt dysfunction at long term. BRTO requires a gastrorenal shunt and does not divert the blood flow. In fact, BRTO increases the portal pressure, leading to worsening of esophageal varices or ascites. So this important article 2018 I want to make you aware of. 27 reports, 11 organ dysfunction, 7 deaths reported with endoscopic cyanoacrylate glue injection. Very important to remember. So why US-guided therapy allows detailed assessment of the complex vascular anatomy, detection rate of gastric varix is increased, precise delivery of glue into the varix lumen, you expand the available treatment options, that is you can use coils which you cannot use just with endoscopic glue, and Doppler confirms obliteration after treatment, so you have real time, you check whether the varix is obliterated or not. It can be done without direct varix visualization, that is even in the presence of food or blood in the stomach, you can perform this procedure under US guidance. And US can identify the main feeding vessels which minimizes the cyanoacrylate needed for obliteration as well as reduces the embolization risk. So what devices do you need? You need a linear US scope, 19 gauge FNA needle, sometimes 22 gauge if you want to use thinner coils. Coils of different sizes, 10 to 20 millimeter, cyanoacrylate glue and sterile water. This is all what is needed. Very important to know about glue and coils. So coils predominantly are soft platinum wires with spaced synthetic fibers, and they initiate the thrombus formation. Very important to know. And coil acts as a scaffold to retain the glue within the varix, which decreases the amount of glue required for obliteration and reduces the risk of glue embolization, which I showed that deaths have been reported with this. So when you see the coils, they have got 3 numbers here. So 35 means 0.35 size of the needle that is needed, that is 19 gauge needle. 14 is 14 centimeters the length of the coil that you will get, and 5 millimeter is the diameter of the coil that you are going to get with this. So you can have this 5 millimeter, you can have up to 20 millimeter. Length is usually 10 to 14 centimeters, and this can either be 35 or 18, that is 0.18. You need a 22 gauge needle to pass that particular coil. So this is how it looks like when the coil is along with the glue. So technique, patient needs to be intubated and placed in the left lateral position. Why intubated? Because you instill a lot of water, and this water you instill primarily because you want to confirm the gastric varix. You want to be sure that you are injected only the gastric varix and not the collaterals. You need to trace the perforator if possible or if required, and you can use a 22 gauge needle or a 19 gauge needle. What we usually use is a 19 gauge needle, which goes either transesophageal or transgastric. 1 or more coils are sequentially placed into the target vessel. No definite data whether varix itself or perforator should be targeted. So we have some reports of perforator also. And Doppler during coil placement can be used to guide the number of coils required. Fluoroscopy without varicillography can be helpful, but is not required. And after significant reduction in Doppler flow, cyanocrylate is injected. You do an upper GI, look for the varix on endoscopy, and then you perform the EUS. So this is what the gastric varix looks like. You inject a lot of water just to be sure that you have some mucosal gastric varix in place and not the perforators. You puncture with a 19 gauge needle, and then the role of the technician becomes very, very important. The technician has, after puncturing, you flush with sterile water, and then you load the coils above like this. So once a part of the coil goes inside, and then you remove the upper part that is being used, disconnect it, and then use the stillet again to push the rest of the coil into the gastric varix lumen. So now the coil is being pushed in further, and this goes down, and then you will see this coming out in the, so the role of the technician again becomes very, very important. And then it goes, then you can see this coil coming out. Once you inject first coil, again flush with sterile water. Very, very important, otherwise the blood goes in, it clots, and you will not be able to pass the second coil. Now the second coil is being deployed. After deployment of second coil, you again flush, and then you pass in the glue. This is the glue that is being injected, around 1 to 2 ml of glue depending upon the need, and this is what you achieve once you have injected the glue as well. So what are the results? So this is a systematic review which tells you whether you should be offering coil plus glue or coil alone or glue alone, and there is hardly any doubt that technical success is more, clinical success is more, rate of adverse events is less, rate of reintervention is less, rate of rebleeding is less if you are using coil plus glue. This again a systematic review and meta-analysis of 28 studies, around 3,500 patients, 2020 endoscopy, which tells you that when you're using an EUS guided coil and glue, then compared to endoscopic glue alone, you have more obliteration of gastric varix and recurrence of gastric varix is less. This conclusion of this systematic review is EUS guided therapy demonstrated clinical efficacy for treatment of gastric varix in terms of obliteration, recurrence, and long-term rebleed, and may be superior. So it's may be superior to endoscopic glue. That means we still need some randomized controlled trial. This slide is very, very important. This again has been suggested in Beveno 7. What this slide tells you is this is the Saad-Caldwell classification, and this classification of gastric varices into 1, 2, and 3, what you need to understand, they have divided 1, 2, and 3 into A and B. B predominantly means that the presence of a gastrorenal shunt. What does that mean? That means that if you are doing endoscopic US guided glue, you should be doing a CT and MR in each and every patient just to pick up gastrorenal shunt, because gastrorenal shunt is mandatory if you are offering, if you need to offer BRTO to the particular patient. And why this becomes further more important is this guideline again, which came in 2021. What this tells you, if you have a Saad-Calvert classification type 2B, that is presence of shunt in the cardiofundal varix, or again 3B, that is presence of a gastrorenal shunt with lesser curve cardiofundal and in the varix, then you need to offer BRTO as a first line treatment option. Though at this point of time, I would disagree with this because we don't have a good study comparing BRTO with US, but this is the evidence that you have as of now. So to summarize, gastric varix bleed occurs in around 20% of patients with portal hypertension and has a higher mortality. Early detection and control of bleeding is important. Endoscopic gastric varix obliteration by glue without lipidol is the treatment of choice. US guided combination therapy, that is glue and coil, is safe and effective. It appears to be the preferred approach for bleeding gastric varices. However, the current use is limited by cost and access to an experienced endosonographer, and further studies to determine the choice of targeted vessels, that is intramural or perforator, size and number of coils, type of injectate used, and cost effectiveness is further required. Thank you.
We will take the questions after the other lecture. Okay. I invite the chairpersons again on stage. I invite Dr. Sanjeev Sachdeva, Dr. Ramesh Roop Rai, Dr. Setu Babu, and the panelist Chalapati Rao, Dr. Munish Sachdev, Dr. Kapil Sharma, Dr. Prashant Solanki, and Dr. Rajneesh Gulati, and the speaker, sir.
Now I invite Dr. Amol Bhapai to talk about closure of endoscopic defects and perforators. You have just seen him on the screen a few minutes back. Thank you.
Good afternoon, and thanks, Dr. Rai, and thanks to Dr. Sood and his team for this kind invitation. So the topic given to me is closure of endoscopic defects and perforations. It's quite a large topic. We'll try and cover as much as possible in 10-15 minutes. So perforation, we know, is the most feared complication of GI endoscopy. It is relatively rare, but it's still unpredictable, more commonly seen with therapeutic procedures, and when it occurs, it definitely has significant morbidity, mortality, and the management differs depending on where it is and how big it is. More importantly, it can increase significantly the cost of care, and it can have medico-legal implications as well. So, common clinical situations where we can have perforations, of course, apart from the post-surgical ones, is endoscopy and instrumentation, particularly with simple things like dilatation, polypectomy, with EMR, ESD more commonly, even with sclerotherapy or Zenker's diverticulotomy, even with overtube sometimes we can get, and sphincterotomy related perforations can also occur. I think that has been covered by Dr. Wadhwa earlier, so I'm not going to talk. It can also be disease related and foreign bodies, spontaneous, and intentionally we sometimes do a perforation when we are performing POEM or notes procedures. Presentation of these patients: they will have unusual abdominal pain with distension, chest pain, subcutaneous emphysema, dyspnea, and rarely they may have SIRS, hypertension, and confusion as well. Early diagnosis, we need to remember, has an impact on the outcome, and therefore a high level of clinical suspicion is important to identify the complication early enough. And getting a CT scan done is usually the best way to identify and is the most sensitive way to identify a perforation if it has occurred. The principles of treatment: remain early diagnosis, followed by containment of the leak by either closing the defect, sealing the defect, or by diversion. Drainage of the cavity, in case it's a little bit of a delayed presentation, then we have to do contamination control, antibiotics, and nutrition supportive care. And traditionally, surgery was the treatment of choice, but we all know that these are post-operative patients. It's an iatrogenic problem often, and some of the locations are quite difficult to access surgically. Patients are compromised, they are high risk, and the surgery has significant morbidity and mortality and costs as well. And therefore, we have several endoscopic methods also. We have endoscopic, percutaneous, and surgical options in treatment. And currently, the new paradigm is that we can achieve most of the desired outcomes, like containment of the leak and clearance of infection and supportive care and drainage by endoscopic methods, and which avoids surgery and kind of provides more recovery. So, several devices have been there and have been described. We have several types of clips. I think there are at least about 10 clip companies which make different kind of clips. And we also have the full thickness clips which are available, which are much stronger. We have the endoscopic sutures, and of course we have stents, or even we have endovac therapies. A word about the strength of the closure. When we talk about endoscopic clip closure, we have to remember that it is primarily a mucosal closure, whereas the eagle claw or the endoscopic suturing is much stronger, but hand suturing or surgical suturing has probably the best strength. But what is important to remember is, we have to, when we are closing with endoclips, so fresh perforations will usually be more amenable for clip closure. But if they are chronic, we need something much stronger than that, because otherwise, because of fibrosis, there will not be optimal closure. So I'm just going to show you a few videos as to what how perforations can be closed. So this is an EMR, and you can see that there is a defect over there, and we have used clips to close the defect. And this is actually a post-colonoscopy perforation. And it is not mandatory that we use the big clips always. We can even use the standard Olympus clips sometimes, because what it can do is, if we can align the clip properly and start at the apex, we can achieve a good closure most of the times. And that is most important in clips. There you can see that we need to have a mucosa to mucosa approximation, and some technical points is that we need a good apposition, and we need a good assistant who can rotate the clip to the proper direction, and clips should be fired only once we are sure about the position and once we've got both the sides. Of course, a large perforation like this can also have gas-related issues, and abdominal paracentesis becomes very important in these patients, because otherwise they can suddenly have respiratory embarrassment, and they can have the drop in saturation. So on one side we are closing this defect, but on one side we have also put in a needle over here to decompress the capnoperitoneum. And here we are seeing that we are using the clip, and the clip is being rotated. And the first clip usually is the most important clip, because we have to get both the opposition of both the edges, and then we can add more clips on both sides to strengthen the effect. Even long linear perforations can be treated. This is a long linear perforation after a partial Borav's, and using several clips, this presented very early, and using several clips we managed to close this. So, if the defect is rounded and cannot be approximated with clips, we can use this technique of endo loop plus clip closure. This is an EFTR for the duodenal NET that we are performing. So I'll just skip the initial resection part, because that is outside the scope of this discussion. So there we can see that the perforation has occurred. And once we have the specimen out, so we use an endo loop and we fix it Now there's the endo loop that we have carried inside using a clip, and we fix the endo loop to the edges of the defect, and then we tighten the endo loop, and that will give us a very secure purse string kind of a closure. And this is facilitated by the use of the detachable endo loop, which is now available, and here you can do a complete closure like this. Another option is to use the full thickness clips, and we are all familiar with the OTSC system. This is a bear claw kind of a style of a clip, which is much stronger than the regular through the scope clips, and it allows large tissue areas to be approximated. This is another, duodenal perforation, which is being treated by endoscopic closure of using the OTC clip. So one advantage of the OTSC clip is we have a twin grasper that is available along with this. So the clip is loaded on the scope itself, and then what we are doing is we are passing the twin grasper inside, and we are holding one edge of the defect, and then we approximate the other edge of the defect. That can get quite tricky sometimes. And then we pull the entire system inside and then fire the clip. One has to be 100% sure that you have grasped both the edges, because once this clip is fired, it is practically impossible to remove it, and then you will end up with a larger defect sometimes, so that will become a big problem. But this is how the closure looks, and it is quite strong. Another device is the padlock device, which also can be used. Now this is a full thickness resection, and post that you can see there over there. And this is the padlock device that we have used. This is a star-shaped clip. The principle is very similar, only thing is the design is slightly different, and this also can be used for defects up to 2 to 3 centimeters, sometimes can be used. An important aspect of upper GI perforations is the ability to use omentum. You can see that the perforation, you can suck in omentum and fix the omentum to the edges of the defect using standard clips, and then we can use the clips to further strengthen that. And using that, it is a simple procedure of a duodenal plug and omental plug closure of duodenal perforations, and using that you can get a really secure closure. A new device from the Apollo has come up, which is the extract device, and this can be used for mucosal closures. So this is an ESD in the cecum that we've been doing, and once the specimen is retrieved, you can see that. So this is the device, this is how it is fitted on the scope. And what it does is, it has a simple this thing, which only attaches to the mucosa. So it is mucosa deep, it is not a full thickness defect, but it can help mucosal closure. So like it has 4 tacks on this thing, and you can tighten once all the tacks have been fired, and then you can tighten and cinch the defect like the endoscopic suturing. So that is how it is. So overstitch is of course the next best thing, and we know that that is one of the best modalities, because here you can actually perform a good suturing, and it can give us a very good full thickness bite, and we can perform that. Right. So FTRT device, we know that that is one of the techniques. I will just skip that. And coming to stents, one thing about stents, we need to remember that we have to replace stents often, and very often stents will only tend to seal but not to heal, and therefore stents are no longer the preferred modality of treatment. And vacuum therapy is the next thing, which probably we have a thing to talk about, and that can be done, but it's more important for this thing. So these are some of the guidelines. Whenever possible, we should attempt endoscopic, and if not possible, then we can go for surgical. Very often possible for gastric, for esophageal, it's more difficult. For duodenal, it is again, surgery is more often required. And for colonoscopy, if there is no contamination, we can attempt endoscopic, but if there's contamination, surgery is required. Therefore, to summarize, endoscopy-related perforations can usually be managed conservatively by endoscopic techniques. Various endoscopic techniques are available, and one can choose based on the the requirement and the local expertise and device availability. Surgery may be required for gross contamination or for failed endoscopic attempts, but early diagnosis and high index of suspicion are vital for favorable outcomes. Thank you so much.
Thank you, Amol, for an excellent talk. So, short of time, probably we can take one question from the floor. I think everybody has understood very well. Thank you very much, sir.
Thank you so much. Thanks to the chairpersons and the panelists. Moving to the next live session, I invite the chairpersons on stage, Dr. B. Ramesh Kumar, Dr. Yogesh Batra, Dr. Vinay Thorat, Dr. Virendra Singh. And delighted to invite the panelists, Dr. Sarthak Malik, Dr. Sandeep Pandey, Dr. Swapnil Dhampalwar, Dr. P.K. Shetty, Dr. Tejaswini Tumma, and Dr. Aditya V. Kulkarni.
To the live session. So first case would be a 71-year-old male who has retrosternal burning for last 12 months. Endoscopy was done, which showed a long segment of Barrett's mucosa, C3M6 as per BRAC, with some dysplastic foci on narrowband imaging. So biopsy came out to be Barrett's with high-grade dysplasia. Patient has a previous history of hybrid APC, so it is a recurrence. So we're planning for ESD. Back to room 1.
Are we audible in the hall?
Hello? Yeah, we
Hi. Are we audible and visible in the hall?
Yes. Please go ahead.
Yeah. So this is a case, as you heard, Barrett's with high-grade dysplasia. In multiple segments, you can see the visible dysplastic lesion. So the professor is just marking the lesion for ESD. He'll show you how the nodulity looks, and they are visible lesions which have to be resected better than ablated. If it is a completely flat Barrett's, then you can take a decision to ablate the entire segment. But here the professor will just be showing the nodular area. You just keep a focus and between the 9 o'clock and the 12 o'clock area when he comes upwards. So you can see this entire area is Barrett segment. You can see the scomocolumnar junction has completely migrated upwards. There is a 3 centimeter circumferential extent and 6 centimeter is the maximal tongue peak. So you can see here on NBI, you can see the capillary loop pattern at the Z line, and then this columnar-like mucosa which we are marking along, which is the Barrett segment which needs to be removed. So we are marking right now with the soft coag mode using the dual J knife, and we are going to now, I think we are just going to complete the marking. The proximal markings are done. Professor, can you just show the nodular area, the lesions, to the audience? Yeah, this, he's saying, 4 o'clock area, 4 to 6 is normal. Yeah. So this, on the 11 o'clock, this is the abnormal area, which comes now in the 9 o'clock area. This is all nodular area. This is where the dysplasia was picked up on biopsy. Whenever we have visible lesions, still the jury is out, but still the American guidelines, Japanese guidelines do concur on the fact that resection is superior to ablation because there can be a risk of buried Barrett's and you can actually understage the dysplasia. There is a high chance, up to 30% of these ESDs in Barrett's high-grade dysplasia turn out to be T1A adenocarcinoma. So it's a good, if not curative, at least it's a good resection specimen to be sent to the pathologist to take the final call whether further something needs to be done for the patient or not. So you don't need the marking dots to be too close. It just needs to, so you can keep, but always aim to keep these dots inside the resection specimen. In an ideal scenario, all these would be a part of the resected specimen. So you can see how the abnormal visible areas have been included inside the marking.
Okay, in the oral side to the double marking.
Okay. Why so? Why do you prefer to do double marking? The oral side for the pathologist. Okay, for the pathologist.
Yes, yes.
Yeah.
Pathology,
Yeah.
we are
And you also know.
judging which is the
Yeah,
oral
oral
side
side,
or
which
which
is
is
the inner
the
side.
inner
Yes.
side.
Okay, okay. So that's a good system we can introduce into our practice, that we can do extra markings on one side, but both parties should be clear on the thinking that the two markings we should mention on the pathology form is the oral side. So now on white light also you can see these nodular areas which we have included. This is the proximal gastric fold. So we are going all the way till the end of the Barrett segment. But if you don't need to, don't do circumferential ELGs in all patients because the stricture rate will be upwards of 90%. So try to determine the dysplastic areas with NBI, double confirm with a biopsy if possible. But I suggest don't use spiked biopsy forceps. Be very careful while taking biopsies because fibrosis becomes a major issue, at least for people who are beginners like me. The professor would not be affected by that, I'm sure.
Yes. Yes. Okay.
So he's starting from the anal side, you can see.
Interesting. Only 2 centimeters is normal. So I first ECG the normal 2 side.
Okay, okay. So we're saying that within this 2 centimeters the possible dysplastic area. So he'll start dissecting almost like a V-shaped manner, so includes all the markings inside.
Okay.
We are using saline or gel fusion? We are using methylene blue as gel fusion. So it stays longer, it's a good injector, inexpensive, easily available in our country, and it stays in much longer. Sometimes the downside becomes that when you're struggling too long, your gloves become very sticky.
You didn't go back? Just.
Yeah.
Okay, okay.
Yeah, correct. Yeah. Even if you want to do a tunnel technique, even then you come out of the distal and then you can do it like a poem.
Okay, okay.
And as you can see, we don't need to retroflex the scope for the marking or for the incision. You can do it in a straight scope manner, so you don't need to complicate things much. And always be sure that you don't go beyond the proximal gastric fold.
Some scar or fibrosis.
Fibrosis would be
esophagitis.
Yeah, esophagitis. But ideally, we should wait long enough for 4 to 8 weeks on proton pump inhibitors when the esophagitis resolves, because when there's an empty mucosa, you can predict submucosal fibrosis to a large extent.
You knife?
So this is the dual J knife that we're using.
No.
Don't take it back. He's saying just show the knife. Yeah.
Keep it
out. Keep it out. Keep it out. Keep it out. Out.
Yeah. Yes. Already keep.
Yes. He will control.
Done.
So I think the language of ESG is what connects Professor and I. I have trained under him in Chengdu in China. So I know what he is capable of resecting, which is mostly everything under the sun. I don't want to jinx it, but he takes a lot of pride in doing the whole procedure with a single knife. He does not like to change knives either. We found a good plane over here, but you can see there's some fibrosis as well. That's right.
There. There.
In the night, through the night. Professor, would you prefer the pocket method of ESG or you like the conventional?
I can see my
What I've seen him, he's not a big proponent of pocket ESG. Most of what I've seen him do, he does in conventional manner. That's why I marked the whole lesion around.
this margin is not clear.
The margin here,
Yeah,
plane
no.
here is not clear, the fibrosis.
Close. Yeah. Not clear. It's my margin.
So he is keeping those dots inside the resected specimen. So be very wary of that. Resect about a centimeter of normal mucosa. And see the dual J, the benefit is the 2 mm dual J, but still it's not going to be deep enough to go through the muscle layer. So you can find the deep SM3 layer and maintain this. See how easily you could join the two sides. It would take most people at least 10 minutes to achieve this particular shape, and he does it in a single arc-like manner.
The change in the span. No soft configuration. No soft.
No, sir. Should we put post?
Yeah,
Post coagulation.
Post.
Turn to post, turn for
Yes,
detection.
yes.
Yes. Okay.
Yeah.
We have switched to now post coag mode. So now we're gonna find we've done the pre-cut, now we find a good plane. Now see the vessel is going through post coag, and it's been almost completely no blood loss at all till now. So now we'll start on this side. So every EFG comes with its own plan. It has to be very clear. Like he started on the amoral side, then he joined on one direction, the dots, and now he is doing it on the opposite direction. No, he's not. I've never seen him use traction. So I think esophageal cancers are his bread and butter in China. In his unit, I think I used to see at least 3 to 4 cases of either squamous or adenocarcinomas, T1A every day being resected. I think that's the only place that I've seen more ESGs being performed in poems. Yeah, you can see there is some fibrosis over there. You expect more bleeding. Bleeding is almost non-existent, and there you can see big vessels in the there. Yeah, wash. Yeah, big vessels here. Yeah. Just either straight or through the channel.
Clear with my
You can just clean the knife. Yeah. Professor, do you think fibrosis will be a problem in this case? Do you suspect a lot of fibrosis?
Yes.
At the lower side.
Yeah.
Yeah, near the
No air. Oh. The pulse.
To see how in a dual J this is one of the benefits
Dr.
that...
Sukrit, we will just shift to a parallel route and we will come back to you if it is okay.
Yeah, not a problem. Okay.
So I will request Dr. Shanky to present the case for the next room.
Sure, sir. So the next case we'll be taking is a 67-year-old female who is a suspected case of autoimmune hepatitis, child's A cirrhosis, whose ANA was weakly positive, ASMA is quite positive moderately, IgG is elevated, and with deranged LFTs. So our plan is EUS guided liver biopsy. So back to room 2.
Melissa, we are live with you in your room.
Okay. So, till the patient is, I just want to say that this is our scope. We are going to introduce it into the esophagus and we expect to see the liver. I am standing like this, pricking my scope over the tongue, reaching the pharyngoesophageal junction, and then slowly rotating it like this to go past the pharyngoesophageal junction. In this elderly patient, we can have sometimes issues of negotiation of scope. So that is why I am always careful in this rotation and I am feeling. Right now I am seeing the left atrium. Can we have EUS bigger? Seeing the left atrium, and I will continue to advance it because my endoscopic vision is not great, but I will advance it by this rotational upward like this, slowly towards the stomach. So now I have reached the stomach and I am trying to arrow. Can you give me arrow? I have a preliminary idea of what is going wrong with the, this is the arrow, and really where I am saying is that this is the wall of stomach and I am saying some structure close to the stomach. So these are the large varices. So why the varices are there? So I sometimes ask the question later whether this patient has got portal hypertension, so CLD, and it is a case of CLD in which we are asked to see what while do a liver biopsy. Now, one more question, is liver biopsy mandatory?
This person is having
autoimmune hepatitis. So now that this much of portal hypertension is there, can we just think, ask the audience, whether because this is going to make a difference or not?
OTPT is still raised. So
There is a chance that despite the presence of cirrhosis, because in this case, what I am finding is large number of varices which are sort of coming up into the fundus area. So we will have to be careful while we are doing biopsy that there is no varix. So just a preliminary impression, these are the fundal varices, and as I rotate it back, these varices are till now not perforating, but here they might or might not be perforating into the submucosal area. Now, here is where this is the liver, and in this case, between the wall of stomach and the liver, I have got large varices, and these varices are, this is aorta, this is crux of diaphragm, and this is the varix here, this is the wall of stomach. So there are varices here. I rotate it left, there are varices here, large varices here, large shunt, and this is the splenic hilum. splenic hilum, and when I rotate it to the left side, in between the liver and aorta, I find large varix. So there is no way till now that I can go through the liver, through the varix, except for this small window. So this is the heart. Can I freeze it? And I measure the distance, because this is the distance between the crux of diaphragm and this is the distance. This, how many centimeter? 1 centimeter distance is what I have got. So apart from that, any other window I have, I don't find any, because the varix is presently, and as I rotate here, here is another window. This is when I see arrow. So this is the inferior vena cava, and this inferior vena cava is going through the liver. So in between this inferior vena cava, this is the inferior vena cava, this is the wall and the liver. In the gastrohepatic ligament, I am seeing another varix. So what is the status of endoscopy?
Isolated gastric varices.
Isolated large gastric varices are there. So in this case, I would say till now I cannot make up my courage to do the endoscopy because these varices are large. I have got a window, but in this case, because this is one place, if I go from here, I will be going through crux of diaphragm into the liver. So this window, when this extreme position, is not a nice window, and there is not much of margin of error. I will rotate it here. Okay. This is no window here, no window here. So this large varix is not allowing me to puncture here. So we will have to try. In this case, we cannot do biopsy from the this. Now from the near. Now here is where again here is where what I find that this part of liver is easily accessible. This is the left lobe of liver. There are no collaterals. So this is segment 2 and segment 3. So this is from where we will do the biopsy from, because here there are no significant collaterals between them. So this is the wall of the chest. This is the liver atrophy. So we will first measure a nice 3 to 4 centimeter segment, and from here we will measure the distance between this point. This is the point where I am going to enter, set, and then measure this point. It is about 3 centimeters. So this is the place we are going to do biopsy from. Okay. So in this case, the conventional way, so freeze. So we will now increase the depth, so that we will increase the depth. This is this is. We will increase the depth, and then check if there are no more varices. This is the gastrohepatic ligament. This is the gastrohepatic ligament, and from here, just see, this is the place we are going to do biopsy from. Okay. Now we are going to use the needle. This is a 19 gauge Boston Scientific needle, and I have rotated the scope like this and like this, and till now I am trying to find a better window. This is a better window. Here these are intra-collaterals within. Just hold it. These are collaterals within the ligament, falciform ligament. So this patient, in my opinion, has a patent umbilical vein. So can you, if the CT has been done, this patient has a patent umbilical vein, and these are the collaterals within the falciform ligament around the umbilical vein, and maybe I can show, if I apply color Doppler, that this patent umbilical vein is present right up to the inferior vena cava. Apply color. So all these are whatever you are seeing around the patent. So these are patent. Remove color. So we have found patent. Can you just check in the report, CT report, because this patient has definite collaterals within the falciform ligament, and the only vessel that is present within the falciform. Yes, color. Is this the patent umbilical vein? Yes, this is the patent umbilical vein that I am showing. Pointer. This is the patent umbilical vein that I am showing. So this is the question that this is the patent umbilical vein which is being shown, and this is the collaterals which are then going into the. Okay. So now I think we are now to just to show the biopsy.
Malay, can you see the hepatic veins?
So we have taken care of how bad is the portal hypertension. We are just using this 19 gauge needle, and we are just checking. That is more of theoretical importance. But this is patent umbilical vein. I generally try not to take any history, and I try to analyze what I am finding. I try not to take the history, and because in this case right now I am finding this is the nodular liver outside, and this is the place where we are going to do the biopsy from. However, we have to be careful. I will release this, I will take the needle out. I will feel it on endoscopy. I will see it on endoscopy. And once I see the needle on endoscopy, I want to move it up and down. And I will see it on EUS. So right now, I want to see the needle. So there are three ways. Feel the needle, see the needle on endoscopy, and see the needle here. So I feel the needle is here. I have to demonstrate the needle. The needle will not be seen if you do not move the elevator up. So I am seeing just a bit of needle out, more out, and just show that this needle is now seen. This is different from other scopes because I can feel the needle again. I will pull it back. I will push the elevator up. I will push the needle out. I will move the elevator down. Close my eyes. Feel the needle. Then I will see it. Yes, this is the elevator that is shadow is moving. I will see the needle on EUS. Yes. So, and then I will lock the needle. The right now it is the same position in which I was. Now I will move it up and again turn to left. Because in this same position, exactly I had decided that I am going to do biopsy from. So this is the outline of the liver. This varices I don't want to hit because these are intra-collaterals within the ligament. I have to plan the trajectory of the needle, and this needle is prime, and I have to plan the depth of the needle. So this needle I am going to puncture only for. So can you push in some? Okay. Are you ready? Okay. I am going to puncture it now. The needle trajectory we will freeze is going to be roughly like this. From here I will enter, and then it will come roughly up to this point. This is what we are going to remove the freeze. I will not use much of elevator. I will now ready. Now as I push it here, I will use slight elevator up. In between I am finding this is the left hepatic vein is traversing. You can see the irregular contour of the left hepatic vein. I want to miss this left hepatic vein, and I am turned. Now I am ready. Little bit elevator up. Okay. Ready? And now my problem is I felt the needle. Yes, okay. I'm going a little bit more deep. Suction. Okay. Now this needle should be maximum, range should be maximum, and I am going to pull it back. I have to release because the liver is moving. Fibrotic liver, which is moving 2, 3, pull back 4, and the final pass. Nothing so far? We will now, blood has come, we'll pull it back. We will have to be now careful, pull the needle out. I will be careful because I have already done a 5 times push inside. Now I will have to take care of stopping the possible bleed. I am moving to left. You are seeing the arrow. I am keeping the arrow here. This is the tract from which the bleed may have happened, and this is the tract here, and this is the place where the bleed. I will keep my pressure here on the up knob, up all the way up, and be careful and stand for 3 minutes in this position. I will remove the flow and then I will apply the flow because the box is on, and I will keep on watching the track. Maybe I will go, and I think I am done, you can shift. So I am done, you can shift to other scale. I will make sure there is no bleed and then come out.
Thank you so much, sir.
Malaysia, ma'am. For this patient, can we do transjugular liver biopsy? Malay?
आ गया?
Request of the Shankar to tell.
नहीं है?
Dr. Shankar, you can present the history, please.
आज तो जाना चाहिए था?
अच्छा कोई
हैं?
नहीं कोई सर ये इकट्ठा हो गया ना सर कोर तो है अच्छा एक्चुअली इकट्ठा हो गया दैट्स व्हाई अदरवाइज एक सेपरेट कोर है इसमें
वो निकाल लेंगे ना वो?
हाँ सर आराम से निकाल लेंगे कोर तो सही है ये सेंटर में ये वाला कोर है
यार तुम को अच्छा आ गया होगा मेरे कहने का मतलब ये तो बढ़िया हो गया ना, मजा आ गया।
Bilateral SAM's placement. हेलो
कहानी तो इधर उधर की बहुत होगी।
We can't
No,
hear
no,
you.
no. You can't hear you. It's not audible.
Am I audible?
Yeah.
Yeah, sure. So I'll repeat it. So we have a 52-year-old gentleman who has obstructive jaundice and bismuth 3A hilar stricture. EUS FNA of the periportal lymph node was done, which came out to be adeno-CA. Our plan is RFA cholangioscopy with bilateral SEMS placement. So back to room 3.
Thank you. So can you hear us now? Who is the panel? Who's in the panel?
Sir, good afternoon, sir. Nagi, sir. Dr. Ramesh Kumar.
Ramesh. Hi, Ramesh.
Yeah.
So this was a very difficult case. So that's why I have an augmented force behind me, helping me out. Randir, Reem and Mahesh are there. Bhagwan, of course, is helping with the accessory.
Season blessings.
Pizza is also very useful because this patient is difficult, requires repeated glucagon buscopania. So we have a number of problems in this patient. If you look at the MRCP, this was a hilar stricture type 3A probably, but we know better once we will, because the quality of MRCP still sometimes we can't make out very sure. Initially when we started cannulating, we found it very difficult. We couldn't get into the bile duct or pancreatic duct. Finally we got into the pancreatic duct, and if you can get the fluoroscopy pictures on now, fluoroscopy, you can see that we have gone into the pancreatic duct. There was an alpha loop which we straightened out. the plan is to put a pancreatic stent and then do a pre-cut on the pancreatic stent. So I'm using a 5 French single pigtail pancreatic stent, and the reason why it's important to know how to place this is that when you get the pigtail, you have to place the pigtail down into the third part of the duodenum so that you can work on rest of the papilla later on. There's also diverticulum on the top there. So the direction of the CBD probably is a little different. Wire carefully, Bhagwan. You're looking at the wire, no? So I'm getting this 5 French stent through now, and it doesn't have flaps inside because we wanted to drop off spontaneously afterwards. The only issue is that we have to see that negotiating across that area of bend so that you can place it firmly. Now I'm trying to do that. To do it carefully.
Keep the wire out. Yeah, veer across.
Across, yeah. And then you can see the
Black mark.
black mark I'm going to get hopefully now.
Yeah.
Yeah, you can see the black mark. We marked it where the pigtail is, and now the very important point is now you see I don't push, I just push the pigtail down. I want to face down so that when it comes out, it goes into the third part of the duodenum. See this now, this is an important step. So I release it right there in the third part of the duodenum, and then we'll release the flap. Yeah, okay? Okay. So we release the flap down.
Beautiful.
So now we have enough space, you have the papilla pointing out, and we'll do a pre-cut. Okay?
Yeah, perfect.
So I'm taking Randir's permission for a pre-cut because it's always risky. I'm going to use a Boston Scientific needle knife with constantly infusing epinephrine saline. It's very important when you're doing a pre-cut sphincterotomy, always have an epinephrine saline on the other side because it's helpful even if there's a small amount of bleed that ooze stops, and post ERCP pancreatitis incidence is a little less. Now,
you're going
the
to
first thing is
from below or upwards?
So there are two ways of doing a pre-cut. You can do from below up or from above down.
Yeah.
I prefer to go from below up. Some people believe that if you do above, the chance of pancreatitis is less, but anyway, this patient has a pancreatic stent projecting out, needle out. So I think we can go from below up in this case. I'll place it here in the expected direction of the bile duct and go at 11 o'clock position. So the part 3 of course has to work. You can see now the direction I am cutting is, again controlling the shaft with my right hand. It's layer by layer, it's like a surgical cut. Okay, now we'll separate the layers and see what we have got here. Yeah, so we are fairly okay here. So somewhere there is opening. I'll ask Bhagwan to infuse some, push some epinephrine saline there. Okay. Now out, needle out. I'll remove this part of the tag so it opens out much better for us to see what's happening inside. Okay. Okay. So now Bhagwan, now this is the direction of the suspected. Yeah. So can we have some again glucagon? So that puja becomes very important here because she is controlling the glucagon and buscopan. You get a lot of fibrosis there. The heart rate is okay for buscopan. So you see a lot of contractions rather than waiting a little. Give buscopan. I am trying to separate out the layers again. How? Yeah, I always cut over a needle knife, and also I put a pancreatic stent always. I know you prefer the Goff technique, Reem. You like to, Reem was suggesting another technique where you can go deep into the pancreatic duct and cut towards the bile duct. Septotomy. Septotomy. I am old fashioned about septotomy. Yeah, okay.
You're the only one in the country possible.
Yeah. So now I'm just studying the deep. Can you get the needle in? It's important to study the area where suspected bile duct is. I think it's Here, yeah. So there's a lot of contraction still.
So you go deeper and deeper, Nagi, or you go
No.
further up?
Up further, little more now. You can actually go a little more further up, superficially to look
Yeah,
at.
so that when you go further up, maybe the lips separate out.
So I'm waiting for a little buscopan effect to come. How? Now I'm waiting for that to come in now. Yeah. So Bhagwan has got the needle out. So you can see that the superficial part we want to cut. This part, what Mahesh is suggesting, sometimes it tends to bleed it there, little there, but doesn't matter. You can always control it. Oh, sorry. Yeah. Now it's very still. That's a good movement for us to cut now further.
Those who are not using glucagon is much better than buscopan, but of course comes at a cost.
Yeah.
How much is the cost of glucagon, sir?
I think
Okay.
almost 2,000. 1100 rupees per injection.
So now we have exposed part of the bile duct here, and then can you inject some, take the needle inside, so that I can use this for a blunt dissection to see actually well, and then now can inject some epinephrine. That's the bile duct area. See that now you can see the pancreatic duct. The bile duct is above this area. Now can you needle out? So I'll cut a little more in this area. Yeah.
So what about keeping the guide wire in the PD and put the stent on the end? Do the pre-cut and put the stent in the PD in the end?
Yeah, you can do that also, but see, managing two guide wires is like managing two wives, not so easy.
Okay, so thanks.
No, Reem is agreeing. Okay. So now you can see I cut very deep inside, and somewhere here is a bile duct. There are two options at this stage to try directly with a guide wire in this area, suspected area. You will see very often it goes inside now, right? You can see that's the lip there of the bile duct. We'll try here. Just above and to the left of the pancreatic stent is always a bile duct. So we'll take, in this case, we'll take a straight wire. Oh, it's okay if you already have a wire. I'll show you the expected direction of the bile duct. In this case, the bile duct is exceptionally small, and that's the reason why it is difficult. Okay, now bend, but the wire. Yeah. So the direction is again very important. See, this is the expected direction here, and no, little to the left. This is the direction. Yeah, just see if you can pass the wire there, a little, pass the wire. No? Yeah. This is the expected direction. No?
So you're preferring a sphincterotomy because of the shape?
Yeah, because of the shape. So direction is very, you can control. You get a feel now, Bhagwan, of going in? No? Okay, we'll come back. And this is, this is now pass. Just over the PD, but to the left and up of the PD. So that's where we are now. There's a little contraction again coming up. Okay, but you can see nicely now the tissues above the PD, which is the area where this is exactly above the PD now. Just do the no. So no. I think I suggest that you take a straight wire, and as we are doing that, you want to change and come back also, and then no problem. So this is interesting. It's a very difficult area. In fact, the papilla itself was very abnormal. The wire. So we are changing to a straight wire. Sometimes, this is. Yeah. So see, now I've just opened up the bile duct area to show where exactly, and maybe one more small cut may be required that area. This is the area of bile duct, yeah. Bhagwan, now it's your job. No? Yeah, a little more I'll do that. So I'm just studying No? See, this is that is sheath. Yeah. The bile duct has got a sheath, yeah. Yeah. Oh, the bile duct. See that where there is one more small layer there. I thought I could actually get my thing through that, but now we might have to. Don't open the needle knife too much, Bhagwan. Just open it a little. Yeah, few millimeters, so that we'll go layer by layer. Just like a surgeon would do a papillotomy, we'll do it the same way.
Dr. Reddy sir, if you can give me just a minute, we'll just switch to Dr. Bingu for a minute, for a few seconds because he's almost about to finish. Is it okay?
Can you inject some? Okay, just can you inject? Yeah, no problem. Yeah. So now we'll open. That's okay. See the small area there. I'm going to open up now. This area. Yeah. How? Still contracting. So open up the little eye a little more, not too much.
Now, we are heading towards another live session, and I thank the chairpersons and the panelists for your precious time, and inviting the chairpersons for the other session. And I invite Dr. Nikhil Sonthalia, Dr. Harsh Udawat, Dr. Naresh Bansal, and the panelists Dr. Saroj Dubey, Dr. Naresh Agrawal, Dr. Shahina Parveen, Dr. Jose Philip Alvarez, and Dr. Vishnu Abhishek as panelists on stage.
So you can see his speed, he's almost done.
Over to the live room.
Yeah, so we are live from room 1. So professor is extremely fast. Just see how he dissects layer by layer. We would be much more cautious than he is, but he's the master of the art. So you can see how his hand moves in a single arc-like manner, and he's already out of the distal part. So basically, started on the anal side, started dissecting from the anal side, and it's mostly he did in a tunnel fashion, but for the right edge he did conventionally. And for the left edge, he's doing it the tunnel fashion. You can see that the opening is the distal most end of the resection of the lesion. So now he's gonna start resecting outwards towards the edges. I think this should not take longer than 10 minutes, Professor, right? And such an ESD in most, I think, of our hands would at least take 3 to 4 hours. So this is, we are back in the esophageal lumen from this side. And he does not like to take a coa grasper, he is very unhappy when he needs to. So he encountered a lot of huge vessels which he has tackled with the dual J knife itself. When these all the resected, you can see the muscle on from 10 o'clock to 4 o'clock. I think with the X1 scopes, we see a lot more than we used to. So you can see this fine vascular pattern, these palisades you can see on the mucosal aspect. I think that's probably one of the last attachments of the lesion.
Okay.
So we'll get at least a 75-degree circumferential specimen. So I had asked him earlier that what's his usual practice post-resection, and he said he also injects intra-bed steroids at the end of the resection. So you can see now on both sides the mucosa is hanging, and it just the traction is provided by the edges of that tunnel. So the pocket patient method allows us to have more traction, and he does not use any traction clips, but to my knowledge, I've never seen him use any traction clips. It's almost bloodless, and it's quite a vascular area. And I spoke too soon. But he gets rid of the bleeding also very quickly.
Fibrosis.
Yeah, fibrosis is on this side. Yeah. With fibrosis comes more vascularity as well.
The speed is amazing.
Yeah, he is extremely fast. I had Japanese masters of EFD ask me how is he so fast, and I didn't know. I was just lucky to train under him. But still can't mimic what he does, not to any extent.
Sukrit, what are the tips
The
to
scope is sometimes have the
yeah, to prevent?
my view no clear.
Wow, what was the question?
Post ESD strictures?
I think you can, first you can inject intralesional steroid, triamcinolone, in multiple aliquots. You can inject throughout the bed on the muscle. There are certain, you can make like we do for eosinophilic esophagitis, I make a viscous with budesonide, using the nebulization budesonide, mix it with sucralfate, and I give it to the patient for at least 2 weeks, 3 times a day. I don't know to what extent it has, there's data to support that, to some extent, but you have to relook after 6 to 8 weeks, or if the patient is symptomatic, or even there's data to suggest that even low dose oral steroids can help. I've had patients with panhypopituitarism who are on steroids, underwent a circumferential 10 centimeter ESD and did not have a significant stricture. So that's not a bad trade-off. I think just a short course of low dose steroids for a month or a month and a half, if you can prevent benign esophageal stricture, which is difficult to tackle. Some people do place fully covered metal stents also, but then again it will not hold very well, then you will use another device to hold it in place, and with the risk of further damaging the normal looking mucosa as well. So we don't have a perfect answer yet, but I think a combination of these would be helpful. It's almost off. It's very vascular pedicle, I think. Probably the last part. And he's so sure of his claims, he doesn't even like to inject like somebody. I like to see blue before I dissect, but he just knows that he's in a submucosa, so he'll keep dissecting. And sometimes these last vascular pedicles can be very troubling. Whenever you think an ESD is over, it can take longer than expected, but I'm sure that won't be the case today. You can see how it's a continuous movement to and fro. He's making arcs. It's like one C after another, and he doesn't take breaks in those arcs. We go like somebody learning how to cycle, taking half pedals all the time. And now most of the specimen is hanging. You can see this. The Barrett segment with high-grade dysplasia is hanging now by a pedicle. It will come off soon. You just fold it upon itself and push it towards the stomach. That will allow traction again on the submucosa.
Open. Injection. Injection.
This is, I don't think it will take very long now.
Okay.
So good, what are the quarterly settings?
Right now he's using endocut Q effect of 2. He is not keen on using precise set, he is using forced coag effect of 5 here. But most of this what you're hearing is endocut Q. So he doesn't need new quarterly settings to help. I think he doesn't get faster than this. So I don't know how precise set helps his practice. So there's one vessel.
Close. Close.
Mucosal aspect.
Close.
In. On the right.
Okay.
And you can imagine it's not easy to work with a technician from a different country altogether. We feel very happy when you have to do live demos with our own technicians. But that doesn't seem to affect his speed either. Yeah. So you can see no traction, device, nothing. Just the scope cap pushing the lesion now towards the stomach, providing all the traction. And you're getting taut submucosal fibers which can be easily cut across. But they are big enough vessels to slow down anyone. It doesn't matter to him. You can see, I think it's almost. It's off. That's it.
On the right side.
Yeah.
Close.
So the important thing to learn, for coagulating, the knife should be in. You don't want to have too deep a current or push through the muscle layer here. So the dual J is pulled back and then coagulation is done.
Clear my knife. No, the left side, already done. Just the
right one attachment.
Right.
And you
yeah.
take the IT
Just
too?
here.
Oh.
Yeah.
Change it.
Of course, the right side is a higher position, it's a low position. So I first cut the low higher position. Water in the
higher, yeah. So it hangs better and now.
Yeah. My stomach is clear.
Yeah.
The water, no bleeding.
Yeah. Very nice. Not a drop of blood in the liquid in the fundus.
In the cardiac and the esophagus, the vessels very big.
The vessels,
and made it.
But you did not use a grasper at all. You did it with a dual knife, which is not the
knife.
Which is one of the smallest knives available.
Sometimes I touch
check
the
neck, chest and abdomen always. So visual cues to look for capnoperitoneum, capnomediastinum, subcutaneous emphysema. Always keep an eye on it. Keep talking to your anesthetist as well.
Just here.
Yeah.
The classic teaching is if the width of the vessel is...
Can you repeat?
Fibrosis and the scar.
In this part? Yeah. Post-procedure stricture formation. Professor, what do you do? Except for steroids, local, what do you do for your patients to prevent stricture formation? To prevent scar, what should be done?
Injection. Okay.
Yeah, big vessel.
Big vessel.
Big vessel. I know you won't take a grasper for this either. I would.
I use the knife.
Yeah, I know. I would take the knife. You use the knife. We follow
Might
the,
touch, might be tight.
Yeah, so greater contact, greater surface area. So the current density decreases and then the duty cycle should be low. So forced coil with greater area of contact. And don't put too much traction on the vessel while coagulating it.
So Krit,
We all feel comfortable when we see blue.
So Krit,
Yeah.
traction is used only by the force of the scope only.
Yeah, all traction is by the scope, now by the weight of the lesion itself, and if needed, the cap and the scope pressure. They all modes of traction. He is not using any additional traction device. But you can use a dental forge, you can use a loop and clip if needed. If you are getting too much fibrosis, you are losing your plane repeatedly, you are injuring the muscle superficially repeatedly, then it's not a bad idea to use traction. There is no pride in
Most of the
emulate him
proximal
without
aspect
getting
has
the
been
same
avulsed.
result.
Sukrit, what is the trick of coagulating thick vessels with this small knife? Like, what is professor doing?
I think any knife, it works on the same principle, increase the surface area of contact when you're using a coagulation mode. So don't just touch the vessel with your tip of the knife, hook it with the knife, increase the contact area and go slow. Don't try to cut through with forced coil. Just multiple times pedal, you'll see it whitening out. So when it's whitened out to at least 1 mm on either side, then you can cut through, then it will not bleed out. And don't keep pulling on the vessel, then you can go through and through without coagulating enough, then you'll have a spurter which might retract in the intermuscular plane, or even further below. It will be a very difficult task to coagulate it without causing collateral damage to the muscle layer.
Now, specimen in the stomach.
Yeah.
I try suction, but the specimen is big.
So you want to
Maybe
get a rotnet?
didn't go to-
Rotnet? Let's come. So the specimen is free now. Is it free or tiny, small bit? Very little. Do you think it's attached or it's free?
No.
Rotnet.
No.
Do you think attachment is there? Tiny attachment towards the esophagus? No, it's not. It's it's there. No.
It's there.
Hello.
Udhar, no?
हाँ
That's why
सुमित हेलो yeah
Rotnet. It's the net to get the. You are free, right? Or this attachment is there?
Yeah.
You should check with the Rotnet.
Yeah. Okay.
what are the comparative results of radio frequency ablation over these endoscopic procedures?
Can you repeat? We are not getting very loud audio. Louder in the room.
The question is, what is the comparative result between RFAs and ESDs in this scenario?
Comparative results are issues when you see this was a visibly NBI visible dysplastic lesion on the background of Barrett's. The data shows that doing a R0 resection, be it EMR, be it ESD on block, is better in terms of recurrence rate. You can ablate everything, but you might miss out on a carcinoma in situ or something even deeper, because when we give a full specimen, a ESD specimen, to a pathologist, very often we end up finding a higher stage than the simple endoscopic biopsies gave us. So first, it's important for pathological staging to the full extent, and also you get the specimen out, you have got the tumor out, ablation, you end up burying a lot of the dysplastic tissue as well. And the recurrence can be buried as well.
Now it's what time?
Yeah.
What time?
What time?
Yeah. 50.
4:50.
4:50. I now go to conference.
No, you give your lecture from here. That's it. Now we'll just mount the specimen. Can you focus on the specimen?
Wonderful. So this was a wonderful demonstration.
Get the pipe
open.
A lot of patience, perseverance is required.
You can keep it here.
Yeah,
Place it. You can see this. You're gonna mount it later. Okay?
So this is
Zoom out
wonderful.
Yeah. So this is, I think, one of the cleanest ESDs I've seen.
Clear scope.
We're just going to relook. Always, once you're done with the resection, The important part starts with the housekeeping job, just seeing if you have made any muscular defects, any bleeder, future bleeders are there. For large vessels, you want to coagulate using a coag grasper.
Sukrit, I think we'll just need to shift to Dr. Reddy's room again once.
Sure.
Yeah, so we'll shift to room 3.
Till we get something what the point is showing.
Sir, we are online in room 3, Dr. Reddy, sir.
Wait.
Ragi, we're live.
Okay.
So as you all can see that we are
Yeah.
still struggling to get a positive result of
Yeah.
P-cut.
So-
the anatomy is grossly distorted. There is a diverticulum, there is
yeah.
fibrosis. Though the pancreatic stent is in place, but we are
So
not
let's-
able to find out the opening.
Can you place some epinephrine? Just show them the anatomy at least.
Sir, what
You
is
can-
the comparison between septotomy and needle knife as compared to?
Yeah, septotomy, the problem in a case like this is the bile duct is very thin. Now we have gone into the pancreatic duct, placed a nice pancreatic stent, and as you can see the anatomy here, we have made a cut. The bile duct should be somewhere in this area. See this where Bhagwan is passing out. Can you make it? We'll show you the area this is the area of suspected bile duct opening, and the bile duct opening is so thin that you can't see it. Now we have cut this quite substantially, so we were also thinking whether it could be an abnormal anatomy with the right-sided origin of the bile duct, but that's not the case. You can see this is where the pancreatic duct orifice is. This is also into the pancreatic duct. Now can you pass a little and see where we are, we'll see. Okay, so we have to be very gentle and probe with it carefully. This is suspected bile duct direction, but you see it doesn't go in very easily. So what we'll do is we'll come back a little and then just inspect what we are going to do.
So to explain the septotomy, it basically means that your sphincterotomy is inside the pancreatic duct,
Yeah.
and you direct it towards the bile duct, towards the left side, and then cut the septum.
Yeah. So it's called the Goff procedure, but I am against that procedure, although Ream does it, yeah.
So does
Is there any
I don't
difference in the success of what is the comparative
You won't have what?
post-op complication?
So see the thing now, anatomy very nicely. This is a pancreatic duct, and this is the tissue above the pancreatic duct. The bile duct should end somewhere here. We are trying to get the bile duct here. This is the area where the bile duct is supposed to come, and we are carefully trying to probe that area. And in spite of a very deep cut that we have done here, we are still not seeing any bile coming out. Could be partly because of the obstruction, but also I think it's partly because of a very abnormal anatomy in this case. Now can you try?
Even on the MRI, it was really hard to see the
Distal duct, I couldn't see. No, wait. See, can you see the anatomy here? I'm just lifting it up to show you where the pancreatic duct is and where the expected bile duct should be there. So maybe we keep trying and then we can come back. There's some opening there.
When would you say stop with Brinker gone 24, 48?
Yeah, so when the anesthetist says stop, we'll stop, and then after 24 hours, very often you'll find the whole area has opened up, edema has gone down, and you can get in very easily.
So Nagi, what's the right time to come back? 24 hours or 72 hours, or what do you think?
I think, 48 hours is the ideal thing. Okay. In fact, we wrote this review.
He averaged.
Yeah. No, we actually put a review there, and we found that average 48 hours is the best time to come back. And then you find that
we find sometime
edema and all that.
So the end point, as Nagi said, one is the anesthetist, and second is if there is significant bleeding, and you have to inject too much of adrenaline, then you don't go ahead.
Sir, if there is IHBRD, is there a possibility of doing a render view?
Yeah, exactly. So if you fail, you come back after 48 hours, you can't go in. You can't do an EUS in this case because you see duct very narrow. So what we can do is we can do a percutaneous rendezvous. That's the easiest procedure. And invariably you will find that because of the dilated duct, they can go in very easily and you have wire coming out.
Yes.
So let's try a few more minutes before we do that. And if you want to go to another room also, you can. See, because of the contractions, I think we can do another cut here also. No.
Just put a cut hole above the skin.
Yeah, we are doing that. But
he's saying we want to cut the mucosa of the tissue.
Just the tissue above.
No, we'll get into the pancreatic duct. No, it's not. It's there. 200% sure it's here. Just how? No? Okay, then we'll make a cut. This needle knife is here. You can put some. Yeah, see, this is the area where it is. Yeah, I'll just tell you where exactly. This is a.
Okay.
Yeah. So some contractions again coming in. Maybe we'll require a glucagon or buscopan, whatever the anesthetist wants to give. See, this is exact. Again. Yeah. Yeah. Very abnormal anatomy.
So there are so many experts sitting in the hall. Any suggestion? Ramesh?
So buscopan or something is given?
Dr. Mishra has to be there. SP Mishra.
Acha, okay. So we'll go to this area on the top.
Basically, you're doing a septotomy from the other side. Basically, you're doing septotomy from the
Very
other side.
fibrotic, huh? Very fibrotic. I don't understand what is the reason for this fibrosis unless he's or is an alcoholic or see, alcoholics sometimes have that or opium intake.
Punjab. Is it?
Some bile seems to be coming from somewhere. Yeah, if we make
that hole in the country.
No, we'll just loosen the pancreatic. So now we are trying the top actually. Oh, where is it? So we'll try and see if we can get it there. So there's a small opening there on the top which we will try. If I'm using my ender now, lose it. You can see the ball moving a little there, so it's obviously not the correct place. Now, so now, anybody have got it? No? No. Oh. So again, we'll examine the anatomy. This is very important that keep doing it in layers. Examine the anatomy. Look carefully to see if any bile is coming out because that will be the potential site before you.
I think learning today has been that Nagi is very so gentle and is going step by step, layer by layer, not rushing to the procedure.
This is very important.
I think that's very important.
Yeah.
And somewhere we may have to call, interrupt the procedure and maybe go back again after 24 to 48 hours.
Now see.
Yes.
Yeah.
Layer by layer.
Now? Now I'm sucking on it. No? Ali? Sometimes, rarely I found that the bile duct comes on the right side like this and then you will find that no? So suck a little, I'll wait a little, suck a little, wait for 2-3 minutes. Some buscopan you have given?
Let them move some other room.
The other thing we have to check is for any air in the bag.
No, there's no air.
No air. No, but be careful about everything when you're doing it.
When did this happen to you last? 2 years back?
Many years back. Actually, generally, when you get a stent into the pancreatic duct,
It's
you'll
easy.
always get into the bile.
Yeah, because
There's no
you
doubt.
go to
because
the
you
left
go
and
to the left and above.
little above.
But this is a very abnormal duct. And I thought Randir was a friend of mine. So we'll give it a little time.
Yeah.
If you want to move to some other thing also, it's okay. Unless you want to discuss something in this
But
area.
there's total silence.
Is there any chance of removing the PD stent and do the educate pancreatic septotomy at the cost of severe pancreatitis?
No. Pancreatic septotomy will not work in this case because the bile duct, if you look at the MRCP, is extremely narrow and it will result in the same thing, you know. What do you mean by pancreatic septotomy? You are cutting from the pancreatic duct through the septum into the bile duct. And already we have cut most of that now. So that's not going to work. The bile duct here is very, very abnormal. The plan in this case would be to wait for 72 hours. You will find everything has opened up and then you can go in again. There's no problem. So that would be safer rather than trying to do all types of septotomies.
Sir, usually how long do you keep the pancreatic stent?
Which one?
Nagi, cholecystokinin.
Oh yeah, cholecystokinin is what Reem is suggesting. Yeah, we don't have cholecystokinin here in India. Otherwise, if we give cholecystokinin, the gallbladder contracts and you can see bile coming out.
Salad dressing or olive oil.
Yeah, maybe. Yeah, maybe something like that.
Sir, what are the tips for a safe pre-cut sphincterotomy?
Lemon juice.
What is the thing?
What are the tips for a safe pre-cut?
Yeah, safe pre-cut is, I showed you now, layer by layer cutting. We also always have epinephrine with us, you know, epinephrine in saline with us, and Bhagwan has this all the time. So as we are cutting, you see, that's why we could control the bleed. Otherwise, some ooze comes sometimes very difficult to control. Deeper vessels we can't control, at least superficial capillaries are controlled. So layer by layer cutting, the edge of the pre-cut should not be too much beyond the papilla, using epinephrine in saline to stop any bleed that's going to occur. These would be the factors.
So there is a diverticula.
Yeah.
So inspecting the diverticula and I mean, would that help?
No, it creates problem.
What happens?
Does diverticulum help?
No, diverticulum creates more problem because the angle of the CBD changes. CBD goes up level and then goes up. So the angle of the CBD changes. So this creates a problem. So we'll have to be changing the angle of the scope. When the diverticula is there, you go up like that and then try and go up. So we'll have to wait for a few seconds before we get in again. Any other, I think this is an interesting discussion point, this case, because we have to, I don't know whether
I think it's a very important issue that when you go back after a conference, you should also realize that even super experts can sometimes have problem because of the anatomy.
Yeah.
Can you give us sort of how you would recognize the back wall versus the duct wall? Sometimes that's
Yeah, so I think the back wall, you can see the muscle layer coming up if you're cutting too much into that area. Whereas in very clearly you can identify, like you have done in this case, the pancreatic duct. The bile duct also is usually very easily seen because it's a nice pouting duct which is seen on the right side up. But of course in this case, there's some abnormality because of the fibrosis, you're not seeing it well. Second thing is usually bile is flowing out, so you can make out very clearly where that opening is. This is not happening.
So what is your recommendation for pancreatic stent? How long do you keep it after the case is over?
Yeah, so pancreatic stent, we always use a single pigtail 5 French stent, and because this is a prophylactic pancreatic stent, we don't have an inner flap like I shown you earlier. So that is very important in these cases.
So it will fall by itself?
It usually falls off by itself. Doesn't, yeah, we wait for 10 days. If it falls by itself, it's okay. If it doesn't, then we remove it.
And what about the
straight
length?
stent you don't advise, sir? Straight
I didn't get the question. What is the question, man?
Come again.
So what about the straight pancreatic stent? Is that not?
Straight stents we don't use because first is migration inside. I'm always worried about that. Second is you don't get this type of angle with a single pigtail stent. You actually put it down. The whole papilla is exposed. If you had seen this papilla before you started the procedure, there is no papilla at all. It was very flat. But because of the stent, the whole papilla got exposed. So this is also important that you use a single pigtail stent, so that you can get this type of anatomy in these cases.
And with the straight stent, sometimes the part of the stent which is in the duodenum may interfere with your approach to the bile duct.
Yeah, and stage stent also, so we have stopped using stage stents for pancreas now because of this problem of migration, and once it migrates inside, especially a 5 French stent is very difficult to get out.
And what about the length of the pancreatic stent?
Usually for this pre-cut type of thing, I use a 5 French 5 centimeter length. That is sufficient. If you use too short, some people use 3 centimeters, but it falls off. There is a randomized, very nice study done by Todd Barron. I think Prablin was the first author for that study, where they showed that 5 French 5 centimeter stents are the best in terms of staying during the procedure, in falling off. If you use a too long a stent, it doesn't fall off. Too short a stent during the procedure falls off.
Even for 3 French, which we used to use earlier, it has been found that it may fall off before it does the
Yeah,
work.
that's right. Even when you're doing the procedure, it falls off. So this is the problem. Okay, so we'll try again.
So Nagi wants to give another last try possibly.
Yeah. So you can see the anatomy here very nicely. This is the pancreatic area. This is not right now. Maybe in the pancreatic duct only. PD. So this should be slightly above. So I'll come out again, and I'm just lifting up. You see the nice anatomy
So
here.
since there is a diverticular above it, can we just inspect the part above the pre-cut area and do fistulotomy, separate fistulotomy? Because maybe
What did she say?
probably there's a opening above it.
I didn't get that.
Probably the opening is just above that.
Just above the diverticular? No,
If we
above that.
inspect
The
part
other,
within the diverticular and see where there is a bulge, and we can go for the fistulotomy, separate fistulotomy, if there is a space.
no, there's no space here to do that. Actually, you can see we exhausted all the space. There's no space at all. So what I'm trying to do is to try another area here, which is very abnormally, totally abnormal on the right side complete.
Nagi sir,
Yeah,
the
please.
patient is
Rajesh is here. Rajesh, could you tell us?
The patient is in supine position.
Yeah, so we are trying that, but you see,
When changing the position of the patient helps.
But don't you think that's unusual side to be on the right side of the pancreas?
what happened?
Above the stent you cut the long chap.
No, we have cut everything about it.
There is a
I don't think
suggestion
we
of
cut.
changing the position of the patient.
The position of the patient is supine position. Can we cut? Here. Yeah, so the right side, Bhagwan is suggesting maybe this is the bile duct, totally abnormal anatomy. But if you want, we can cut a little more there and see.
That slit-like thing which is seen,
Yeah.
if you extend that. But it will be very unusual.
Yeah, this will be one of the very rare cases where. So this is what you're suggesting, eh?
There's a bulge there, but
Wait. So I'm just trying to dissect it out carefully, and you can see the tissue there is not like a duct that I'm going into. Just studying this again. There's no bile coming out at all.
it must be. Will Ruby?
Nagi,
So, yeah.
this junk delivery here,
Yeah, Jang, tell me.
I wouldn't cut anymore.
Yeah. So, Jang, I agree with you. I think we should. No, this is okay. I mean, the patient is absolutely okay. There's no leak also. But what we're trying to do is probe carefully to see where exactly the bile duct is. So the belief was this right side, you can see the bulge here, Jang. People felt this was a bile duct, but I don't think that's a bile duct.
No.
I think it's basically above here somewhere, but I cut very deep inside, still we're not getting it. So, huh?
Just going inside. Just cut a little to the right.
So we have a lot of suggestions coming in here. Yeah, we have a lot of backseat drivers. Huh. Here?
Dr. Reddy sir, we will just switch to one more room. There's an interesting case there, if it is okay.
Yeah, okay, please.
Thank you, sir.
This way.
So we'll switch to room number 2 for an interesting case which is already started, but we want to show you something important.
इसको आगे लाओ क्या किया हुआ है
You're not audible.
Say tunnel deep.
Can you repeat the summary? Can't hear you.
चलो चलो रोशी कॉल लगा
We can directly switch to the room. I think.
Zubin, maybe you can read out the summary.
Yes, so this is a 74-year-old female who is post-laryngectomy, is currently on tracheostomy and has a tracheoesophageal fistula. The plan is for an TOF closure by either endoscopic suturing or by any other means. So we switch to room 2.
I thank the chairpersons and panelists and request the chairpersons to please join us on the stage for this session. Dr. Arvind Khurana, Dr. Malay Sharma, Dr. Devendra Singh and Dr. Rajneesh Monga. I invite the panelists Dr. Shri Ram Agarwal, Dr. Anil Singh, Dr. Ashish Jha, Dr. Chitranshu V and Dr. Hardik Koteja as panelists on stage. I welcome you all.
This way, I mean, we can subsequently do a second one horizontal, but the first one we can bring one suture there, one there. Once both the sutures are dropped, then I grab them with baby biopsy forceps, bring out through the mouth. Then we go back and put the horizontal, and to that we attach whatever we want to attach. I think stent she will benefit from, and these sutures are absorbable. They'll get absorbed in several weeks. By that time, the stent will actually help her.
Are we live?
Yes, sir. Sir, you are live in room 2.
So, as you were told, this is a lady who has been having tracheoesophageal fistula for last 7-8 years, and no, it doesn't matter. So he, very difficult patient. There was a stenosis in the esophagus. Even the baby scope will not go. But she has been eating some food, and she has been keeping a tracheostomy, which she keeps on taking in and out herself, clean it, put it back again. But she wants this to be closed if it is possible. 3 attempts have already been done by putting in, various closure devices which have failed. So now it is we were planning to put in do it with the endoscopic suturing device. The problem is that the lumen of the esophagus is so small that conventional suturing device will not even go down. So Navtej has thought of a very unique way that we will, can you focus on this? Can you be on the side? Just be on the side. And focus on this. There is a, this is the tracheoesophageal fistula. There is a hole we can see into the esophagus. You can see the endoscopic view. My guide wire moving. Do you see that? From the hall? Hello?
Yes, sir, we see that.
So this is the area which we want to see whether we can close. We are going to put in a suture which has been passed through a Venflon. And can you show this?
So what we have is we've taken one of the IV cannula. Through that we put an absorbable suture. So we will pass this from the tracheal side into the esophagus. 2 of them, one proximal to it, one distal to it. Then take a pediatric biopsy forceps, grab them, bring them out through mouth. That will be the round 1. And round 2 will be same approach horizontally. So there will be 4 of them coming, and then we were debating whether we put a cut stent or something that holds these sutures on the esophagus side while they are healing on the tracheal side. So this part you may be able to only partly see. Dr. Sood will send this suture immediately distal to the, there you go, perfect. Immediately distal to it, and can I get a pediatric biopsy forceps?
You see the bulge in the lumen? It's like doing a peg.
Yep. And I'm going to put, okay, pull back just a touch. It's trying to go on to the opposite side. And I wanted to avoid the scope injury. There it is. There it is. Is the wire there? Is needle coming or? There you go. Okay, now send the wire in, sorry, thread in. There you go. Keep going.
Wait.
Yep. Yeah, keep sending as much as you can. And I will take the scope close to it. There you go. Good. Hold it right there. That's okay. Open. A little bit more suture. Close.
Wait.
Oh, sorry. Suture is, oh, okay.
Bending.
Bend. Okay, I think I can hold it. Close. You just see. Okay.
Wait.
Open.
Tensile strength.
Close. Good.
Yeah.
So you got to keep sending me the, there you go. Now you can take the needle out, Datsu. There you go, good. Okay, that's good. It'll sit right there. Let's cut this needle, I think, or should we leave?
We'll leave
yeah,
it
we
for the
need,
time being.
okay.
We leave it
all right,
because
then you get the second
one.
Second one.
Ooh, the other way. Vent flown or now? One flown. Vent flown. तो कोई भी दे दो 14 दे दो 14 जब 20 दे दो जब
14 में आ जाएगा 14 में आ जाएगा so what I'm going to do is just to be on safe side I'm going to drive this one into the stomach so that we have it secured there. Open. And
Vent
close.
flown, please. क्या इतना टाइम लगता है vent flown में? इतने सारी चीजें पड़ी हुई हैं. Where is the anesthesia?
जहाँ patients है ना उस room में there is a cannula there 14.
पड़े हुए सारे. No, what you have for?
Live fluoro for second. Keep the wire in. Don't let the wire come out. Yeah, hold the wire there.
Push लो ना.
And can I get the biopsy for? That's true. This time, what I'll do is I'll open the biopsy forceps where you're bringing your needle, so that it doesn't get onto the other side.
Yeah. Yeah, I'll just
Let me just find this bit. Okay. Live fluoro for second. Okay, so let me actually come close to where the hole is. Okay, open the cable now. So superior to that actually will be really nice. I'll pull my scope back here. I think it's going on the side a little bit.
Yeah.
About a centimeter superior or half centimeter superior. There you go.
I'll go on the
Yeah.
upper.
Yeah. Okay. All right.
Is okay?
Trying to see where it is coming, where it wants to come. Did it go? It went? Okay, just a second. Let me find it where it is. Live fluoro? So, wire is there. So that is where the top of the wire is. And it should be right here in this area.
Oh, I think we'll have to make another.
Yeah, you probably have to pull it back. आ गया? कहाँ पे आया? Okay, अच्छा. So it's there. So why don't you send the thread?
I
Huh?
pulled it.
You pulled it back? Okay. Okay, let me just again. The air that we are trying to insuffle just gets
Actually,
out.
I'll just do one thing. I'm taking the sheath out.
Okay.
Keeping the wire
Yeah.
only.
Take the sheath out. Yes.
Keeping only the candle in. So
Yes.
the sheath is making it tougher for it to go in.
There it is. There it is. It's in right there.
I'll push in the wire.
And that's so if you turn it horizontally from one side to other, okay, it's out there, but it's hitting the opposite wall. So let me just see if I can find it one more time. Live fluoro. Okay, so the wire is there and the needle should be right there, right in this space.
Where's the guide wire?
Guide wire. Live fluoro? It's quite higher than guide wire. Oh, wire is actually straight, so that's what it is.
Wait. Where's the hole?
The hole. Live?
Oh,
so right
this
there,
is
so
here.
that's the needle.
Yeah.
It's trying to come at an angle, so if we turn the angle
So
different direction. Likely running parallel to it. Oh, there it is. Yep, now you send the thread. Yep. Send the thread. Okay, let me just see. Open. Let me just move this other tissue back a little bit. And it's hitting the opposite wall, so I'm just trying to move that opposite wall out of your way. Okay. Once this the suture gets wet, it's stop that oomph in it. Okay. Yeah, keep sending it. The needle is still in. It's good.
No, needle is still. I'm just trying to put a pressure so that I'm away from the wall.
Okay. Other thing I was thinking, if I should hold the needle with the cable. Yeah.
Hello. Yeah, hi Navtej, this is Amit Maidev.
Hello.
Hi.
Close.
I just had one suggestion. We recently did a case like that in Mumbai. What I did was, to prevent collapse of the esophageal lumen, attach a cap at the tip of your scope. Your needle will become visible much better, so that the needle doesn't touch the opposite wall. So how we do for POEM and ESD, just attach a cap of to the scope.
This is a pediatric upper scope ultra thin. I tried to put a cap, and the cap I tried to, in US, those suction cannulas are of good size, and I tried to cut it, but it didn't make it into a cap. Other thing is, Randir, you can put a wire through this.
Yeah.
I grab the wire, and then we will figure it out how we exchange.
This thread is not going.
You can actually cut the thread and use the fresh side of the thread.
Yeah, just give me the cut. Just give me the scissors, please. Scissors.
Open.
Cut this. That.
Just a second. Let me open. And Just a second. I'm going to hold the needle. Okay. And slowly close. No, open.
Can we use another suture?
We can use some non-absorbable ones.
दूसरा suture लो जरा. Holding लिया. So this is not going to be cut it on the wrong side. This is the best. The hub doesn't take this. Can somebody focus on the
Dr. Sousa, we will just switch to room
Sure,
1 for a minute and we'll come back, sir. So, Dr. Shanky, can you please give the history for the case in room 1?
From this side. There, a little bit this side. Just a second.
Sure,
Yeah.
sir. So, in room 1, we have a case of a 63-year-old female who came with symptoms of dyspepsia. Endoscopy was done, which revealed a submucosal nodule.
We need
in
sound,
D1.
please. Don't hear you so well.
So, EUS showed a hypoechoic mask of around 10 mm in size, which was originating from layer 3, and which was biopsied, and biopsy came out to be neuroendocrine tumor. So, our plan is ESD.
Sir, we live in room 1 with Dr. Nilay, sir.
Hi, so basically I'm Nilay. Pankaj is going to guide me. If there is a duodenal NET, which we nowadays can encounter very frequently. The question is, should we be removing it? Yes, all duodenal NET theoretically should be removed. How should we be removing it? With EMR or modified EMR or ESD or full thickness resection. Full thickness resection is good if the lesion is bigger, like 1 to 2 centimeter, and there is a possibility that it has gone into muscle or the muscle layer has become very thin. Otherwise, either you can do EMR or ESD. Again, if it is less than 1 centimeter, as you can see over here, I prefer a band EMR. So normal EMR, the problem is that these lesions are mucosal but also submucosal. In fact, it is more submucosal. So you try to do a simple EMR, you can cut through the tumor. So it's better to do a modified EMR, either band EMR, or you do a complete circumferential resection with an ESD knife, which is called pre-cut EMR. But again, that has also a potential of cutting through the lesion. So either I can do ESD, so if this lesion was 1 to 2 centimeter, with EUS, and EUS is absolutely mandatory before doing any resection technique for duodenal NET. So if it has shown that it has gone into muscle, then I would do an ESD, or because there is a chance that I can have full thickness perforation. So here what I am planning is band EMR, and that's what probably Pankaj, what
Yeah,
do you
I
say?
think that is a very safe option for small lesions like this, because you don't need to struggle with an ESD, and the results are equally good. So what we do is do a band and cut below the band, so the chances of cutting through the tumor becomes very less.
And for normally when we do ESD, we see the depth of invasion by doing an NBI. In net, probably that's not very useful. So what scope I'm using is 1500, and that's a X1 series high def 4K. So my colleague is saying it's not high def, it is 4K, right? So I am still missing 8K over here. So basically, and it has something called TXI. RDI you all seen when the bleeding occurred during ESD. They
Yeah,
all showed, and even poem time we saw RDI. So this is TXI. It enhances the texture. So can you just start the normal thing and immediately start the TXI? Can you start TXI now? So it enhances the mucosal pattern, as you can see over here, and you can see a lesion very clear. So without wasting much time, so I'll just check whether this can be sucked into the band, and normal band, we only use esophageal band. So you seen the cap over the scope, and I try, and so entire lesion is coming in. So I am good. So now what I'll do is I'll take out my scope and go back again with an esophageal band ligator device.
One more important thing is any duodenal ESD, I think what we do, or whatever, EMR, ESD, whatever, it is mandatory to close the defect.
Absolutely.
That is what I think we should follow.
Before starting procedure. So our plan is take it out. If there is a full thickness resection and there is a perforation, then we'll use full thickness resection, full thickness clip like ovascope. If that is not the case and we can still see muscle, then we'll close with the duodenal, with the normal clip. It is mandatory to do something in duodenum, then close it, because you have a high chance of delayed perforation in this scenario, especially if you have used cautery.
Absolutely.
Can we use a loop and loop followed by EMR?
Yes. Loop followed by EMR. This lesion cannot be taken with loop. Loop will slip off. Loop will not stay over here.
Loop and clip, usually you need
he's not asking about closure. Before resection, can you use
apply a loop
like polyp? No, here the loop will not stay.
Yeah.
Yeah.
Nilay, will you do a submucosal injection and then do?
Oh yeah, very good answer. Very good question. Don't do submucosal injection over here, because if you do it, the lesion will become flat. You don't have to do marking also. If you are doing ESD, you need a marking, because you are going to do submucosal injection. When you do submucosal injection, the lesion becomes flat. That's why you do marking. Here you don't have to do anything. Just go in, suck it, take it in a band, go beneath the band, cut it, and then examine whether it's a full thickness resection, whether it's a complete resection, or there is something else.
This is a regular band ligation, what we are doing. I'll let you. This is attached to the muscle.
So this is true for any band. If you have froth and mucus, you just suck the gastric mucosa and it will clear off, as you can see over here.
Nilay,
yeah.
Which small lesions you would not do band EMR?
I think you can do all. Previously, we used to believe that at certain places submucosa is thin. You can do can't do band EMR, but with our closure technique, I think that doesn't hold true nowadays. You can do band EMR anywhere. And in fact, band EMR is the treatment of choice for rectal NET. You see rectal NET, band EMR is the, so two places, small duodenal NET and rectal NET, do a band EMR.
Enhance the suction as much as possible, and then just apply a band like we do for varices. And then just take it out and then see. Yeah. Perfect. You see the entire lesion has been banded. So now we'll just take out the cap and go in with a scope and a normal cap.
Nilay sir, just give us 1 minute. We can go back to Dr. Reddy's room for a minute. We'll come back.
Yeah. You can go and come back.
Thank you, sir. So we are back with room 3, Dr. Reddy sir.
Cap laga dena hai.
Problem is, yeah. So as you are aware, we had a lot of discussion, and this turned out, I think we actually didn't follow Jung's instructions. Usually I follow his instructions, but this time didn't follow his instructions. We cut a little more. Jung, you're there. So we cut a little more, and then we're now deep into the bile duct. Can you see the anatomy? Who is sitting there? Panel?
Ramesh was there. Yeah.
Ramesh.
Devendra is there. Devendra, Arvind.
Yeah. Arvind. So Arvind, if you can see what happened here, the bile duct is arising totally from the right side of the pancreatic duct. Totally abnormal anatomy, reported in 4% of people, but in this case it's much more abnormal. If we can actually look, if we can have some glucagon or bus. Can you see the anatomy now? The pancreatic duct stent is on the left side, the bile duct is on the right side, right?
Yes, sir.
We're not getting any feedback from there.
Hello.
You agree?
Yes,
Can
sir.
you hear us?
Yes, sir.
Dilavari is
Yes,
there.
yes.
Dilavari is there. Young Dilavari.
Yes, I'm there.
Yeah. So Dilavari, see the anatomy. What you taught us is totally different.
Yeah, I know, I know.
It's coming from the right side.
I
Very
was-
abnormal. So when we cut the right side, it opened up a little more and you could see the bile duct. So now the wire is deep in the bile duct. I'm coming out, and then what we're going to do is short sphincterotomy before we go further. Now I'm going to see this. Can you see the anatomy now?
Yes.
Very nicely. The left is the pancreatic duct, right is the bile duct, totally opposite of what happens normally.
Yes.
Can you bend the sphincterotome a little, Bhagwan? Needle knife, it's
No, no, sphincterotome.
just to come out, yeah. Now you can see the sphincterotome out there. I'm going to do a sphincterotomy. Open the bile ducts now. Okay, so that next time somebody goes in, you won't have this problem. You see, this is the bile duct now opened, and see the anatomy of the pancreatic duct and bile duct. There's some gross abnormality there. Okay, now we come back, come out, and you can see the lesion on the fluoroscopy here. What I'm going to do is quickly do a radiofrequency ablation. Can we define the lesion very well, Bhagwan? Better we inject some contrast, define this lesion well.
Sir, this
From
altered
below.
anatomy is because of the diverticulum or some fibrosis has happened
No.
there?
It's I think a combination of fibrosis, diverticulum, and some sort of a congenital anomaly. In fact, Reem was looking at the MRCP and pointed out that can you inject some contrast. You see, fortunately for us, maybe you can get away with a single stent in this case, because you can see the stricture there. You can see all the ducts are communicating now. Okay, and right on the top, you see the right anterior duct, which with other ducts are communicating. So I think what we'll do is we'll do a RFA of that lesion, and for the RFA, just have a look at the machine here. Quickly, so that we took too much time. So this is a totally abnormal anatomy, and that's the reason this problem. And I think collective heads helped here. Screen, fluoro, please. Yeah.
Dr. Reddy sir, if you just give a minute, we are ready with the snare there for the
Okay, no
pulpectomy.
problem,
We'll
no
just come back, sir, in 1 minute.
Push the screen.
Room 1, please.
Okay, so basically
I think
what we
that-
did when you were away, we changed the scope with a cap.
Dr.
and-
Nilesh sir, we are alive.
Yeah, so we changed the scope, and you can see that now I put my snare beneath the band. You can see it if you can. And so before that, I orient the lesion towards the 7 o'clock, because that's where the channel of the snare will come out of the channel. So initially it was at the 11 o'clock, but I changed the scope orientation, and then I put it at 7. And now we'll start cutting.
Use endo cut.
Okay, cut. It's done. Okay,
Suck out,
so
suck out,
first let me take out the tumor, and then we'll examine the.
Just suck. वो ये निकाल दो, snare निकाल दो, तो suck होगा ना? बस.
बैंड आ गया यार, कोई बात नहीं, इट्स ओके. ऊपर है, पानी डाल दे. So suck it in a cap and take it out.
Retrieve it, yeah.
First retrieve the tumor, because otherwise you can miss it.
Continuous suction.
Dr. Eli?
High chance of falling in the oral cavity or somewhere.
Okay.
Dr. Eli?
So, yeah.
Can you hear
Pani,
me?
pani.
Can you give us some
Okay.
tips how to prevent perforation? We are always scared of perforation in such patients.
Yeah. So perforation can happen. If you see, there is a complete removal of the tumor. Can you see this?
Yes.
So I think that we should not call it a perforation. It is a full thickness
It's a
resection.
complete resection of the tumor.
Yeah,
because
so I
you
think-
don't see any tumor at the base. Now we'll go in and examine the wound or the resection site. And of course, depending on what sort of resection it is, we'll decide on the clip. So let's go in.
CO2 on है?
CO2 on, yeah. Okay. So, see muscle is seen properly. There is no tumor.
So this is always, usually this is what we see when you do a band EMR.
So, no need to do ESD when the lesion is less than 1 centimeter. Band EMR is equally good. Unless you want to increase your ESD number, there is no other indication.
Nilesh sir, thank you sir. I think we're ready with the RFA in the first room. Dr. Reddy sir, we are coming back to you live for the RFA sir.
Close clip.
So you can see that what we did was we put the RFA probe inside. It's just at the stricture side. Can you see the fluoroscope images?
Yes, sir, we can.
You can see the RFA catheter just exactly at the site of the stricture. Now I want you to concentrate on the RFA generator. This is the ELRA generator. Can you see the generator on the screen?
No, sir, we are not able to see the generator.
Now?
Yeah,
Now can you see? Yeah, now you can. No. Focus.
Focus on this.
This is very important looking at the RFA generator. No, focus. RFA generator.
This part.
It is out of focus.
Now you can see exactly, yeah, right. So you can see that is showing seconds on the right. Mahesh can point towards the seconds.
Yep.
And then you can see the wattage on the top.
This is the
that's
time.
the seconds. And this is
Temperature.
actually temperature, which is very important. So what you're seeing there, the temperature 71, 72, that's important. The wattage you can see on the top is varying and impedance is varying. So impedance and wattage can vary a lot. Earlier machines we used to fix at a certain wattage, which was wrong, and now you can see why it's wrong, because even if maintaining temperature 75, you get a wattage of 0, whereas sometimes it goes up to 10. So you fix it at 10 and hope this is temperature sensitive. It stays at 70 to 75 all the time, and that's where the best RFA occurs. It's a slow cooking at that point of time between this period. So we just have another 10-15 seconds.
So Nagi, you do it for 2 minutes.
Yeah.
You'll do it for 2 minutes.
I usually do for 2 minutes with between 70 to 75.
And the area it covers is 33 millimeters?
This covers 33 millimeters.
And the depth?
The depth usually, if you do it for 2 minutes, it gives a depth of about 10 mm. And no time. No, I don't think.
Then we should have shown it before.
Yeah, I think now best.
Sequentially go after that.
Yeah, so if there's a long stricture, this stricture is about 3 centimeters, so this should be okay. The long stricture I do sequential. That is what I do is I start from above and come down. So you can leave the wire in place.
So we decided to put only a single stent because we can see both the right and the left ductal system is getting filled. So Nagi, you're going to choose that long stent?
Yeah, long stent. I'm going to choose a uncovered metal stent. Again, Hylar uncovered, push the wire. Uncovered stent is very important. And now you can see some bile also coming out nicely. Finally, we're seeing bile coming out. And you can see again the relationship between Arvind is there on the floor.
Dr. Nagi?
Yeah.
I do a lot of anal papillotomy, and I've seen almost 21 patients, they have the CBD opening on the right side rather than on the left side, around 1 o'clock position.
No, yeah, we can, if you want to put 2 stents, usually uncovered, but on rare occasions, we can put one covered on one side and uncovered. But generally for Hylar, we prefer to do completely uncovered on both sides. So now you can see the anatomy again very nicely between the bile duct and the pancreatic stent there.
Bring them back, or do you just bring them back out?
So we have 2 protocols. If you're doing repeated RFAs, we put a plastic stent and call them back after the second week to the second RFA and then put a final stent. But if you put a metal stent, we don't call them back. This is final now. And this patient will go on chemotherapy, and some of them respond to a combination of chemotherapy. Along with that, they live 3 to 5 years quite comfortably.
So when there is a type 2 block, you'll prefer a right rather than the left?
A type 2 block, the wire goes straight in right anterior. That's the reason why I'm preferring that. Otherwise, a bend can sometimes make it some more difficult. But because this is, you can see exactly that this wire is in the right anterior, and it makes it very easy. Can you see the stent going in now?
Yes, sir, we can see.
Yeah. So this is a 10 millimeter, 10 centimeter stent, a very long stent, because you have to go right up to the top there. Fluoro, please, you can see that I have now gone. Can you see the stent on the fluoroscopy? You
Yes,
can
sir,
see an
we
air
can-
cholangiogram.
We can see it
quite
going
well.
beyond hilum.
Yeah, it's beyond hilum. I am right up in the right anterior hepatic duct. Now you can see the lower part of the stent. Can you go down a little and show me the lower part? Lower part of the stent is still not out of the endoscope. But what we'll do is we release the stent, and as we release it, it goes up, and then you can see the lower part very well. Can you, Bhagwan, can you release the stent? So Bhagwan is releasing the stent. You can see here the stent being released.
Yes, so Nagi, I can see the yellow mark there.
Yellow mark, just outside, yeah. Now it's traveling up. Now I think, can you see the endoscopy picture, the yellow mark there?
Yes, sir. Yes.
Can you see it there on the screen? So that is the lower end of the stent. So constantly we keep the lower end of the stent outside the papilla, about 2 centimeters when you are releasing it, and gets finally released, it's 1 centimeter. Now you can see the upper part of the stent is just getting released now. Yeah, you can start releasing it. Start releasing it, start. So I'll just keep carefully watching the lower part. So Mahesh, everything is okay?
Yes.
Keep.
Nagi, do you ever dilate this stricture?
If I'm putting plastic stents, I sometimes dilate.
Or
But metal stents, if it's a very tight stricture or 2 stents, I always dilate. Now can you, I can see now the upper part of the stent has just opened up. Can you see this? And the lower part now, we'll concentrate on the lower part now. Open, close. Yeah, open the stent, open the stent. Open this. Open the stent. Open, Bhagwan. Okay. So now you can see nicely it's opened up.
Yes,
you can see full.
We are not hearing some claps.
A huge round of applause, sir, from all.
Very nice case.
Yeah, so it's a very difficult case, and you can see the stent nicely in
Yes.
place now. And again, you can see the relationship between the pancreatic stent and the bile duct stent. And you can see the stent is already opening up the stricture. So post RFA, the stricture becomes a little soft and opens up much more easily than non-RFA patients. And you can see the stent nicely in place now. Okay.
So Nagi, you showed that managing one wife may be difficult sometimes.
No, I think there's also several lessons from this case. One is that pre-cut you have to do layer by layer carefully, use epinephrine saline to flush, watch very carefully each layer, and of course, you again, like Jung said very correctly, that don't go beyond a certain point. But sometimes you can have an abnormal anatomies like this, and of course, persistence is very important.
Yes, sir. There
And
are so
it's
many.
also good to have advisors like we have here, yeah.
There are many take-home points from this particular one case, but perseverance is, I think, the top of all.
Perseverance, safety. Safety is more important. I think that is the key thing.
Yeah.
Nagi.
So thank you. I think this patient should
Nagi.
have good relief now. Yeah.
I'm glad you proved me wrong.
Thank you, Jang. We always follow you. Yeah. Thank you.
Thank you so much, sir. We'll just go to room 2 with Dr. Sood and Dr. Buttar there for the
Sorry,
special
Steve,
update.
I didn't want to put a cholangitis and prolong this patient's for anesthesia.
We have, put
Two
in
wires.
two sutures, and now we have taken these sutures out from the mouth. We are going to put in another suture. This is where is it? So this is this.
So I should be,
Wait.
you see me?
Wait. I think just pull the needle back. Pull the needle back. It's hitting the opposite side.
Now?
Yeah. Just pull it back a little. I'll separate it out.
Do you see the thread?
I don't see because I don't see the needle yet.
Oh, you
but
don't
it's
see
it's
the
at the opposite wall. That's why. But I can see the needle now. I see the guide wire.
And you see the thread?
I see the previous thread.
Not this one, huh?
We are working in a very narrow space.
Can I get another artery forceps?
Give another artery forceps. But Navtej, if you bring the needle back a bit,
okay,
and then I'll know that what you're hitting is the right spot. Because
it came out.
Yeah. Now I know.
Okay.
Now I know where you are.
Actually, the thread is already in. And, anyway, I'll pull it back again.
Slightly back.
Okay. So, okay.
hand out of the way for a second.
Yeah. Yeah, I can see the needle impinging.
On the opposite wall
yeah,
or the same wall?
Same wall, same wall.
Okay, so more
yeah,
of
more
it?
of it, more puncture, because you're not punctured yet. Because it's quite fine. Yeah, now you have punctured it and gone to the opposite wall. Just hold in. Let me separate it out from the opposite wall.
I was actually thinking if I have artery forceps, I can put it from here and, okay, so. Do you see it?
In fact, I'm blinded for a moment, yes. Now. We are impinging on the opposite wall.
Okay.
So I'm understanding it, you just pull it a little, then possibly it will. Yeah.
You see it?
Yeah.
Okay, do you want to, you have a way of grabbing that thread?
No, let me see. Just go scope ko pakdo.
Hold the scope.
Hold the scope here. Yeah. Just a minute. I'll take my forceps here. Open. Close. Wait. You see, thoda sa open karo. Open. Now you say you withdraw a little. Withdraw a little. Withdraw a little. Withdraw a little. Little more. Little more. Little more.
Good.
Yeah. Now it's good. Now I just push it in a little, because I'm keeping the opposite wall away. Wait. Now I think I will be able to do it. Abhi close kar lo. Open karo. Bas. The problem is that when the space is so little,
yes,
that the wall it goes into the opposite wall.
Opposite wall, yes. Let me just see if I can.
You see,
can you take this out of the sheath? Yeah, take it out completely, please. Yep.
Sheath ko nikal.
Yep. There you go. You hold the wire on your side, huh? Don't worry about it. I have a handle on it. Just a second, huh? Am I able to send any more thread?
No,
or no?
Actually, I'm not able to see the wire and your needle anymore, because let me position myself again.
Okay.
Yeah, this is where you are impinging it. So this is going into the opposite wall.
Okay, so it's going in. So if I move it around, will that help? Is that needle out there?
Yeah, there's the needle. I see the wire now.
I see your scope hitting the needle.
Yeah. Not the biopsy forceps.
Okay.
Open. Open. No. Close. I'm trying to pull the needle upwards.
Yeah, let me just see, hold this thing. You don't need that one.
Wait a minute. Now I have got enough needle to see, to decide, to try to grab the wire. Can you rotate the needle?
Yes, which direction? Tell
now
me.
it's okay. Now it's okay. Now it's okay. Okay, just hold on. Open. तुम इधर देख, तुम अपना उधर ना देखते यार. Close करो. Open. The needle is because it's a tangential.
You want me to rotate? Let me rotate the needle. Tell me when it's good or not.
The problem is that I wait. Grab the needle, close. No, it's slipping because it's only the part. I thought I'll pull it up upwards.
So let me just do this. I'm just going to send this one and use this one to keep the area open. And then you see
Wait.
this is the cable.
Yeah, I can see the needle now. I can see the.
Sood sir. Dr. Sood sir.
The forceps.
Yeah, I put the forceps, and the forceps will keep the posterior wall out of the way.
Wait. No, I think, but I see the forceps only. I don't see the needle.
Oh. Okay. So.
Needle is in this wall.
Needle should be a little bit proximal to that.
Yeah. The needle is
on
distal.
Let's go move the wire out of the way for a second. Actually, I think if we take the wire out, it may actually help us. Yeah, take the wire out. Take the wire out. And do you now see the?
Wait.
Let me just see.
Section. Yeah. No, I don't see anything.
Let me just see if I can. Okay. Let me send this again so that you can see it whether, so you see my forceps?
I'll have to see where the forceps is now. I think needle is, yeah, needle I can see now. Now this is forceps or needle? Needle, this is the needle.
Okay.
Yeah, wait, इसको पकड़ो, ऐसे पकड़ो, ऐसे. Just rotate the needle. Rotate it, open, rotate it. Rotate it further. ये तुम तेरे से नहीं. Close. नहीं. The needle is actually embedded in the opposite wall. Slightly, if you pull it,
okay,
it might make it easier.
You know what I was thinking? If I take that fistula and pull it up a little bit. Now, do you see more space?
Wait. Yeah, I see more space. Wait. Yeah, just here. Open.
I think you're tugging on it, it looks like.
Yeah. I'm tugging and just trying to get into the right plane. Yeah, close. Like open. Close.
I think thread is getting pulled.
I caught the thread.
Pull it into the channel, see if it.
Yep, it's going. Going, good, 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 good. Keep taking, keep taking, keep taking. Stop now.
Stop?
No, I have a very small, so you have the thread there, right?
Yeah.
Okay, so I'm going to take this needle out for a moment. That way I can give you, I'll hold it really at the tip here. Now you can gently pull it. Keep pulling. Okay, now that's enough. Now I'm going to pull the scope out. And if you can send send that back into the lumen. We got the thread. All right. Push it out. Push it out, push it out, push it out. There you go. Okay.
Dr. Sood sir, can you please tell us what are the challenges we are facing there?
Okay, so now we have
Yeah.
no challenges at all. Life is simple. Okay. Now the question is, we need there are two options.
Can we take the scope out of the way?
Actually, we can show with the scope. What we did is, if I can show, there is the fistula in the trachea on the endoscopic image. And we have 3 sutures, 1, 2, and the third one. So they are almost like a triangle around this hole. That's the fistula. And there is 1 suture, 2, and there is a third. There are 3 of them. And now what we will do is that we brought all 3 of them out here in the mouth area. And what we will do is we will put a budget or a part of the stent so that it doesn't allow to cut through, and then we're going to stitch these sutures on the trachea side. Okay? So now we need to bring all 3 of them.
So biliary fully covered stent, partially covered stent, or scissors. Size is 4 centimeters sufficient, and get the cheaper one.
Yeah. And we have 1 thread, we have 2. Oh, that thread is nearly, it came off of this, and so if you pull it, I don't know which one it is. Okay, stop, there it is. Yep, that's that one. So we have barely enough. Yes.
वॉल फ्लेक्स नहीं चाहिए ना, मैं तेरे को क्या कि सस्ती वाली उसको बोलोगे चीपेस्ट जो कवर्ड स्टेंट है वो दे दो बिलरी या इवन बिलरी चाहिए मेरे को. आई डोंट वांट इसोफेजियल.
Can we throw the sharp?
Yes.
So that no one gets hurt. Thank you. I'm always thinking that if we partially deploy one of your biliary stent, put that thing and use that to attach.
चलो और ले आओ, 6 में ले आओ.
So मैं ये सोच रहा हूँ कि जो तो पीस छोटा काटेंगे. Yeah, Val, do you have one of those? We know why we waste stent. We can just use one of those plastic things.
Okay.
And है क्या वो? Do you have it?
डॉक्टर पवन को बुला दीजिए.
Maybe we can leave it. I'll
Can we have the
this is
external
long
camera
enough
view?
cable, so I'll put this one here. There you go.
Just have to coordinate कि वो लगे. मेरा सेल फोन किसके पास है?
Yep, tracheostomy side to put the 3 sutures, grab them out of the esophagus side.
उसको बाद में दिखा देंगे, अभी लाइव खत्म.
Right. So there, that's
अब लेक्चर शुरू करो, लाइव छोड़ो.
See it?
ठीक है ना?
That
हाँ,
right.
लेक्चर स्टार्ट.
I'm grateful to the chairpersons and the panelists for sparing their time. And now we are moving to our next session, potpourri. And for this, delightfully, I invite the chairpersons on stage. Dr. Kaushal Madan, welcome, sir. And Dr. V.K. Mishra. Dr. V.K. Mishra and Dr. Kaushal Madan on stage. Thank you, gentlemen. And I invite the panelists, Dr. Ramchandra, Dr. Ramchandra Soni, Dr. Rajesh Gupta, Dr. Itish Patnaik, and Dr. Sabir Hussain. We are all set for the session, and I turn the time over to the chairpersons.
Good afternoon, friends. For this session, the well-known speakers are there. Number one is Dr. Nageshwar Reddy. Dr. Amit Madhav. Oh, sorry. The first lecture is to be delivered by Dr. Amit Madhav. Dr. Amit Madhav needs no introduction. He is very accomplished endoscopist and very well-known endoscopist all over the world. He is our pride, Dr. Amit Madhav. He is going to talk about ampulectomy tips in the trachs. And we already saw one of the best case we saw today in the afternoon. Dr. Amit Madhav, please.
Thank you. So I'll be very brief and quick. Today you saw the procedure of ampulectomy, but that was the other extreme of ampulectomy, not the normal routine. So I'm going to show you something which is normal routine. Just to put things in the right perspective, that ampullary adenomas, the prevalence is somewhere between 0.04 to 0.12 in autopsy studies. Sporadic, or it can be with familial adenomatosis polypi. Now, if you have FAP-associated ampullary adenomas, then the pre-malignant potential is very high. So you see here, so this you have to be very careful. Clinical presentation, most of it is painless jaundice, 50 to 75%, or vague dull abdominal pain. Rarely ampullary adenomas may cause pruritus, cholangitis, or colic, nausea, vomiting, pancreatitis, anemia, and GI bleeding. So how do you diagnose it? One is indirectly. Patient comes with a sonography report of a dilated PD and CBD, which may be probably showing a mass or a filling defect in the lower end of the CBD. And direct diagnosis is with a duodenoscopy and biopsy. But let me tell you that accuracy of forceps biopsy of an ampullary adenoma varies between 62.85%. The reason is that quite a few ampullary adenomas are submucosal. So if you just try to take a biopsy, you'll just get some mucosa. You may not get the diagnosis of the ampullary adenoma. So therefore, you may have to cut open the ampulla and then take a biopsy from inside, or the best accuracy is a resected specimen. So if you're suspecting a localized ampullary adenoma, just take the whole thing out, send it for biopsy. That is the best accuracy of a diagnosis. So duodenoscopy with biopsy, what is the recommended biopsy protocol? 6 biopsies are recommended, and obviously away from the pancreatic orifice. So you should approximately imagine where the orifice of the pancreas is. Try to take biopsies from a different location. Otherwise, you may cause pancreatitis. And as I told you before, if it is predominantly submucosal, do a sphincterotomy first. But in case in your mind you are going to resect that tumor in the future, don't do a complete sphincterotomy. Because if you do a complete sphincterotomy, you may not be able to catch it in a snare at the time of ampulectomy. So cut it only sufficient so that some fleshy tissue bulges out, from which you can take a biopsy. Now, what are the indicators of an indwelling malignancy? If it looks indurated, rigid, or if there is mucosal ulceration, in your mind there should be an alarm that this may not be just a simple adenoma, it could be a malignancy. Why? Because ampulectomy is not the answer for malignancy. If it is a malignancy, the treatment is resection. Surgical resection, usually a local or a Whipple's. Then after you have diagnosed that it looks like an ampullary adenoma, you should stage it. Endoscopic ultrasonography is the best for staging because it's superior to CT, MR as well as ultrasonography. Now you see here that this is the way it looks, and here you can see there's a little bit of ulceration here. With EUS you can see the depth of the lesion, and most important, you'll see extension inside the CBD or PD. Very important because this can be one of the contraindications for endoscopic removal. IDUS is better than US but not available everywhere. MRCP is important. Why? Because invariably if you are going to undergo ampulectomy, the patient is going to undergo endoscopic ampulectomy, you have to put a prophylactic pancreatic stent. So you have to know on MRCP whether there is a alpha loop in the pancreatic duct. Because if there is alpha loop, then your stenting is not going to be possible. So you have to be extra careful to prevent pancreatitis. Or of course, if you find a divisum, then you don't have to worry at all. Then you can directly cut it. You may not even need a pancreatic stent because the duct is draining through the minor papilla. So MRCP is essential before taking the patient up for ampulectomy. So what are the suitable criteria for endoscopic resection? You can see from various studies. This was the ASG Standards of Practice Committee meeting, the paper which was published in GI endoscopy. Evidence level 2C, size up to 4 centimeters. Sometimes we can remove even larger ones, what you saw today. If the biopsy is negative for malignancy, if the intraductal extension is less than 1 centimeter, and if there is absence of advanced duodenal polyposis, then you are justified in doing endoscopic resection. So otherwise, don't do endoscopic resection. So endotherapy, what we do? 2 ways. En bloc ampulectomy, if it is a contained lesion, or a piecemeal resection, what you saw today, what I did, with adjunctive therapy, if it is a large lesion, sessile nature, and a lateral spreading component. Exactly what you saw in today's procedure. It was a piecemeal resection with adjunctive therapy. But if you have a contained lesion like this, the technique what we do is, I usually try to cannulate the pancreatic duct first and go inside the pancreatic duct with a glide wire, and then I inject a little bit of methylene blue, diluted methylene blue in the pancreatic duct. Why? Because when I remove the ampullary adenoma, it's easier to identify the pancreatic orifice. You'll see a little blue color on the surface. So this is what we do. So first inject methylene blue, then I'm taking out the sphincterotome after injecting the methylene blue. Now after this, you can just put a snare around it. Either you can put a snare from above downwards, or you can put a snare from below upwards. Now in this particular case, I put a snare from below upwards. So you open the snare, pull the scope back, bring the snare above the ampullary adenoma, completely around it, here, and then gently close it. And then move it and see. If the entire duodenal wall is moving, that means you have caught too deep of the adenoma. And then just cut it. You can see here the blue color. The blue color indicates that this is the pancreatic duct. Above here you can see this is the bile duct. Now it's not always as simple as this. Many times when you cut the ampullary adenoma, you may start seeing a little bit of oozing from the edges, and that oozing slowly increases as your procedure is ending. So usually after doing the procedure, as I told you, we have to place prophylactic stents because these orifices can stenose. So you place a prophylactic pancreatic stent and a prophylactic bile duct stent. Nowadays, we always place a single pigtail 5 French pancreatic stent and any type of bile duct stent. These stents are of course temporary, which you have to remove when you have the next relook endoscopy. What happens if there is intraductal extension? If the extension is not too much, it's less than a centimeter, but there is some intraductal extension, this is what the technique what we follow. See here, now I put the snare from above downwards, we resect the adenoma first, and then I go in the bile duct and I extend the biliary sphincterotomy. With this now you see some fleshy tumor from inside the bile duct which is coming out. So how can we take this out? Here, whatever tumor has come out, again go around it with a snare, catch it and take it out. If some tumor remains inside the bile duct, then we use a special type of a technique where you can see here, inside the snare we have loaded a biopsy forceps. So what we can do is, we can catch it first as much as possible with the snare itself, and if that is not possible, then inside the snare you load a biopsy forceps, and then With that biopsy forceps, we can catch the tumor and pull it out. Whatever is the little bit of lateral extension, that also we take out. You see here, this is the biopsy forceps. Now I passed inside the duct, and over this biopsy forceps, the snare is loaded. So with the biopsy forceps, pull the intraductal extension out and then push the snare. With this, you can actually pull out the tumor which is inside the bile duct, catch it, and then completely resect it. Of course, bleeding is one of the most major problems after ampulectomy. Here you can see how do we tackle the bleeding. One of the commonest ways is identification of the bleeding. Don't do blind coagulation. Properly flush some water. Here you can see now that we have cut the adenoma, and after cutting the adenoma over here, slowly the bleeding starts increasing. You can see a spurting type of bleeding, and here you can grasp it with a coag grasper, which we use for the POEM procedure. Pull the grasper back while applying a forced coag current. Preferably don't do soft coag, because even if the current is called soft coag, the depth of penetration is higher in soft coag. So here you may damage the muscle and create a delayed perforation. So this is the way you do it. And then what I personally do is, whenever we resect the tumor like this, and if there is any bleeding from the edge, after we have placed a pancreatic stent, here of course in this patient there was a divisum, so the stent was in the minor papilla. There was no need of a stent also, so we can close this defect by using clips. So what we do is, to further prevent delayed bleeding, you can close this defect completely by using clips, making sure that the pancreatic as well as bile duct opening which is cut is open. How do we prevent post-procedure pancreatitis? Routine use of prophylactic pancreatic stents after ampulectomy is recommended. Evidence level grade 1B. Meta-analysis of 5 prospective trials and 1 randomized control trial. So invariably, after every endoscopic ampulectomy, prophylactic pancreatic stent is a must. So after ampulectomy, what is the surveillance? If the specimen size is more than 2 centimeters, or if there is high-grade dysplasia in the specimen, then duodenoscopy within 1 to 3 months, and then every 6 months for 2 years. But if the size is less than 2 centimeters and no HGD in the specimen, directly perform the duodenoscopy after 6 months, and then after every year. Complications, it can be a dangerous procedure. Morbidity in reported studies is almost 23%. In some patients can be mortality also. If you are not careful, you can even create a duodenal perforation or massive bleeding, which you see as 0 to 21% in various studies. Pancreatitis is also common. So don't take this procedure lightly. You have to be an expert. Be very, very careful. And even after the ampulectomy is over, wait there for some time. Don't directly take the patient out of the OT. After 10-15 minutes, again put a scope inside and see. You will be surprised to find that bleeding has started. And control it, and only then send the patient back to the ward. Thanks for your attention.
It was a great lecture. Thank you, Dr. Amit. Any questions to Dr. Amit? Dr. Madhav, all those very tiny adenomas, say for example, incidentally which are found on upper GI or side wing endoscopy, and their size is 1 centimeter or so, should we routinely biopsy if they are looking absolutely benign?
Most of such type of adenomas are neuroendocrine tumors, if you ask me, most of them. So they don't require treatment all the time. However, if you want a tissue diagnosis,
you should.
You have to take the whole thing out, because they are very easy to remove also. The success is very high and the complication rate is very low. So might as well take them out and send them for a biopsy.
And if I don't take them out and they are very small, say for example 1 centimeter or even less, how often?
6 monthly. 6 monthly you can do a surveillance with a duodenoscopy. Yes, Mohan.
Yes, sir. Can I ask?
Dr. Mohan, yes.
Yeah. Sir, excellent lecture. And my comment about bleeding is sometimes the bleeding can be in front of us while we, as you said, we are putting metal plastic stent into PD by the time oozing start. But we have seen, in our series, we are called so often in the night. So what we have started doing is we do ampulectomy, keep the patient on recovery, don't send in the ward. And after 2 hours, once our work is getting over, by the end, we just pass a side wing endoscope and see. And you can believe 30% of the patient have bleeders which need some intervention.
Yes.
So that has prevented us to come late in the night or a sudden catastrophic bleed.
Absolutely true. But it also depends upon the current you are using while cutting, Mohan, and there are various factors to it. But it is a very good idea that you have a look once in the night.
Yeah.
But we routinely do have a look next day morning for sure, if not in the night.
Dr. Madhav, routinely, this is basically the endocut current which you use or the coil?
I use the normal endocut current, but in that case what we keep the cut interval little longer. So allow the coagulation to happen little longer.
One of the method, excuse me, sir. One of the method is to place a pancreatic wire and then do a ampulectomy over the wire. Then how we retrieve the tissue?
Yes, that is one of the techniques to make sure that you get the pancreatic duct orifice after the ampulectomy. But it is not easy because over the wire, how are you going to cut the specimen? The wire will come in the way, right? That's the problem. So therefore, we prefer to cut it and then cannulate the pancreatic duct. You should be reasonably sure. In fact, to tell you the truth, today's procedure, after I did the complete ampulectomy, it was just looking everything white. I could not see any orifice because I had not cannulated any duct. I did not put methylene blue. So only by imagination, I went in the pancreatic duct, and bile duct was easy after I went in the pancreatic duct.
From the floor? Yeah.
Excellent talk, sir, again. I just had two questions about the biopsy. Is there any specific recommendation for the biopsy forceps that you would love to use if you want to do a biopsy for adenomas, number one? And as you said, we need to take 6 biopsies. Is there any clinical marker during the first or the second biopsy bite which should stop us from proceeding further and taking any more biopsies?
That's very difficult to say, but if you have a fleshy tissue, which definitely looks like non-normal tissue, abnormal tissue, then you can even stop at 3 biopsies if you have sufficient tissue available. As far as biopsy forceps is concerned, we have a tendency of using the regular gastroscopy biopsy forceps, which are very stiff, and they don't bend easily with the ERCP scope. See, previously Olympus used to give us, along with the ERCP scope, special ERCP biopsy forceps, which were very flexible at the distal end. So ideally, for ERCP biopsy, you need a flexible biopsy forceps, where you can properly position it and take proper deep biopsies. But with increased experience, you can use any biopsy forceps, even with a spike.
Thank you,
sir. Rajiv?
Dr. Madhav, sir, regarding intraductal extension of tissue, you said that we can put biopsy forceps. So how it can be used? On one hand, we are putting a snare, either is
around the biopsy forceps, you load the snare.
Around the outside?
Yeah.
Okay.
Through the same channel.
Okay, through the same channel.
Yeah.
Okay, perfect.
So first you put the push the biopsy forceps, catch the tissue, pull it,
then
and then push the snare. So snare automatically goes around the tissue.
Perfect. Thank you.
One last question. I think extension of what Shabir asked. Why not, since you are cannulating the PD first, why not put a small stent and do the ampulectomy over it? Any contraindication to that? Or
yes, stent will come in the way of your ampulectomy, no? Because when you cut the entire tumor, there will be a stent in the middle. Your snare will not be able to close.
But it has an end. What he asked was a wire, then I understand it's a difficult thing.
Same thing.
A stent has an end. It can come out. It can still come out. The tissue can still come out. Wire is in the scope, but stent has an end in the lumen.
Yes, but you will have to ultimately cut it, right? Completely. So with a stent inside, you will not be able to resect the tumor.
I have one question.
Yes.
Sir, if the tumor has intraductal extension, so how do we ensure that the entire tumor has been removed from the duct? And do you routinely do biliary stenting even if the LFT is normal?
We usually do, unless your bile duct opening is so wide that you don't need to bother. But what's the harm in placing a temporary stent? There is no harm. Why to leave anything to chance? Because you have done so much amount of resection in that area. And for ensuring that you have removed it completely, the only way is to do a cholangioscopy. So you can do a cholangioscopy and make sure that nothing is remaining inside.
Right. Thank you so much. We have to move forward. Kunal, we can ask the question later. Thank you, sir.
Thank you, sir.
So, so for the next talk, it's a pleasure to invite Dr. Mohan Ramchandani, who will be talking on cholangiopancreatoscopy present-day applications, and I think he also doesn't require any introduction. All the three speakers are stalwarts in their own field. Mohan, please.
Thank you, Dr. Madan. At the outset, I thank Dr. Sood and their team for excellent workshop. I will be speaking about the cholangiopancreatoscopy. I think we are using this since long, and this has been the timeline. It started with surgical cholecystoscopy in 1941, but there was not much development until 2007 when fiber optic catheter-based cholangioscopy was introduced, and it became affordable for all the people. And then it suddenly started, there was surge of literature all over the world. So let's see how cholangioscopy is being used now. We have been using this for difficult stone targeted biopsies. These were the two major indications previously, but as we grew in the experience, pancreatoscopy, guided foreign body removal, tumor ablations, and intraductal tumor delineation, everything started coming up. So let's see what is there in each things, what new is happening. So the first indication which we use cholangioscopy most commonly is when we are not sure whether the stricture which we are dealing is malignant or benign. And in this era, it is not only important to differentiate between benign and malignant, but it is also important what benign. Say for example, chronic pancreatitis benign biliary stricture will require multiple plastic stent or metal stent, while IgG4 related disease which is benign but will be reversed by steroids, and if you have a tubercular stricture, it will require anti-tubercular treatment. Even malignant, you need subclassification, like say for example, lymphoma will require a chemoradiotherapy versus a cholangiocarcinoma which requires surgical intervention. So it's not only important for us to say what is benign and which is malignant, but what benign, what malignant, and we need some good tissue, guided tissue, and cholangioscopy provides us this opportunity to characterize and do the tissue acquisition. So everything started with image criteria. People started seeing the bile duct. It's like doing colonoscopy versus barium enema. So if you do barium enema and you have many diagnoses, but if you do colonoscopy to characterize a malignant or a lesion, you have a you are much more wiser. And in cholangioscopy also similar thing happened. People started seeing tumor vessels, and they saw if you have a tumor vessel, none of the benign have big tumor vessels. So the positive predictive value of tumor vessel is very high. And as we know, the cholangiocarcinoma is of three types: the nodular type, the infiltrative type, and papillary type. It is the infiltrative type which is most important because you won't get any mass on imaging. There is a severe desmoplastic reaction. You do how many brush, you will get all negative. So we want to do more, more interrogation of such strictures where a stricture is there, but nothing is positive. And that's how this cholangioscopy guides us. And we devised criteria like what is malignant, what is benign based on many studies, and irregularly dilated tortuous vessels and nodular mass, they were all suggestive of malignant lesions. Subsequently, because the inter-observer variation was so high that people started doing classifications, because if you have some certain classification that, okay, this is a villous pattern, but there are no tumor vessels, it is benign. Or you have a fibrous stricture like this. You can see there is a stricture which is like a fibrous. See that that's a very tight stricture, fibrosis. This is benign. So as soon as you see this type of tumor, you say that you don't even take biopsy, it's benign. While malignant tumors, you can see they can be of flat type, polypoidal type. Look at this tumor. This is a polypoidal variety of tumor with large tumor vessels. Or you may have a honeycombing pattern. You can see here infiltrative. This is the infiltrative variety of cholangiocarcinoma
where the biopsy pickup rate, cholangiographic breast cytology or biopsy pickup rate is very less. And moment you see such type of honeycombing on top and this infiltrative lesion with tumor vessels, this is malignant. Such type of classifications helps us to reduce the inter-observer variations. You can see the kappa value is around 80%, which is very high. If one person is saying malignant, other is also saying malignant. So this is how inter-observer variation using such classifications are gradually reducing. And we are also involved in a very large trial, including almost 300 patients, and we saw that sensitivity was much high of the visualization of cholangiocarcinoma. So is it okay if you do only visualization and do not take biopsy? Answer is no. There are certain varieties of strictures, like say for example, this is a stricture at hyla, and if you see the cholangioscopy, it looks like malignant. But if you take targeted biopsy, you saw there is no malignancy, only plasma cells, and once you started steroid on this, there is complete opening of this hilar stricture. So this is how the reversibility can happen if you have a proper guided biopsies and proper visualization of the tumor. Moreover, you need more tissue. Say for example, this is a stricture and this is the stricture. Both are same. But if you see there is a mass over there, and if in this also there is a mass. Both are malignant. But if you take targeted biopsy right from the mass, they are both malignant, but one is cholangiocarcinoma and other is lymphoma. The treatment completely changes. So that's how these cholangioscopies are helpful. But everything is not so smooth. You may get a very small tissue, but proper tissue handling is very important. And one of the things which we also do in our routine practice is take these what is known as rose tick. That is, a pathologist is in our room, and we call them and we take the tissue samples and do a tissue imprint cytology. That is, to take out the tissue on slide, and then we either take a smash protocol or just move the tissue on the slide and rapidly stain right in front of us in our endoscopy suite, and we get a rapid on-site evaluation, and that is almost equal to EUS guided ROSE. And this improves the negativity of if somebody is traveling from very far away and you always say, oh, it's still negative, we don't know what is to be done, at least we can give a proper tissue diagnosis. We also do lavage cytology. That means if you have a cholangioscope in the bile duct, you have taken biopsies, you don't come out, you instill some saline through one channel and aspirate all the bile from the other channel, and that will give you bile lavage cytology. And if you do the bile lavage cytology, the intrahepatic or unreachable cancers, your increase in pickup rate is there. So don't leave anything, do a good tissue imprint cytology, take proper tissues and do bile lavage cytology. That improves the pickup rate of cancer very much. The cholangioscopy are now expanding applications. There are many new coming up, like there is NBI cholangioscopy, chromoendoscopy. We are now doing ablation guided by cholangioscopy. We'll talk about this. This was one of the paper where methylene blue used to be injected in the bile duct, and if there is a cancer, the methylene blue does not take up the does not stain the cancerous cell, while the inflammatory cells and normal scarred cells takes up the methylene blue. So this was one of the few reports of chromoendoscopy within the bile duct, but this was not subsequently very popular. There is more image enhanced endoscopy enabled scopes coming up, especially the mother baby scopes and even the Boston scopes. They are working on it to improve the image enhanced endoscopy, and soon we'll be seeing some of the endoscopes which has narrow band imaging or other image enhanced endoscopy, which makes these tumor vessels much more prominent. You can do radio frequency ablation guided by cholangioscope, because you don't want to leave any area of a tumor to be left behind. You can see here like a PDT is being done based on cholangioscopy. This PDT and RFA are same type of ablation techniques which enhance not only the quality of life, prolongation of there is good quality of life studies available on both radiofrequency ablation, and so only thing is you should complete the procedure. In this procedure you can see you have done one ablation, but if you totally depend on ERCP, cholangiographic image, you may leave some islands of tumors. But if you are using cholangioscopic image, and every time you are doing one sitting and seeing the bile duct, and you are not stopping unless you have completely ablated the tumor, not only RFA, PDT is not being used in our country, but similar things can be done with RFA also. There are now through the scope, cholangioscope accessories available like snares, baskets, and now reports are coming to treat very high strictures which are not amenable to dilatation. You can do thulium laser guided ablation of these benign strictures. That's one of the method where you can do burning of these strictures as we do in esophagus web-like strictures, where we do the star-shaped excision of the margin. Similar burning of controlled, very controlled excision of the benign strictures are done, and they are early reports of good resolution of these strictures. Now the cholangioscopes, as I told you, you have accessories which can pass through, and under vision you can have cholangioscope. In this example you can see a stone which is difficult, sometimes it goes intrahepatic ducts, or when the bile duct is totally dilated, even a small stone becomes a problem. And under vision you can catch these small stone, hanging stone, or once you have done ESWL, you want to know that complete clearance of bile duct has been done or not, you can use such type of technologies. Non-complex biliary stones, now there are many reports including our series where we are doing a radiation-free ERCP, where bile duct is cannulated, bile is aspirated, and then subsequently a cholangioscope is passed to see the stones, and all the stones are removed under vision of cholangioscope, and subsequently cholangioscope is passed to say that bile duct is cleared. So this is radiation-free ERCP, and gradually we are moving. Once we have cholangioscopes which are so commonly available, we may move away from fluoroscopy completely, but still the many work is required, and this is one of the randomized trial which we have participated, and results are awaited. Percutaneous cholangioscopy with a 65 centimeter cholangioscopes are also available, and we use it when we are dealing with complex strictures, intrahepatic strictures, and once a PTBD is there inside, you can go through this PTBD and do many therapeutic procedures, including selective guide wire placement. You can see there is a stricture over there at the hepatico-jejunostomy side. No way we are able to pass the wire into the jejunum because the opening is so small. You can see the opening is just like a wire thick. You guide, under guidance, we can pass this wire right into the jejunum, and then subsequently once the wire is inside, you can dilate and put the stent. So this is another study which we were part of. This is known as cholangioscopy discovery, where 88% of patients achieve clinical success. I will not go into the detail. We are doing much laser lithotripsies now, which is very known. The laser lithotripsy in patients who have severe cholangitis or those who are transplant patients, you can pass these cholangioscopes through the disposable duodenoscope and complete procedure as a disposable one. Not only the ERCP, but also the cholangioscopy, guided lithotripsy, are being offered to very, very sick patients. Cholangioscopy is one, you can pass the same scope into the pancreatic duct and achieve pancreatic ductal lithotripsy. So this is known as intraductal pancreatic lithotripsy, where if you do not have the access to ESWL, you can use intraductal lithotripsy, but every patient in our country are not amenable for intraductal lithotripsy because our stones are very hard, spiculated behind the strictures. We may not be able to pass pancreaticoscopy in all patients, but yet in Western literature they have shown a big success, but I have my reservation on this. We also use pancreaticoscopy for assessment of IPMN, where you can guide your surgeon about the R0 resections. You can decide whether the IPMN is non-invasive or invasive. The disease extent you can change the diagnosis. You can have minimal complications with this, and you can see that as you are coming out from pancreatic duct, you can see a fish egg appearance of the pancreatic ductal mucosa, and this is nothing but IPMN, and you can pinpoint how much is to be resected and how much is the duct which is normal. So with this, I'll end my talk in one more slide, that we also did a randomized trial with fluoroscopy-less ERCP. There is no radiation. You do ERCP under direct visualization. And our ERCP patients who came to us, we randomized them either to routine conventional ERCP versus patients who were not done ERCP but direct cholangioscopy. And that increased sensitivity, and overall cost was reduced, because if you have a conventional ERCP and multiple negative studies versus one procedure where there is upfront cost, but it is much more sensitive, and you can avoid multiple hospital visits. So that's a food for thought for everybody. As I said, cholangioscopy has got a lot of inter-observer variation, and here comes the role of AI. And as you see, the inter-observer, the kappa value is 66% on the non-expert to decide whether one tumor is malignant or benign, and much AI work has been done. And once AI is applied on these images, there is a huge bank of image, and then our kappa value from 66 improved to 86%. So with this, I'll end my talk. I have one more slide, but anyway, cholangioscopy and pancreatoscopy are now very important tools in our day-to-day clinical practice. We routinely use this as an accessory rather than a tool which was previously, when I came to therapeutic endoscopy, mother-baby cholangioscope was very precious. Even it was last case, and people were worried whether it will break or not, because it is very difficult to get it repaired, but not anymore. We have now catheter-based cholangioscopy, which has made life easier, and we are using it day in, day out as an important accessory rather than a very costly tool. With this, I'll end my talk, and thank you very much for your patient hearing.
Thank you, Rohan, for an excellent presentation. Since we are running short of time, just one question or comment. Or maybe the organizer is saying not even a single question. So we'll move on. Thank you, Mohan.
Good evening, friends. For the next talk, I invite Dr. Nageshwar Reddy. Dr. Reddy needs no introduction at all. He's so well known to the world and to the country that he needs no introduction. He'll be speaking on robotics in GI endoscopy. Are we getting there? Dr. Reddy, please.
Thank you. So I have this topic on robotics, probably potential future, but you can see that, can you start from the beginning? Yeah. So a Japanese samurai can become very consistently accurate and do the same thing again and again without any problem. But for all of us routine human beings, this is not possible. We require a machine like this which potentially can do the same thing, exactly do the same task with precision all the time. So this type of precision cannot be attained by human, because as we go along, we get a certain amount of fatigue, our posture changes, and exactly the same task repeatedly being done becomes a failure. And that's the reason where robotics come into. In fact, if you look at what happened in endoscopy over the last 6 years, it's the same. The same light source, the same, it's just that from fiber optics we changed to video scopes, but still working in a three-dimensional way in a same process. So what are the areas that endoscopy can improve? Of course, image processing has improved to a large extent. We have enhanced images now. What can improve, of course, is steering of the endoscope and endoluminal therapies. And for this, of course, robotics is going to be useful. So the next 5 years, I think the trend in endoscopy is going to be a shift towards robotics and also a shift towards artificial intelligence. What is happening now is very interesting, is that we're now starting to get new robotic systems, along with them artificial intelligence added to that. There are at least 3 of them commercially available now, very costly, right now mostly in the field of third space. And this is an interesting development that occurs that is definitely improve the quality of diagnostic endoscopy and also therapeutic endoscopy. This is the first ever human robotic flexible endoscopy done in the world. We published this several years back in clinical gastrohepatology, where it is called a master-slave system, where I am the slave here and my colleague Dr. Pradeep actually is in the back doing the procedure. I am just showing the camera for him to do the procedure. And a complex ESD is being done, and you can see completely resected. This would have normally taken 8 hours, but using this mother-slave robotic system, it just took us 15 minutes to complete the procedure. This is the advantage of robotic system. So there are several things, again, because of time I won't go into the theoretical aspects, but you can see the robotic driven instrumentation, there are several now available. Some 3 of them are commercially available, costing about $1 million each, so very I think expensive for us. The main use of robotics in steering and locomotion is to reduce pain and discomfort during endoscopy. For example, in colonoscopy and enteroscopy, we know that the robotic systems take a straight pathway without causing any problems. Of course, to reduce complications like perforation, to enhance, of course, to reduce the stress and workload on endoscopies. So these are the main, and that's how technology is developing in this area. Of course, we require also some more things to develop in this area, better tissue retraction devices, tissue approximation devices. Most of the works in robotics is now being done in these 2 areas, retraction of the tissues and apposition of the tissues. Because if you look at what is happening in the surgical field, there's a dramatic developments here. In fact, these Da Vinci systems that are available, and now 2 other Medtronics and Cambridge have come up with similar robotic systems, which give fantastic ability and triangulation to do all these procedures. Unfortunately, this cannot be replicated in our flexible endoscope because of the complications involved in trying to do this. There are 2 types of flexible endoscopic platforms, the mechanical ones, which came initially, and some of them are being still developed, but mainly now you have the electronic ones, the electronic robotic system, the master-slave system is the one which is most commonly used. So just the concept of endoluminal manipulation using a robotic system is like this, that you have a central endoscope and you have triangulating arms. Again, a very simple concept. So you're working like a laparoscopic surgeon. So we have this ability now to not only dissect but also to suture, because this ability to move our hands 360 degrees, which cannot be done with the conventional endoscopes that we're using now. And so I think this is something that is coming up, and in fact this is the device that is now available currently, which is being used in some of the centers in the world where you can use this to guide our actual device. In fact, the whole idea of endoscopic robotic very interestingly came from a dinner that Sidney Chung was having with Lawrence Ho in Singapore, and they were eating a Singapore crab, and they thought, why not endoscopy have claws like this crab? And this is the first diagram of the crab claw that Sidney Chung actually drew on the napkin in the hotel there. And from there, this whole concept came up and developed. Interesting concept. And this was the first endoscopic system, and this is a study that I told you about. In fact, Rob Hoss wrote an editorial in Clinical Gastroenterology Hepatology after this article was published, saying that this is a small case series. We actually did only 6 patients, but it was a giant stem for endoscopy. Unfortunately, since then, the development has been very slow because of the regulatory problems involved, the economics involved, and so on. But it's now started now in recent times that we're starting to get this system activated again, where you can even see that we have started getting manufacturing things done. So with this new system that's now available, which is probably going to be available from somewhere in the middle of next year, a variety of procedures like this, dissections and all can be done, suturing and so on also. And you can see this, how retraction has improved remarkably. You can in fact retract, cut the tissue and like a surgeon hold it up and then dissect. You don't have to use submucosal injections, try and dissect, and all these complex things can go off using this system. Very neatly you can cut, and in fact the surgeons use a laparoscopic techniques to do some of these things in the rectum, but it's very difficult because they're rigid. But with flexible systems we can do it very easily. These are the first series of studies published using this master-slave system on colonic ESDs, and you can see that the average time taken initially used to be large, but now it's getting small. There's no difficulty in manipulation and absolutely very few complications with this system. So I think this is going to be the future. The first clinical trials have started and they're almost finished now, some of which we are also participating. So for the endomaster system, a little difference from what we use in the standard endoscopy room, it looks more like an OR room. So I think as endoscopists, you should start getting used to this OR room concept, where the surgeon stands, where the anesthetist stands and so on. But look at this, we can really manipulate well. We can, after a little submucosal injection, you can really remove these tumors extremely fast. In fact, with some of the master-slave systems, even me who's not into third space endoscopy like Mohan or Zahir in our unit, even I could do this type procedures in just about 4 or 5 minutes. So I think this is the advantage, that even an average endoscopist will be able to do very complex ESDs and third space procedures with this type of scopes. And of course, there's been another recent study from Hong Kong which published the series of 45 cases where ESDs were done in different levels and very little adverse effects, and of course bleeding in all these patients can be controlled very easily because of the new cartridge systems that have come. There are of course going to be other methodologies are available. Medro robotics is now available in United States. 5 institutions in US are using the system predominantly for rectal area, where you can see again how easily it is, and most of these experiences have been reported also from Dr. Burham, and in South America another group is also using this. So this is, you can see very easily how you can retract the tissues and take it off, so that, like I said, for even an average person, big ESDs become very easy. IRCAD in Strasbourg in France has developed another system, little different system, but you can see this system where triangulation is much more. IRCAD actually is run by a group of surgeons, and they started to do flexible endoscopy work, so they think like surgeons, and you can see how much triangulation they could achieve, so that you can actually do typical surgical procedures that you would do using this. And this is of course Colabris, which is another system that is developed in Strasbourg, and how this Endoquist robotics are being used. Again, you can see in all these videos they're predominantly used for ESDs. We still don't have robotic system for doing ERCPs or US. I think that's going to take some time. There are potentially a lot of applications for this. For example, massive bleeding peptic ulcers can be very easily tackled if you have this type of system. Perforations and leaks can be very easily closed. And I think in future, endoscopic bariatric surgeries are going to be done predominantly by robotic system, because it makes it much more easier to do this type of thing. And you can see the suturing technique that I told you about. Just like a surgeon using these systems, we can easily suture using a flexible endoscopy. So I think this is going to be one of the major advantages that's trying to drive robotics in GI endoscopy. So this is recently a new arm that's going to come in, which again some very new developments in this area. This is still not published, but this is an arm system that is being developed at the Chinese University of Hong Kong, and gives it, you can see how flexibility is there to actually do suturing and so on. But ultimately it's going to be nano robots. These are actually medical micro robots which can go into the system and get in fact reorganized and do a variety of procedures. In fact, I was surprised that our Indian Institute of Science at Bangalore and the IIT at Hyderabad have already have these micro robots. We have been looking at some of these, and these robots are very small. They go into the body, reorganize themselves as tools. In fact, engineers are already using these tools, and then can do a variety of procedures. In fact, this early animal studies are being done with these robotic systems, where going inside, you can use these robotic systems to go. They have an assembly system, and for example, you can drop them in the bile duct, they assemble together, go to the area of target, like for example, a tumor in the bile duct or in the deep segments of the liver, and then you can either give radiation, chemotherapy and so on in a very precise fashion. So these are coming in, and I think these are going to be something that are going to be available in our lifetime itself. So this is an interesting development that's occurring in this area. So I think in future, you'll find that both artificial intelligence and robotic systems are going to be used mainly not only to enhance the diagnosis, but to do complex procedures more easily and to do certain procedures that we can't do now. The future is, of course, is going to be nanorobots, and that is going to be a very exciting development. Of course, there are many hurdles for these to come into clinical practice. It requires, in fact, both engineers and doctors to come together, which is not very often. It requires, of course, strong clinical evidence that these type of procedures are superior to current procedure, not only in terms of clinical outcomes, but also in pricing, economics. Unless it's cheaper, people won't use it. So this, I think, is very important. Of course, we realize that still human brain is very important. It drives the robots, but ultimately we have to take the help. We are now, I think, presently only limited by what we can imagine. The way engineering is developing, it's just that imagination is a limitation for us, and because this is going to come. In fact, with so much of development in both AI and robotic system, so for the first time in history, there walks upon this planet a species so powerful that it can control its own evolution at its time of choosing. That is us, Homo sapiens. So who will be the next created species? And I think it's going to be these autonomous robots, not only in endoscopy, but all aspects of life. Thank you for your attention.
Thank you, Dr. Reddy. This was one of the very futuristic lecture we ever heard. And I understand that this is possibly the future which we are going to see. But the organizers tell us that there are no time for questions. So no questions. And thank you so much. Thank you so much. And now we are going for 2 or 3 minutes live to the endoscopy room. Am I right? 30 seconds.
Over to the live room.
We are live, sir. 42.
Just give us a minute. We are on for you here. Okay. Can you hold this? Needle is right there. Can you hold the needle?
42.
Can you hold? Do I have the another?
OT2.
Yes, so what we did is we
are live, sir.
Okay. So we'll show you from, okay, you can cut it right here. I can take the endoscope. Okay, if you can, there you go. So what we did is we took a suture from trachea side and brought it out through the mouth, and then tied this a rubber sheath. So there are knots on this side. That's the hole right behind it, right behind the pleasure there. And then we brought those sutures out and stitched them right in this space on the trachea side. And so early on there was a hole right here where the sutures are, and they are now covered with the stitch. That's the knot. And we had three stitches, one going at 12 o'clock, one at one at 8 o'clock and one at 4 o'clock, and they're all tied together to close this area. Problem with this lady is every time she'll put a tracheostomy tube, she'll injure it again. So that's what we will be putting a smaller size pediatric tube. We thought about putting a stent here, a LAMS type of stent, but that will create a pressure necrosis and extend this fistula up on the 12 o'clock or 9 o'clock location right here, because there will be some lateral pressure. We also thought about leaving this open, but the trouble is the tracheostomy may close. Although this is a chronic tracheal fistula, it shouldn't close. So that's where we are with. We have one last suture that will put it together and we're done. Thank you. अच्छा इसको थ्रेड इसको नॉट को भेजना नीचे.
Now is the time for the EPL Cup, and I am delighted to invite the judges on his stage. I welcome Dr. Amit Medeo, Dr. Mahesh G. Goenka, Dr. Sandeep Laktakia, Dr. Amol Bapai, Dr. Rajesh Puri, and Dr. Pramod Garg on stage.
So as we are getting ready and the judges are joining us on the stage, let me tell you the rules of the game. We have 6 presentations, and each presentation will be for 5 minutes, followed by 2 minutes of interaction. So the request to everybody who is presenting is not to exceed their time, because that will get a negative mark. Dr. Puri, you are supposed to join us on the stage. So is Dr. Amit Medeo here? Sandeep Laktakia and Dr. Pramod Garg. Otherwise, we'll start.
We have 6 shortlisted candidates for the EPL Cup. I request the speakers to first introduce themselves and then present their videos. I request the judges to give the score between 1 to 10, 1 being the least and 10 being the highest. So I invite our first presenter here, and that is Dr. Shivam Khare. Dr. Shivam Khare.
Good evening, everyone. So my video topic is stir for large irregular shape multilobulated 90 to 5 centimeter lower esophageal subepithelial tumor, challenging removal of tumor from the tunnel and closure of mucosal incision. So 35-year-old female presented with complaint of dysphagia. Endoscopy shows the large subepithelial tumor near the GE junction, and CT also showed large subepithelial lesion in the esophageal wall without any metastasis. In endoscopy, we can see this mass causing obstruction to pass upper GI scope into the stomach. So what would be the treatment options? Surgery and endoscopy. So for STIR criteria for tumor removal, tumor transverse diameter should be less than 30 to 35 mm and tumor mass index less than 1000. But here transverse diameter is more than 50 and tumor mass index was very high. Discussed with thoracic surgery team, they also felt the surgery would be difficult, and also discussed with patient prefer endoscopic treatment. So first 2 centimeter mucosal incision was created. Then after getting the entry into the tunnel, tumor was separated from the mucosa and muscularis propria, and after this in few areas tumor was found adhere to the mucosa, where getting adequate space for dissection was difficult. So hence risk of mucosal injury is there. So caution should be taken during dissection in this area. After that, the two lobe of tumor was clearly seen after creating the tunnel distal to the tumor. But another small lobe of this tumor was found deeply embedded into the muscularis propria. This tumor was carefully dissected from the muscularis propria because I wanted to save at least longitudinal muscle fiber of muscularis propria to avoid complication related to CO2 insufflation. So here we can see the completely separated third lobe of the tumor from the muscle and mucosa. But I found another fourth lobe of this tumor, which is deeply embedded into the muscularis propria. Again, carefully dissection was done in this area, and tumor was separated completely. So the shape of this picture shows the shape of the tumor. It has 4 lobes and quite broad transverse diameter. First, I tried to get this tumor in en bloc, but I couldn't get success. Then I tried to snare polypectomy, but I removed only small fragment of the tumor. So finally, I decided to go with special surgical electrocochlear settings, auto cut, watt 100 and effect 4. That will help to fast cutting of the tumor, and it is also time saving. Here I use the IT knife that will help to avoid mucosal injury and muscle injury here, because that is very fast cut. So first that tumor is divided into 2 part, then in 4 pieces. Then each fragment removed using the snare. The one large fragment impacted into the upper esophagus, but I could able to remove this by using a snare. So this is the resected specimen. Then this is quite big tunnel. After the removal, here due to multiple attempt of the removal of the tumor, which causes the wide opening the mucosal incision and thinning of mucosal plaque, but I could manage to close this defect by using the clip. And patient kept NPO for 2 days, but on day 2, gastrographin was going into the tunnel. So again patient kept NPO for another 3 days, and on 5th day, X-ray showed minimal pleural effusion. So on endoscopy, there was complete dehiscence of the lesion. So what were the options for large mucosal filling defect? We can keep the patient NPO or NJ feeding, recrippling or suturing, or mucosectomy. But these are not possible in this case because there is evidence of pleural effusion. So I decided to go with stenting. So first I removed all clip one by one because that can be cause of delayed healing. One small clip seen inside the cavity, that was also removed. So I preferred beta stent in this case because the diameter is 24 and it has low risk of migration. And stent also fixed by the using loop and clip technique here. And gastrographin was so no leak, and stent was removed after 4 weeks, and complete mucosal healing was seen here. So conclusion, we can prefer the endoscopic removal over surgery in large multi-lobed tumor. Don't try to get en bloc resection if transverse diameter is more than 3 to 3.5 centimeter. If these tumors are hard, so they're difficult to cut. A special electrocautery setting can be used for piecemeal resection, and use IT knife here to avoid mucosal and muscular injury. Novel endoloop and clip technique can be used for stent migration. Thank you very much.
Excellent demonstration, Shivam. Congratulations. One question. When you perform an intracorporeal morcellation, which you showed that using the autocut technique, unless the tumor is attached in some way to the, inside the tunnel, it is very difficult to generate the electrical current, basically because the electrical current will not pass through. So did you perform the morcellation while the tumor was attached, or did you
do
it after the
tumor was completely separated? But I think the reason of this tumor is still in the cavity. Tumor was still in the cavity. So I think current was passing from the mucosa or some fluid inside the cavity that will also create the current path.
In that case,
yes,
most likely there was more mucosal injury, and that was the cause of the dehiscence, because that can lead to more mucosal injury because the current is transmitted to the mucosa.
Okay.
Any questions from the house?
Otherwise, sir, this was very broad tumor. If I didn't cut, then I can't remove
No,
this
you
tumor.
need to cut that,
Yes.
definitely, but probably leave some attachment and then at that time cut.
What was the histology?
Sir, leiomyoma.
The whole thing was leiomyoma.
Yeah. Welcome.
With the permission of the judges, I invite the second speaker, and that is Dr. Aditya V. Kulkarni. I welcome you, sir, on stage. Request you to kindly introduce yourself and then present your video. Thank you.
Good evening, judges. Many thanks for this opportunity. I am Dr. Aditya Kulkarni from Kolhapur. My case today is endosonography guided duodenojejunostomy as an access to anastomotic stricture dilatation for choledochojejunostomy done for a patient, and he was presented with recurrent cholangitis. So, choledochojejunostomy is a primary surgery done in type 1 to 3 choledochal cysts. The incidence of anastomotic stricture is up to 13.2%. The treatment options include surgical redo with a subcutaneous biliary axis limb or a gastric limb, percutaneous transhepatic drainage, or a enteroscopy guided recurrent stricture dilatation. We did a endosonography guided duodenojejunostomy with a hot axial stent as an access for a stricture anastomotic dilatation. So this was a 26-year-old lady who was presented with recurrent cholangitis, who had underwent a choledochojejunostomy at 16 years of her age, and now she had developed anastomotic stricture with bilateral IHBR dilatation and multiple stones. We had attempted a spiral enteroscopy but couldn't reach the stricture site because of an acute bend. So she underwent PTBD to relieve her cholangitis. This was the PTBD pictures. 2 weeks later, we had called the patient back and we did a US guided duodenojejunostomy. So this was the pictorial image. Through the duodenum, we could see the anastomotic site here, and through the PTBD stent, we infused water and methylene blue and filled the jejunal loop, which was to be targeted. And once the loop was targeted, we were able to deploy a hot axial stent across. This was the deployment of the proximal flange, and then completed the procedure by deploying the distal phalange and creating a duodenojejunostomy. After that, the patient was discharged in the next day and called back after 2 weeks again for the appropriate stent dilatation. After that, after 2 weeks, we were able to pass an endoscope, normal endoscope or under CO2 insufflation through the hot axial stent into the axis limb, and we were able to see the PTBD stent in situ. We are able to push a guide wire across the anastomotic stricture, and then we had dilated the stricture with a balloon. This is the post-dilatation anastomotic stricture. A 7 French stent was placed and the patient was discharged. She was having no recurrence of any symptoms or cholangitis. She has been with us for follow-up for almost about 9 months now without no other symptoms. 9th month after, she had come again. When we did an endoscopy, we could see adequately dilated anastomotic site. So we had removed the lamps which we had replaced, and we could see a duodenojejunal anastomosis which can be easily accessed through a gastroscope for any further intervention required. So to conclude, US guided enterostomy as an access for biliaroenteric anastomotic stricture dilatation is a novel procedure which can be a very good alternative if patient refuses surgery. There are only few case reports of such procedure being done, although long-term results are lacking. Thank you.
Congratulations. Very nice case, very innovative.
Thank you, sir.
What's the long-term option?
Yes.
How much have you followed up after the stent removal?
Sir, we removed the stent just recently, just about a month back, sir. So we need to know the long-term follow-up of these patients. Of course, they can have a stricture again, but since the stent is not in situ presently, But if in such case we have to dilate and go in again. So
Not a definitive surgery. She's a young lady, a definitive
yes,
surgery would be a much better
so
option.
we had given her an option of a definitive surgery, but she refused it. And even with surgically, the other option is there are chances of again re-anastomosis further. So usually surgeons either keep a biliary axis limb or a gastric limb. This is the US guided way of creating an axis limb for recurrent anastomotic dilatation.
So very nice technique, very novel idea. So which endoscope did you use to go through your lamps, number one? And number two, any long-term complications of the newly created duodenojejunectomy?
So I used a regular 170 gastroscope, Olympus 170 gastroscope for the to pass through the stricture. I had used 20 lamps, so the anastomosis was quite good for the endoscope to pass by. And the only concern is after the removal of lamps, the chances of the stricturing of the anastomotic site. But the long-term results we need to follow up and see, sir.
After how much time you removed the lamps?
After 9 months.
After 9 months you kept the lamp?
Yes, sir.
My second question is, you anastomotic site, how many plastic stent you placed? What was your protocol for dilatation?
I did not place a plastic stent. I placed only one 7-French stent at the hepatico-jejunostomy stricture site, sir.
So do you think hepatico-jejunostomy stricture can be all right by putting one stent? Is it possible, like all gastroenterologists, patients require PTBD and at least 4 sessions of dilatation with the 2 or 3 catheter in place. So 7 French stent is sufficient to dilate the edge stricture?
So we had dilated.
You have a tract in front of you. You might have gone every 2 months. You would have dilated multiple times as the PTBD protocol is there. Or any benign biliary stricture, you go put multiple plastic stents. So why you have not done only one plastic stent was sufficient?
So the patient did not have any recurrent symptoms of this thing, and when we did an endoscopy, we could see that the anastomotic site was quite dilated.
Dr. Puri, brief question, please.
One quick question. You already had a PTBD inside.
Yes.
So why couldn't you dilate the stricture through the PTBD? Of course, it's very innovative what you did, but isn't that a lot more simpler?
Can you add your question to that?
Yeah, so my question is, you had PTBD and you had a place to insufflate the jejunum, which is attached to the hepatic. What if there is no PTBD? Can still the jejunal loop be punctured without being filled with water? I've seen few reports, but
Yes.
that makes this procedure much more important because there is
Yes.
no PTBD done at all. So now as the questions were there, once PTBD is there, why not to utilize that first? Once failure occurs, then go for this. But other way would be without PTBD access, if you can distend that loop by needle, and then it will be much better, much more non-invasive.
I think we
Sir,
will move on to the next presentation.
Thank you so much, sir.
The next presenter is Dr. Savan Bopanna. I invite you on stage, sir.
Good evening, everyone. Today I will be presenting a difficult ASD, basically a duodenal flat lesion at D3, D4, and the location of the lesion is what made this difficult. So, as a 63-year-old female presented with a history of melena, endoscopy was done outside, which showed some blood clots beyond the ampulla and a sessile flat polyp in D3 beyond the ampulla. Biopsy was taken, which was suggestive of a adenoma with low-grade dysplasia, and she was referred for endoscopic removal. So, this is how the lesion looked like. You can see that it's beyond D2, and that's the lesion. It's a well circumscribed lesion and Paris 1S. So we plan for a endoscopic submucosal dissection to achieve an en bloc removal of this lesion. So the standard methods were followed. Submucosal injection of saline was done, and fortunately we could achieve a good submucosal lift. The initial mucosal incision was placed on the oral side of the lesion. We then enter the submucosal space by careful dissection. Then by repeated submucosal injection, we could find a good plane, and then we dissected in the submucosal plane between the muzzle and the mucosa. We followed the conventional technique of ESD, and there were large submucosal vessels, and as we see in the duodenum, which is very vascular, and they were all prophylactically coagulated using the core grasper. And the dissection was completed till the entire lesion was raised as a mucosal flap. Following this, we used the IT knife to cut the mucosa and finally dissect out the lesion. Following complete dissection, we retrieve the specimen using a snare. And then the base and the edges were coagulated. And that's the final defect. Because it's a duodenal defect, we decided to close it with the loop and clip application. So we used a detachable Olympus loop, and clips were attached all along the mucosal defect. And finally, the loop was closed. And an adequate mucosal closure was achieved. So the histopathology showed that it was an adenoma with high-grade dysplasia with no invasion beyond the basement membrane. The lateral margins were free. So post-operative period, the patient was asymptomatic. We did a recheck endoscopy prior to discharge, which showed that the loop and the clips were seen intact, thus reducing the risk of delayed perforation or bleed. So the reason for a challenging ESD in a location like this beyond D2 is basically it's in the post-bulbar location, and the scope fallback is repeated because of the C shape of the duodenum. The lumen is narrow, and therefore there's limited space to work. The duodenal wall is thin, and it's therefore prone to perforation. There's extensive vasculature in the submucosa, especially in the duodenum, and therefore it makes it prone to severe bleeding. And there are a lot of Brunner's gland in the submucosal layer, and at many places the lift is not sufficient. And in case of any problem, surgery in this area is going to be extensive and morbid. So these are the reasons why we found the challenges that we actually foresaw before performing the procedure, but we could remove the lesion en bloc. Thank you.
Dr. Papanam, good demonstration. The question is that what is the best procedure? Could we have done this with an EMR, a cold EMR, underwater?
So cold EMR would be preferred if the lesion was smaller than 1 centimeter. Otherwise, in a lesion like this, we would have to do probably a piecemeal EMR. And underwater, at this location, the water really doesn't stay like we saw in the morning, so it keeps moving off. So, but it can be done, and it's an option. It's an option which can be considered versus ESD.
Yeah, because this would have been quite faster and easier with a simple underwater EMR.
Yeah, and actually water will stay at D3, D4 level. Water will usually stay there because there's a DJ flexor is at an angle. So if you paralyze the duodenum well, water will stay there, and the lesion wasn't that large. I think you could have gotten an en bloc underwater. That is what I thought at least.
So yes, I agree that could be done on underwater EMR.
Any comments from the house?
I think the interesting part of the presentation, we had dots in the video where you could play those points, which is a learning for us also. I don't know, any of you noticed that?
Thank you, sir.
Thank you, sir. Now I invite the fourth speaker, and that is Dr. Arun Arora, on stage. Welcome, sir.
Good evening, everyone. I am Dr. Arun Arora, Fellow in Advanced GI Endoscopy from Dinanath Mangeshkar Hospital, Pune. Now I am going to talk on topic Modified Parectal Endoscopic Myotomy Technique using ultra-slim gastroscope in a child with Hirschsprung disease. A 14-month-old male child presented with constipation since birth. Stool frequency was once in 4 days. He was dependent on laxatives. Bare minimum was suggestive of congenital megacolon. Anorectal manometry, rectal inhibitory reflex was present. Sigmoidoscopy, cap EMR biopsy was taken at 4 centimeters, 7 centimeters. Histopathology showed aganglionosis in both the biopsy specimens taken at 4 and 7 centimeters. IHC, calcitonin is negative and transition zone at 7 centimeters. So we decided to perform PRAME under general anesthesia, patient in jackknife position. Initially, PRAME was performed with adult gastroscope using conical cap. Submucosal elevation by using 22 gauge injector. Mucosal incision was done using dual J knife. However, we faced some challenges. Entry into the submucosal tunnel using adult gastroscope was difficult. So we decided to do PRAME by using ultra slim scope. So PRAME was carried out using ultra slim scope. We fashioned a customized distal attachment from a proximal tip of 5 and 5 mm ET tube. Proximal end of ET tube was cut flat to create an 8 mm long attachment. Cap was approximately 2 mm beyond the distal tip. Ultra slim transnasal gastroscope chosen. Diameter is 5.5. Distal attachment 5.5 from ET tube. The other challenges were specific knives could not be passed through 2.2 mm working channel of ultra slim scope. A 25 mm polypectomy snare and 6-inch system was used. Submucosal tunneling was carried out with ultra slim scope. Initially, submucosal tunneling was done with the help of a 25 mm polypectomy snare. The difficulty was it was harder to push into submucosal tunnel for the initial 1 to 2 centimeter of tunnel, and the scope was kept falling out. So initial 1 to 2 centimeter of the tunnel was difficult, and needle injector was used for injection as 25 mm polypectomy snare could not be used to inject. So we decided to use replace 6-French cystotome as it can simultaneously inject and dissect the submucosal space. Ultra slim scope submucosal dissection was carried out using 6-French cystotome. Simultaneous injection and dissection was carried out using 6-French cystotome. And small 10 centimeter submucosal tunnel was made. Bluish hue was seen crossing the contracted segment, confirming adequate submucosal dissection. 6-French cystotome was replaced with the 25 mm polypectomy snare as 6-French cystotome was too blunt to carry out myotomy. So the myotomy was carried out using a 25 mm tip polypectomy snare, and the myotomy was carried out in a retrograde fashion. The myotomy was carried out posteriorly. Almost a 10 centimeter myotomy was performed posteriorly. After the completion of myotomy, again the slim scope was extended with the normal adult gastroscope for closure of mucosal incision using the endoclips. Post-procedure day 1, patient passed semi-solid stools, and on day 4 he was discharged. Follow-up at 1 week, patient was passing normal stools with a decrease in unit laxative usage and without any requirement of enemas. On 2 weeks, sigmoidoscopy showed rectum with solid stools. Distal cap fashioned from 5.5 mm tube provided optimal functionality. Challenges during submucosal tunnel entry. Limited submucosal tunneling was possible due to space constraints. Ultra slim scope was floppy and therefore harder to push into submucosal tunnel for the initial 1 to 2 centimeter of tunnel dissection and kept falling out. Snare tip does not allow simultaneous injection and dissection during tunneling. 6 French cystotome was superior because it has the ability for injection and dissection. Snare tip and blunt tip of cystotome may prevent injury to the mucosa or muscle layer and therefore may be preferable to snare tip for submucosal dissection. Cystotome tip was too blunt to carry out myotomy. 6 French cystotome and 25 mm polypectomy snare are alternatives to conventional knives for performing submucosal dissection and myotomy due to small diameter of working channel.
So, Dr. Arun, I think it's a very good case, good novelty, and things was very good. The only one question is why you use the ultra slim scope. It was not upper GI, it was a rectal route. So what was the reason of using the ultra slim scope? You would have used the pediatric scope or the small diameter scope because your accessory would have worked better. So what was the reason for that? It was not esophagus, it was a rectum.
So due to difficulty in initial entry of the submucosal tunnel, sir. Submucosal tunneling was not possible with the gastroscope. So we have to use the slim scope, sir.
And suppose this patient, your expertise was not there, then what is the other option you have advised to the patient?
Yeah. Good presentation. Just two questions.
Sir.
What was the length of the A ganglionic segment? And second, why wasn't the patient sent for the Duhamel procedure or the modifications of the Duhamel procedure?
Sir, length of the ganglion is 7 centimeters, sir. So when compared to the surgery, this frame technique has less morbidity when compared to DML procedure, sir. And the functional outcome is also good when compared to surgery, sir, because there is decrease in laxity requirement, and the Hirschsprung HIQL questionnaire score was also improved when compared to pre-frame procedure, sir.
But the question is, child is 4 years old. We don't know what is the long-term result. Your Duhamel, you have, I think, more than 10 years follow-up.
Sir, but subjectively, patient was showed significant improvement, sir, because there is requirement of enemas pre-procedure, but post-procedure there is no requirement of enemas, and laxity was also decreased, sir.
Thank you so much. Now I invite the fifth speaker, and that is Dr. Sharat Chandra. Dr. Sharat Chandra, welcome on stage.
Good evening, everyone. My presentation is on endoscopic ultrasound guided transesophageal drainage of radiologically inaccessible segment 8 liver abscess. Radiologically inaccessible abscesses are managed with laparoscopic or open surgeries, which carries high rate of morbidity and mortality. EUS guided drainage allows easy access to these abscesses. It's a safe, minimally invasive alternative approach in such patient. EUS allows easy access to radiologically inaccessible left lobe liver segments, whereas in the right lobe, only segment 5 and 6 can be approached. Here we report 3 patients with radiologically inaccessible segment 8 liver abscess who underwent successful EUS-guided transesophageal drainage. Coming to the clinical presentation, a 31-year-old male presented with history of high-grade fever and abdominal pain of 7 days duration. His investigation showed a leukocyte count of 17,800 with 89% neutrophils. His platelets, prothrombin time, and renal functions were normal. Ultrasound done showed a subcapsular heterogeneous abscess in the caudate lobe, which was radiologically inaccessible. Patient was started on IV antibiotics, antiamemics. However, he continued to have high-grade fever and severe abdominal pain. As the abscess was located in the caudate lobe, which is easily accessible by EUS guidance, patient was given the treatment option of EUS-guided transluminal drainage. On EUS evaluation, EUS evaluation showed a large abscess situated deep to the IVC. The abscess content was partially liquefied. The segment 4A and the caudate lobe was not involved. There was a window available to access the abscess cavity, transcaudate alongside of the IVC. A 19G needle was carefully introduced within the abscess cavity. Aspiration yielded anchovy sauce suggesting amoebic etiology. We went ahead with the plan of our EUS-guided transluminal drainage. First, the guide wire was coiled within the abscess cavity. This was followed by tract dilatation, first with a 5 French, 6 French, followed by 7 French, and then a 10 French Sohendra dilator. Cystotome was not used as we are going along the side of the IVC and there was little margin for error. This was followed by deployment of a 10 French nasocystic drain within the abscess cavity, ensuring all the side holes of the NCD are within the abscess cavity under fluoroscopic and EUS guidance. The CT scan done showed that the NCD was passing through the right crus of diaphragm through the caudate lobe into the abscess cavity. NCD was put in intermittent suction until there was spontaneous drainage aided by gravity. Patient improved following EUS guided drainage. NCD was internalized on day 4 and patient was discharged. NCD was removed at 8 weeks. The second patient was a 55-year-old female with segment 8 abscess with contained rupture. Her total leukocyte count was 22,500 with 92% neutrophils. Based on our previous experience, patient was offered the option of EUS guided transesophageal drainage. The EUS again showed that the abscess was situated deep to the IVC. Within the segment 8, the caudate lobe and segment 4 was not involved. The abscess cavity could easily be accessed transcaudate alongside of the IVC. The rest of the steps were the same as in the first case of guide by coiling, tract dilatation, followed by deployment of a nasocystic drain within the abscess cavity. Third patient was another 41-year-old male with segment 8 liver abscess, which was radiologically inaccessible. Again, the EUS finding showed that the abscess was deep to the IVC and it could easily be accessed transcaudate alongside of the IVC. All these 3 patients improved following EUS guided drainage. Coming to the clinical implication and the lesson learned, abscess that are localized to the posterior medial aspect of segment 8 in the vicinity of caudate lobe can be radiologically inaccessible. Such is the location of these abscesses is that they at times can be misinterpreted as caudate lobe abscess. A detailed radiological localization of inaccessible abscesses allows better planning and execution of EUS guided drainage. Coming to the axis, there are 10 reported cases of EUS guided drainage of right lobe liver abscess. In all, transduodenal approach was considered. Right lobe abscess, especially segment 5 and 6, can easily be accessed from the duodenum. Transduodenal access is not feasible for segment 8 as it is only partly visualized, is located far off from the probe. There is limited maneuverability in the duodenum. IVC comes in the path of access. Segment 8 abscess can be accessed transesophageally to the right crus of diaphragm alongside of the IVC through the caudate lobe. This is the first report in world literature on transesophageal EUS guided drainage of segment 8 liver abscess. The transesophageal route is safe for EUS guided drainage. There are 4 reports of EUS guided transesophageal drainage of left lobe liver abscess. When we drain segment 8 abscess, we are going little higher up through the right crus of diaphragm alongside of the IVC through the caudate lobe. The technique, it's safer to use mechanical dilators than cystotome for tract dilatation as we are going alongside of the IVC. Liberal tract dilatation should be avoided as we are going through the crus of diaphragm. Coming to the endoprosthesis, nasocystic drain is the preferred endoprosthesis for transesophageal drainage. NCD placement required concordant tract dilatation compared to stents which require liberal tract dilatation. It makes drainage more predictable by allowing active aspiration and or flushing if it gets blocked. It can diagnose biliary communication. Fully covered SEMS or LAMS are not a suitable option as we are going to the crus of diaphragm. In conclusion, EUS guided transesophageal drainage is a viable option for draining radiologically inaccessible segment 8 liver abscess. Thank you.
Are you concerned of adverse events which can happen since you're very close to the IVC? And what is the backup plan in case there is any adverse event which happens to us?
So, attempt to enter the abscess was only made when I was sure there is a window available. What happens when there is an abscess? It expands the abscess cavity. So what happens? The IVC is little displaced. So there you get a window, especially where it is near the segment 4A. There is a site where you can get a window. In all the 3 cases, it was at that site we could get the window to enter into the abscess cavity because we did 3 cases and none of the patient there was any problem.
When will you consider sending to an intervention radiologist?
Actually, sir, these abscesses, the threshold of draining these abscesses varies. In state-of-the-art hospitals, we have experts. We can do anything because they have the infrastructure. Most of the 2-tier cities and in places where they don't have a structure, they don't have a backup plan, there's no surgeon available at times, no interventional radiologist there to intervene in such patients. So that is the thing, isn't that if we can, endosonographer can do these procedures. This is a high reward procedure, simple technique and easy to do.
Dr. Sharad, do you think putting a fully covered metal stent and going repeated time in is a better option?
Yeah, actually when we can achieve the same result with a simple nasocystic drain, which is very cheap, and there are no chance of any complication because it's not going to get migration. There is no migration risk. When we do anything in the esophagus, there is a very high risk of migration.
So I have a 2 concern why I'm asking. You have done, I think, around 8 or 10 cases?
So I've done around 30 cases plus now.
30 cases.
Yeah.
Because the 13, the only most important that when you put a nasocystic catheter inside, the pus is thick and it gets blocked.
Yeah.
And you need to flush it.
So actually, I mentioned that for first 24 hours, they are on continuous suction. We use a syringe just like what we use in our US needle. We put a syringe on continuous suction. Usually in 24 hours, it usually empties off. Whatever we wait is for the biliary communication, because these patients
How much negative suction you apply?
We apply a good amount of suction with a 10 cc syringe, what we use in US
What
needle.
you apply on the back to create a negative suction?
We apply a syringe. We put a syringe and we apply a smaller syringe to make a continuous suction. Like what we do in our US needle, we have that system. Similar, we can use two syringes to apply it. One is a big syringe. Other is the two ends we can put another syringe in between. So that gives a continuous suction. So that's a simple way of giving suction. And we give it for 12 to 24 hours and it usually empties off.
Okay, thank you.
Thank you.
Thank you, sir.
Inviting the last presenter today, and that is Dr. Sandeep Pal with Abhishek Chakravarti. Dr. Sandeep Pal with Abhishek Chakravarti.
Good evening, respected judges, faculties and delegates. So I'm Dr. Abhishek Chakravarti representing R.N. Tagore Hospital in Kolkata, and the case that I'm going to describe is one where we did sequential drainage of the biliary system and GI in a case of locally advanced carcinoma of the gallbladder. So our patient was a 47-year-old female with carcinoma of gallbladder locally infiltrating the cystic duct who had underwent an ERCP and decompression of the right hepatic system before. And patient was on chemotherapy when she presented to us with fever, pain, abdomen and vomiting with a total bilirubin of 19.2 4 months after the first ERCP. A contrast CT of the abdomen showed that there was a GB mass which extended up to the hilum with separation of the left and right hepatic ducts, with proximal end of the previous ERCP stent decompressing the right anterior hepatic duct with IHBRD in the right posterior and left hepatic duct. So a repeat ERCP with stenting of the left hepatic system was planned. However, when introducing the duodenoscope, we found that the pyloroduodenal channel was grossly infiltrated and narrowed, and scope could not be passed to the second part of the duodenum. So what we encountered is a problem that I have tried to pictorially depict in this picture. There were two obstructions at the level of the biliary hilum as well as at the level of the D2D. So both of this had to be mitigated. So since the patient was in cholangitis, the first thing that we attempted was a EUS guided hepatogastrostomy using the echoendoscope from the lesser curvature of the stomach. We identified a dilated duct in the left lobe of the liver in around segment 3. We introduced a 19 gauge EUS FNA needle. The position was confirmed fluoroscopically and also by aspirating bile. Once bile was aspirated, a bit of contrast was given into the inside the ducts and a cholangiogram was obtained. Once the complete cholangiogram was obtained, the guide wire was negotiated and was made to cross the hilum into the right hepatic duct. Once we went into the right biliary system, since the common hepatic duct was completely obliterated, so we placed 10 millimeter into 10 centimeter partially covered geobore type of stent with the uncovered portion inside the biliary system and the covered portion, as we can see in this diagram, the covered portion outside in the gastric lumen. There was free flow of bile noted. So 2 days post this procedure, that is after 48 hours, we attempted the next procedure, that drainage of the gastrointestinal system. We avoided, did not go for a duodenal stent. What we attempted was EUS guided gastrojejunostomy. Since the pyloroduodenal channel was, D1 was infiltrated, so we advanced a guide wire through the duodenal obstruction into the second and third part of the duodenum. What we were doing was a nasojejunal tube assisted gastrojejunostomy, but rather a small modification of it, where we passed a nasobiliary drain in place of an NJ tube, and through that nasobiliary drain we instilled continuously normal saline mixed with methylene blue into the jejunal lumen. Around 250 to 300 ml of fluid was instilled into the jejunal lumen. Also a bit of contrast, and the position into the jejunal lumen was confirmed. Then through the from the posterior wall of the stomach, the insufflated jejunal wall was identified, and using electrocautery assisted LAMPS device, that is a hot axios, Boston Scientific hot axios LAMPS device, the jejunal wall was punctured, and under EUS guidance, the distal end of the distal flange was deployed into the jejunal lumen, and so we can see the jejunal, the distal flange being deployed, and the proximal flange, which was inside the gastric lumen, that was deployed under direct endoscopic vision. The proper placement of the lamps, the gastrojejunostomy lamps, was confirmed by the coming out of the visualization of methylene blue mixed fluid into the gastric lumen. Also, so we can see in this part of the video, the methylene blue mixed fluid coming into the gastric lumen. Also, to confirm the presence through fluoroscopy, we also injected a bit of dye through the lamps into the gastric lumen, and it showed the visualization of the lumen. So 2 days after this procedure, that is on the 4th day of hepaticogastrostomy, we repeated the liver function test, the liver biochemistry, and we found a reduction in bilirubin of at least 4 points. Patient was tolerating soft diets and was discharged the day after.
Good presentation. Our main concern is that you are depending on the plastic stent for the right ductal system even now. Whereas, was there opportunity to change this to a metal stent, because you know that the plastic stent possibly got blocked, or if it is not blocked, it will get blocked?
That's true, sir. Actually, the first procedure was not done by us. Patient had,
but could you have changed that plastic stent to a metal stent?
We could not proceed into the second part of the duodenum, sir. I mean the D1, we could not proceed.
Other methods like a percutaneous method, which is available.
Yes, sir. We could have opted for PTBD, but then again, the patient would have had to suffer the discomfort of having a bag at least for a few days outside in the.
Yeah, but it's better than getting cholangitis, segmental cholangitis on the right side.
Definitely, sir.
Because that right duct stent is likely to get blocked at some point in time.
Yeah.
Another question is, why did you decide to stage the procedures? Why did you not do the GJ in the same session? And did you place an nasogastric tube in that? Because the amount of bile that drains out through a hepatogastrostomy, sometimes these patients can develop,
Yes.
they can even get aspiration if you're delaying it too.
We kept the patient on Riles tube aspiration for 2 days, sir. We kept the patient on. Yeah, we kept the patient on Riles tube aspiration for 2 days. Actually, we.
Nice case.
Thank you, sir.
Actually, ideally what Amol is also saying is correct, that if you have to drain both the system, it's always better to do GJ first, followed by biliary obstruction, for the simple reason that the stomach food does not go into the stent and again cause cholangitis.
Sir.
And one question which I am not able to understand completely, you said it's a type 4 block.
Sir.
Is that right?
Yes, sir.
In type 4 block, you have put the hepaticogastrostomy. What is going to happen in the rest, right anterior and posterior? You injected so much of dye and you opacify entire biliary radicals both on the right and the left side. And that is one of the disaster while doing the type 4 drainage. Number one, I think this patient would not have required. If required, then it required through the PTBD rather than an only left-sided hepaticogastrostomy. If that was a right, if it's a type 4 block.
Thank you. Thank you, sir.
I think with that we come to the end of the EPL Cup. the examiners are looking at the question answers carefully and calculating the. It's a very nice assortment of cases that we had from our younger people.
Dear friends, we have enjoyed putting up EPL 2023 for you. Keep enjoying it.
Ladies and gentlemen, it is an absolute honor to welcome the legendary cricketer, Mr. Virendra Sehwag, to EPL 2023. Let's welcome him with a big round of applause. His contribution to the world of cricket have been nothing short of extraordinary. Sehwag, where cricket meets carnage, where boundaries are just a suggestion. The champions of champion is himself with us to give away the awards of EPL Cup 2023. I proudly invite the champion, Mr. Virendra Sehwag, onto the stage. Welcome, sir. With a big round of applause, I also invite Dr. Randhir Sood, Chairman, EPL 2023, and Dr. D. Nageshwar Reddy, sir, on stage.
Ladies and gentlemen, we have this tradition of, having a legendary cricketer to give away the prizes of our EPL Cup. And I'm happy to have Viru with us today, whom I know since he was a young boy, was not so accomplished a person. So that's why he readily agreed in spite of World Cup coming up and his being so busy with all the promo videos. Even today he had to go for a book launch and he preferred coming here just because all of you. And so we have the winners of our EPL Cup today. I'll call the second runner-up, Dr. Aditya, on the stage, please. And certificate. Please bring the certificate and the third prize. I'll call upon Dr. Mahesh Goenka to please come on the stage. This carries an award of various devices given as a gift by Boston Scientific worth 30,000 rupees. So, may I invite Dr. Sandeep to come on the stage. And the second, Shivam, I invite him. He has stood second. And please come on the stage to get your certificate and the prizes. Where's Dr. Shivam? Yeah. I don't think you expected the prize. That's why you're sitting so far back. Yeah, Nagi, you were expected to be here, so please, because so now I call upon Dr. D. Nageshwar Reddy has come. He's so, ladies and gentlemen, the first prize goes to Arun Arora. So not only they get the prize, they also get an autographed certificate from Viru himself. So these are devices gifted by Boston Scientific worth 75,000 rupees to the first winner. Thank you. Now, Viru, you should tell us, tell people about, your story so that they can get inspired. And please give him the mic.
Hello. Yeah, thank you, uncle. थैंक यू अंकल, मुझे पहली बार बुलाने के लिए यहाँ पर। आपने कहा कि मेरा बहुत बिजी शेड्यूल था, लेकिन जब अपने बुलाते हैं तो आपके पास टाइम ही टाइम होता है, आप फ्री होते हो। तो मैं एक छोटी सी स्टोरी शेयर करता हूँ कि नेवर गिव अप। मैं क्रिकेट खेलना मैंने 10वीं के बोर्ड के एग्ज़ाम के बाद शुरू किया। जब मैं पहली बार किसी क्लब में गया, नजफगढ़ में एक छोटा सा क्लब होता था, तो वहाँ पर मेरे जो कोच थे उन्होंने पूछा, भाई क्या करते हो? मैंने कहा सर मैं सब कुछ करता हूँ, ऑलराउंडर हूँ। अच्छा, तो पहले दिन उन्होंने मुझे बॉलिंग करा दी, फास्ट बॉलिंग। दूसरे दिन विकेट कीपर नहीं था तो उन्होंने विकेट कीपिंग करा दी। तीसरे दिन स्पिनर नहीं था तो स्पिन करा दी। चौथे दिन मुझे बैटिंग करने को मिली। तो जब चौथे दिन मैंने बैटिंग की तो उन्होंने 3-4 बॉल के बाद मुझे बाहर बुला लिया। तो मैंने पूछा सर क्या हुआ, अभी तो बैटिंग शुरू भी नहीं। कह रहे नहीं बेटा, बाकी से तेरा टैलेंट तो मुझे पता नहीं, लेकिन तेरी बैटिंग बहुत बढ़िया है, तो तू कहीं आगे जा और क्रिकेट को कैरियर बना। मेरे टाइम में क्रिकेट को कैरियर बनाना मतलब घर वालों से लड़ाई लड़ना था कि अगर मैं अपने माँ बाप को बोलूँ कि मुझे क्रिकेट खेलना है और अपना कैरियर बनाना, वगैरह पागल हो गए, पढ़ ले, या हमारे 100 एकड़ लैंड है वहाँ पर फार्मिंग करनी है तो वहाँ जाके उसकी तैयारी कर। तो खैर उनको बगैर बताए मैं क्रिकेट को परस्यू किया आगे। तो उन्होंने एक ही बात बोली, अगर फेल हो गया तो हम तुझे नहीं खेलने देंगे, जब तक तू पढ़ाई कर रहा है तब तक तू खेल सकता, फेल नहीं होना। तो 11th क्लास में मैंने एडमिशन लिया, जहाँ पर एक गवर्नमेंट बॉयज़ सीनियर सेकेंडरी स्कूल था जी ब्लॉक विकासपुरी में। वहाँ पर एक कोच थे एन शर्मा जी, उनके यहाँ। तो 11th 12th मैंने वहाँ पढ़ाई की, वहाँ क्रिकेट खेली, स्कूल को काफ़ी जिताया। लेकिन जब भी मैं अंडर 16 और अंडर 19 के ट्रायल पे गया दिल्ली DDCA के लिए, कभी सिलेक्ट नहीं हुआ। तो मुझे 6 बॉलें मिलती थी खेलने के लिए, 1000 बच्चा आता था ट्रायल पे, और मैं 6 बॉलों में 3-4 छक्के मारता था, दूर रोक देता था। जब वापस सर आता था स्कूल तो सर पूछते थे क्या हुआ, मैं कहा सिलेक्शन नहीं हुआ। बोला क्यों? मैंने कहा शायद मैंने वो 2 बॉलें रोक दी, इस वजह से नहीं हुआ, अगर 6 के 6 छक्के मारता तो शायद हो जाता। तो वो हंसने लगे, बोले ऐसा नहीं होता। तो 12th में भी ऐसा ही हुआ मेरे साथ, मेरा सिलेक्शन नहीं हुआ। फिर मैं फर्स्ट ईयर में गया कॉलेज, जामिया मिलिया इस्लामिया यूनिवर्सिटी में मैंने एडमिशन लिया, और वहाँ पर मैं जब ट्रायल पे गया DDCA के अंडर 19 के, तब भी मेरा सिलेक्शन नहीं हुआ। तो मैं वापस अपने कॉलेज आया, वहाँ प्रैक्टिस कर रहा था, तो एक बहुत मोटे आदमी वहाँ पर घूम रहे थे। तो जब मैंने बैटिंग शुरू की तो उन्होंने रुक कर मेरी बैटिंग देखी और मेरी बैटिंग देखने के बाद आधा घंटा मैंने बैटिंग की और उसके बाद मैंने पैड वैड उतारे और फिर मैं आधा घंटा रनिंग की, तो 1 घंटे मेरे लिए रुके। फिर आके मुझे पूछे कि बेटा आप कहाँ से खेलते हो? तो मैंने कहा सर जामिया यूनिवर्सिटी से भी एडमिशन लिया। नहीं कौन से क्लब से खेलते हो? मैंने कहा एक क्रांति स्टार क्लब है उससे खेलता हूँ। तो उन्होंने पूछा कि आप अंडर 16-19 खेले हो? मैंने कहा नहीं सर। कह रहे आप ट्रायल पे नहीं गए? मैं कहा सर नहीं, पिछले 3 साल से जा रहा हूँ लेकिन सेलेक्ट नहीं हो रहा। तो उन्होंने कहा कि बेटा आप एक बार फिर जाओ अंडर 19 के ट्रायल पे जहाँ पर आपका सिलेक्शन हुआ। एक शील मेहरा करके एक चेयरमैन है, सिलेक्टर है, उनको जाके बोलना कि सतीश शर्मा ने मुझे भेजा है, एक बार ट्रायल दोबारा दे के आओ। तो मैं दोबारा गया अगले दिन, शील मेहरा जी को मैंने बोला कि सतीश शर्मा जी ने मुझे भेजा है। तो उन्होंने कहा पैड करो। मैंने बैटिंग की, वही 5-6 बॉलें मिली, उन्होंने देखी, उन्होंने कहा मैंने देख लिया है, वापस जाओ। तो मैं अपने घर चला गया। नेक्स्ट डे कॉलेज गया तो वो मुझे फिर मिले वहाँ वॉक करते हुए। तो उन्होंने पूछा क्या हुआ? मैंने कहा सर मैं ट्रायल पे गया, शील मेहरा ने देखा और वापस भेज दिया। बोले उन्होंने कुछ नहीं कहा? मैंने कहा नहीं सर उन्होंने कुछ नहीं कहा। अंडर 19 की टीम बन गई, मेरा सिलेक्शन नहीं हुआ। तो जो सतीश शर्मा थे उन्होंने एक मैच रखा अंडर 19 दिल्ली स्टेट वर्सेस जामिया 11, एक प्रैक्टिस मैच था। तो जो स्टेट की टीम सेलेक्ट हुई थी उसके खिलाफ मेरा मैच था। और उन्होंने प्रेसिडेंट, सेक्रेटरी, सिलेक्टर सबको बुलाया। सबको बुलाने के बाद उन्होंने जामिया पे एक ब्रेकफास्ट ऑर्गेनाइज़ किया, क्योंकि ब्रेकफास्ट बहुत अच्छा मिलता है जामिया पे। तो जब बैटिंग जामिया ने टॉस जीता और मैं बैटिंग करने जा रहा था तो उन्होंने कहा कि मुझे रोक करके बेटा आज तू दिखा दे इनको। मैं ग्राउंड पे गया, मैंने बैटिंग शुरू की। 40 ओवर के मैच में मैंने 156 रन बनाए, 17 छक्के मारे, एक भी छक्का ग्राउंड में नहीं गिरा। और जब मैं वापस आया नॉट आउट, तो जो प्रेसिडेंट थे उस समय अरुण जेटली जी प्रेसिडेंट थे। तो उन्होंने मुझे बुलाया, तो उन्होंने पूछा बेटे कि आप स्टेट में ट्रायल पे नहीं आए? मैंने कहा सर मैं पिछले 3 साल से ट्रायल पर रहा हूँ लेकिन सिलेक्ट नहीं हो रहा। तो उन्होंने शील मेहरा को बुलाया कि शील इधर आओ। कह रहे ये बच्चा सिलेक्ट क्यों नहीं हो रहा? कह रहे सर ये ट्रायल पे नहीं आता। मैं सर परसों तो आया था, आप आपने ट्रायल लिया था, सतीश शर्मा जी ने भेजा था। अच्छा तुम थे वो? तो ऐसा कहकर उन्होंने टाल दिया। फिर जो अरुण जेटली जी थे उन्होंने कहा कि ये लड़का अगर 40 ओवर के मैच में 156 रन बना सकता है तो सोचो अगर ये 90 ओवर खेल गया तो ये तो 300-400 रन बना देगा। तो उसके बाद मुझे एक मैच दिल्ली का होने के बाद मुझे टीम में सिलेक्शन हुआ। तो मैं अंडर 19 खेला, मैंने उस साल खूब सारे रन बनाए। फिर मैं नॉर्थ जोन खेला, फिर मैं अंडर 19 वर्ल्ड कप इंडिया के लिए सिलेक्ट हुआ। फिर मैं वापस आया, मैं फर्स्ट क्लास क्रिकेट का मैच खेला। फर्स्ट क्लास में खेलने के बाद मैंने ढेर सारे रन बनाए। फिर मैं दिलीप ट्रॉफी खेला और 1 अप्रैल 1999 को इंडिया खेला। ये बात है 1997 अक्टूबर की, जब मैं पहली बार अंडर 19 दिल्ली स्टेट के लिए खेला। और 1999 1 अप्रैल को मैं भारत के लिए खेला। अगर मैं हिम्मत हार जाता या गिव अप कर देता तो शायद आज यहाँ खड़ा होकर आपके सामने भाषण नहीं दे रहा होता। थैंक यू अंकल।
Thank you, Viru. Thank you. Wonderful having you here. And it was nice of you to have accepted our invitation. Thank you very much, Viru. Thank you.
Thank you so much for this wonderful session. Viren Sehwag, where boundaries are just a suggestion. Sultan of Sweat, Viren Sehwag's cricket magic. Sehwag, the storm of sixes. We are really honored to have you here with us, Mr. Sehwag. Thank you. And we can't miss to have a commemorative photograph with you. A photograph that we will cherish for life. A photograph that will inspire youth and all of us to never give up and be the best. And a token of appreciation for being here with EPL 2023. Let us give a big round of applause to the gentleman. Thank you so much. This is how legends work. There are a series of selfies being clicked with him. We'll resume shortly. Ladies and gentlemen, we are heading towards a very interesting session, awaited one. I request your presence in the hall. Thank you so much. Please stay in the auditorium. We'll now have the conversation of Dr. S.K. Tyagi with Madam Sharmila Tagore, the legendary Sharmila Tagore. So I request everyone to please take your seats. Before that, I would like to introduce Dr. S.K. Tyagi. Dr. S.K. Tyagi is a senior gastroenterologist currently practicing in Meerut. His interest areas are not limited to the field of medical academics, as indicated by his well-researched publication in the journal titled Changing Portrayals of Doctors in Hindi Cinema from 1940 to 2020. Is it the time for introspection? Dr. Tyagi is an avid photographer, traveler, a decent and an accomplished short story writer. His latest non-academic foray is into films, with his first all-India release this year. Many of the delegates would have listened to his interview of Ms. P.V. Sindhu last year. We will have them shortly in the auditorium. Let us witness this gala event. The Bollywood enchantress Sharmila Tagore would be here any moment. Sharmila Tagore, the silver screen's jewel. We are really honored to have her here with us in this event, EPL 2023. We are going to have lasting memories of this EPL 2023.
a trailblazer in Indian film. Sharmila Tagore's influence is lasting 10 ages, and we will witness her charm today here on this stage very shortly. The timeless icon of Indian cinema would be here any moment. I know all of us are waiting for her. And the time has come, and we have the timeless icon of Indian cinema with us. Madam Sharmila Tagore. A big round of applause to the legendary Sharmila Tagore, and I invite Dr. S.K. Tyagi, who interviews the well-known film personality, Madam Sharmila Tagore. I invite Dr. S.K. Tyagi onto the stage.
Ladies and gentlemen, I am sure all of you have been waiting for this evening, and definitely it's not to either look at me or to hear me. What you are here for is to have a conversation through me with the iconic Sharmila Tagore ji. Before we start it all, there's going to be a 2 or 3 minute clip of the famous songs so that you can live the memory of the films of the 60s, 70s, and 80s. May we have the clip, please?
मेरे सपनों की रानी कब आएगी तू, आई रुत मस्तानी कब आएगी तू, बीती जाए जिंदगानी कब आएगी तू, चलिया तू चलिया। लिया। रूप तेरा मुस्काना, प्यार मेरा दीवाना। रूप तेरा मस्ताना, प्यार मेरा दीवाना। भूल कोई हमसे ना हो जाए।
तेरा मुझसे है पहले का नाता, कोई यूं ही नहीं दिल भाता कोई। तेरा मुझसे है पहले का नाता, कोई यूं ही नहीं दिल भाता कोई। जाने तू या जाने ना।
गुनगुना रहे हैं भंवर, खिल रही है कली कली। गुनगुना रहे हैं भंवर, खिल रही है कली कली। कली कली
गुनगुना रहे हैं भंवर, खिल रही है कली कली। के सजन सावन में, आपके सजन सावन में आग लगेगी बदन में। घटा बरसेगी मगर तरसेगी नजर, मिल न सकेंगे दो मन एक ही आंगन में।
ना जा कहीं अब न जा, दिल के सिवा। ना जा कहीं अब न जा, दिल के सिवा। है यही दिल पूछा तेरा, है मेरे हमदम मेरे दोस्त। ना जा कहीं अब न जा, दिल के सिवा।
Well, for many of us, that would have brought lots of memories back. Ladies and gentlemen, allow me to introduce the legendary Sharmila Tagore, an iconic figure in the world of Indian cinema. She made her debut as an adult actor, as a grown-up actor, at the age of 13 in the film Apur Sansar, directed by none other than Satyajit Ray. And since then, she has left an indelible mark on Indian cinema. She shifted to Bombay, which was now called Mumbai, in Bollywood, and straight away started with a hit in Kashmir Ki Kali. She made it not just, she made it entirely because of her talent, and the next line has been told to me to say by my friend Dr. Ajay Kumar, who's not here, but he's going to put me in trouble. She has worked in some of the most prominent directors and actors in the industry, delivering memorable performances in classic like Aradhna, Mausam, Chupke Chupke. And as The Guardian wrote, she has very successfully done justice to realistic Bengali cinema as well as Bollywood song and dance cinema. Few have achieved both at the same time. Her talent has earned her numerous awards, including several National Film Awards. She is one of the 3 female leads of Hindi cinema to have been honored by Padma Bhushan. Not only has Sharmila Tagore excelled in the world of cinema, but she has also made significant contributions to humanitarian cause, including her role in UNICEF as UNICEF Goodwill Ambassador. Her enduring charm, elegance, timeless appeal continues to inspire generations of enthusiasts and artists alike. Married to a cricketing legend and the youngest captain of the Indian cricket team, Mansoor Ali Khan, lovingly known as Tiger, she is mother to Saif and Sabah Ali Khan and to Soha. Madam, I invite you here to, as Ajay said, to charm everybody. He says, several heart attacks every time you smiled and he saw your dimples. She's been escorted by the First Lady of Endoscopy, because Jung Dilavri is the godfather of endoscopy, and the First Lady of this conference because Randhir is the chairperson. I know many of us would not have become cinema buffs when Sharmila ji started her career. Madam, everybody likes anecdotes. And you know, that's what livens up, because they are spontaneous and they are entertaining as well. At the age of 13, how did Satyajit Ray, the iconic Satyajit Ray, pick up a 13-year-old girl for his movies?
Well, first, allow me to, is this on? To congratulate you for your audio-visual. That was quite something.
Thank you.
And so I can see that besides your medical qualifications and whatever, you have this creative department as well, which was quite entertaining. Thank you very much. And thank you all of you for staying back, because it's getting on to be a certain time when one's thirst increases a bit. And
you know, ma'am, just let me interrupt you here.
Yeah.
All of them are singing in their hearts.
Yeah.
Mere sapno ki rani kab aayegi
Okay,
tu.
all right. I shall leave it at that. So, going back to what you asked, because I've just done an interview with Twinkle, and I was reading all the comments, and they said it's about time somebody asked her another question, and with a different reply. Now, I can understand the questions, but I can't really, if somebody asks, you know, what happened, how did Satyajit Ray found you, I can't really give a different answer different times, because after all, I can't change the reality, right? So I think if I knew the name, I would ask the gentleman, I mean, what else can you say? I mean, it's okay, not to start at the beginning.
Yes,
right?
your audience is not the type who sees movies too often.
Well, I don't know, they might change. It's not good for us if they're not seeing movies, because no matter how busy you are, you know, really, on a serious note, I realized the importance of entertainers, because they can really, you know, when you're going through a rough time or you're grieving, they can change your mood. They can uplift you. And you know, after a day's surgery or whatever, even if you see a little bit of something that obviously speaks to you, not something that doesn't speak to you, then you can relax, you know, without having to read or make an effort. It comes to you as entertainment. I think all of us need that little respite. But yes, going back to age 13, I won't go into how he found me. Let's say that he found me, and he would know how he found me. But it absolutely changed my life, and I am so grateful. And it must be something to do with, it is obviously destiny, but it must be, you know, some plan up there, because I was growing up in a wonderful joint middle-class family, and kind of orthodox and conservative. We were not allowed to see films. And suddenly one day the phone rang, and this great man on the other side wanted me to act in his film. the third of the trilogy. The first was Pather Panchali, second was Aparajito, and both won awards everywhere at Cannes and international acclaim. And to act as, and it's a very well-read book in Bengal, Amatir Bhepu, Vibhuti Chandra Bandyopadhyay. So it's a very, very famous book. So all of us have read it as and like I said, when we were not allowed to go to the movies, we were allowed to go and see Pather Panchali because that was okay, because Satyajit Ray was okay to watch. It was not like any other film. So I'll just say it was divine intervention that this beautiful world of cinema, this magical world of cinema, which has given me so much, so that world opened to me.
For this, you've actually used the word memorable coincidence.
Yes, a divine intervention.
Divine intervention or memorable coincidence.
Yes.
Her words, not mine. You know, in Apur Sansar, I am not sure how many of you have seen it, but very few would have. There's this 13-year-old girl who gets married by sheer accident to somebody, and there's this beautifully acclaimed scene where it is the night after the wedding. And, you know, it's impossible to imagine that a 13-year-old girl could do it with such sensitivity. And I wonder how the director was able to explain to a 13-year-old how, you know, to react to that clip being found under the pillow or to...
It's a scene where it implies the first night this couple have spent together. So the scene opens when they're living near a railway track. So there's sound of train, and she wakes up, and she's going towards to do whatever she wants to do, but her pallu is kind of tied to his part of his clothing, something like shirt or a dhoti or something. So she can't really go forward. So she kind of slaps him playfully on his back and then unties and goes away. And then she's lighting the chula to cook or to start the day's proceedings when her husband sort of takes a, wakes up, yawns and turns around and immediately reaches for a cigarette, and like Satyajit Ray did himself, and that caused him his heart problem later. And so reaches for his cigarette, and he opens the packet, and there it's written that you have promised one after lunch. I mean, two, like one after lunch and one after dinner. So he was allowed that. So he smiles and he puts it away, and then he looks at her. So it's such a sweet, beautiful scene. So I don't know how I could have done it, but I read the book, and I was little, I mean, some people who are Bengali in this audience would understand. I was Paka. Paka means that not precocious, but somebody little older than her age, because living in a joint family, interacting with perhaps a voracious reader. So I lived in a world of imagination most of the time. So I could imagine whether love actually haven't happened to me at the age of 13, but I loved romantic novels, and I could understand what love was all about.
Your next movie, again with Satyajit Ray, was even more difficult. Devi today, in Devi, she plays a young bride whose father-in-law imagines or dreams that she is the Devi, and she's goddess.
Reincarnation of Kali.
Reincarnation of Kali. And she, at that young age, she's actually made to sit there and heal people, and people come and touch her feet and things like that. Now, would you have, this is very specific, at that time you were probably too young to realize the implications of all that. Would you have played it with the same innocence and anger or disappointment?
Well, this is where I think the director comes in, because when Apur Sansar, when I was doing that, I was so friendly with the team, and they were very friendly with me. Somebody became a kaka, somebody became a dada, somebody became, all these, Satyajit Ray was Satyajit, Manikda, and it was very happy atmosphere on the set. But on the Devi, nobody was speaking to me. I felt kind of alienated. They left me alone just to add to the isolation of the girl. Because one fine day, I mean, imagine a very young girl, totally illiterate, so far away from her parents, because those days children used to get married at the age of 12, 13, 14, and 14 would have been too old. And her entire upbringing has been to believe and respect your elders. And how can the patriarch of the family be wrong? And the scene where he has this dream that his daughter-in-law is actually Devi incarnated. So he, in this intoxication of religion, he rushes to her room and calling Ma, Ma. Yes. And then she, completely shaken, because her husband is away in Kolkata studying, so she opens the door with, completely, covering her face with ghungat and everything. And he falls at her feet, calling her, I didn't know if I've done something wrong. Please forgive me. I had no idea that you were Devi. And, and she pulls her toes together. She shrinks within herself, and she puts her hand, the nail on the wall, and she kind of scratches it. So it's like how brutalized she feels. I mean, the scene is very, very moving. Brutal. And then he turns around to his son-in-law, who's come out with all this noise, that please touch her feet. And the son-in-law, of course, doesn't quite believe, but follows the father's suit. So she is completely isolated from everything she knows. Husband is away. She cannot write. So she asks her sister-in-law to please write a letter to her husband. And she's given another room. The maid says, please forgive me if I've done something wrong. Her favorite nephew, the only little child in the house, who was her friend, who couldn't sleep without her, avoids her. So she's completely isolated. So this excessive worshipping and kind of destroys her mind.
I know. And you did a third film with Satyajit Ray, and then you just switch off and you come to Bollywood.
Not third film. After Devi, I went back to, I was still schooling. Devi and Opu Samshar was done during my school holidays. And then I gave it a break. In fact, Manikda asked me to work in a film called Kanchanjunga, which I couldn't because I was sitting for my senior Cambridge. And then I joined college. I started working professionally then with Bengali films. And
professionally, you meant you were paid for the first
yes,
time. That's what I
right,
I read.
Because my father made
Till
it
now, you were doing it all.
Yes, because my father made it very clear that she's not a professional actor. She will not take anything, and if she makes a fool of herself, please, don't take her.
But why did you come to Bollywood? Such fame and
Well, all the Bengalis ask the same question because
but
you know
I'm
how
not a Bengali.
The Bengalis feel they're the best in the world, and they have this grand ideas about themselves, and they felt that after Ray, that working with Shami Kapoor was a big letdown. But no, I just felt that from regional cinema to go to national cinema was obvious that you need to go, and it gave me more visibility, more recognition.
I believe every time you did a Bollywood film, you want to give up films.
Not really, yeah, to some extent, because I remember when I saw the rushes of Kashmir Ki Kali, I went to the makeup room and started crying, and Shashi Kapoor was there, and he said, "No, but you're not that bad." I said, "Yes, I'm very bad." So he became a friend. And he had seen Opu Samshar, and he was a fan of mine, and I was a fan of his because I had seen Prem Patra of Bimal Roy, and he was so gorgeous, and he had these lovely eyelashes. So I kind of liked him very much. So he was very sweet, and so I kept saying no to films. I mean, I didn't want to, this is my last film, but kept on signing
Kept
films.
on signing films.
And so the mid-film, you know, like you're under contract. You cannot leave till you finish the film. So by the time I finished the film, I'd already
The very
signed
first
another.
song that came, Mere Sapno Ki Rani. You know, I say films are the most beautiful fraud that you can have. What you see on the on the screen and what's actually a fact are two very entirely different things. Apparently, in Mere Sapno Ki Rani, you and Rajesh Khanna never did a scene together. You did separately, he did separate, and then
That's
it was
right, because-
edited together. What's that story?
Because Shakti ji had booked my entire dates with Rajesh Khanna, because Rajesh Khanna was in extremely busy. No, he was not famous at that time. He was very much in demand because he had won this contest, which was sponsored by 12 producers. So the contract, the condition was that if he wins that contest, then he has to do 2 films with each of them. That meant 24 films. So he was continuously shooting for them. So his dates were difficult to obtain. So Shakti ji had taken his dates, and after we were midway through the film, Manikda rang me up and he wanted me to work in Days and Nights of the Forest without break for about 25 days in the middle of April in a place called Chipa Dohar, in what is in Jharkhand now, which is probably a place where you can't even go now. So
the two of you were never together.
When
in the
Shruti
scene.
Ray asks you, you don't say no.
You don't say no.
So I did a little negotiation with Shakti ji, and he kind of gave in and allowed me to go. And so my scenes were done in the studio, and Rajesh Khanna's scenes were on the actual location, driving and all that. And they took shots of the moving train and then matched
Were you
close-ups
actually
with me.
reading Alistair MacLean, or were you just holding it in your hand?
I probably was reading at
Reading
that
it.
time, and then maybe it looked better. And somebody told me that I was reading it upside down.
No,
I'm
you
not
weren't.
quite sure.
No, you weren't. No, you weren't. I've seen the movie.
I don't have that
I've
ability.
seen the movie 7 times. You know,
Okay.
that book was upright.
All right.
So that's that's not there. And another thing that I want you to tell the audience is the song Chingari Jo Bhadke in Amar Prem. Apparently, that beautiful song, you know, so lovely and romantic, was done on a stinking pool.
Well, you couldn't have done it Hooghly, most certainly, because the camera movements and all that couldn't possibly
So
be
they made a
done.
pool
So
which started to
they
stink.
did a pool in Natraj Studios and filled it up with water, but it took about 10 days for the entire
Shot.
shoot to be completed, and everybody was in knee-deep water, moving lights and things. So I guess, yeah. So we not only just it stank, but even when we, after 8 hours, when we got off the boat, we were, you know, having a little bit of vertigo because, you know, everything was
Moving.
swaying a little bit. But how lovely it looks.
It looks
on
very
the screen.
nice, and you can't imagine that
And
it's on
lovely
a-
songs, both Amar Prem and Aradhna
So the songs,
and Kashmir Ki Kali.
you know, the songs of our times
Absolutely.
had beautiful words. The
You know,
songs of today,
I'm
there
so
are some
sorry
words
to
that
interrupt you because I was coming from home, which is in Vasant Vihar, so it was a bit of a distance, although there was no traffic. So I always listen to music, and I listen to these old, you know, and they're really, truly lovely. I mean, Vahida ji's, Nutan ji's,
How do you compare them with
Devanand's
today's
song.
songs?
No, obviously there's no comparison.
no
These are not
comparison.
songs. But to answer your question, what makes them so special is because of the language.
lyrics.
And,
yeah.
and because of the beautiful combination of Urdu and Hindi. You know, so now the Urdu is completely no-no because we don't use Urdu words. Even if, like I did a ad with Sara where we have to...
With all due respect, now there are a lot of Punjabi words being used in songs.
And English, a lot of English
And English
A
words.
foreign language is allowed, but Urdu is not allowed.
You weren't much of a fan of cricket, madam. Rather,
Yes.
you knew nothing about cricket.
No, I didn't know anything
and
about cricket.
and Tiger Pataudi knew very little about Bollywood cinema. So
You
it
don't
was
have to
really
know
a
about
memorable,
cinema.
it
You
was
have to-
memorable coincidence that you two
watch
met.
cinema and you enjoy it. You don't have to, but for cricket you really need to know
You
a
need to
little
learn.
bit. Yes.
Did you know much about cricket?
No, I didn't know. I don't know now also very
You
much
don't know
about
now?
cricket.
All right.
But I do enjoy cricket. I know enough to enjoy.
You don't see
And I told Peter May, I had this long chat with Peter May, because I always telling a Sarod player how to play Sarod and telling somebody else, a doctor, how to do his job. I was always a bit, beyond myself. So I was talking to Peter May and showing off how much I know about cricket. So at some stage I said, this wonderful leg cut. Then I got this massive kick under the table. Anyway, I shut up instantly. And then later on, I was told in no uncertain terms that you will not ever talk about cricket because it's called late cut and not leg cut. So I learned a bit.
I believe he never saw your films.
He didn't see films, but he liked Vajantimala and he liked Meena Kumari very much.
Not Madhubala?
Well, his favorite was Vajantimala and Meena Kumari. Madhubala must have been, because I don't think he went back that
far.
much, yes.
And
Lataji was his favorite.
Okay.
But throughout Oxford, Girish Karnad tells me that he only heard Lataji and he went and heard her. She was our neighbor. She was in Prabhu Kunj and we were in...
He courted you with letters and with flowers and roses. But what's the story about refrigerators that he sent you?
You see, those days we were not allowed to. No imported items came to India. I mean, you needed special permission for everything. So I was staying with a friend and I got this message that he had left a message without identifying himself. He left a number saying that 5 fridges have come for you.
5 of them?
Yes. So I was a little worried because I thought, somebody's trying to create problem for me because it's not custom cleared or whatever. So I naturally returned the call and there was much laughter at the other end and it was a joke. And I, later I discovered that he had a very peculiar sense of humor. So we were all prey to that. Most of his friends and family were prey to. Not just him, my mother-in-law also had a very wicked sense of humor. So unsuspecting guests were caught unawares and something terrible happened to them.
Your daughter's written a book, Perils of Being Moderately Famous.
Perils of being moderately
famous.
Yeah.
But what about the perils of being extremely famous, insanely famous? I believe you and Tiger were coming out of the airport and you were literally mobbed and you lost some jewelry. And
Not airport. This was at Metro. There was a cinema called Metro near Bombay Gymkhana. And that area was very crowded. And those days nobody had any bodyguards or anything. So there was a lot of mobbing because the only place a normal person could see a film actor was at the premiere. So they would queue up and see us, or maybe at a traffic stop or something. Otherwise, there was no television, there was no interacting, like Salman Khan now cycles to the studio. Social media, everybody knows who's eating what, who's watching, everything about actors or stars. Those days, we were a bit of a mystery. So I think they like to mob. And Metro was particularly dangerous because, and Tiger had just come back from Australia via Singapore, and so both of us, when we came out, we were absolutely mobbed. But after Arunni Din Ratri at the Ranchi station, we were mobbed by about 5,000.
My God.
They sat on the railway track, wouldn't move for about 4 hours. It was the most frightening experience of my life.
Cricket and Bollywood is a very, very dangerous combination,
Cinema and
cricket.
Not
and
just
cricket.
Bollywood.
Yeah, cricket, that's really something. You have worked with practically every actor of your times, except Raj Kapoor.
Raj Kapoor.
Apparently, you were to work in Mera Naam Joker, the second part.
Third part, the circus
The
part.
circus part, but it
Yes.
didn't work out.
No, then he had a Russian collaboration. He had come to Palace Hotel because we used to shoot in Kashmir at least twice a year, once around April, May, and once around September, October, because that was the best
Colours of
spot.
fall, yeah.
No, it was so scenic, it was so beautiful. And at a time, there would be about 6, 7 units shooting there. And some of them stayed at the Palace Hotel. So I was shooting for Talash, and Raji came to see me. And he said, would you be keen? And I didn't really know about, you know, how one should negotiate these things. So I told him that I'm committed to somebody called Zul Villani, which was a very unknown director. And Sanjeev Kumar was the hero. So I was committed those days that he wanted to Zul Villani. So he didn't say much. He says, okay, we'll think about it and we'll talk further. And then he told Shakti ji later that your heroine told me that she was committed to Zul Villani. Now Raj Kapoor is asking, and who is Zul Villani? So, yeah, so there was so much to learn.
Yes, there was. But, you worked with Devanand and Dilip Kumar. I mean, they were iconic figures. Which one of the two was more difficult to work with?
They were both very good, but both were terrible films.
That's
like,
what-
yes,
Yes, they were.
Dev Saab ke saath jo film tha, the only wonderful thing was that we shot in Meghalaya.
You were,
And
you,
we
you
were
were
there
a Chinese.
I was Naga.
You were a Naga,
You have to get
alright.
these things,
Yeah,
you
you're
have to
Naga, yes.
politically correct about these things, even if it's Bollywood. But anyway, so, and the first day's shooting was on an elephant, and the elephants were as high, you know, they were quite like beyond first floor. And I was supposed to ride with a kind of a spear, without a howdah, then I had to jump from there, which I did with another 5 elephants behind me. Like if I had fallen, I would have surely would have been the end of me. But anyway, I managed to do that. And then he says, now jump. I said, most certainly I will not jump. He said, jump. I said, no, I'm not jumping. So I didn't jump, and my double jumped and sprained her ankle immediately. I said, now if I had jumped the very first day of shooting, what would have happened? So, and we saw such beautiful location. It was a matriarchal society, and their local brew was made out of orange. So apparently didn't give hangovers, so a lot of the crew members were drinking that. So it was a wonderful experience being there for
I saw that movie.
It was
It
terrible.
was terrible.
Yes. We are
and
in a
Dag with
and Dastan was also not that great.
And Dastan with Dilip Kumar.
Yusuf Saab. But again, the takeaway again was working with Ais Johar. They used to all write their dialogues in Urdu, and the whole atmosphere, B.R. Chopra. So working with them was a wonderful experience.
It was a wonderful
Yes.
experience. You took a sabbatical. You know, you were really at the peak in cinema at that time, and then for about, you know, in the 90s,
I
you started
didn't-
doing very few films. Why?
I didn't really ever give up films. There was what you call the sabbatical time. I did Mississippi Masala. I did a lot of
Very few
Bengali
of them.
films. Because my mother-in-law was not well, and Tiger being the only son, we moved from Mumbai to Delhi to be with her. The girls joined the British school. So we did move in '84 and stayed with her. So that was one of the reasons. Then I joined the Air India board. I was with UNICEF. I worked with Karan Thapar in Eyewitness. Those days you didn't have.
Yes.
There was Madhu Trehan doing the other, and I was doing Eyewitness
She was
with
here
Karan.
yesterday.
Yes. So, yeah, because of Naresh, of course. And so I kept myself busy doing a lot of things. I became the PTA chairperson, which I thought was a wonderful experience. So when I walked into school, I was Mrs. Khan, and I got so much respect from the students. So and then I became the CBFC chairperson. So there was, I was always busy.
In one of the interviews, you say what has changed is that the male role, the heroes are now on time. So they were never on time in your times?
Nobody was on time, no.
Who was the most late Latif of all?
Shashi Kapoor was the punctual person, and then when Amitabh came, he came much later than I, was punctual, nobody else was. And the late, if there was a competition, then there would be Shatrughan Sinha, because there was one film poor Raj Khosla was doing with Zeenat Aman and Amitabh Bachchan and Shatrughan Sinha. So they, we used to have those factory timings, 7 to 2, 2 to 10, because the money wasn't in place and there was double shifts. So anyway, so these 2 to 10 shift, there was no sign of Shatrughan Sinha. So 10 o'clock, Amitabh's car would be leaving and Shatru's car would be entering. So poor Raj Khosla lost a lot of hair, and you won't find three of them together in the same shot. It was always over the... So Shatru would be sitting at home, but not... I believe when he became the minister, he was also late.
Always.
For his, yes,
Yes,
as a health minister, you should know, he was late. For his wedding reception, he most certainly was late, for about a couple of hours late.
So in all those films, is there a film that you wish you had done and you didn't do?
Oh, most certainly. I would have loved to have done Charulata,
Okay.
which Madhavi Mukherjee did. Manida gave me the short story, I read it, and he asked me. And then I think after Mahanagar, Madhavi was such a wonderful, her wonderful performance. So she replaced me. So that I felt.
About the time you were doing very well and you were famous, came Stardust and later Cineblitz, and they were all about gossip and things like that. And apparently, I believe you went for an interview, and you took the interview of the editor.
Yes.
What happened
Uma.
then? And they got very nervous about it,
No,
because
she
you
started crying.
You
and
asked
she
very
was-
difficult questions.
Yeah. I said something about her father. So she says, how can you be, I said, but you're asking us about our husband or about
So you
whatever.
were getting even with them.
Absolutely.
Absolutely,
No,
she said.
earlier there was Screen and Filmfare. And
Yes,
then
but they weren't-
they were very, very different. And then came Star in Style, where Devyani Chaubal was,
Yes.
she was
Bad.
she was really bad. And it used to irritate me so much, because we'd walk into a party and Tiger would go and shake hands with Devyani, have a long chat. I said, how can you possibly talk to her? She said, no, it's okay. We must remain. So I hated that. Anyway, she was there. But then came Shobha with her Hinglish.
Day.
Yeah, with her Hinglish. So there was a lot of English words in
English,
a
yes, that's
Hindi thing. So that was a different style. And Cineblitz. Cineblitz wasn't that bad. Stardust was also not really that gossipy. The
Filmfare.
gossipy thing would go to Devyani Chaubal. She would be number one.
Filmfare again brings the question of that most famous photograph of yours on the Filmfare cover, and you must have told that story several times as to
Yeah.
how a poster was put right in front of your house, and your mother-in-law was to come and visit you, and Shakti ji wanted to, cover up, and he...
No, Shakti ji didn't. I did.
You
but,
got it moved.
but I've been, how foolish, because I just took down one poster, my driver did, but obviously there were other posters from the airport
over the
to
town.
so it didn't cross my mind that she would have, anyway, she never mentioned it, so I didn't mention it either.
Well, she wasn't the first one in a swimsuit, behind this. You'll be surprised, Nutanji was one of the first ones. But that never made it to the
No,
gossip
that
columns.
was a one-piece swimsuit. I wore a bikini.
No,
so
that was on Filmfare cover. I'm talking about An Evening in Paris.
Yeah, so that didn't create any problem.
The two got connected and people started
No,
saying you
yeah,
were
then
in a...
later, because people, as it is, people suffer from amnesia. And, what happened 10 years ago, people won't remember. So obviously, they don't really know us. They just put two and two together and get a third story. So it's
Then you became the chairperson of the
CBFC.
censor board. And
It's not called censor board. It's called
film
certification board.
CBFT.
And I couldn't even teach my staff members to say that. They would pick up the phone and say censor board. I said, it's not censor board, for God's sake, it's CBFC.
But did you have any, there's always controversy around it. Any controversial
Not
things
controversy.
that happened?
It's not controversy. It is just, it's a job that everybody does. It's a structure is that you have a chairperson who works pro bono, and then you usually taken from the film industry or from the, like Leela Sampson.
Did you set some rules about
I
how
think
you're going to
so.
give the film
I
A
think
or
so.
UA?
I was there for 12 years. So
Yes, you were there for 12 years.
I created extra committees to look at films. Like if there was a controversial film on, say, let's say homosexuality, I would invite a homosexual to come and sit on the panel and advise us, like that.
So it was smooth sailing, basically.
No, it was not smooth sailing. That was the time when there was a lot of street censorship was happening. We were getting better, but there were a lot of protest about
The
what
contents.
was that Babbar Shah Rukh Khan film. So there was that Teli Bhi Kabhi Sonar Nahi Bante or something like that. So they
That
were,
was the song in which
that was
this,
a song. So all those extra, then Fana wasn't the film.
Fana.
So usme bhi there was a lot of film were banned and things. Jodha Akbar created so that all happened in my tenure. So it was, and then Da Vinci Code. When the Pope didn't
object
mind,
to it, so why would you?
released in Vatican or in Rome. Nagaland objected, where there's maximum Christian. Then Punjab, where there's no Christian, objected.
Coming towards the end of the questions, in 2019 you got the Vogue Beauty Award.
Did I?
Yes, you did.
Oh, I
I've
didn't
saw
know.
the photographs. You don't
Okay.
remember it.
All
So the
right.
question actually is not you are beautiful. The question is not about the beauty. How do you stay fit?
Am I fit? I don't
I think you're
so.
fit. Is she fit?
I used to be.
Yeah.
No, I look fit. Mentally fit, perhaps, still, touch wood. But I think a little bit of exercise. I think more than all that. That, of course, all of you know that you have to eat right and do a little bit of exercise. But I think the thinking, you have to be engaged with life. You shouldn't retire and look the other way and get very involved with yourself. I think that's what it is. The remaining curious, looking around you, and being basically engaged. Yeah?
I think the audience here never retires, or rarely retires, or retires rather late.
They change.
But the
though.
point is that the work-life balance of a doctor is really, really bad, and it's because the public expects us to be working all the time and being available.
Not just the
most of
public, I think you expect yourself
to be aware.
also to, you can't really, I mean, during
Say
COVID,
no.
the stellar work that the doctors have done, you can't really turn your back to, I mean, I suppose some can. But if somebody really needs you, you can't just switch off. That's why it's a vocation. It's not just a profession. It's something that you have to feel.
And the absolute end of the interview, how did you get to that Buffon hairstyle and the winged eye
I
makeup?
was very
You were
peculiar.
advised or you devised
no,
it
No,
yourself?
I was very peculiar from
The very beginning.
from the beginning. Like anybody asked me anything, my parents, my aunts, because in a joint family, everybody has equal rights over you. Like if my aunt gave me, slapped me, I went to my mother would slap me back and said, obviously you've done something. So, we learn to survive there. But anyway, if anybody asked me to do something, I'll say why. So everybody knew, and I was very obstinate and you had to convince me. So throughout my life, I've done that, and I've followed my own conviction. And later, I've said, yes, I'm very sorry, that was a wrong thing I did, but I had to learn the wrong thing. So the bouffant was most certainly the wrong thing. I mean, in most glamorous role, it was okay. But in some roles, it didn't fit.
It didn't
and
fit.
when even directors like Rishikesh Mukherjee, they came to my room, my dressing room,
Yes.
and told me that
Don't do it.
Rinku, because that's my name, that you know, this is a motherless daughter. She can't really be like this, you know. Can you please? And I didn't listen to him.
You
I'm
didn't listen,
ashamed
you
to
still
say.
had that.
But somehow I
Looking-
got away because it was a black and white film, and they framed me in such a way that
They cut
the
off half
6
your
inches
head.
was out of the frame.
Okay. Now, we had talked about, you know, allowing a few questions from the audience. Considering the restraint of time and it getting late, we can have 2 questions. So, anybody wants to ask her a question? Yes, Dr. Roop Rai, sir, from Jaipur.
Thank you.
I'll repeat it, sir. आप बोल दीजिए.
In which role you find yourself the best? As a mother, as a wife, as an actor, or now as a leading personality to guide many people as to how should they live their life?
I don't think any of us here in the room have singular personality. We are an combination of many. I mean, I'm a woman, I'm a working person, I am a mother, as you say, I'm a Bengali. So there are lots of things. Nobody has a unique, single personality. And it all comes together to make one human being. So that would be my answer to you.
So the best role.
The best role also because it's I have a friend made a very funny film. They did a home film where they showed that when you're young, you're talking about, you know, school, and then later you're talking about boys and boyfriends and clothes, etc. When you talk about marriage and husbands, then you talk about children and maids and what to cook and what not to cook, etc. And then later on you're talking about, you know, my knee's hurting and my back is hurting and I can't eat this and can't eat that. So every age has its own challenges and own rewards. And so you cannot specifically, but all I needed, I wanted to play many roles. I didn't want to be a working person and a career woman and not be married. So I wanted to marry, I wanted to have children, and I also wanted to be a working person. Also, I wanted to travel, read.
And you wanted to be a dancer?
No, I had no pretension of being a dancer. I was taught dancing as, you know, Bengali household, dancing, music. I was taught, I was taken to, you know, learn violin, etc. Those were not serious thing. I would have gone to Shantiniketan most certainly had I not gone into movies. Yeah.
Devinder, I am going to call you on stage. That's Dr. Devinder Singh, and Devinder told me a little, gave me a little information which actually gives us the insight, the heart of the lady before me. Devinder says that he was a junior doctor in the ICU at Gangaram Hospital when Madam Sharmila's mother-in-law was admitted, and they really worked hard, and when she was discharged, she brought in a big cake and gave it to all the junior doctors. He hasn't forgotten that gesture, ma'am, and it must be several years ago that happened. And Devinder, for remembering that, I'd like you to come and receive another gift from her. That's a signed book called Pataudi, the Nawab of Cricket, in which she's written a foreword. Ma'am, please give it to Devinder.
Impressed by that gesture, ma'am. And I'm impressed
He
once
says
again.
he was hugely impressed by that gesture.
Can I call my
And
wife for a joint photograph, ma'am?
I'm not in charge.
Thank you, Devinder. Thank you for that input. And I think, ladies and gentlemen, we need to put our hands together for the wonderful, open, and unrestricted answers that Madam was able to give us. And Madam, if I did a bad job, forgive me. If I did a good one, mention it.
No, I'm sure it was very enjoyable, and thank you very much. It was very nice. And Dr. Sood, of course, is very special to me. He knows that. I call him from wherever I may be, across timeline, time zone. So he always returns my call.
When we are on holiday, I've actually had telephone calls coming from you.
Yeah, I'm sure. Thank you very much, and thank you.
Now, I request Dr. Randhir Sood, Chairman of EPL 2023, to please present a token of appreciation to Madam Sharmila Tagore and to Dr. S.K. Tyagi. Conversation that sparkle, an engaging interview experience today with you, ma'am. We are delighted to have you here with us. Please put your hands together for this memorable moment. From heart to heart embrace. A round of applause to the interviewer and the interviewee, and a thank to the organizers, especially the chairman, for giving us an opportunity to experience the scientific sessions and the cricketing experience and the entertainment and grace that we have witnessed today. Thank you so much, ladies and gentlemen. Thank you to Madam Sharmila Tagore. I have a quick announcement to make. The gala dinner is open for you all, and by the time the stage is set for the band Do Re Mi to perform, we would like to have you here to enjoy the performance. By the time, please enjoy the dinner. Thank you. Me, Dr. Ankita, signing off for today. Thank you.